Καλή σας μέρα, καλώς ήρθατε. Πρωί Σαββάτου. Υπήρξε και μία ενημέρωση για το ότι θα ξεκινήσουμε λιγάκι νωρίτερα, οπότε δεν έχουμε πάρα πολύ κόσμο εδώ. Βέβαια, έχουμε διαδικτυακά, όσο ξέρω, 20 άτομα. Επομένως, καλό θα ήταν να ξεκινήσουμε για να προλάβουμε τον χρόνο. Η πρώτη ομιλία έρχεται από τον κύριο Αρμακόλα. Ο κύριος Αρμακόλας είναι αναπληρωτής καθηγητής στο Εργαστήριο Φυσιολογίας Ιατρικής Σχολής του ΕΚΠΑ και συνεργάζεται, θα μας μιλήσει για ένα νέο μονοκλονικό αντίσωμα. Κύριε Αρμακόλα, ευχαριστούμε. Δεν έχετε σύνδεση. Θα συνδεθείτε αμέσως.
Καλημέρα και από μένα, κύριε Πρόεδρε, καλημέρα. Καλημέρα, κύριε Συνέδρη. Ευχαριστώ πολύ που μου δώσατε την ευκαιρία να πω δύο πράγματα για το νέο μονοκλονικό αντίσωμα που έχουμε φτιάξει. Στην ουσία, ένα νέο μονοκλονικό αντίσωμα δεν είναι τίποτα χωρίς το στόχο του. Ο στόχος λοιπόν του νέου μονοκλονικού αντισώματος είναι αυτό εδώ πέρα το πεπτιδιάκι. Το ίση πεπτίδιο. Τι είναι αυτό? Είναι μέρος μιας ισομορφής, είναι το πεπτίδιο που χαρακτηρίζει την ισομορφία IGF-1-EC του γονιδίου IGF-1. Ο IGF-1 βγαίνει σε τρεις πρόδρομες ισομορφές, την EA, την EB και την EC. Όλες κόβονται και μας δίνουν τον όριμο IGF-1, που η λειτουργία στον καρκίνο είναι γνωστή. Επάγει τον πλασιασμό κατά βάση και τη μεταστατικότητα. Αυτό που δεν ξέραμε είναι τι κάνει το πεπτιδιάκι αυτό. Και τα άλλα δύο, εν πάση περιπτώσει. Κοιτάξαμε αυτό. Βρήκαμε ότι το πεπτιδιάκι EC, υπό φυσιολογικές συνθήκες, το χρειαζόμαστε πότε? Όταν κάνουμε επισκευή. Όταν ένας ιστός δηλαδή έχει πάθει βλάβη, παράγεται η ισομορφία αυτή του IGF-1, βγαίνει το πεπτιδιάκι και φωνάζει με σεχηματικά κύτταρα, τα οποία επισκευάζουν τον ιστό μας. Στον καρκίνο κάνει το ίδιο πράγμα. Επισκευάζει τον καρκίνο όταν αυτός υφίσταται βλάβη από το ανισοποιητικό ή από ακόμα και χημειοθεραπεία και παράγεται όσο ο καρκίνος μεγαλώνει. Έχει μια αυτοκρινή παρακρινή δράση και επάγει κυταρικό πολλαπλασιασμό και μεταστατικότητα μαζί με την επισκευή του όγκου. Οπότε λοιπόν, αυτό που κάναμε αρχικά είναι πήραμε κυταράκια του μαστού, τα οποία δεν είχαν λόγο να εκφράσουν το πεπτίδιο ε-EC και τα κάναμε να το υπερεκφράσουν. Και αυτό που είδαμε, κοιτάζοντας το πρωτέωμα, με κόκκινο είναι οι πρωτεΐνες οι οποίες υπερεκφράζονται. Με πράσινο αυτές που υποεκφράζονται. Είδαμε ότι στα κυταράκια του μαστού έχουμε αυτό το προφίλ, ενώ στα ίδια κύτταρα τα οποία υπερεκφράζουν το πεπτίδιο ε, έχουμε ένα τελείως διαφορετικό προφίλ. Άλλες πρωτεΐνες εκφράζονται εδώ, άλλες εδώ. Αυτές οι πρωτεΐνες είχαν να κάνουν κυρίως με τον πλασιασμό και μεταστατικότητα και διήθηση. Κοιτάζοντας τώρα το φώσιμο πρωτέωμα, να δούμε ποιο μονοπάτι ενεργοποιήθηκε για να ενεργοποιήσει όλες αυτές τις πρωτεΐνες, είδαμε ότι το μονοπάτι που ενεργοποιήθηκε ήταν το MAP kinase, ERK1, 2 κτλ. Οπότε λοιπόν, τι έχουμε? Έχουμε τον καρκίνο μας, ο οποίος όταν βρεθεί σε δύσκολες καταστάσεις, από το νοσοποιητικό σύστημα ή από χημειοθεραπεία, παράγει την ισομορφία αυτή του IGF-1, παράγει τον IGF-1, κόβεται αυτή η ισομορφή, για να έχει τον όριμο IGF-1 και έχουμε το πεπτίδιο ε-C που βγαίνει έξω, το PEC, δρά αυτοκρινώς ή παρακρινώς και ενεργοποιεί τον κυταρικό πολλαπλασιασμό και τη μεταστατικότητα. Ενώ ταυτόχρονα φωνάζει με σεγχηματικά κύτταρα η επισκευή του όγκου. Ωραία λοιπόν, οπότε τι πιο φυσικό, για εμάς τουλάχιστον, να φτιάξουμε ένα αντίσωμα εναντίον αυτού του προσδέτη, του πεπτιδίου ε, με σκοπό να σταματήσουμε όλες τις λειτουργίες του. Οπότε αρχικά πήγαμε στα κυταράκια. Τα κυταράκια μας, είπαμε, δεν εκφράζουν το πεπτίδιο ε, οπότε το υπερεκφράσαμε. Και όταν το υπερεκφράσαμε, κοιτάξαμε κυταρικό πολλαπλασιασμό και είδαμε ότι στις 24 ώρες και στις 48 ήταν πολύ μεγάλος σε σχέση με το φυσιολογικό, το καρκινικό χωρίς το πεπτίδιο ε. Και όταν δώσαμε το αντίσωμα, ο κυταρικός πολλαπλασιασμός σταμάτησε. Ελέγξαμε το μονοπάτι το ERK1-2 που είπαμε προηγουμένως ότι ενεργοποιείται και αυτό σταμάτησε να εκφράζεται όσο αυξήσαμε την δόση του αντισώματος. Άρα λοιπόν είχαμε μια καλή ένδειξη ότι δουλεύει. Το μονοπάτι αυτό, ERK1-2, ενεργοποιεί και την μεταστατικότητα του όγκου. Οπότε αυτό που κάναμε μετά, κοιτάξαμε το φαινόμενο επιθύλια του mesenchymal transition. Τι γίνεται εδώ πέρα τώρα? Έχουμε τα επιθυλιακά κύτταρα που εκφράζουν ε-κατερίνη, που είναι σφιχτά δεμένα μεταξύ τους, και έχουμε και τα μεσενχηματικά κύτταρα τα οποία εκφράζουν βιμετίνη, τα οποία είναι αυτά που δίνουν μεταστάσεις και διηθήσεις. Έτσι λοιπόν, στα κυταράκια του καρκίνου του μαστού στην καλλιέργεια, έχουμε επιθυλιακά κύτταρα και όχι μεσενχηματικά. Είναι ήρεμα, όμορφα και ωραία. Στα ίδια κύτταρα, όταν τα βάζουμε να υπερεκφράζουν το πεπτίδιο ε, σταματάνε να είναι επιθυλιακά και είναι μεσενχηματικά, είναι επιθετικά. δίνουν μεταστάσεις και διαιτήσεις. Τώρα, όλα σε αυτά τα κύτταρα που δίνουν μεταστάσεις και διαιτήσεις, τους δώσαμε το αντίσωμά μας, σταδιακά γύρισαν πίσω στον επιθυλιακό φαινότυπο, τον ήρεμο φαινότυπο. Και η δράση του αντισώματος στην μετάσταση και στη διαιτήση επιβεβαιώθηκε μια σειρά πειραμάτων invasion και migration assays. Ένα χαρακτηριστικό ήταν αυτό το wound healing assay, όπου σε μια επιφάνεια κυττάρων κάνουμε μια χαρακιά και περιμένουμε να δούμε σε τακτά χρονικά διαστήματα πότε θα κλείσει αυτή η χαρακιά. Και βλέπουμε στα κύτταρα του μαστού, σε 18 ώρες έχουν καλύψει το 20% του κενού περίπου. Τα ίδια κύτταρα τα οποία υπερεκφράζουν το πεπτίδιο ε στις 12 ώρες το κάλυψαν όλο, πολύ επιθετικά. Τώρα αυτά τα κύτταρα στα οποία δώσαμε το αντίσωμά μας δεν έκαναν τίποτα. Και αυτό φαίνεται χαρακτηριστικά και εδώ, όπως συγκρίνουμε τα κυτταράκια του μαστού που εκφράζουν το πεπτίδιο ε στην πορτοκαλί γραμμή, σε σχέση με την γκρι γραμμή που είναι τα ίδια κύτταρα που δώσαμε αντίσωμα. Ωραία, λοιπόν. Πάμε στα ποντικάκια μας. Κάναμε καρκίνο μαστό σε ποντίκια. 20 ποντίκια με το αντίσωμα. Το αντίσωμα χορηγήθηκε όταν η όγκη ήταν ψηλαφιτή. Να προσωμιάσουμε το ανθρώπινο μοντέλο, εν πάση περιπτώσει. Αυτό που είδαμε είναι ότι μόνο 2 ποντικάκια είχαν όγκους, τα υπόλοιπα δεν είχαν όγκους και δεν είχαμε όγκους για νοστοσχημία. Οπότε αυτό που κάναμε ήταν με real-time PCR, είδαμε ότι οι όγκοι μας εξέφρασαν καδερίνη, τον επιθυλιακό δείκτη, σταμάτησαν να εκφράζουν μεμεντίνη, το μεσαιχηματικό δείκτη, δεν ήταν επιθετικά, και σταμάτησαν να εκφράζουν και το Ki67 που είναι ο δείκτης πολλαπλασιασμού. Άρα λοιπόν σταμάτησαν να είναι μεταστατικά και να πολλαπλασιάζονται. Όσο αφορά τις μεταστάσεις, αυτό που είδαμε είναι ότι τα ποντικάκια στα οποία δεν δώσαμε το αντίσωμα είχαν 6 στα 10, το 60% είχαν διηθυμένους λεμφαδένες, αυτός ο λεμφαδένας φρουρός, και δώσαν μεταστάσεις σε απομακρυσμένους ιστούς, όπως το είπα εδώ πέρα στην περίπτωσή μας. Σε αντίθεση με τα ποντικάκια που πήρανε, που δεν είχαν καμία μετάσταση. Τώρα η απορία που δημιουργήθηκε είναι γιατί οι όγκοι ήταν μικρότεροι. Σταμάτησε ο κυτταρικός πολλαπλασιασμός, σταμάτησε η μεταστατικότητα, η διαιτήση. Γιατί ήταν μικρότεροι? Η απάντηση είναι αυτή. Αναλύοντας τους όγκους, είδαμε ότι υπάρχουν περιοχές νεκρωτικές. Και οι όγκοι στους οποίους δώσαμε αντίσωμα είχαν πολύ μεγάλη έκφραση των αποπτωτικών δικτών. Τι έγινε? Εδώ πέρα βλέπουμε στο σχεδιάγραμμα ότι ελέγξαμε τους όγκους για μεσαιχηματικά κύτταρα, για κύτταρα του νοσοποιητικού συστήματος. Όπου έχουμε κόκκινο χωρίς πράσινο, είναι κύτταρα μεσαιχηματικά. Όπου έχουμε και τα δύο χρώματα μαζί, είναι κύτταρα του νοσοποιητικού. Οπότε βλέπουμε τα ποντικάκια τα οποία δεν πήραν το αντίσωμα, οι όγκοι τους έχουν πολλά μεσαιχηματικά κύτταρα που επισκευάζουν. Ενώ στα ποντικάκια που πήραν το αντίσωμα, έχουμε λίγα μεσαιχηματικά κύτταρα, μόνο 3 εδώ πέρα, και πάρα πολλά κύτταρα του νοσοποιητικού, που καταστρέφουν τον όγκο. Άρα λοιπόν αυτή η λειτουργία του πεπτιδίου ε που φωνάζει μεσαιχηματικά για επιδιόρθωση έχει καταργηθεί. Άρα ο όγκος πεθαίνει έμεσα. Το επόμενο βήμα που κάναμε είναι κοιτάξαμε τοξικότητα και ειδικότητα του σώματος. Τοξικότητα δώσαμε μια πολύ μεγαλύτερη δόση από αυτή που δίναμε συνήθως. Εμείς δίνουμε 10 mg ανά κιλό 2 φορές την εβδομάδα. Τώρα δώσαμε 30 mg ανά κιλό 4 φορές την εβδομάδα για 2 μήνες. Ήπαρ, νεφροί, πνεύμονες, εμείς, καρδιά, όλα καθαρά. Η ειδικότητα, κοιτάξαμε πάλι τους ίδιους ιστούς, αυτή τη φορά με ένα βιοτηλιωμένο αντίσωμα, και είδαμε ότι βασικά το αντίσωμά μας το πιάνει μόνο στον όγκο και πουθενά άλλου. Επομένως, λοιπόν, όσο αφορά τα συμπεράσματά μας, τι βρήκαμε? Εμείς φτιάξαμε ένα μονοκλονικό αντίσωμα εναντίον του πεπτιδίου EC, της ομορφής IGF-1C, το οποίο μπορεί να καταστέλει τον κυτταρικό πολλαπλασιασμό, μετάσταση και διήθηση, ενώ επάγει και την ογκομείωση. Τη μείωση του όγκου πώς? Έμεσα. Καταστέλλοντας τα μεσαιχηματικά κύτταρα, αυτό να πάνε να επιδιορθώσουν και επάγοντας το νοσοποιητικό σύστημα να επιτεθεί. Επιπλέον, αυτό που είδαμε είναι ότι το μονοκλονικό αντίσωμα δεν φαίνεται να είναι τοξικό και αυτό έχει να κάνει με την ειδικότητά του για τον όγκο. Ευχαριστώ πολύ για την προσοχή σας. Ευχαριστώ πολύ.
Ευχαριστούμε πάρα πολύ. Είναι μια εξαιρετική ομιλία. Λυπάμαι που δεν έχει κόσμο μέσα εδώ. Είναι πραγματικά και ο τρόπος που αναλύσατε και πώς γίνονται ο μηχανισμός δράσης είναι εξαιρετικός. Δεν ξέρω αν το ξέρετε, στο Έλενα ήταν η πρώτη προσπάθεια νοσοθεραπείας. Ήταν το πρώτο πρωτόκολλο με εμβόλιο του Μαστού, το 1986, το οποίο για κάποιο λόγο σταμάτησε το πρωτόκολλο. Το 2004-2005 ο Βασίλαρος το είχε ανακοινώσει στο Σεν Γκάλεν σε πόστερ και κόντεψε να βραβευτεί. Ήταν μια εξαιρετική προσπάθεια για Μιούκ 1.
Το θυμάμαι, το έχω ακούσει.
Συγχαρητήρια, πάρα πολύ ωραία ομιλία.
Ευχαριστώ πολύ.
Να κρατήσουμε τις ερωτήσεις για το τέλος. Θέλει κάποιος να ρωτήσει κάτι? Όχι. Ευχαριστούμε πολύ.
Ευχαριστώ και εγώ.
Η δεύτερη ομιλία είναι από την κλινική του κυρίου Ξαπαπαδάκη. Θα μιλήσει η κυρία Φωκιανού. Η κυρία Φωκιανού είναι από το ΙΑΣΟ. Είναι retrospective, είναι με μεγάλο αριθμό ασθενών. Καλή επιτυχία.
Ευχαριστούμε. Καλημέρα και από μένα. Ευχαριστώ πολύ για την πρόσκληση. Θα μιλήσουμε για μία σειρά περιστατικών μεταπλαστικών καρκινομάτων με παραγωγή θεμέλιας ουσίας της κλινικής μας. Μου έκανε εντύπωση καθώς έψαχνα ότι η πρώτη δημοσίευση είναι το 1989 που μιλάνε για τα μεταπλαστικά καρκινόματα Μαστού και αναφέρουν μέσα σε όλα ότι η χημειοθεραπεία και η ακτινοβολία φαίνεται να έχουν περιορισμένη αποτελεσματικότητα. Το ρίχνανε τότε την πενταετή επιβίωση στο κομμάτι το χειρουργικό. Σήμερα επιβεβαιώνεται αυτό, ότι πραγματικά η χημειοθεραπεία και η ακτινοθεραπεία έχουν ένα όφελος, αλλά θα δούμε και παρακάτω ότι την επικουρική δεν έχει και πολύ μεγάλη σημασία στα matrix producing. Οπότε προχωράμε. Στην εισαγωγή μας, ένας πολύ σπάνιος πότυπος διαιτητικού πορογενούς καρκινόματος. Αποτελούν το λιγότερο από 1% όλων των περιπτώσεων διαιτητικού πορογενούς. Έχουν κακή πρόγνωση και υψηλό κίνδυνο υποτροπής. Τα μεταπλαστικά καρκινόματα με παραγωγή θεμέλιας ουσίας είναι ένας ακόμα πιο σπάνιος πότυπος μεταπλαστικών καρκινομάτων και αποτελούν κάτω από το 0,1% όλων των διαιτητικών και εμφανίζονται συχνά ως τριπλά αρνητική καρκίνη. Εδώ μια εικόνα από το παθολογοανατομικό μας τμήμα, που βλέπουμε την παραγωγή χόνδρινης ουσίας. Η θετική έκφραση των νεοπλασματικών κυτάρων στο δείκτη P63 είναι διαγνωστικό στοιχείο για τα μεταπλαστικά καρκινόματα. Και εδώ είναι μια εικόνα που θα την έκανα συζήτηση. Βλέπουμε τη μαγνητική, μια βλάβη TAF 2-0, και θα λέγαμε ότι είναι πριν το χειρουργείο. Και όμως αυτή είναι μετά από την επικουρική θεραπεία η γυναίκα. Οπότε βλέπουμε ότι ίσως η επικουρική θεραπεία σε αυτά τα κορίτσια δεν έχει και μεγάλο όφελος. Τα μεταπλαστικά matrix, όχι όλα τα μεταπλαστικά, τονίζω. Το κέντρο μας διαθέτει περίπου 8.500 ασθενείς με διαιτητικό και μη διαιτητικό καρκίνο. Από αυτούς, 38 έχουν διαγνωστεί με μεταπλαστικό καρκίνο και 14 έχουν αυτόν τον σπάνιο υπότυπο που μελετάμε. Τα αποτελέσματά μας. Η μέση ηλικία διάγνωση ήταν τα 60 έτη. Το περιμέναμε. Σύμφωνα με την TNM ταξινόμηση, το μέγεθος του όγκου ήταν TAF 1 σε 5 ασθενείς, TAF 2 σε 7, TAF 3 σε 1, TAF 3 σε 1, συγγνώμη, και TAF 4 επίσης σε έναν ασθενή. Η κατάσταση των λαμφαδένων ήταν, όπως περιμένουμε και από τη διεθνή βιβλιογραφία, νη 0 στους περισσότερους, ενώ δεν υπήρχε ασθενής με de novo μεταστατική νόσο. Η ενοσοϊστοχημία, λοιπόν, έδειξε αυτό που περιμέναμε, 11 στους 14 τριπλά αρνητικό τύπο με grade 3 και έναν υψηλό δείκτη πολλαπλασιασμού, 85%. 6 ασθενείς έκαναν γενετικό έλεγχο και μόνο ένας είχε μια παθογόνο παραλλαγή στον BRCA1 γονίδιο. Από αυτούς τους ασθενείς, ένας είχε μετάσταση στον εγκέφαλο, ενώ 2 εμφάνισαν τοπική υποτροπή, η οποία ανταποκρίθηκε πλήρως στην υπόλοιπη θεραπεία και μέχρι σήμερα οι ασθενείς μας είναι καλά. Οι περισσότεροι έλαβαν επικουρική θεραπεία, 9 στους 14, ενώ οι επικουρικοί έλαβαν 3 στους 14 χωρίς πλήρη παθολογική ύφεση, μπορούμε να πούμε χωρίς καμία ανταπόκριση στη θεραπεία. Καθώς και η ακτινοθεραπεία. Η μία, μάλιστα, ήταν τριπλά αρνητική, είχε λάβει και νοσοθεραπεία, είναι τώρα πρόσφατα. Η μέση διάρκεια παρακολούθηση ήταν 44 μήνες, έχουμε ένα καλό follow-up και τα συμπεράσματα. Τα δεδομένα αντιπροσωπεύουν την εμπειρία μιας κλινικής. Επομένως, έχουμε ένα μικρό ποσοστό, ένα μικρό περιστατικό, αριθμό περιστατικών, που όμως σχετικά με αυτόν τον υπότυπο είναι αρκετά υψηλός. Η ακριβής διάγνωση απαιτεί χειρουργική βιοψία, γι' αυτό είναι πάρα πολύ σημαντικό να το συζητήσουμε σε ένα συνέδριο χειρουργικής. Η προεγχειρητική διάγνωση παίζει πολύ μεγάλο ρόλο στην καλή ανταπόκριση αυτών των ασθενών και στο χειρισμό τους. Ενώ η θεραπεία περιλαμβάνει συνήθως τη χειρουργική εξαίρεση, επικουρική και ανεπικουρική θεραπεία, αλλά βέλτιστες στρατηγικές για τη διαχείριση αυτού του υπότυπου δεν έχουν ακόμα καθιερωθεί λόγω της σπανιότητας αυτής της κακοήθειας. Έτσι, πολύ σημαντικό να τονίσουμε ότι η διεπιστημονική προσέγγιση, η εξατομικευμένη θεραπευτική οδό αποτελούν τη λύση στη βέλτιστη διαχείριση αυτών των ασθενών. Εδώ είναι η βιβλιογραφία. Ευχαριστώ και θα χαρώ να ακούσω ερωτήσεις μετά.
Έχετε ερωτήσεις? Όσο πιο... Πάρα πολλές φορές προβληματιζόμαστε για το πώς θα αντιμετωπίσουμε ένα καρκίνο. Σίγουρα πρέπει πρώτα να το γνωρίσουμε πάρα πολύ καλά. Επομένως, ναι, όντως, η βιοψία. Όσο για τον αριθμό, μην ανησυχείτε. Πιστεύω σε 2-3 χρόνια, κύριε Ξαπαπαδάκη, θα είσαστε στις 20.000. Ναι, κύριε Σκουρδάκη.
Σε πάει σε ένα όγκο 3 εκατοστά. Το οποίο η συλλογική ήταν μεταπλαστικό καρκίνωμα. Προσκοπώντας τη βιογραφία, βρήκατε τίποτα να σχετίζεται με μια ακτινοθεραπεία ή χημειοθεραπεία σαν αιτιολογία?
Όχι, δεν βρήκαμε κάτι τέτοιο. Εγώ προσωπικά στη δική μου έρευνα. Το μόνο που βρήκα είναι μήπως χρειάζονται στα μεταπλαστικά καρκινώματα να γίνεται ανασκόπηση πλακιδίων μετά το χειρουργείο, για να βρούμε αν είναι με παραγωγή θεμέλιας ουσίας, δηλαδή να κατηγοριοποιούμε και το μεταπλαστικό, γιατί υπάρχουν διάφοροι υπότυποι και του ίδιου του μεταπλαστικού. Οπότε ουσιαστικά και στην core biopsy, επειδή το υλικό είναι συγκεκριμένο, μπορεί να μην μπορούμε να βάλουμε πολύ εύκολα. Με διαφορετικό υπότυπο στην αρχή.
Θα μπορούσε να προϋπάρχει. Θα μπορούσε να προϋπάρχει.
Μα στα 3 εκατοστά.
Δεν υπήρχε. Πιστεύω ότι ακόμα και τα νεοπλάσματα. Είναι το όνομα, το ίδιο ρωτήσαμε. Ακριβώς το ίδιο ρώτησα. Να το συζητήσουμε και στο διάλειμμα μετά αυτό με ησυχία ίσως. Ευχαριστούμε πολύ την κυρία Φωκιανού.
Ωραία. Καλημέρα και από μένα. Να καλέσουμε τώρα τον κύριο Παπαδόπουλο, που είναι και αυτός από την κλινική Μαστού του ΙΑΣΟ, να μας μιλήσει για μια προοπτική μελέτη παρατήρησης προεμινοπαυσιακών ή αρθετικών χερτού αρνητικών ασθενών στην Ελλάδα με ογκολογικό φορτίο μασχάλης, αλλά χαμηλό Oncotype DX, οι οποίες δεν έλαβαν χημειοθεραπεία.
Καλημέρα και από εμάς. Μια μικρή ιστορική αναδρομή, όλοι τα ξέρετε και τα γνωρίζετε αυτά. Οι γονιδιακές υπογραφές δημιουργήθηκαν για την ανάγκη έβρεσης νέων προγνωστικών εργαλείων. Δηλαδή, προγνωστικό εργαλείο εννοούμε ένα εργαλείο το οποίο προφανώς, όπως ξέρετε όλοι, θα μας έλεγε πώς θα τα πάει ένας ασθενής μας εάν δεν του κάναμε τίποτα. Και τα παλιότερα προγνωστικά εργαλεία τα οποία είχαμε, δηλαδή από την κατάσταση μασχάλης που είναι ο πιο ισχυρός προγνωστικός παράγοντας, μέχρι το TAF, μέχρι τα ιστρογόνα, το Grade, το KX17, ήταν σε θέση να αναγνωρίσουν ένα πραγματικά κακό όγκο, αλλά όχι τόσο ικανά στο να αναγνωρίσουν έναν καλό. Είχαμε αυξημένη ευαισθησία σε όλα αυτά, αλλά μειωμένη ειδικότητα. Και οι γονιδιακές υπογραφές, τα ξέρετε όλοι πάρα πολύ καλά, ξεκίνησαν με αυτό το σκοπό σε ορμονοεξαρτώμενους αρχικά ασθενείς με αρνητική μασχάλη. Η Taylor-X σχεδιάστηκε την αποκλιμάκωση της χορήγησης χημειοθεραπείας. Φάνηκε αρχικά ότι με ένα χαμηλό σκορ η χημειοθεραπεία δεν θα είχε όφελος, οπότε πέραν από προγνωστικό είδαμε ότι είχαμε και μια προβλεπτικότητα μέσα σε αυτές τις εξετάσεις. Πρώιμα ερευνητικά στοιχεία από τη μελέτη αυτή είχαν δείξει ότι οι γυναίκες κάτω των 50 μπορεί να είχαν ένα μικρό όφελος από τη χημειοθεραπεία με ένα σκορ από το 21 στο 25 που μπορεί να έφτανε μέχρι στο 7%. Και το όφελος αυτό ήταν ανεξάρτητο από τα παλαιά προγνωστικά στοιχεία που ανέφερα πριν, που είχαμε για την έβρεση των όγκων. Αναδρομικά σε προοπτικά, μετά σε θετική μασχάλη, είχαμε μόνο σε μετεμινοπαυσιακές, με τις WOG 88-14. Οπότε χρειάστηκε να γίνει μία μελέτη, και αυτή ήταν η Responder, η οποία θα μας έδινε, από τέλος πάντων κάποιες απαντήσεις, στο πώς διαχειριζόμαστε τις προ- και τις μετεμινοπαυσιακές γυναίκες με θετική μασχάλη. Φάνηκε από τη μελέτη αυτή ότι στις μετεμινοπαυσιακές γυναίκες αυτά που ίσχυαν στη Taylor X συνέχιζαν να ισχύουν, ενώ στις προεμεινοπαυσιακές γυναίκες φάνηκε ότι υπήρχε όφελος από τη χημειοθεραπεία ανεξαρτήτου σκορ. Στην Responder υπήρχε μικρός αριθμός ασθενών με micro. Στην αρχή είχαν πει στα inclusion criteria να ήταν ασθενείς με νη ένα νόσο και micro, αλλά μετά ο αριθμός των ασθενών με λεμφαδενική μετάσταση στο φρουρό, με μικρομετάσταση κάτω από 2 χιλιοστά, ήταν ιδιαίτερα χαμηλός, όπου φάνηκε σε μια subgroup ανάλυση τάση, αλλά όχι σημαντικότητα ωφέλους από τη χημειοθεραπεία. Οπότε, με όλες αυτές τις μελέτες είχαμε ένα shift στο σκεπτικό μας και ενώ οι κατευθυντήριες οδηγίες πριν από την Responder δεν υπήρχε ένας σαφής διαχωρισμός μεταξύ εμεινοπαυσιακής κατάστασης στο αν θα έπρεπε να χορηγήσουμε χημειοθεραπεία ή όχι. Αυτό που μετρούσε ήταν το ογκολογικό φορτίο από τη μία και η υποκειμενικότητα του θεράποντος στο πώς θα διαχειριστεί μια ασθενή του. Ενώ μετά την Responder υπήρχε ένας διαχωρισμός μεταξύ προ- και μετέμεινοπαυσιακής κατάστασης με θετική μασχάλη στο πώς θα διαχειριστούμε αυτές τις ασθενείς και αν θα έπρεπε να δώσουμε χημειοθεραπεία ή όχι. Ο σκοπός της δικιάς μας μελέτης ήταν μια προοπτική μελέτη παρατήρησης και τη δημιουργία βασικά ενός μητρώου ασθενών και η παρουσίαση όσων δεδομένων μπορούσαμε να έχουμε στο distant recurrence free interval σε προ- ή περιεμεινοπαυσιακές γυναίκες με θετικούς λεμφαδένες, είτε ήταν νη 1 είτε micro, μέχρι λοιπόν από 0,2 έως 2 χιλιοστά, με ένα recurrence score 0-25, οι οποίες είτε λόγω επιλογής τους, είτε λόγω συνοσηρότητας, είτε πριν το 21, δεν υποβλήθησαν σε χημειοθεραπεία και έλαβαν μόνο ενδοκρινική θεραπεία με ή χωρίς OFS. Και μια μελέτη έμεσα του υποπληθυσμού με θετική μασχάλη με μικρομεταστάσεις, κοντά στα 50 λοιπόν, που έλαβαν ενδοκρινική θεραπεία και OFS. Ήτανε τα ασθενείς της Β' κλινικής Μαστού, του Ιατρικού Αθηνών και της Λάρισσας. Δημιουργήσαμε έτσι μια κόρτη ασθενών πριν την Responder με χαμηλό ογκολογικό φορτίο. 85% των ασθενών που θα δείτε τώρα είναι πριν από την Responder. Ήταν ασθενείς που αρνήθηκαν σε μεγάλο βαθμό τη λήψη χημειοθεραπείας. Ήταν ασθενείς με συνοσηρότητα που δεν μπορούσαν να λάβουν χημειοθεραπεία. 47 ήταν ο αρχικός ο αριθμός, 40 συμπεριλήφθησαν στη στατιστική μας ανάλυση. Ήταν ασθενείς με ημερομηνία επέμβασης από 26 Εβδόμου του 12 έως 20 Δευτέρου του 24. Δεν μπήκε μία ασθενής η οποία είχε ITCs στη μασχάλη της και low risk. Ήταν άλλη μία ασθενής με endopredict, η οποία και αυτή χειρουργήθηκε πριν από 3 χρόνια, 4 είναι ακόμα εν ζωή, προφανώς χωρίς μετάσταση, αλλά δεν μπήκε και αυτή στη στατιστική ανάλυσή μας. Και άλλη μία ασθενής η οποία αρνήθηκε και τη λήψη ενδοκρινικής θεραπείας, οπότε ούτε και αυτή μπήκε μέσα. Και 4 τελικά που είδαμε ότι έλαβαν χημειοθεραπεία. Οπότε πίνη 1 ή πίνη micro με ένα oncotype 0-25, οι οποίες δεν έλαβαν χημειοθεραπεία. Και έχουμε ένα μέσο follow-up σε αυτές τις ασθενείς στα 5 έτη. Με μία μέση ηλικία διάγνωσης στα 47,5. Αυτά, εδώ πέρα βλέπετε τα προγνωστικά, τα δημογραφικά στοιχεία του πληθυσμού, το είδος συστηματικής θεραπείας που έλαβαν οι ασθενείς αυτής της κοόρτης. Βλέπετε ότι με TAF1 έχουμε περίπου 80% των ασθενών, με ένα grade 1 το 25% και grade 2 το 70%. Ένα micro έχουμε στο 60% των ασθενών της κοόρτης μας και με ένα κανονικά το 40%. Ηλικία κάτω από 50, 70%. 60 περίπου τα 100 των ασθενών μας έλαβαν ενδοκρινική θεραπεία και OFS και είχαμε και ένα recurrence score από 0-13 που ήταν περίπου στο 65%. Και πράγματι, εάν τη συγκρίνουμε το δικό μας τον πληθυσμό με την Responder, βλέπουμε κάποιες εμφανείς διαφορές. Ποιες είναι αυτές? Καταρχήν, στην Responder ενδοκρινική θεραπεία και OFS έλαβε ένα 12,7%. Στη δικιά μας τη μελέτη ένα 42%. Η ηλικία κάτω από 50 ήταν περίπου παραπλήσιες. Μένει ένα micro, άλλη μια μεγάλη διαφορά με την Responder είναι αυτή, ένα 12,8%, ενώ στη δικιά μας τη μελέτη, στην κοόρτη, 60% των ασθενών μας είχαν μικρομετάσταση στο λεμφαδένα. Το 0-13 το recurrence score, γιατί στην Responder και στην Taylor X δεν φάνηκαν ότι υπήρχε προγνωστικότητα στο score, αν και νομίζω ότι υπήρχε μία τάση, έτσι, ούτως ή άλλως γι' αυτό είναι και ο διαχωρισμός και από 21-25 παραδείγματος χάρη. Έχουμε 65% με πολύ χαμηλό oncotype, ενώ στην Responder οι ασθενείς με 0-13 ήταν περίπου στο 38,7%. έχουμε πολύ περισσότερες ασθενείς με ταφένα, μέχρι 2 εκατοστά νόσο, 80%, ενώ στην responder ήταν 55,9% και τα grade ήταν περίπου τα ίδια. Με ένα διάμεσο χρόνο παρακολούθηση στα 5 έτη, που το εύρος βασικά ήταν από 3 έως 130 μήνες, είχαμε μόνο μία ασθενή, η οποία εμφάνισε μακρινή υποτροπή, πνευμονική ήταν αυτή, και είχαμε ένα distant recurrence free interval rate στο 97,5%. Αναφέρω την ασθενή με υποτροπή, ήταν 39 ετών, ήταν ένα π-ταφένα, μη ένα μάικρο, grade 3 και ένα recurrence score στο 17. Η πνευμονική υποτροπή εμφανίστηκε στους 37 μήνες, με ημερομηνία επέμβασης 13 Πρώτου του 2016. Οπότε θα έλεγα ότι τα ενθαρρυντικά αποτελέσματα που έχουμε για το distant recurrence free interval προσφέρει ίσως τη δυνατότητα εξατομίκευσης και νομίζω περαιτέρω μελέτης της χρήσης των προγνωστικών εργαλείων που έχουμε στη διάθεσή μας σε συγκεκριμένους υποπληθυσμούς προέμεινοπαυσιακών γυναικών ή αρθετικών, περισσότερο θα έλεγα από 0,2 έως 2 χιλιοστά μετάσταση, με μικρό ογκωτά φένα, με ηλικία κοντά ή κάτω από τα 50 και ένα χαμηλό recurrence score. Προφανώς ο ρόλος της καταστολής των θικών σε προέμεινοπαυσιακές γυναίκες με θετική μασκάλη, όπως ανέφερε και ο Καλίνσκι ούτως ή άλλως από την responder, γιατί δεν είχε γίνει responder για αυτόν τον λόγο, δηλαδή τη σύγκριση της ενδοκρινικής με χήμιο σε σχέση με την ενδοκρινική και ο FS θα μελετηθεί καλύτερα με την offset η οποία τρέχει αυτή τη στιγμή, και νομίζω ότι χρειαζόμαστε και μεγαλύτερο αριθμό ασθενών, μεγαλύτερο χρονικό διάστημα follow-up, το οποίο θα ενισχύσουν περισσότερο τη στατιστική δύναμη της παρούσης μελέτης. Να αναφέρω ότι η GeneCore έχει, από όσο μου έχουν πει, γύρω στα 200 περιστατικά γυναικών στην Ελλάδα προεμεινοπαυσιακών, οι οποίες με χαμηλό σκορ και θετική μασχάλη δεν έλαβαν χημειοθεραπεία, ή τουλάχιστον πιστεύουμε, γιατί εστάλει το Oncotype, ότι δεν έχουν λάβει χημειοθεραπεία. Τώρα αυτό θα πρέπει να μιλήσουμε με τους θεράποντες, να δούμε αν θα μπορούσαμε συγκεντρωτικά να μαζέψουμε κάποια στοιχεία που θα τα παρουσιάσουμε κάπου από γυναίκες οι οποίες ήταν προεμεινοπαυσιακές, έχουν χαμηλό recurrence score και δεν έλαβαν χημειοθεραπεία. Και βρήκα και έξω και μια μελέτη, λέγεται UNIRAD, η οποία είναι του EndoPredict και αφορά ακριβώς τις ίδιες γυναίκες που έχουν ένα αριθμό, το οποίο υποθέτω ότι έχει παρουσιαστεί κάπου σημαντικά, κάπου υψηλά, σε κάποιο ιδιαίτερο συνέδριο, δεν ξέρω αν έχει δημοσιευτεί κιόλας, με 105 ασθενείς. Εμείς είμαστε ήδη στις 47, οπότε νομίζω με κάποιες συμμαχίες και με λίγο συγχρονισμό εδώ πέρα στην Ελλάδα θα μπορούσαμε να παρουσιάσουμε ένα πολύ μεγάλο, ικανό αριθμό ασθενών, τα οποία θα μπορούσαν να παρουσιαστούν και έξω. Σας ευχαριστώ.
Ευχαριστούμε πολύ, κύριε Παπαδόπουλε. Καμία ερώτηση, κανένα σχόλιο?
Συγχαρητήρια, λοιπόν. Ευχαριστούμε
Εξαιρετικά,
πολύ.
Ναι.
Εξαιρετικά. Η τέταρτη ανακοίνωση δεν θα γίνει διαδικτυακή θεραπεία του λεμφιδήματος, οπότε θα προχωρήσουμε κατευθείαν στην ομιλία που μας έρχεται από την Κρήτη, κυρία Κορώνα, η οποία είναι χειρουργός στο Παγνί. Καλώς ήρθατε. Καλή επιτυχία.
Καλημέρα σας και από μένα. Θα σας παρουσιάσω μία αναδρομική μελέτη που αφορά τους προγνωστικούς παράγοντες για ανέβρεση διηφυτικού καρκινώματος σε ασθενείς με προεγχειρητική διάγνωση DCIS. Όπως ξέρουμε, περίπου σε ένα ποσοστό 10 με 25% των ασθενών που υποβάλλονται σε επέμβαση για DCIS ανεβρίσκεται στο χειρουργικό παρασκεύασμα και διηφυτικό στοιχείο και εκ των υστέρων διενεργείται βιοψία λεμφαδένα φρουρού. Η βιοψία λεμφαδένα φρουρού γενικά δεν ενδείκνυται στο DCIS, εκτός αν οι ασθενείς θα υποβληθούν σε μαστεκτομή, αν υπάρχει κάποιος παράγοντας υψηλού κινδύνου για την ύπαρξη διηφυτικού καρκινώματος. Έχουν προταθεί ποικίλες παράμετροι ως ενδείξεις για διηφυτικό καρκίνωμα στο τελικό παρασκεύασμα, όπως και προγνωστικά μοντέλα. Έχουν μελετηθεί διάφορα χαρακτηριστικά για την προγνωστική τους αξία στην ύπαρξη διηφυτικού καρκινώματος στο τελικό παρασκεύασμα, όπως είναι η παρουσία μάζας στην απεικόνηση, το μεγάλο μέγεθος, το υψηλό grade, το commendotype, η αρνητική ιστρογονική και προγεστερονική υποδοχής, η παρουσία νέκρωσης, η παρουσία ψηλαφιτής μάζας και η πολυκεντρική νόσος. Σκοπός της μελέτης μας ήταν η αναγνώριση ανεξάρτητων προγνωστικών παραγόντων που θα υποδεικνύουν την προσθήκη βιοψίας λεμφαδένα φρουρού κατά την αρχική επέμβαση στην εκτομή για DCIS. Μελετήσαμε αναδρομικά όλες τις ασθενείς που υποβλήθηκαν σε επέμβαση για DCIS στην Κλινική Χειρουργικής Ογκολογίας του Παγνί από το 2013 έως το 2024. Όλα τα δεδομένα αντλήθηκαν από το αρχείο του ιατρείου Μαστού της Κλινικής. Καταγράφηκαν οι εξής παράμετροι: τα δημογραφικά στοιχεία, κλινικά ευρήματα, το είδος της επέμβασης, τα απεικονιστικά χαρακτηριστικά και τα ιστοπαθολογικά χαρακτηριστικά των βλαβών. Έγινε στατιστική ανάλυση με σκοπό την αναζήτηση παραμέτρων που είχαν στατιστικά σημαντική διαφορά μεταξύ των ασθενών με τελική διάγνωση DCIS και διηθητικού καρκινώματος. Κατά το διάστημα αυτό αντιμετωπίστηκαν χειρουργικά 86 ασθενείς, όλες ήταν γυναίκες, και η τελική διάγνωση αναβαθμίστηκε σε διηθητικό καρκίνωμα σε 26 ασθενείς, το 30 περίπου της 100. Ο μέσος όρος ηλικίας των ασθενών ήταν τα 56,6 έτη, οι περισσότερες υποβλήθηκαν σε εκτομή της βλάβης. Στα 2 τρίτα των ασθενών απεικονιστικά υπήρχαν μικροαποτιτανώσεις. Στο 78% το Byratch ήταν 4 και σε ένα 16,9% 5. Το μέσο μέγεθος των βλαβών ήταν 26,8 χιλιοστά. Και στην πλειοψηφία τους είχαν θετικούς ιστρογονικούς και προγεστερονικούς υποδοχείς. Συγκρίνοντας τις δύο ομάδες, την ομάδα που η τελική διάγνωση ήταν DCIS και διηθητικό καρκίνωμα, βλέπουμε ότι περίπου στο 71% της πρώτης ομάδας και το 68% της δεύτερης απεικονιστικά υπήρχαν μικροαποτιτανώσεις. Στο 5% των ασθενών με DCIS υπήρχε ψηλαφητή μάζα, έναντι 24% των ασθενών με διηθητικό καρκίνωμα. Στην πλειοψηφία τους οι βλάβες ήταν κάτω των 2 εκατοστών. Και επίσης στην πλειοψηφία τους είχαμε θετικούς ιστρογονικούς και προγεστερονικούς υποδοχείς και στις δύο ομάδες. Η πολλαπλή ανάλυση παλινδρόμησης ανέδειξε ως ανεξάρτητο προγνωστικό παράγοντα για την ανέβρεση διηθητικού καρκινώματος μόνο την ύπαρξη ψηλαφητής μάζας. Στα αποτελέσματά μας, λοιπόν, στατιστικά σημαντικές διαφορές μεταξύ των δύο ομάδων είχαμε μόνο ως προς την ύπαρξη ψηλαφητής μάζας και το βαθμό διαφοροποίησης, ενώ η πολλαπλή λογιστική παλινδρόμηση έδειξε ως μοναδικό ανεξάρτητο προγνωστικό παράγοντα την ύπαρξη ψηλαφητής μάζας. Οι περιορισμοί της μελέτης ότι πρόκειται για αναδρομική μελέτη και είχαμε ένα μικρό μέγεθος δείγματος. Συμπερασματικά, λοιπόν, στις ασθενείς με προεγχειρητική διάγνωση DCIS που θα υποβληθούν σε εκτομή της βλάβης, η ύπαρξη ψηλαφητής μάζας θα πρέπει να μας κατευθύνει στην διενέργεια βιοψίας λαμφαδένα φρουρού. Σας ευχαριστώ.
Ευχαριστούμε πάρα πολύ και για το χρόνο που την είπατε την ομιλία σας, οπότε έχετε κάτι να ρωτήσετε. Εμένα μου έκανε εντύπωση το κομμέντο, μου φάνηκε πολύ ψηλό το ποσοστό.
Ναι,
μπορούμε να γυρίσουμε λίγο
πιο
πιο 35%
ναι,
κομμέντο.
ήταν πάνω από 50%.
Δηλαδή αυτό... Ναι. Μου φάνηκε πολύ, δεν ξέρω, εσείς τι νομίζετε. Δηλαδή στα in situ τα οποία θα βρούμε 35% ίσως είναι μικρό το δείγμα. Ευχαριστούμε πολύ. Κάτι άλλο?
Ωραία, να συνεχίσουμε τώρα με τον κύριο Λαϊνά, που είναι στην Β' Χειρουργική Κλινική του Ερυθρού, που θα μας μιλήσει, ναι, έχει να μας πει 2-3 εργασίες.
3 εργασίες, θα τις πείτε.
2 εργασίες.
2 βασικά, την επόμενη θα την πει ο κύριος Νταλαπέρας.
Ωραία, επομένως θα πείτε...
Okay.
Ωραία. Ευχαριστούμε.
Ωραία.
Λοιπόν, καλημέρα και από μένα. Να ευχαριστήσω καταρχάς την Οργανωτική Επιτροπή του Συνεδρίου για την αποδοχή της εργασίας μας για προφορική ανακοίνωση και εσάς που είστε εδώ σήμερα. Η ανακοίνωση αυτή έχει να κάνει με τη σταδιοποίηση της μασχάλης μετά από προεγχειρητική συστηματική θεραπεία με χρήση του ΣΠΙΟ, του υπερπαραγωγικού οξυδίου του σιδήρου, σε συνδυασμό με μπλε χρωστική ουσία. Δεν υπάρχει κάποια σύγκρουση συμφερόντων. Όπως γνωρίζουμε, η σταδιοποίηση της μασχάλης μετά από προεγχειρητική συστηματική θεραπεία είναι μια απαιτητική διαδικασία. Έχει αυξημένα ποσοστά ψευδώς αρνητικών ευρημάτων, αλλά είναι απαραίτητη για την κατάλληλη σταδιοποίηση των ασθενών μας και τη βέλτιστη έκβασή τους. Προτείνεται από όλες τις οδηγίες ουσιαστικά να γίνεται διπλή τεχνική εντόπισης για να μπορούμε να ανιχνεύσουμε λεμφαδένα φουρό σε περίπτωση που θα ξεκινήσουμε λεμφαδένα φουρό, και ο συνδυασμός του υπερπαραγωγικού οξυδίου του σιδήρου με μπλε χρωστική αποτελεί μια ασφαλή εναλλακτική στη χρήση ραδιοισοτόπου. Ο σκοπός της ανακοίνωσης είναι να παρουσιάσουμε την εμπειρία της μονάδας μας με την τεχνική αυτή. Το ΣΠΙΟ είναι ένα ενεώρημα νανοσφαιριδίων της τάξης των 59 νανομέτρων, που περιλαμβάνουν υπερμαγνητικό οξύδιο του σιδήρου. Αυτά τα σωματίδια ουσιαστικά μπορούν να μαγνητιστούν παρουσία μαγνητικού πεδίου, αλλά δεν έχουν μαγνητικό σήμα από μόνα τους. Αυτό σημαίνει ότι με ένα μαγνητικό παλμό μπορούμε να τα κάνουμε να έχουν μαγνητικό πεδίο και στη συνέχεια να τα ανιχνεύσουμε με έναν ειδικό ανιχνευτή. Η τεχνική που χρησιμοποιούμε είναι η έγχυση 1 ml σπίο υποθυλαία μία μέρα πρώτου χειρουργείου και η έγχυση 2,5 ml patent blue V διαλυμένου σε 2,5 ml φυσιολογικού ορού άμεσα προεγχειρητικά με το που κοιμηθεί η ασθενής. Στη συνέχεια χρησιμοποιούμε τον ειδικό ανιχνευτή για να βρούμε το φρουρό λεμφαδένα. Η μέθοδος αυτή έχει κάποια πλεονεκτήματα που είναι η ευελιξία στο χρόνο χορήγησης της ουσίας. Αυτό μπορεί να γίνει σύμφωνα με τις οδηγίες από 1 μήνα μέχρι και 1 ώρα πριν από το χειρουργείο. Δεν είναι ραδιενεργό, διευκολύνοντας έτσι λίγο τη διαχείριση των ασθενών, ενώ μας αποδεσμεύει από τμήμα πυρηνικής ιατρικής ή επιτρέπει σε νοσοκομεία όπως το δικό μας που δεν έχουν τμήμα πυρηνικής ιατρικής να μπορούν να χρησιμοποιήσουν μέθοδο διπλής εντόπισης. Τώρα, το υλικό της εργασίας μας είναι 15 ασθενείς οι οποίες υπευλήθησαν σε προεγχειρητική συστηματική θεραπεία και στη συνέχεια σε βιοψία φρουρού λεμφαδένα ή και target axillary dissection με τη χρήση του σπίου σε συνδυασμό με patent blue V. Οι ασθενείς υπευλήθησαν σε συμπληρωματικό λεμφαδενικό καθαρισμό επίπεδου 1 σε περίπτωση που δεν είχαμε θετικό έβριμα, ενώ σε περίπτωση θετικού ευρήματος σε λεμφαδενικό καθαρισμό επίπεδου 2. Πρώτης λήψης θεραπείας, το δείγμα μας το 46,7% είχε κλινικά αρνητική μασχάλη, το 33,3% είχε κλινικά αρνητική μασχάλη, αλλά ύποπτος λεμφαδένος στο υπερηχογράφημα επιβεβαιώθηκε θετικός με FNA, ενώ το 20% είχε κλινικά θετική μασχάλη. Βρήκαμε φρουρό λεμφαδένα σε όλα τα περιστατικά. Δεν υπήρξε αποτυχία της μεθόδου. Και ο μέσος αριθμός των εξαιρεθέντων φρουρών λεμφαδένων ήταν 3, με ένα εύρος από 1 έως 7. Είχαμε ένα ψευδός αρνητικό έβριμα, από την άποψη ότι ο λεμφαδένας που ήταν μπλε και είχε μαγνητικό σήμα ήταν μεν αρνητικός, αλλά κατά τη διαδικασία του dissection βρήκαμε και έναν ύποπτο ψηλαφιτικά λεμφαδένα, ο οποίος αφαιρέθηκε επίσης και ήταν θετικός, δηλαδή ήταν άλλος από το φρουρό, ο θετικός λεμφαδένας. Το 69,2% των ασθενών είχε αρνητικό λεμφαδένα φρουρό, το 7,7% είχε μικρομεταστάσεις, το 23,1% είχε μακρομεταστάσεις. Είναι πολύ σημαντικό να τονίσουμε ότι σε καμία από τις ασθενείς που είχαμε πλήρη παθολογική ανταπόκριση στη μασχάλη, ο επίνη 0, δεν βρήκαμε στο συμπληρωματικό λεμφαδενικό καθαρισμό θετικούς λεμφαδένες. Συμπίπτει μάλλον λίγο με τα δεδομένα που έρχονται σιγά-σιγά και ίσως μας επιτρέψουν να σταματήσουμε τους λεμφαδενικούς καθαρισμούς στο μέλλον μετά από προεγχειρητική συστηματική θεραπεία. Συμπερασματικά, ο συνδυασμός του σπίου με το patent blue V στη σταθεροποίηση της μασχάλης μετά από προεγχειρητική χημειοθεραπεία είναι μια ασφαλής εναλλακτική στη χρήση του ραδιοσωτόπου με καλό αριθμό εξαιρεθέντων λεμφαδένων και χαμηλό ποσοστό ψευδός αρνητικών ευρημάτων. Σας ευχαριστώ.
Ευχαριστούμε πολύ. Νομίζω οι περισσότεροι κάνουμε με 2 μεθόδους, έτσι δεν είναι? Και το fluorescent, το 7 μπορεί να μου φάνηκε πολύ, όπως και το ότι βγάλατε ένα ψηλαφιτό λεμφαδένα ο οποίος δεν ήταν βαμμένος.
Δεν ήταν βαμμένος, δεν είχε σήμα, αλλά ήταν σκληρός.
Προφανώς ήταν κλειστή η πύλη του. Δηλαδή, επομένως εκεί δεν θα έπρεπε να γίνει φρουρός κατά πάσα πιθανότητα ή θα έπρεπε να γίνει χημειοθεραπεία πριν.
Ψηλαφιτικά εκτός της μασχάλης, ψηλαφιτικά πρώτου χειρουργείου δεν έπιανες κάτι. Ήταν πολύ μικρός, ήταν 5 χιλιοστά σε μέγεθος.
Ωραία, όχι, συμβαίνει. Συμβαίνει.
Είναι ένα από τα προβλήματα δυστυχώς μετά από θεραπεία.
Ωραία, σας ευχαριστούμε πολύ. Συνεχίζετε με τη δεύτερη. Θέλετε κάτι να ρωτήσετε για την πρώτη?
Θα συνεχίσει ο κύριος Νταλαπέρας και μετά.
Ωραία. Ο κύριος Νταλαπέρας, λοιπόν, από το ίδιο τμήμα του Ερυθρού Σταυρού. Ο κύριος Νταλαπέρας θα μας μιλήσει για τον καρκίνο του μαστού στους άντρες.
Γεια σας, καλημέρα σας. Ονομάζομαι Νταλαπέρας Κωνσταντίνος και είμαι ειδικευόμενος και εγώ στη Β' Χειρουργική Κλινική. Αρχικά θα ήθελα να ευχαριστήσω την Οργανωτική Επιτροπή για την ευκαιρία να συμμετάσχουμε στο συνέδριο. Σήμερα θα σας παρουσιάσω την εμπειρία της κλινικής μας όσον αφορά τη διάγνωση και τη διαχείριση του καρκίνου του μαστού στους άντρες. Ο καρκίνος του μαστού στους άντρες είναι ένα σπάνιο νόσημα, λιγότερο από 1% των καρκίνων του μαστού παγκοσμίως. με lifetime risk 1 στους 1000 για τους άντρες και 1 στους 8 για τις γυναίκες. Η επίπτωση της νόσου τώρα αυξάνεται με την ηλικία, με οικογενειακό ιστορικό θετικό για καρκίνο του μαστού, έκθεση στην ακτινοβολία, με φορείς γενετικής προδιαθεσικής μετάλλαξης, BRCA1, 2, CHEK2, PALB2. Ειδικά χαρακτηριστικά τώρα της νόσου, NST στο 90% τον καρκίνο του μαστού στους άντρες, DCS αντιστοιχεί στο 5 με 7%, ενώ AR θετικά στο 90% των περιστατικών και PR θετικά στο 81% των περιστατικών. Οι περισσότεροι ασθενείς τώρα θα έρθουν λόγω ανώδυνης ψηλαφιτής μάζας. Άλλοι ασθενείς θα έρχονται με έγκριμα θηλής, δερματικές αλλοιώσεις, εσωτερική θηλής, λεμφαδενική διόγκωση. Η μάζα συνήθως εντοπίζεται έκεντρα και όχι στο άνω εξωδαρτημόριο όπως στις γυναίκες. Διαφορετική διάγνωση πρέπει να είναι η γυναικομαστία. Συνήθως είναι TAV2 όγκοι με μέσο μέγεθος στα 42,8 χιλιοστά, ενώ υπάρχει αυξημένη πιθανότητα μετάστασης με πιο συχνή τα οστά κατά τη διάγνωση. Όσον αφορά την αντιμετώπιση τώρα, υπάρχουν περιορισμένα δεδομένα και βασίζεται σε μελέτες για το γυναικείο πληθυσμό. Οι χειρουργικές τεχνικές περιλαμβάνουν την τροποποιημένη ειδική μαστεκτομή στο 70% των περιστατικών, την απλή μαστεκτομή σε όγκους TAF1 και TAF2, την ογκεκτομή σε 1 με 13% των περιστατικών, ενώ ακολουθεί λεμφαδενικός καθαρισμός ή βιοψία φλουρού λεμφαδένα, καθώς το 50% των ασθενών θα έχουν θετικούς λεμφαδένες. Επικουρικά χορηγείται ακτινοθεραπεία σε ογκεκτομή, σε όγκους TAF3 και πάνω, επιθετικών ορίων ή όταν έχουμε 4 θετικούς λεμφαδένες. Και επικουρικά ορμονοθεραπεία με πιο σύνθεση τιμοξιφένη για 5 χρόνια ή την κλασική χημειοθεραπεία. Τώρα, νεότερα δεδομένα που έχουν από κλινικές μελέτες όσον αφορά το γυναικείο πληθυσμό, αλλά θεωρείται ότι μπορεί να έχουν εφαρμογή και στους άντρες, με 3 από τις οποίες είναι η CreateX, η Monarch και η Keynote 522. Ο σκοπός της εργασίας μας είναι η παρουσίαση της εμπειρίας 10 ετών της μονάδας Μαστού από τη διαχείριση των 13 περιστατικών, η καταγραφή και η επισήμανση των ιδιαιτεροτήτων της νόσου, καθώς και η πιθανή ενσωμάτωση των νεότερων δεδομένων στην αντιμετώπιση του καρκίνου του μαστού στους άντρες. Μελετήσαμε το χρονικό διάστημα 2013-2023, όπου συνολικά αντιμετωπίστηκαν 13 ασθενείς, που αποτελεί το 1,85% των ασθενών με καρκίνο μαστού της μονάδας μαστού μας, με μέση ηλικία τα 69,9 έτη. Η πλειοψηφία ήρθε λόγω ψηλαφιτής αλλίωσης και έγινε καταγραφή και ανάλυση των χαρακτηριστικών των ασθενών, των χαρακτηριστικών του όγκου, καθώς και της έκβασης. Στα αποτελέσματα τώρα, NST ήταν το 77% των όγκων, Grade 2 50%, ER θετικά το 92%, HER2 θετικά ήταν το 27%, ενώ HER2 low ήταν το 50%. Το 80% των όγκων ήταν luminal B. Ένας ασθενής είχε ER πλην PR πλην HER2 θετικό TAF1 μη 0 όγκο, ενώ στο 30% είχαμε κλινικά θετικούς λεμφαδένες, συνολικά βρέθηκε ότι στο 75% των ασθενών θα έχουμε λεμφαδένες θετικούς. Ένας ασθενής είχε λοβιακό καρκίνο, ενώ 2 είχαν in situ νόσο, DCS και EPC. Συνολικά είχαμε 6 θανάτους, 3 σχετιζόμενους με τον καρκίνο του μαστού, με διάμεσο περίοδο παρακολούθησης του 43 μήνες. Από τους 3 αυτούς ασθενείς, οι 2 είχαν τοπική και συστηματική υποτροπή, ενώ ένας είχε μόνο συστηματική υποτροπή. Με disease-free survival τους 48 μήνες και διάμεση overall survival τους 68 μήνες. Για τους υπόλοιπους ασθενείς τώρα, το 85% αυτών παραμένει ελεύθερου νόσου με διάμεση παρακολούθηση τους 22,14 μήνες, ενώ οι 2 ασθενείς με το in situ νόσο αντιμετωπίστηκαν με χειρουργείο διατήρησης του μαστού, συν ακτινοθεραπεία, συν ορμονοθεραπεία. Ο ασθενής με το λοβιακό και TAF3 νη 1 μη 0 νόσο υπευλήθη σε νεοπικουρική θεραπεία, σε τροποποιημένη ριζική μαστεκτομή, συν λεμφαδένα φλουρό που ήταν θετικό, συν λεμφαδενικό καθαρισμό και επικουρικά ακτινοθεραπεία και ορμονοθεραπεία. Ο συγκεκριμένος ασθενής τώρα παρουσίασε τοπική υποτροπή στο δέρμα σε 38 μήνες και διενεργήθη τοπική εκτομή και χορήγησε αναστελών CDK4/6. Κλείνοντας τώρα, η διάγνωση και αντιμετώπιση του καρκίνου του μαστού στους άντρες παραμένει ένα ιδιαίτερο θέμα λόγω της χρονικής καθυστέρησης στη διάγνωση, της έλλειψης εξειδικευμένων κατευθυντηρίων οδηγιών. Η διατήρηση του μαστού μπορεί να προσφερθεί σαν χειρουργείο εκλογής σε ορισμένους ασθενείς και πρέπει να μελετηθεί η αποτελεσματικότητα των νέων θεραπευτικών παραγόντων. Και κλείνοντας, σημαντική είναι η δημιουργία μιας πολυκεντρικής βάσης δεδομένων για άνδρες με καρκίνο του μαστού. Σας ευχαριστώ.
Συγχαρητήρια, ευχαριστούμε πάρα πολύ. Υπάρχει κάποια ερώτηση? Ναι.
Στην παρουσίαση σχεδόν θετική καταπληκτική ότι στα θετικά όρια, στο
Τι είπατε? Είπα ότι ακτινοβολία όταν είχαμε στα θετικά όρια εκτομής. Ρωτήσετε αν δεν άκουσα.
Αν ακτινοβολείτε. Τα
Κοιτάξτε, τώρα κανονικά θα μπορούσε να έχει γίνει μια επανεπάμβαση, αλλά να ζητώ στη διεθνή βιβλιογραφία βρήκα ότι σε αγγεκτομή με θετικά όρια, παράδειγμα, ότι μπορεί να γίνει ακτινοβολία.
Κατά πάσα πιθανότητα συζητάνε μάλλον για τη βιοψία που έγινε η διάγνωση και τα όρια είναι θετικά και προφανώς μετά τη χημειοθεραπεία δεν υπήρξε επανεπέμβαση, υπήρξε θάνατος. Σαν μήνυμα είναι λάθος. Ναι. Δεν αφήνουμε χειρουργικά όρια εκτομής και ευχαριστούμε για την επισήμανση.
Ναι, κύριε Καριδάκη.
Κοιτάξτε, ουσιαστικά διενεργήθη στα περιστατικά που είχαν in situ καρκίνο. Όχι σε ασθενείς με διαγνωσμένη κακοήθεια προεγχειρητικά. Ναι.
Δεν είναι και ο κύριος Λανίτης, οπότε ας μην επιμείνουμε πολύ στις ερωτήσεις. Ναι.
Κοιτάξτε, το δείγμα τώρα είναι πολύ μικρό, είναι 13 ασθενείς, δεν έχει γίνει διαγωνιδιακός έλεγχος σε κάποιον από αυτούς.
Εμένα θα μου επιτρέψετε να πω ότι άντρας με καρκίνο του μαστού είναι εξορισμού μπρακαθετικό. Τώρα πια βέβαια το επιβεβαιώνουμε και γονιδιακά. Σωστά. Και πέρα κάνουμε και την υπόλοιπη διερεύνηση για τα υπόλοιπα συστήματα. Θα καλέσουμε τον κύριο Λαϊνά, γιατί με μαεστρία σας άφησε αυτή την ομιλία για να σας τριμούξουμε. Οπότε ο κύριος Λαϊνάς ας έρθει για την τρίτη ομιλία. Η τρίτη ομιλία για την ανοσοθεραπεία στην καταπολέμηση του HER2. Του HER2 αρνητικού. Κύριος Λαϊνάς.
Γεια σας πάλι. Η ανακοίνωση αυτή έχει να κάνει με τη κλινική εφαρμογή των δεδομένων της Keynote 522 και 756 για την καταπολέμηση του HER2 αρνητικού καρκίνου του μαστού. Δεν υπάρχει κάποια σύγκρουση συμφερόντων. Μ' αρέσει καμιά φορά να ξεκινάω τις παρουσιάζουμε αυτή τη διαφάνεια που δείχνει την ιστορία της αντιμετώπισης του καρκίνου του μαστού, ξεκινώντας από τη μαστεκτομή του Halsted, και σιγά σιγά πώς προχωρήσαμε σε λιγότερο επεμβατικές, λιγότερο παρεμβατικές μεθόδους, αυξάνοντας παράλληλα, βελτιώνοντας βασικά την έκβαση των ασθενών μας. Για μεγάλο διάστημα, το όπλο που μας επέτρεψε να ρίξουμε, να γίνουμε λιγότερο επεμβατικοί ήταν η ακτινοθεραπεία. Συνέχεια προσθέθηκε η συστηματική θεραπεία και πλέον είμαστε στην εποχή της εξατομικευμένης ιατρικής, της προεγχειρητικής συστηματικής θεραπείας, της ανοσοθεραπείας. Και η αλήθεια είναι ότι όλο και περισσότερες ασθενείς υποβάλλονται σε προεγχειρητική συστηματική θεραπεία με σκοπό να προσφέρουμε περισσότερες επεμβάσεις διατήρησης του μαστού, ενώ να έχουμε καλύτερη έκβαση για ασθενείς που επιτυγχάνουν PCR, που αποδεδειγμένα οι ασθενείς που επιτυγχάνουν PCR έχουν καλύτερη έκβαση. Όσον αφορά τώρα τον HER2 αρνητικό καρκίνο του μαστού, έχουμε καταρχάς την Keynote 522 από το 2020, η οποία ασχολείται με TAF1C, NI1-2 ή TAF2 έως 4, NI0-2, triple negative καρκίνους του μαστού, στον οποίο την προεγχειρητική θεραπεία προσθέθηκε pembrolizumab. Είχε πολύ ενθαρρυντικά δεδομένα, με αύξηση του PCR από το 51,2% στο 64,8%, αύξηση του disease-free survival στους 18 μήνες από το 85% στο 91%, με βέβαια 5% περισσότερες ανεπιθύμητες ενέργειες και μια πολύ μικρή αύξηση της θνητότητας. Πλέον, υπάρχει η Keynote 756 από το 2023, όπου προστίθεται το pembrolizumab σε τοπικά προχωρημένους πολύ επιθετικούς ή αρθετικούς HER2 αρνητικούς όγκους. Έχουμε και εδώ βελτίωση στο PCR, το οποίο βέβαια παραμένει αρκετά χαμηλό, πήγε από το 15% στο 24,3%, το γνωρίζουμε αυτό. 6% περισσότερες ανεπιθύμητες ενέργειες, ενώ υπήρξε και ένας θάνατος στον πληθυσμό της μελέτης. Ο σκοπός της εργασίας μας είναι να εκτιμηθεί πόσα περιστατικά επηρεάζονται θεωρητικά από την προσθήκη ανοσοθεραπεία στην αγωγή τους. Χρησιμοποιήσαμε λοιπόν την προοπτικά συμπληρωμένη βάση δεδομένων της κλινικής μας με 724 περιστατικά για να κάνουμε μια αναδρομική μελέτη. Αυτά είναι τα στοιχεία του δείγματός μας, με μία μέση ηλικία στα 62 έτη, ένα μέσο μέγεθος του διαιτητικού στοιχείου στα 23 χιλιοστά. Το 21,5% των ασθενών είχε κλινικά θετική μασχάλη, ενώ τελικά μετά και το χειρουργείο 41,5% βρέθηκαν θετικοί λεμφαδένες στη μασχάλη. Υπάρχει μια υπεροχή στα luminal B. Η πλειοψηφία των ασθενών προφανώς έχουν NST, ενώ το 30% των ασθενών πήρε προηγητική θεραπεία. Το 11,5% των ασθενών ήταν triple negative. Από αυτούς, πολύ μεγάλο ποσοστό, το 86,5% πληρούσε τα κριτήρια της Keynote 522. Αυτές οι ασθενείς είχαν ένα μέσο όρο ηλικίας στα 60 έτη, στο 56% αρνητικούς λεμφαδένες, ενώ οι υπόλοιπες είχαν 1, 2 ή 3 και παραπάνω. Μια υπεροχή του grade 3 στο 78,7%, ενώ το μέσο μέγεθος του διαιτητικού στοιχείου 24,5 χιλιοστά. Παρότι το 60% των περιστατικών είναι ή αρθετικά, HER2 αρνητικά, μόνο ένα 5,4% έχει επαρκώς επιθετικούς grade 3 όγκους, οι οποίοι να μπορούν να ωφεληθούν, να μπορούν να πάρουν pembrolizumab στην προχειρητική θεραπεία τους. Οι ασθενείς αυτές είχαν μικρότερη ηλικία από τις άλλες, ήταν στα 54 έτη, με ένα θετικό λεμφαδένο στο 57%, 3 ή πάνω από 3 οι υπόλοιπες. Δεν είχαμε ασθενείς με 2 θετικούς λεμφαδένες για κάποιο λόγο, ενώ το μέγεθος διαιτητικού στοιχείων στο 34,4 χιλιοστά. Συμπερασματικά, γνωρίζουμε ότι το 25 με 35% των περιστατικών χρήζει επίσημα, βάσει κατευθυντήριων γραμμών, προεγχειρητικής χημειοθεραπείας ή συστηματικής θεραπείας. Και η προσθήκη της ανοσοθεραπείας σίγουρα μπορεί να βελτιώσει την έκβαση σε πολύ μεγάλο ποσοστό των τριπλά αρνητικών καρκίνων. Όμως, για τους ER θετικούς, HER2 αρνητικούς όγκους, μόνο ένα πολύ μικρό ποσοστό ωφελείται από την προσθήκη του pembrolizumab και σίγουρα πρέπει να γίνουν περισσότερες έρευνες για να δούμε τι άλλο μπορούμε να δώσουμε και πώς μπορούμε να βελτιώσουμε και άλλο την έκβαση των ασθενών αυτών. Σας ευχαριστώ πολύ.
Όπως ξεκίνησαν οι ομιλίες, ξεκινήσαμε με μια ανοσοθεραπεία. Η ανοσοθεραπεία πιθανώς είναι η λύση στα προβλήματά μας. Απλά δεν ξέρουμε ποιο είναι υποδοχέα και με ποιον τρόπο να το
υποδοχέα, αν θα είναι αντίσωμα, αν θα είναι μικρομοριακός ανοστολέας, τι θα...
Στα triple negative και με γονιδιακή, με μπράκα θετικό, έχουν δώσει πολύ καλά αποτελέσματα οι ανοσοθεραπείες. Έχετε να ρωτήσετε κάτι, θέλετε να συζητήσουμε κάτι παραπάνω? Ωραία. Επομένως, ας προχωρήσουμε.
Ευχαριστώ.
Προχωρήσουμε στον κύριο Μουστάκη.
Είναι ο κύριος Μουστάκης, είναι από το Ναυτικό Νοσοκομείο. Ιδιαιτής εμπειρία σε αποκατάσταση με ελεύθερο κρυμνό DEP.
Καλημέρα, αξιότιμο Προεδρείο. Ευχαριστώ πάρα πολύ για την δυνατότητα που μας δίνετε να παρουσιάσουμε τα περιστατικά μας κατά την τελευταία διετία. Για όσους δεν γνωρίζουν, ονομάζομαι Μουστάκης Νικόλαος. Είμαι πλαστικός χειρουργός, επιμελητής της Πλαστικής Χειρουργικής Κλινικής του Ναυτικού Νοσοκομείου Αθηνών, όπου μαζί με τον Διευθυντή Δημήτρη Λαουλάκο τα τελευταία 2 χρόνια κάνουμε μια προσπάθεια μαζί με τους συνεργάτες χειρουργούς Μαστού να προσφέρουμε μια επιπλέον επιλογή στην αποκατάσταση Μαστού με αποκατάσταση με ελεύθερο κρυμνό και δι με DEP. Και ο σκοπός της παρουσίασής μας είναι να παρουσιάσουμε περιστατικά τα οποία για διάφορους λόγους οδηγήθηκαν στο να ακολουθήσουν αυτή τη μέθοδο. Η αποκατάσταση Μαστού είναι κάτι πρωταρχικό για την ποιότητα ζωής μιας ασθενούς. Αφού ολοκληρώσει την ογκολογική της θεραπεία, η μικροχειρουργική έφερε μια επανάσταση στην αποκατάσταση του μαστού, καθώς από το Reconstructive Ladder περάσαμε στο Reconstructive Elevator, συγκεκριμένα για το DEP Flap, η αυτόλογη μεταφορά του δέρματος και λίπους από την κοιλιακή χώρα με διατήρηση των κοιλιακών μειών και αναστόμωση στα αγκία της έσωμαστικής και των θωρακοραχείων, δίνει μια δυνατότητα επιπλέον για φυσικά αποτελέσματα και αποτελέσματα διαρκούν στον χρόνο. Περιγράφει το 89 από τον Κωσίμα και έχει μια καμπύλη εκμάθησης. Τα πλεονεκτήματα του DEP σε ασθενείς που έχουν προηγηθεί ακτινοθεραπεία, σε ασθενείς που για διάφορους λόγους δεν ανέχτηκαν ή απέρριψαν το ένθεμα, ασθενείς που επιθυμούν αμφωτερόπλευρη αποκατάσταση και ασθενείς με ανατομικές ιδιαιτερότητες, όπως παραδείγματος χάρη σε σύνδρομο Πόλαντ. Πού μπαίνει η μικροχειρουργική αποκατάσταση? Μελέτες μεγάλων κέντρων όπως ο Κορντέιρο το 2014 στο PRS που δημοσίευσε ή ο Ιμπραήμ στο Harvard το 2016, δείχνουν και οι δύο για τις επιπλοκές, το υψηλό ποσοστό επιπλοκών που εμφανίζονται στην Alloplastic Reconstruction όταν υπάρχει ακτινοβολία ή κάπνισμα. Έτσι, που φτάνει το 40-60%. Αυτό σημαίνει ότι άνθρωποι που έχουν υποβληθεί σε ακτινοθεραπεία ή καπνίζουν, είναι ένα flip of coin. Δηλαδή, ρίχνεις μια ζαριά και ελπίζεις να πάει καλά η υποκατάσταση πολλές φορές, ενώ τα προβλήματα είναι μπροστά σου. Ο σκοπός λοιπόν ενός κέντρου Μαστού είναι να συζητάει αυτά τα περιστατικά και ενίοτε να οδηγεί τον ασθενή ή να τον συμβουλεύει προς τη σωστή θεραπεία, εφόσον διαθέτει όλες τις δυνατότητες και όλες τις επιλογές. Και αυτό πρέπει να ενθαρρύνεται. Θα παρουσιάσουμε κάποια περιστατικά από το Ναυτικό Νοσοκομείο και από άλλα νοσοκομεία της Αθήνας. Πρώτο περιστατικό είναι μια 43χρονη ασθενής, η οποία είχε αριστερή διαιτητικό προγενή καρκίνο, μη καπνίστρια, αριστερή μαστεκτομή, λεφαδενικός καθαρισμός, ακτινοβολία. Μπήκε διατατήρας. Ο διατατήρας μπήκε και έγινε ακτινοβολία εκ των υστέρων. Η διάταση, όπως βλέπετε, η διάταση δεν είναι ποτέ optimal και με τακτινικές αλλοιώσεις του δέρματος που κάνουν κάψουλα contracture. Και βλέπετε το θώρακα πώς έχει συμπιεστεί προς τα μέσα. Η εικόνα είναι τέτοια. Είναι ένα ρίσκο να κάνεις αποκατάσταση με ένθεμα στο δεύτερο στάδιο. Συζητήσαμε με την ασθενή σε ένα ογκολογικό συμβούλιο εκ νέου και αποφάνθη να κάνει αποκατάσταση με ελεύθερο κρυμνό. Σχεδιασμός. Αναστόμωση. Συνήθως κάνουμε 8-9-0 νάιλον για το εναρτήρια, κάπλερ για τη φλέβα. Αποκατάσταση σε δεύτερο χρόνο. Η γυναίκα αυτή πριν από 2 εβδομάδες με ενημέρωσε ότι έκανε το πρώτο της παιδάκι και χαίρομαι ιδιαίτερα γι' αυτό. Δεύτερο περιστατικό, ακτινοβολία, επιμόλυνση τραύματος. 45χρονη ασθενής, αριστερή μαστεκτομή, λεφαδενικός καθαρισμός, χημειοθεραπεία, ακτινοβολία, σε προσπάθειες να γίνει nipple sparing μαστεκτομή, 2-stage reconstruction, επιμολύνθηκε το ένθεμα στο δεύτερο στάδιο και αναγκάστηκε να αφαιρεθεί. Αυτή είναι η εικόνα της όταν συζητήθηκε με εμάς. Αποκατάσταση με ελεύθερο κρυμνό με DIEP. Εδώ να τονίσουμε το εξής. Το κάπνισμα είναι σχετική αντένδειξη και για τον ελεύθερο κρυμνό. Παρ' όλα αυτά, οι επιπλοκές που μπορεί να εμφανιστούν είναι περισσότερο διαχειρίσιμες, κατά τη γνώμη την ταπεινή τη δική μου, σε σχέση με όταν μπαίνουν σε μια διαδικασία, μια alloplastic reconstruction. Επόμενο περιστατικό, μια κυρία 47 ετών, μαστεκτομή. SNMB αρνητικό. Μπήκε διατατήρας. Μετά από αφαίρεση DCIS. Δυστυχώς, και ενώ είχε αρχίσει η διάτασή της, η ιστολογική έδειξε ότι τα όρια ήταν θετικά. Αποφασίσαμε από κοινού να αφαιρέσουμε το διατατήρα, να γίνει re-excision. Τα όρια ήταν καθαρά, δεν χρειάστηκε περαιτέρω θεραπεία. Και σε αυτή τη γυναίκα η αλήθεια είναι ότι θα ήθελα την γνώμη και των συναδέλφων όσον αφορά το re-excision για τη θεραπεία εκ των υστέρων. Έγινε breast reconstruction με DIEP. Τέταρτο περιστατικό, 51 ετών ασθενής, αμφωτερόπλευρη. Αρνητικός λεφαδένας φρουρός. Εργαζόμενη γυναίκα. Μένει εκτός Αθήνας. Δεν ήθελε αποκατάσταση με ενθέματα. Ήταν επιλογή της. Δεν ήθελε γιατί ήθελε να γυρίσει στη δουλειά. Ήθελε αποκατάσταση το συντομότερο να γυρίσει πίσω. Δεν ήθελε φουσκώματα και διατάσεις. Αμφωτερόπλευρη αποκατάσταση. Εδώ είχαμε μια διαχειριστική, ένα challenge όπου η έσω-μαστική φλέβα αριστερά ήταν μικρότερη στη διάμετρο. Κάναμε μετάθεση της κεφαλικής φλέβας. Συνολικός χρόνος 10 ώρες. Εδώ έχει σημασία να τονίσουμε ότι εμείς τουλάχιστον στο Ναυτικό Νοσοκομείο προσπαθούμε να είμαστε two-team approach, 2 ειδικοί, 2 senior εκπαιδευόμενοι, όπως μάθαμε και εμείς άλλωστε, προκειμένου να μειώσουμε το χειρουργικό χρόνο και να είμαστε ανταγωνιστικοί γενικώς. Σημειωτένω ότι οι 10 ώρες του χειρουργείου συνολικά ήταν και με ένα μικρό αιμάτωμα το οποίο παρατηρήθηκε διαχειριτικά και παροχητεύτηκε επί του χειρουργείου. Εδώ είναι τα αποτελέσματα μετά, με την αποκατάσταση της στήλης. Τελευταίο περιστατικό, μια 66χρονη καπνίστρια, μαστεκτομή, SNMB αρνητικό, ιστορικό με πολλές αλλεργίες. Κάποια στιγμή είχε γίνει κάποια προσπάθεια για αποκατάσταση με διατατήρα, δεν μπορούσε να το ανεχτεί. Και προσφέραμε την επιλογή της αποκατάστασης με ελεύθερο κρυμνό, με DIEP. Αυτό που σας είπα για τη two-team approach, πάντα 2 ειδικοί, στην προσπάθειά μας να βελτιώσουμε να μειώσουμε τη δυνατότητα λαθών, να βελτιώσουμε τους χρόνους μας, να ανταγωνιστούμε τους χειρουργικούς χρόνους μιας συμβατικής αποκατάστασης, σε εισαγωγικά συμβατικής. Συμπερασματικά, είναι ένα εργαλείο που πρέπει να το έχει κάθε κέντρο μαστού. Πρέπει να το ενθαρρύνουμε. Δίνει λύσεις και είναι καλό αυτό να το συζητάμε και πριν καν ξεκινήσουμε την ογκολογική χειρουργική θεραπεία. Είναι προτιμότερο να δώσουμε μια λύση πριν παρά να την δώσουμε μετά. Και βέβαια σε αυτό η κλειδί είναι η συνεργασία μεταξύ των χειρουργών μαστού και των πλαστικών χειρουργών και των υπόλοιπων ειδικοτήτων. Ευχαριστώ πάρα πολύ.
Θέλετε να ρωτήσετε κάτι? Να συνεχίσουμε λοιπόν στην επόμενη ομιλία, η οποία έρχεται από πολλά νοσοκομεία ταυτόχρονα. Είναι από τον κύριο Αντωνόπουλο, ο Μάρκος ο Αντωνόπουλος, ο οποίος αυτή τη στιγμή βρίσκεται στην Αγγλία, στο Σεντ Τόμας. Καλή επιτυχία.
Καλημέρα και από μένα. Ευχαριστώ πολύ την Οργανωτική και Επιστημονική Επιτροπή για την αποδοχή της εργασίας μας. Σήμερα θα σας μιλήσω για την εμπειρία μας με τη χρήση του σχεδιασμού Double Buttwing σε μαστεκτομή και άμεση αποκατάσταση, είτε με ένθεμα είτε με DEP κρυμνό, προκειμένου να επιτευχθεί μείωση δέρματος και επανατοποθέτηση του συμπλέγματος στη λύση άσαλο. Αρχικά, να αναφέρω πως, όπως γνωρίζουμε, διάφορες τεχνικές έχουν προταθεί στο παρελθόν για μαστεκτομή και μείωση δέρματος με ανόρθωση μαστών. Οι περισσότερες όμως αναφέρουν τη χρήση διατατήρων με κατά συνέπεια απέτηση για επανεπέμβαση για αλλαγή σε μόνιμο ένθεμα. Και άλλες τεχνικές για άμεση αποκατάσταση με ένθεμα και πλέγμα έχουν αναφέρει υψηλά ποσοστά στη βιβλιογραφία έως και 18% νέκρωσης του συμπλέγματος στη λύση άσαλο. Να αναφέρω πως ο σχεδιασμός και η τεχνική που θα περιγράψω έχει περιγραφεί από τον κύριο Κοντό το 2020, ο οποίος τη χρησιμοποίησε με ADM και Tissue Expander. Εδώ είναι και το άρθρο του στο PRAS. Ο σχεδιασμός που χρησιμοποιείται είναι όπως βλέπετε και όπως βλέπετε και στην εικόνα. Αρχικά σχεδιάζονται δύο ημικύκλια, τα οποία θα αντιπροσωπεύουν τη νέα θέση της στηλής στη άσαλο. Η μέτρηση της ακτίνας γίνεται ανάλογα εξαρτάται από την ασθενή, είναι από 4 έως 5 εκατοστά. Τα σημεία D, C που είναι τα δύο άκρα αντιπροσωπεύουν τα όρια του εντυπώματος του μαστού στο θωρακικό τείχομα. Όλη η περιοχή που βλέπετε που είναι μαρκαρισμένη στην εικόνα C είναι η περιοχή που θα γίνει η αποεπιθυλιοποίηση του δέρματος και η διακεκομένη γραμμή κόκκινη που βλέπετε στην εικόνα κάτω δεξιά είναι η full thickness τομή που θα χρησιμοποιηθεί προκειμένου να γίνει η μαστεκτομή και μετά κατά συνέχεια και η αποκατάσταση. Double Buttwing είναι μια ονομασία που είναι λόγω του σχήματος, προσομοιάζει μια νυχτερίδα με ανοιχτά τα φτερά της. Η δικιά μας εμπειρία, από τον 8ο του 22 μέχρι το Σεπτέμβριο του 24, 14 ετερόπλευρες και 18 αμφωτερόπλευρες μαστεκτομές διενεργήθησαν με άμεση αποκατάσταση και την προαναφερθήσα τεχνική για ταυτόχρονη διόρθωση των πτωτικών μαστών. Χρησιμοποιήσαμε την μέθοδο αυτή για μαστεκτομή και άμεση αποκατάσταση είτε με ένθεμα σε προθωρακική θέση, είτε με ελεύθερο κρυμνό DEP. Το βάρος της μαστεκτομής κυμάνθηκε από 350 μέχρι 1100 γραμμάρια. Δεν είχαμε καπνιστές στη συγκεκριμένη σειρά. Το εύρος πτώσης μαστού που διορθώθηκε ήταν από 25 μέχρι 32 εκατοστά και ο όγκος των ενθεμάτων που χρησιμοποιήθηκαν ήταν από 400 μέχρι 630 cc. Τα ενθέματα που χρησιμοποιήσαμε ήταν πολυουρεθάνη. Σε κάποια περιστατικά να σημειώσω πως χρησιμοποιήθηκε και ICG κάμερα για να επιβεβαιώσουμε 100% την αιμάτωση της στηλής, σε συνδυασμό με να κρίνουμε και την αιμάτωση του DEP κρυμνού. Και η τομή του ολικού πάχους για την πρόσβαση της μαστεκτομής έγινε στην έξω πλευρά του μαστού και της αποεπιθυλιοποιημένης περιοχής όταν είχαμε περιστατικά που η αποκατάσταση θα γινόταν με ένθεμα, είτε στην έσω μεριά όταν είχαμε περιστατικά που η αποκατάσταση θα γινόταν με DEP για να έχουμε πρόσβαση στα έσω μαστικά αγκία. Η τεχνική, ο σχεδιασμός, όπως προαναφέρθηκα, εδώ είναι ένα περιστατικό με πτώση στα 29 εκατοστά. Βλέπουμε τον προεγχειρητικό σχεδιασμό των δύο ημικυκλίων και όλη η περιοχή η οποία θα γίνει από επιθυλιοποίηση. Διεγχειρητικά, στην εικόνα αριστερά πάνω βλέπετε όλη την αποεπιθυλιοποιημένη περιοχή. Δεξιά βλέπετε, όπως ανέφερα, την full thickness τομή που γίνεται στην αποεπιθυλιοποιημένη περιοχή για την πρόσβαση της μαστεκτομής, όπως βλέπετε στη μεσαία πάνω φωτογραφία. Εδώ το συγκεκριμένο περιστατικό, η αποκατάσταση έγινε με ένθεμα, οπότε η τομή έγινε στην έξω πλευρά της περιοχής. Δεξιά πάνω είναι το αποτέλεσμα μετά από την αμφωτερόπλευρη μαστεκτομή και κάτω βλέπετε την αποκατάσταση όταν έχουν μπει και τα ενθέματα και έχει γίνει η μείωση δέρματος και η ανόρθωση του συμπλέγματος στυλής στηλέας άλο. Άλλο το συγκεκριμένο περιστατικό εδώ είναι άμεσα μετεχειρητικά, λόγω και των παροχητεύσεων που χρησιμοποιήσαμε. Άλλο ένα περιστατικό αμφωτερόπλευρης μαστεκτομής με άμεση αποκατάσταση με ένθεμα σιλικόνης. Η πτώση εδώ ήταν στα 27 εκατοστά. Βλέπετε αριστερά ο προεγχειρητικός σχεδιασμός. Στη μέση διεγχειρητικά η αποεπιθυλιοποιημένη περιοχή. Έχουν μπει και τα sizer. Το sizer στον αριστερό μαστό. Δεξιά δεν έχει γίνει ακόμα αποκατάσταση. Και στη δεξιά φωτογραφία το τελικό άμεσα μετεχειρητικό αποτέλεσμα. Εδώ είναι άμεσα μετεχειρητικά. Άλλο ένα περιστατικό, αμφωτερόπλευρη μαστεκτομή, άμεση αποκατάσταση με ένθεμα σιλικόνης. Η πτώση εδώ ήταν μικρότερη, ήταν στα 25 εκατοστά. Βλέπετε, έχουμε επιτύχει ένα πολύ καλό αισθητικό αποτέλεσμα και στους δύο μαστούς. Και εδώ είναι ένα περιστατικό με αμφωτερόπλευρη μαστεκτομή και άμεση αποκατάσταση με κρυμνό TEP. Η πτώση εδώ ήταν στα 32 εκατοστά. Στον αριστερό μαστό είχαμε καρκίνο, δεξιά έγινε προφυλακτική μαστεκτομή. Άλλο ένα περιστατικό, αμφωτερόπλευρη μαστεκτομή με άμεση αποκατάσταση με ένθεμα σιλικόνης. Αριστερά, τελικά διεγχειρητικά βρέθηκε ότι έπρεπε η θηλή να αφαιρεθεί. Οπότε, δεξιά ήταν προφυλακτική μαστεκτομή. Αριστερά η θηλή αφαιρέθηκε, αλλά ακολουθήθηκε η ίδια τεχνική για να έχουμε συμμετρία στις ουλές. Άλλο ένα περιστατικό, αμφωτερόπλευρη μαστεκτομή, άμεση αποκατάσταση με ένθεμα, προεγχειρητικά και 3 μήνες μετεχειρητικά. Δεξιά μαστεκτομή και άμεση αποκατάσταση με ένθεμα. Εδώ το αναφέρω αυτό το περιστατικό γιατί να σας δείξω ότι ο συγκεκριμένος σχεδιασμός του double batwing μπορεί να χρησιμοποιηθεί και για ανόρθωση μαστού, χωρίς να χρειάζεται να είναι... χωρίς να έχει προηγηθεί μαστεκτομή. Μπορεί να συνδυαστεί με ένα central mount pedicle. Εδώ η πτώση ήταν στα 28 εκατοστά. Και τα αποτελέσματά μας, μείωση δέρματος, ανόρθωση και επανατοποθέτηση του συμπλέγματος στυλής στηλέας άλο επετεύχθη σε αισθητικά ικανοποιητικό σημείο σε όλες τις ασθενείς. Δεν είχαμε απώλεια αποκατάστασης ή ολική νέκρωση ή νέκρωση δέρματος ή νέκρωση του συμπλέγματος στυλής στηλέας άλο. Από τις επιπλοκές μας είχαμε ένα περιστατικό με μετεχειρητικό αιμάτωμα το οποίο χρειάστηκε επανεπέμβαση για εκένωση, ένα περιστατικό ελάσσονος διάσπασης τραύματος το οποίο αντιμετωπίστηκε με χειρουργικό καθαρισμό και πρωτογενή σύγκληση υποτοπική αναισθησία και μια ασθενής η οποία ήταν με BMI παραπάνω του 32. Είχαμε μερική νέκρωση του συμπλέγματος στυλής στηλέας άλο, το οποίο και αυτό αντιμετωπίστηκε με καθαρισμό και πρωτογενή σύγκληση. Εδώ είναι οι επιπλοκές μας. Αριστερά είναι η διάσπαση τραύματος και δεξιά είναι η μερική νέκρωση της θηλαίας άλο. Τα συμπεράσματα, η συγκεκριμένη τεχνική αποτελεί μια ασφαλή και αξιόπιστη τεχνική για μείωση δέρματος, επανατοποθέτηση του συμπλέγματος στυλής στηλέας άλο και στην άμεση αποκατάσταση του μαστού, είτε με χρήση ενθεμάτων ή ελεύθερων κρυμνών που περιγράψαμε εμείς, είτε με χρήση πλεγμάτων και tissue expander που έχει περιγράψει ο κύριος Κοντός. Μπορεί να χρησιμοποιηθεί και για ανόρθωση μαστού σε συνδυασμό με central mount pedicle. Και στα θετικά στοιχεία έχουμε ότι δεν παραβιάζουμε την υπομάστια πτυχή, αποφεύγουμε επιπλοκές τραύματος που, όπως όλοι γνωρίζουμε, που μπορούν να συμβούν στο T-junction, παραμένει ακέραιη στο μεγαλύτερο ποσοστό η αιμάτωση της στυλής, μπορεί να εφαρμοστεί σε μεγάλο εύρος πτώσεων, αλλά στα αρνητικά έχουμε μια μεγάλη περιοχή από επιθυλιοποίησης που, όπως όλοι γνωρίζουμε, κανένας δεν αρέσει να κάνει αποεπιθελιοποίηση. Απαιτεί προσεκτικές προεγχειρητικές μετρήσεις και σχεδιασμό της ασθενούς και το παράθυρο της μαστεκτομής μπορεί να είναι μικρού μήκους, το οποίο μπορεί να είναι λίγο challenge για κάποιους χειρουργούς. Και ευχαριστώ. Αυτή είναι η εμπειρία μας. Ευχαριστώ πολύ.
Σαν παρατήρηση να μείνω στο πρώτο τελευταίο που είπατε, το προεγχειρητικό σχεδιασμό και το υπόλοιπο σωματότυπο της γυναίκας και το πού βρίσκεται ο όγκος, γιατί τα περισσότερα από αυτά τα κάνουμε. Εμείς τουλάχιστον τα κάνουμε για μία νόσο και όχι για το αισθητικό αποτέλεσμα. Είναι πολύ καλό και είναι και μία τομή που σου δίνει πρόσβαση σε όλα τα σημεία του μαστού. Θέλετε κάτι να σχολιάσετε, κάτι να ρωτήσετε? Έχετε πιάσει μάλλον όλες τις κλινικές μας, οπότε δεν έχουμε να σας κάνουμε ερωτήσεις. Κανένας? Όχι. Ναι. Κύριος Καλές. Ναι, όχι. Παρακαλώ, δεν σας είδα.
Κάποια, συγγνώμη. Ναι, αν απλά μπαίνει μέσα. Όχι, το ένθεμα μπαίνει προθωρακικά και στη συγκεκριμένη σειρά μπήκε προθωρακικά. Τα ενθέματα που χρησιμοποιούμε εμείς στα συγκεκριμένα περιστατικά ήταν πολυουρεθάνη, τα οποία έχουν ένα περίβλημα που φανταστείτε το λειτουργεί σαν κριτσ-κράτς. Το βάζεις και κάθεται. Από εκεί και πέρα η θήκη του ενθέματος προσαρμόζεται. Αυτή θα είναι η επόμενη μελέτη μας. Μέχρι ώρας έχουν... Κάποιοι
μπορεί να μην είχαν από πριν το εξτώσεις.
Ναι.
Αλλά ο λόγος να κάνεις αυτό ή να μην κάνεις ένα κάποιο παράδειγμα είναι μόνο η αισθητικότητα. Το οποίο είναι σημαντικό.
Σε μεγαλύτερο ποσοστό διατηρείται μέχρι ένα μέρος. Σε μεγαλύτερο ποσοστό. Έχουμε περιστατικά τα οποία δεν είχαν μετά αισθητικότητα στη θηλή, αλλά θέλουμε να παρατηρήσουμε αν υπάρχει κάποιο συγκεκριμένο ποσοστό ή κάποιο συγκεκριμένο μοτίβο.
Ναι, παρακαλώ.
Ναι.
Αυτό ήταν για λόγους οικονομικούς ή για λόγους πρακτικούς, δηλαδή επίσης χρησιμοποιήθηκε διαχειρητικά ή μεταχειρητικά την άλλη μέρα. Και εν τέλει άξιζε τον κόπο.
Η χρήση της κάμερας, καταρχάς, σε όλες τις περιπτώσεις που χρησιμοποιήθηκε ήταν διαχειρητικά. Κατά κύριο λόγο χρησιμοποιήθηκε και σε περιστατικά που η αποκατάσταση έγινε με κρυμνό DIEP, για να κρίνουμε και την αιμάτωση του κρυμνού, για να ξέρουμε ποιο κομμάτι θα κρατήσουμε και ποιο κομμάτι θα χρειαστεί να φύγει από τις ζώνες, όπως πολύ καλά γνωρίζετε. Στα περιστατικά που χρησιμοποιήθηκε όταν είχαμε αποκατάσταση με ένθεμα σιλικόνης, ήταν τα περιστατικά που είτε το BMI ήταν λίγο παραπάνω, είχαμε κάποια στοιχεία από το ιστορικό της ασθενούς, που θα θέλαμε να επιβεβαιώσουμε 100% ότι η αιμάτωση της στηλής έχει διατηρηθεί. Παρακαλώ.
Ωραία. Ευχαριστούμε πολύ, κυρία Αντωνόπουλε. Συγχαρητήρια. Να καλέσουμε τώρα τον κύριο Λιμπερόπουλο, που είναι και αυτός από το Mild Yorkshire.
Συνεργάζεται με την κλινική του ΙΑΣΟ. Είναι πλαστικός και θα μας μιλήσει για DIEP.
Καλημέρα και από μένα. Ευχαριστώ το Προεδρείο και επίσης να συγχαρώ και την Οργανωτική Επιτροπή, και είναι χαρά μας ως πλαστική χειρουργική να βλέπουμε ότι μιλάμε εδώ πέρα για οτόλογους Reconstruction και το DFLAP. Θα προσπαθήσω να είμαι όσο πιο σύντομος και περιεκτικός. Η πρώτη ερώτηση που πάντα θέλω να απαντήσουμε είναι γιατί χρειαζόμαστε τη μικροχειρουργική στην επανορθωτική μαστού. Και ο λόγος είναι κυρίως γιατί κάποιοι ασθενείς είναι η μόνη επιλογή που έχουν για επανόρθωση, είτε γιατί το ένθεμα έχει αποτύχει, είτε επιθετικούς καρκίνους, οπότε αυτή η επιλογή πρέπει να υπάρχει. Επίσης, είναι μια περιοχή που είναι για εκπαίδευση της μικροχειρουργικής. Ένας άλλος λόγος που αναφέρω στους πλαστικούς χειρουργούς και μερικές φορές δεν τους αρέσει, ζώντας στην Αγγλία, ξέρω ότι κάποια στιγμή στο μέλλον οι πλαστικοί χειρουργοί να μην χρειάζονται για να κάνουν τα ενθέματα. Οπότε ο ρόλος του πλαστικού χειρουργού μέσα σε ένα breast MDT πρέπει να είναι χρήσιμος, πρέπει να έχει να πει κάτι καινούριο για να μπορέσει να βοηθήσει τον ασθενή που έχει καρκίνο του μαστού. Οπότε θα σας μιλήσω τι μάθαμε μετά από 200 κρημνούς στην εμπειρία μου ως consultant και πώς μάθαμε και πώς αλλάξαμε. Πολύ close monitoring, τι κάναμε, τα λάθη μας, τις επιπλοκές μας, αλλά ταυτόχρονα χρησιμοποιήσαμε τη βιβλιογραφία και παρουσιάζαμε πολύ συχνά τα αποτελέσματά μας σε meeting και επίσης πολύ ανοιχτά παίρναμε feedback από συναδέλφους και άλλες ειδικότητες να δούμε πώς μπορούμε να κάνουμε optimize τα results. Και αρχικά βρήκαμε στο πράκτη μας ότι 4 προβλήματα τα οποία θα θέλαμε μπορούμε να τα φτιάξουμε και αυτά τα 4 προβλήματα τα φτιάξαμε με 4 διαφορετικές μελέτες. Το πρώτο που αντιμετωπίσαμε ήταν ότι είχαμε περισσότερα προβλήματα από ό,τι θέλαμε στη δότρια περιοχή. Επίσης, προσπαθήσαμε να τυποποιήσουμε πώς κάνουμε manage την αναλγησία στη δότρια περιοχή. Επίσης, είχαμε προβλήματα με mastectomy skin flap necrosis. Και τέταρτον, θελήσαμε να δούμε πώς μπορούμε να βελτιοποιήσουμε στην επίσκεψη όταν μιλάμε στους ασθενείς για deep reconstruction, ούτως ώστε και αυτοί να το καταλάβουν και να υπάρχει καλύτερη συνένεση μεταξύ μας. Το deep flap reconstruction είναι ένα σχετικά περίπλοκο χειρουργείο και αυτό που λέω είναι ότι δεν είναι μόνο απλά να πάρεις το κρημνό και να το συνδέσεις και ματώθηκε και όλα καλά. Έχει πολλά κομμάτια τα οποία με marginal gains να φτιάξεις μικρά πράγματα θα σου δώσουν καλύτερα αποτελέσματα. Δεν είναι μόνο απλά ο μαστός να αιματωθεί, είναι να μην έχει και άλλα προβλήματα ο ασθενής. Όπως είπαμε, στους πρώτους 120 ασθενείς παρατηρήσαμε ότι είχαμε 12% προβλήματα στη δότρια περιοχή. Και αυτά ήταν φλεγμονές, wound breakdown, καθυστέρηση στην επούλωση και είχαμε και κάποια περιστατικά που έπρεπε να πάνε πίσω στο χειρουργείο. Επίσης, επειδή μέχρι εκείνη τη στιγμή χρησιμοποιούσαμε πλέγματα σχεδόν για όλα τα περιστατικά, έπρεπε να αφαιρέσουμε και 3 πλέγματα. Βρήκαμε ότι το υψηλό BMI και ασθενείς που είχαν bilateral procedure ήταν αυτοί που ήταν σε υψηλότερο ρίσκο. Τι κάναμε, κοιτάξαμε στην υπόλοιπη Αγγλία, κάναμε μια μελέτη να δούμε οι υπόλοιποι τι κάνουν. Και βρήκαμε ότι σε όλη τη χώρα δεν υπάρχει ομοιογένεια. Άλλοι χρησιμοποιούν MES, άλλοι δεν χρησιμοποιούν, οπότε ουσιαστικά κανείς δεν είναι σίγουρος τι κάνει. Η απάντησή μας σε αυτό το πρόβλημα ήταν να μειώσουμε το BMI, να έχουμε ένα όριο 30 για τα delayed reconstruction και 32 για τα immediate. Επίσης, αρχίσαμε να πλένουμε την κοιλιά για να φύγει οποιοδήποτε λίπος υπάρχει που αργότερα μπορεί να χρησιμοποιεί να κάνει fat necrosis και μόλυνση. Πλέον χρησιμοποιούμε πολύ σπάνια πλέγμα και όταν χρειαστεί να το χρησιμοποιήσουμε το διαχειριζόμαστε σαν ένθεμα, δηλαδή με αντιβιωτικά, αλλάζουμε γάντια και betadine wash. Αυτό μείωσε τις επιλογές σε λιγότερο από 2% και πλέον δεν είχαμε κανένα ασθενή που να γυρίζει πίσω στο χειρουργείο. Δεύτερο κλινικό πρόβλημα ήταν πώς διαχειριζόμαστε τον πόνο μετά το χειρουργείο. Ο πόνος σε αυτούς τους ασθενείς μετά το χειρουργείο είναι κρίσιμος για να μπορούν να κοινοτοποιηθούν και να πάνε γρήγορα σπίτι. Ο μέσος αριθμός ημερών που μέναν ήταν 2,4 μέρες και οι επιλογές που είχαμε για τη διαχείριση του πόνου ήταν 1 ή απλά με μπλοκ τοπικά στην κοιλιά, 2 ή με μπλοκ με βοήθεια των αναισιολόγων με χρήση υπερήχων ή με high volume local anesthetic, ουσιαστικά να κάνουμε dilute όσο τοπική αναισθησία μπορούμε και να το βάλουμε σε μεγάλη περιοχή. Πάλι κοιτάξαμε τι κάνει η υπόλοιπη χώρα και πάλι υπήρχε ένα χάος. Διαφορετικοί άνθρωποι κάνανε διαφορετικά πράγματα και ακόμα πάρα πολλοί χρησιμοποιούσαν ενδοφλέβια, μορφίνη και PCA. Κοιτώντας πώς επηρεάζει ο πόνος στο να πάει ο ασθενής σπίτι, βρήκαμε ότι η χρήση περίχων και το στοχευμένο local anesthetic είχε τα καλύτερα αποτελέσματα και ο συνδυασμός ακόμα καλύτερα. Οπότε αυτό που βρήκαμε εμείς έκανε μεγάλη διαφορά είναι παρότι ότι χρησιμοποιείται στο υπέρηχους ο ασθενής παίρνει το καλύτερο αποτέλεσμα, αλλά χρειάζεται και μια εκπαίδευση από τον νοσιολόγο, αλλά το πιο ασφαλές ίσως είναι όσο περισσότερο local anesthetic σε μεγαλύτερο volume, στη μεγαλύτερη περιοχή για να μπορέσει ο ασθενής να πάει γρήγορα σπίτι. Επίσης, να αποφεύγουμε όσο μπορούμε την ενδοφλέβια μορφίνη. Τρίτο πρόβλημα το οποίο κοιτάξαμε να φτιάξουμε ήταν το mastectomy skin flap necrosis. Όλοι ξέρετε τις συνέπειες και τα προβλήματα, αλλά το πιο σημαντικό είναι όταν έχεις ένα τέτοιο πρόβλημα μπορεί να καθυστερήσει το adjuvant therapy. Κοιτώντας τα δεδομένα, τη βιβλιογραφία και επίσης τη τεχνολογία που μπορεί να μας βοηθήσει, βρήκαμε ότι όταν χρησιμοποιήσαμε wise pattern μαστεκτομή, αυτό είχε τα περισσότερα προβλήματα. Σχετίζεται με ποιον χειρουργό μαστού δουλεύεις μαζί. Το BMI πάλι ήταν risk factor, αλλά και επίσης πόσο μεγάλο ήταν το dissection. Και αυτό που κάναμε είναι αρχίσαμε να αλλάζουμε πώς κάνουμε τις μαστεκτομές. Η πρώτη επιλογή είναι η πιο εύκολη, άμα έχεις λίγο πτωτικό μαστό θα κάνεις στρογγυλή, αλλά η δεύτερη επιλογή για να αποφύγουμε το wise pattern πρέπει να κάνουμε μία έλλειψη και στο τέλος του χειρουργείου με ένα nipple marker κάνουμε μία τρύπα για να βγει το skin paddle. Επίσης χρησιμοποίησαμε το ICG και εμείς για να είμαστε πιο ακριβοί με την αιμάτωση και αυτό που βρήκαμε είναι ότι η ICG κάμερα είναι πολύ ακριβής. Και αυτό ουσιαστικά μείωσε από 19% που είχαμε το mastectomy skill flap necrosis στο 2%. Και αυτά ήταν 3 κλινικά προβλήματα, τα οποία με 3 μελέτες φτιάξαμε. Και τέλος, το τέταρτο ήταν, και ίσως και πιο βασικό, είναι πώς μπορούσαμε να κάνουμε τυποποίηση της επίσκεψης. Γιατί ο ασθενής να καταλάβει τι σημαίνει DF flap, τι σημαίνει αυτόλογο reconstruction. Και δημιουργήσαμε ένα βίντεο 9 λεπτά χρησιμοποιώντας εμάς ως animation που ταξιδεύει τον ασθενή σε όλο το ταξίδι. Και αυτό ήταν πολύ σημαντικό να είναι ένας εύκολος τρόπος και να το χρησιμοποιήσουν και οι χειρουργοί μαστού, αλλά και επίσης να είναι κάτι που ο ασθενής μπορεί να το χρησιμοποιήσει στο σπίτι επίσης για να εξηγήσει και στην οικογένειά του και στα παιδιά σε ένα φιλικό τρόπο τι περιμένει για το υπόλοιπο ταξίδι. Αυτά από μένα. Συγγνώμη. Αν 30 δευτερόλεπτα ήμουν παραπάνω.
Ευχαριστούμε πολύ. Έχουμε χρόνο. Πολύ ενδιαφέρουσα επίσης η ομιλία. Νομίζω ότι είναι τα πλαστικοί χειρουργοί πρέπει να κάνουν κάτι παραπάνω από το απλά να βάζουν ένα μόσχευμα κάτω από το δέρμα. Και εκεί σας χρειαζόμαστε και αυτό είναι υπέρ των ασθενών. Οι επεμβάσεις μας πρέπει να είναι ογκολογικές και οι δικές σας να είναι επανορθωτικές. Κάτι να ρωτήσετε, κύριος Αντωνόπουλος.
Πολύ ωραία παρουσίαση, εξαιρετικότατη. Δεν έχω να ρωτήσω κάτι, απλώς μια υπενθύμηση ότι χρησιμοποιούμε πάρα πολύ τα local anesthesia, τα οποία διαφοροποιούν τελείως την μεταχειρουργική πορεία και το hospital stay των ασθενών. Απλώς μην ξεχνάμε, όταν ο αναισθησιολόγος κάνει τα blocks αυτά με τον υπέρηχο, θα κάνει στην αρχή της επέμβασης.
Στο τέλος.
Στο τέλος.
Στο τέλος.
Οπότε πρέπει να αλλάξουμε την στον αναισθησιολόγο να μας το κάνει στο τέλος.
Στο τέλος. Διαφορετικά έχει ξεπληθεί. Μετά από 6 ώρες έχει φύγει το...
Άρα
στο τέλος.
Κάνουμε εμείς οι χειρουργοί.
Εμείς είμαστε χειρουργοί, κυρία Αντωνόπουλη. Πλαστική εννοεί. Εσείς πλαστική.
Κάνουμε μια τελική δόση PAP, regional anesthesia, το οποίο πράγματι δίνει μεγάλη διαφορά στην μεταχειρουργική πορεία.
Ναι, αυτό που βρήκαμε είναι ότι το TAP είναι χρήσιμο και είναι το παραδοσιακό, αλλά είναι μικρό volume. Άμα δεν μπορούμε να κάνουμε τα μπλόκα, εκτός από το TAP μπορείς να κάνεις dilute σε 200 ml, πόσο είναι το maximum του local anesthetic, να βάλεις και TAP αλλά και παντού, σε όλη την κοιλιά. Ακριβώς.
Ωραία. Πολύ fluently πλαστικοί, οι οποίοι μιλάνε very well English. Θα έρθει ο κύριος Αντωνόπουλος για την επόμενη ομιλία. Έχουμε χρόνο και για χιούμορ σε αυτό το session.
Καλημέρα σε όλους. Εγώ δεν ξέρω, τελευταία χρόνια όλο τελευταίο με βάζετε. Και μου λέτε τελείωνε.
Σας αγαπάμε, θέλουμε να μένουμε με τη γεύση Αντωνόπουλος.
Να ευχαριστήσω την Οργανωτική Επιτροπή για την τιμή που μου κάνει τα τελευταία χρόνια να παρουσιάζουμε έτσι τη δουλειά μας. Και κάθε χρόνο πιστεύω παρουσιάζουν και κάτι διαφορετικό και ενδιαφέρον. Αυτό που θα σας παρουσιάσω εγώ είναι η εμπειρία δικιάς μας από την κλινική Μαστού του Μετροπόλιταν, όπου συνεργάζομαι με τον φίλο μου τον κύριο Βενιζέλο, όπως επίσης και με τον κύριο Χαβελέ στην Πάτρα. Είναι εξελιγμένες τεχνικές ογκοπλαστικής και το ερώτημα είναι αντικατάσταση του όγκου ή ανακατονομή του όγκου του μαστού. Μερικά πράγματα όλοι τα ξέρουμε, να μην χάνουμε χρόνο. Η ογκοπλαστική είναι συνδυασμός ογκολογικής επέμβασης με τεχνικές πλαστικής χειρουργικής, ώστε στο τέλος να δίνει ένα ογκολογικά ασφαλές, μην το ξεχνάμε ποτέ, και ένα αισθητικό τελικό αποτέλεσμα ικανοποιητικό για την ασθενή. Όταν όμως οι ογκεκτομές αυτές αρχίζουν να γίνονται πιο μεγάλες, εκεί αρχίζει το πρόβλημα. Διότι το να κάνουμε μια ογκοπλαστική και να κρατήσουμε το μαστό, αλλά να δώσουμε ένα αισθητικό αποτέλεσμα ασύμετρο ή όχι υψηλών προδιαγραφών, νομίζω ότι δεν είναι ο στόχος μας. Άρα λοιπόν σε μεγάλες εκτομές, ειδικά σε εκτομές του άνω έσω τμήματος του μαστού, το οποίο είναι και το πιο δύσκολο στην αποκατάσταση με ογκοπλαστικές τεχνικές, είναι μια έτσι challenging για μας, ας πούμε, χειρουργική αντιμετώπιση. Η επιλογή της ογκοπλαστικής τεχνικής που θα οδηγήσει στο επιθυμητό αποτέλεσμα εξαρτάται από το μέγεθος των μαστών. Μιλάμε για μεσαίου μεγάλου μεγέθους μαστού, συνήθως πτωτικούς μαστούς. Η θέση της βλάβης είναι πάρα πολύ σημαντική. Ο όγκος του παρασκευάματος της εκτομής και τελικά τι έχει απομείνει μετά από μια ογκεκτομή από το παρέχημα του μαστού για να μας δώσει εμάς το δικαίωμα να προχωρήσουμε να κάνουμε την ογκοπλαστική. Υπάρχουν τεχνικές μετατόπισης του όγκου του μαστού με αναδιαμόρφωση του παρεχήματος, όπου αυτές θα σας παρουσιάσω, τεχνικές αντικατάστασης του όγκου με τοπικούς ή απομακρυσμένους ξυπνούς και κλασικά τεχνικές μείωσης του όγκου, δηλαδή ένα wise pattern, σαν να κάνοντας μια μείωση ανόρθωση, ένας άλλος τρόπος. Θέλω να σας δώσω αυτό εδώ. Νομίζω ότι η ανατομία είναι η αρχή της χειρουργικής, όπου στη συγκεκριμένη ανατομική περιοχή του μαστού θα πρέπει να ξέρουμε όλες αυτές τις αγκιακές παροχές στην περιοχή του μαστού, όπως βλέπουμε δεύτερο, τρίτο, τέταρτο μεσοπλεύριο, από την έσωμαστική, από την πλάγια θωρακική, άλλους κλάδους, βλέπουμε τα intercostal αρτηρίες. Άρα λοιπόν κάθε κομμάτι, κάθε αρτηρία μπορεί να τη χρησιμοποιήσουμε ανεξάρτητα, κρατώντας ένα παρέχημα του μαστού, το οποίο στο τέλος αυτό θα μπορούμε να το πάμε όπου θέλουμε και να κάνουμε μια αναδιοργάνωση του εναπομείναντος μαστού για να μας δώσει ένα αισθητικό αποτέλεσμα. Αυτό βεβαίως το επιβεβαιώνουμε και με το Doppler, είτε προεγχειρητικά. Δεν έχουμε ήχο, δεν πειράζει, αλλά και διεγχειρητικά. Ακούμε τους διαδικούς κλάδους αυτούς, οι οποίοι θα στηρίξουν το παρέχημα. Σαν μια εύκολη, γρήγορη λύση της αντικατάστασης του όγκου μετά από μια μικρή ογκεκτομή είναι όπως αυτό το περιστατικό εδώ βλέπετε, στο άνω έξω τεταρτημόριο, και γίνεται η ογκεκτομή και αντικαθίσταται ο όγκος που έχει αφαιρεθεί με ένα ένθεμα σιλικόνης πίσω από το μείζωνα θωρακικό γύρω στα 150 κυβικά εκατοστά, και δίνει αυτό το αποτέλεσμα το οποίο γρήγορο κτλ. Βέβαια το ερώτημα της μεταχειρητικής ακτινοθεραπείας και δημιουργία κάψας στο ένθεμα της σιλικόνης είναι ένα ερώτημα, τέλος πάντων είναι όμως μια λύση. Τώρα την περίοδο 4 χρόνων χειρουργήσαμε 19 ασθενείς ηλικίας 28 έως 60 ετών, 14 περιπτώσεις αμφωτερόπλευρα, 5 ετερόπλευρα, 5 αμφωτερόπλευρα. Η εκτομή του όγκου της ογκεκτομής ήταν συνήθως πάνω από 200 γραμμάρια μέχρι 500. Η μαστή ήταν πτωτική μεσαίου μεγάλου όγκου. Οι κρυμμοί που χρησιμοποιήθηκαν είναι άνω έσω, πλάγιος, κατώτερος και ο γνωστός κρυμνός Λάικα. Σε 2 περιπτώσεις χρησιμοποιήθηκε το σύμπλημα της στυλής και της στήλας άλλου σαν μόσχευμα. Στις τετερόπλευρες ογκεκτομές γίνεται πάντα συμμετροποίηση του άλλου μαστού και όλοι οι ασθενείς αυτοί υποβληθήκαν σε μετεχειρητική ακτινοθεραπεία. Η κατανομή τώρα στο μαστό των περιστατικών αυτών του όγκου, βλέπετε ότι οι περισσότεροι, όπως ξέρουμε βέβαια, είναι το άνω έξω τεταρτημόριο σε 12 περιστατικά, άνω έσω σε 3 περιστατικά, κάτω έσω 2, κάτω έξω 2 περιστατικά. Η κρυμνή που χρησιμοποιήθηκαν ήταν ο κατώτερος κρυμνός, στηριζόμενος στο 4ο-5ο διαδυτρώσα αρτηρία, ο έξω πλάγιος σε 2 περιστατικά, Λάικα 4 περιστατικά και συνδυασμός πασπαρτού διάφορων κρυμνών σε 4 περιστατικά. Μερικά έτσι ενδεικτικά, εδώ έχω μια γυναίκα που θα υποβληθεί σε ογκεκτομή σε αυτή στο άνω έξω τεταρτημόριο, όπως βλέπετε στην πλάγια φωτογραφία, με μεσαίου όγκου μαστού και πτωτικούς μαστούς. Έχει σχεδιαστεί συμμετροποίηση του άλλου μαστού. Εδώ βλέπετε το παρασκεύασμα διαχειρητικά. Έχουμε χρησιμοποιήσει αυτόν τον κατώτερο κρυμνό, ο οποίος στηρίζεται πάνω στο 4η-5η μεσοπλεύρη αρτηρία. Η πλαϊνή κρυμνή, η θηλία έχει κρατηθεί σε έναν mediolateral, σε ένα άνω έσω ανεξάρτητο μαστό. Άρα λοιπόν βλέπετε ότι έχουμε 1, 2, 3, 4 κομμάτια. Όλα αυτά όμως αγγιώνονται από συγκεκριμένες περιοχές, στις οποίες κατά την επέμβαση θα πρέπει να κάνουμε διατήρηση των αγγείων. Και 1,5 χρόνο αυτή η κυρία μετά από την ακτινοθεραπεία, με ένα συμμετρικό και ικανοποιητικό αποτέλεσμα ογκολογικά και αισθητικά βέβαια. Ένα άλλο πιο έτσι aggressive περιστατικό, βλέπετε εδώ πολλά σύρματα σαν αχινός. Άρα λοιπόν μεγάλη περιοχή που θα πρέπει να εκταμεί από το άνω έσω τεταρτημόριο στη γυναίκα αυτή και συμμετροποίηση, μάλλον όχι συμμετροποίηση. Βλέπετε εδώ έχει ένα άλλο σύρμα, αλλά αυτή η εκτομή θα γίνει αφαιρώντας το wise pattern για να γίνει ανόρθωση. Άρα η δυσκολία επικεντρώνεται στον δεξιό μαστό. Εδώ βλέπουμε το έλλειμμα που έχει δημιουργηθεί στην άνω έσω περιοχή. Βλέπουμε ότι η θηλία έχει κρατηθεί σε έναν πλάγιο κρυμνό. Γίνεται διατομή αυτού του κρυμνού, ο οποίος αυτό σηκώνεται ανεξάρτητα, όπως βλέπετε, και αυτός ο κρυμνός γεμίζει την περιοχή αυτή είναι εκεί. Και από πάνω έρχονται τα υπόλοιπα για να κλείσουν τον μαστό. Αυτό είναι το άμεσο αποτέλεσμα και αυτό είναι το απότερο αποτέλεσμα της γυναίκας μετά από 1 χρόνο. Εδώ αυτή η φωτογραφία κάνει χημειοθεραπεία. Πάλι ένα άλλο περιστατικό, ογκεκτομή 300 γραμμάρια στο δεξιό μαστό και συμμετροποίηση του αριστερού μαστού. Βλέπετε κεντρική περιοχή και άνω έξω τεταρτημόριο, μεγάλη εκτομή. Βλέπετε ότι και εδώ έχει διατηρηθεί ένας κατώτερος κρυμνός πάλι κάτω στα 4η-5η μεσοπλεύρη αρτηρία. Η όλη ιστορία με αυτό το κρυμνό είναι το εξής, ότι έχει, όπως βλέπετε εδώ, έχει διαταμεί η βάση του από την σκάρπα και βλέπετε ότι ενώ αυτή η περιοχή κανονικά είναι εδώ, έχουμε κερδίσει μια απόσταση περίπου 3 εκατοστά, που σημαίνει ότι αυτή η διατομή κάνει αυτόν τον κρυμνό πάρα πολύ ευέλικτο και μπορεί να γυρίσει στο έξω, στο μέσο και στο έσω τεταρτημόριο πάρα πολύ εύκολα. Βέβαια, πρέπει να είμαστε σίγουροι ότι υπάρχει αγκίωση γιατί είναι Perforator flap, είναι κρυμνός διαδυτρονισών. Και βλέπετε εδώ το έλλειμμα, πώς έρχεται και γεμίζει η ανακατανομή και το απότερο αποτέλεσμα, το οποίο ας πούμε είναι ικανοποιητικό για τη γυναίκα και για μας. Ένα άλλο περιστατικό πάλι, εδώ 2 διαφορετικές βλάβες. Η μία άνω έξω, η άλλη έσω και κεντρικά με αφαίρεση της στυλής, οπότε 2 διαφορετικοί κρυμνοί. Ο δεξιός μαστός έχει γίνει η έκταση, η εκτομή. Ενδιαφέρον αυτό εδώ που θα πρέπει να καλύψει, όπως βλέπετε, το άνω έσω τεταρτημόριο, νάτος ο κρυμνός αυτός. Εδώ έχουμε σηκώσει το κρυμνό, βλέπετε πώς πηγαίνει και γεμίζει στο άνω έσω τεταρτημόριο του μαστού και βλέπετε αυτή η γυναίκα, τυχαίνει να είναι και την Πάτρα, αυτή είναι φωτογραφία πριν μια εβδομάδα, έχει υποβληθεί σε ακτινοβολία και έχει ένα ωραίο αποτέλεσμα και τα nipple graft να είναι βιώσιμα. Ένας άλλος ενδιαφέρον κρινός είναι ο θώρακο-επιγάστριος σε μια γυναίκα η οποία έχει ένα έλλειμμα κεντρικό, αφαίρεση 410 γραμμάρια, γίνεται η αποεπιθυλιοποίηση του θώρακο-επιγάστριου, ανακατασκευή της υπομάστιας πτυχής χρησιμοποιώντας ένα progressive tension κοιλιακό κρυμνό και αυτό είναι το απότερο αποτέλεσμα μετά και από ακτινοθεραπεία. Ογκεκτομή του άνω έξω τεταρτημορίου σε μια γυναίκα εδώ, όπως βλέπετε, ο κρυμνός Lycap, ο οποίος έχει αποπηδηληθεί, εδώ είναι ο διατηρώντες κλάδι, όπως βλέπετε, έχει αποπηδηλιοποιηθεί και έχει έρθει μέσα και έχει γεμίσει το έλλειμμα στο πλάγιο τείχομα, στο πλάγιο μέρος του μαστού. Εδώ είναι το απότερο αποτέλεσμα. Βλέπετε, χωρίς να έχει αλλάξει του μαστού, πώς έχει γίνει αποκατάσταση. Σε ένα δύσκολο περιστατικό τώρα, μια γυναίκα που έχει υποβληθεί σε ακτινοθεραπεία, έχει κάνει ογκεκτομή πριν 9 χρόνια, έχει κάνει υποτροπή στον άνω έξω πόλο της περιοχής. Άρα λοιπόν εδώ έχουμε έναν ακτινοβολημένο μαστό. Θα πρέπει οι χειρισμοί μας να είναι πάρα πολύ προσεκτικοί και όχι μεγάλες μετακινήσεις κτλ. Άρα εδώ χρησιμοποίησαμε τον central mount, δηλαδή ο μαστός έχει κρατηθεί όλο το πανέχημά του κεντρικά στηριζόμενο σε διατηρώντες κλάδες πάνω στο πρόσθετο θωρακικό τείχομα και έχει κάνει μια στροφή, όπως βλέπετε, για να έρθει το κάτω μέρος να γεμίσει τον άνω πόλο και συμμετροποιήσει στον άλλο το μαστό και να μας δώσει αυτό το αποτέλεσμα ικανοποιητικό. Όλοι οι κρεμίες ήταν βιώσιμοι, χωρίς στοιχεία λιπονέκρωσης, δεν είχαμε μεταβολή του όγκου του μαστού ιδιαίτερη. Πάντα υπάρχει μεταβολή μετά από ακτινοθεραπεία, αλλά όχι ιδιαίτερη. Γι' αυτό στο μαστό που πρόκειται να ακτινοβοληθεί τον αφήνουμε λίγο μεγαλύτερο. Υψηλή βαθμού ικανοποίηση των ασθενών και δεν είχαμε επιπλοκές, παρά μόνο μερικές προβληματάκια της επούλωσης των τομών, τα οποία άνευ σημασίας. Τώρα, σαν συμπέρασμα, αυτή η τεχνική, μάλλον αυτό το σκεπτικό, γιατί η κρεμνή αυτή είναι γνωστή, δεν παρουσιάζουμε κάτι καινούριο. Αυτό που παρουσιάζουμε είναι το σκεπτικό πώς μπορείς να χρησιμοποιήσεις σαν ένα puzzle αυτούς τους κρυμνούς για να μπορέσεις να δώσεις ένα τελικό αποτέλεσμα ικανοποιητικό στους ασθενείς για όταν γίνεται μεγάλη ογκεκτομή. Και θα σου πει άλλος, αφού θα αφαιρεθεί μισό κιλό στήθος, γιατί δεν κάνεις μαστεκτομή. Η γυναίκα όμως δεν θέλει μαστεκτομή. Άρα λοιπόν πρέπει να προσφέρουμε αυτές τις λύσεις. Αυτά τα λίγα λοιπόν και σας ευχαριστώ πάρα πολύ. Εδώ προσομοιάζω την μπανάνα με τα flaps και βλέπετε πως ο μαστός γίνεται φύλλο φτερό, αλλά πάντα μην ξεχνάμε όλα αυτά έχουν τη δικιά τους αγγείωση, την ξεχωριστή αγγείωση. Ευχαριστώ πολύ.
Ευχαριστούμε πολύ και για το χρόνο που μιλήσατε, που ήταν ακριβής. Γι' αυτό σας αφήνουμε.
Έπεσα μέσα στον χρόνο.
Διπλάσια.
Για πρώτη φορά.
Έχετε κάτι να ρωτήσετε, κάτι να σχολιάσετε. Πολύ ωραία η παρουσίαση, πολύ εμπεριστατωμένη και με αληθινά περιστατικά. Πώς θέλετε να ρωτήσετε κάτι? Ναι. Σας ευχαριστούμε πάρα πολύ. Είναι χαρά να είναι τόσο ψηλό το επίπεδο στις ελεύθερες ανακοινώσεις από την πρώτη μέχρι την τελευταία ανακοίνωση. Σας ευχαριστούμε πάρα πολύ για την ώρα που ήσασταν εδώ.
Καλημέρα σας και από μένα. Ήθελα να ευχαριστήσω σας που είστε παρόντες Σάββατο πρωί εδώ να μας ακούσετε. Και το θέμα το οποίο έχουμε είναι σχετικά με τις γονιδιακές υπογραφές και όσον αφορά τη δεύτερη γενιά γονιδιακών υπογραφών, το EndoPredict. Φαίνεται να υπερέχει σε κάτι, θα δούμε αν υπερέχει, θα το δούμε στην παρουσίαση του κυρίου Λίπα, ο οποίος είναι παθολόγος ογκολόγος και είναι ο expert στο θέμα αυτό. Πού είναι ο κύριος Λίπας? Καλημέρα κύριε Λίπα.
Καλημέρα. Ευχαριστώ την Οργανωτική Επιτροπή και την Gene Analysis για την ευγενική πρόσκληση και το εκλεκτό Προεδρείο για τον συντονισμό και τα σχόλια που θα κάνουμε στη συνέχεια στην ομιλία μου. Το ζήτημα λοιπόν το οποίο κλήθηκα να αναπτύξω έχει να κάνει με την γονιδιακή υπογραφή, τη μοριακή υπογραφή του EndoPredict, η οποία όπως ανέφερε και ο κ. Κωσιλάκης, πρόκειται για μια δεύτερης γενιάς μοριακή υπογραφή με βάση την οποία θα αποφασίσουμε την διαχείριση μιας ασθενούς με ορμονοεξαρτώμενο πρώιμο καρκίνο του μαστού. Το EndoPredict μας δίνει τις πληροφορίες και τις απαντήσεις στα ερωτήματα εάν μια γυναίκα χρειάζεται να πάρει χημειοθεραπεία επικουρικά μετά το χειρουργείο της ή αν πρέπει να την αποφύγει και επίσης αν έχουμε την δυνατότητα ή πρέπει να επεκτείνουμε τον ορμονικό μας χειρισμό πέραν της 5 ετίας ή απλά να σταματήσουμε στα 5 έτη. Γνωρίζοντας από νωρίς και στα πρώιμα χρόνια από τη δεκαετία του 90 ότι υπάρχουν οι γυναίκες οι οποίες δεν χρειάζεται να πάρουν χημειοθεραπεία, θα πάνε καλά μόνο με ορμονικό χειρισμό, προσπαθήσαμε να ανακαλύψουμε και να βρούμε ποιες είναι αυτές που μπορούν να μείνουν έτσι ή και να αποφύγουν την χημειοθεραπεία. Στην από εδώ μεριά του Ατλαντικού περισσότερο, αλλά και στις Ηνωμένες Πολιτείες, κλασικοί προγνωστικοί παράγοντες είναι αυτοί που βλέπετε αριστερά, όμως το 2004 είχαμε μια πραγματικά μεγάλη αλλαγή με την ανάπτυξη της πρώτης γενιάς γονιδιακών υπογραφών, το MammaPrint και το Oncotype, και περίπου μία δεκαετία αργότερα είχαμε τις δεύτερης γενιάς γονιδιακές υπογραφές, το EndoPredict και το PAM50, το Prosigna. Τι διαφορά έχουν οι δεύτερης γενιάς μοριακές υπογραφές σε σχέση με αυτές της πρώτης? Μια βασική διαφορά είναι το γεγονός ότι στον σχεδιασμό της υπογραφής και της εξέτασης συμπεριλαμβάνονται και ενσωματώνονται οι κλινικές πληροφορίες. Έχουν τη δυνατότητα να βρούνε όχι μόνο τις υποτροπές οι οποίες θα γίνουν μέσα στην πρώτη πενταετία, αλλά αυτές που θα γίνουν και πιο αργά, στη δεύτερη πενταετία και πιο πέρα. Ξέρουμε ότι στον ορμονοεξαρτώμενο καρκίνο δεν λύγει το παιχνίδι στην πενταετία, αλλά και μετά έχουμε υποτροπές και ίσως πιο συχνά. Και επίσης, μια τρίτη διαφορά και σημαντική είναι το γεγονός ότι σχεδιάστηκαν έτσι αυτές οι εξετάσεις ώστε να μην χρειάζεται να γίνονται κεντρικά, αλλά να μπορούν να γίνουν και σε τοπικά εργαστήρια με απόλυτη αξιοπιστία. Τι είναι λοιπόν το EndoPredict? Το EndoPredict είναι μια μοριακή υπογραφή 12 γονιδίων, η οποία έχει αναπτυχθεί για τις γυναίκες με καρκίνο του μαστού, στις οποίες είναι πρώιμος, μη μεταστατικός, ορμονοεξαρτώμενος, HER2 negative και τόσο με θετικούς όσο και με αρνητικούς λεμφαδένες. Συνδυάζει τα κλινικά χαρακτηριστικά του T και του N, του μεγέθους του όγκου και του λεμφαδενικού στάτους και φυσικά την έκφραση των γονιδίων που προαναφέραμε. Το αποτέλεσμα χωρίζει τις γυναίκες ξεκάθαρα σε υψηλού και χαμηλού κινδύνου, δεν υπάρχει γκρίζα ζώνη ή ενδιάμεση κατηγορία και γίνεται τοπικά. Πώς σχεδιάστηκε αυτή η μοριακή υπογραφή? Ξεκίνησε ουσιαστικά με περισσότερες από 22.000 θέσεις του DNA, κάλυψε όλα τα γονίδια, όλο το γονιδίωμα. Εξ αυτών επιλέχθηκαν γύρω στους 4.000 και γονίδια τα οποία έχουν σχέση με τον μαστό και με τον καρκίνο του μαστού. Εξ αυτών φάνηκε ότι τα 104 ξεχωρίζουν και έχουν πιο ισχυρή συσχέτιση και τα τελευταία 12 τα οποία επελέγησαν έχουν να κάνουν και με και με πρακτικές παραμέτρους του να μπορεί να ελεγχθούν σε μονιμοποιημένο υλικό σε κύβο παραφίνης. Δύο κατηγορίες έχουν τα γονίδια αυτά. Τα πρώτα τρία έχουν να κάνουν με τον πολλαπλασιασμό, με την ταχύτητα πολλαπλασιασμού. Η δεύτερη κατηγορία έχει να κάνει με την εξάρτηση από τις ορμόνες. από τα ιστρογόνα. Και υπήρχαν επίσης και 4 γονίδια, τα οποία λειτουργούν λίγο πολύ σαν control, ότι όντως σωστά έχει γίνει η εξέταση. Σε ένα μεγάλο αριθμό ασθενών, 1.324 ασθενείς, εξετάστηκε ποιες από τις παραδοσιακές παραμέτρους που βλέπαμε έχουν σχέση με την έκβαση της νόσου και με το τι θα γίνει αν πάρει ή δεν πάρει μια γυναίκα χημειοθεραπεία. Φάνηκε λοιπόν ότι από αυτές το T και το N είναι που παίζουν ρόλο και φυσικά η μοριακή υπογραφή συνολικά. Οι υπόλοιπες άλλες παράμετροι, όπως ηλικία, ορμονική υποδοχής και η A67, δεν φάνηκε να έχουν στην πολυπαραγματική ανάλυση καμία στατιστικά σημαντική ισχύ. Έτσι λοιπόν, συνδυάζοντας αυτές τις 3 παραμέτρους, βγαίνει το EP Clean Score. Αυτός είναι ο αριθμός που θα κατατάξει τις γυναίκες σε υψηλού ή χαμηλού κινδύνου. Τώρα, κανείς θα σκεφτεί δικαιολογημένα πιθανώς ότι κλέβει κατά κάποιο τρόπο η μοριακή υπογραφή βάζοντας μέσα κλινικές παραμέτρους. Αν όμως ήταν έτσι, τότε θα είχαμε όλες τις γυναίκες με θετικούς λεμφαδένες να είναι υψηλού κινδύνου, όλες τις γυναίκες με μεγάλο όγκο να είναι υψηλού κινδύνου. Αυτό δεν ισχύει, διότι οι κλινικές παράμετροι, όπως βλέπετε σε αυτή την εξίσωση, γιατί με αυτή την εξίσωση υπολογίζεται τελικά το EP-Clean, το τελικό σκορ, υπάρχουν διάφοροι πολλαπλασιαστές, οι οποίοι έχουν μια διακύμανση. Και βλέπουμε ότι το μεγάλο βάρος, τη μεγάλη διακύμανση μπορεί να είναι μέχρι 15, έχει το μοριακό σκορ, ενώ οι άλλες παράμετροι, όπως το μέγεθος του όγκου, περιορίζονται σε χαμηλό αριθμό και το λεμφαδενικό στάτους στην πραγματικότητα είναι 1 ή 2, γιατί τα 3 και 4 αφορούν πολύ μεγάλο αριθμό λεμφαδένων. Συνδυάζοντας λοιπόν κλινικές και εργαστηριακές παραμέτρους, έχουμε την κατάταξη των γυναικών σε υψηλό και χαμηλό κίνδυνο με cut-off το 3,3. Ένα ξεκάθαρο αποτέλεσμα, χαμηλός κίνδυνος, δεν χρειάζεται να πάρει γυναίκα χημειοθεραπεία και θα πάει αρκετά καλά με ενδοκρινική θεραπεία και μάλιστα διάρκειας 5 ετών σύμφωνα με τις μελέτες που χρησιμοποιήθηκαν. Υψηλού κινδύνου η γυναίκα πρέπει να πάρει χημειοθεραπεία και, γιατί θα έχει σημαντικό κλινικό όφελος. Επίσης, θα μας απαντήσει και στο ερώτημα εάν υπάρχει αυξημένος κίνδυνος να έχουμε υποτροπή της νόσου και πέραν της πενταετίας μέχρι και 15 έτη, κάτι το οποίο έχουμε την ατυχία οι θεράποντες ογκολόγοι να βλέπουμε στις ασθενείς που παρακολουθούμε για καιρό. Ένα παράδειγμα της παραμέτρου που σας είπα προηγουμένως είναι ότι εδώ έχουμε μια γυναίκα η οποία έχει έναν όγκο TAF2, για παράδειγμα 4 εκατοστά και 2 θετικούς λεμφαδένες με τεμινοπαυσιακή και βλέπουμε ότι το EP Clean Score της είναι χαμηλό 2,63. Είναι χαμηλού κινδύνου, δεν χρειάζεται να πάρει χημειοθεραπεία. Αντίστροφα, εδώ έχουμε μια γυναίκα με ένα μέγεθος όγκου 7 χιλιοστών αρνητικούς λεμφαδένες, έχει ένα υψηλό EP Clean Score 3,8 και αυτή η γυναίκα θα πρέπει να πάρει χημειοθεραπεία. Επομένως, είναι αρκετά ζυγισμένη η ενσωμάτωση των κλινικών παραμέτρων μέσα στο σκορ το οποίο παίρνουμε. Πώς τεκμηριώθηκε ότι αυτή η εξέταση δουλεύει σωστά? Έχει τεκμηριωθεί σε 6 κλινικές μελέτες, 6 ξεχωριστούς πληθυσμούς, στους οποίους είχαμε προεμινοπαυσικές, μετεμινοπαυσικές γυναίκες, είχαμε γυναίκες με θετικό και με αρνητικό λεμφαδένα, σε ομάδες που πήραν ενδοκρινική θεραπεία ή σε ομάδες που πήραν και τα δύο. Παρά το γεγονός ότι οι μελέτες δεν είχαν πληθυσμούς που είχαν τυχιοποιηθεί προοπτικά συνολικά, είναι αναδρομικές αυτές οι αναλύσεις, όμως πρόκειται για προοπτικές μελέτες. Και βλέπετε ότι αυτό είναι το πιο σημαντική πληροφορία, ότι αυτό που θα ορίσει το EndoPredict ως χαμηλός κίνδυνος έχει επιβεβαιωθεί σε όλες αυτές τις σειρές με πολύ πολύ χαμηλά ποσοστά υποτροπής 10 έτη μετά την διάγνωση. Αυτό αποτυπώνεται και σε αυτά τα διαγράμματα. Βλέπουμε λοιπόν εδώ παρακολούθηση 10 ετών στους πιο πάνω πληθυσμούς, στις 3 από τις παραπάνω μελέτες που αναφέρεται, παίρνοντας 5 έτη ενδοκρινικής θεραπείας μόνο, βλέπουμε χαμηλότερα ποσοστά υποτροπής και στους 3 αυτούς πληθυσμούς και πρακτικά πανομοιότυπες τις καμπύλες, πολύ καλή η αναπαραγωγή των δεδομένων και πώς η καμπύλη, βλέπετε, του χαμηλού κινδύνου είναι πραγματικά πολύ χαμηλή και με αυτόν τον τρόπο 55, 65 και 59% των γυναικών θα αποφύγουν την χημειοθεραπεία με αρκετή ασφάλεια. Προοπτικά δεδομένα θα αναφέρουμε από την μελέτη UNIRAD, ενώ τρέχει και μελέτη Rescue στην Γερμανία και την Ελβετία που θα έχουμε τα δεδομένα της το 2026. Πάμε να δούμε και κάποιες άλλες κατηγορίες και να δούμε, πριν να φτάσουμε σε αυτές, να δούμε πώς συγκρίνεται με τους συμβατικούς παράγοντες κινδύνου. Φανταζόμαστε ότι μια γυναίκα με ένα χαμηλό grade μπορεί να αποφύγει τη χημειοθεραπεία. Αντίστροφα, μια γυναίκα με ένα high grade καρκίνωμα θα πρέπει να πάρει χημειοθεραπεία. Βλέπουμε όμως εδώ ότι 22% των γυναικών με grade 1 είναι υψηλού κινδύνου, άρα πρέπει να πάρουν χημειοθεραπεία και μας το λέει αυτή η πρώτη καμπύλη, ενώ στο άλλο άκρο γυναίκες με high grade καρκίνο grade 3, αυτό που θα δούμε στην ιστολογική και θα πούμε πρέπει να πάρει χημειοθεραπεία, θα καταταχθούν σε ποσοστό 19% σε γυναίκες χαμηλού κινδύνου και θα αποφύγουν ευλόγως και με μεγάλη ασφάλεια την τοξικότητα της χημειοθεραπείας. Κατά αντιστοιχεία και το KI67, ένα χαμηλό KI θα μας δώσει ένα αίσθημα ασφάλειας ότι δεν έχει νόημα, δεν θα χρειαστεί να πάρει αυτή η γυναίκα χημειοθεραπεία, όμως το EndoPredict θα ξεχωρίσει τις γυναίκες που θα πρέπει να πάρουν. Και αντίστροφα, οι γυναίκες οι οποίες έχουν ένα υψηλό KI67, κάτι το οποίο τρομάζει νομίζω πιο πολύ εμάς, ίσως τους παθολόγους, ογκολόγους, θα αποφύγει σε ένα ποσοστό 34% χημειοθεραπεία, η οποία δεν χρειάζεται με μεγάλη ασφάλεια. Σε ό,τι αφορά τις προεμεινοπαυσιακές γυναίκες, σαν ιδιαίτερα ευαίσθητος πληθυσμός, έχουμε την μελέτη η οποία συμπεριέλαβε 385 προεμεινοπαυσιακές γυναίκες. Ήταν μια αναδρομική μελέτη στην πραγματικότητα, η οποία είχε αρνητικούς λεμφαδένες και με δυσκολία κατάφερε να βρει και γυναίκες με θετικό λεμφαδένα, οι οποίες δεν είχαν πάρει χημειοθεραπεία. Αυτές οι γυναίκες έκαναν EndoPredict και βρέθηκε λοιπόν ότι στην πολυπαραγωγική ανάλυση το επικλίνη ήταν η μόνη παράμετρος η οποία θα είχε στατιστικά σημαντική συσχέτιση με την έκβαση της νόσου. Είδαμε λοιπόν σε αυτό τον πληθυσμό συνολικά ελαχιστότατα ποσοστά υποτροπής στην δεκαετία σε γυναίκες οι οποίες ήταν χαμηλού κινδύνου σύμφωνα με την εξέταση, άρα έχουμε ένα πολύ καλό διαχωρισμό. Και αυτό ίσχυε και σε γυναίκες με θετικό λεμφαδένα, αλλά και σε γυναίκες με αρνητικό λεμφαδένα. Εδώ να σημειώσουμε ότι πρόκειται για λίγες γυναίκες, ήταν αρκετά δύσκολο να βρεθούν προεμεινοπαυσικές γυναίκες που δεν πήραν χημειοθεραπεία με θετικό λεμφαδένα. Ετούτοις όσες γυναίκες βρέθηκε, τα ποσοστά υποτροπής στην low risk ήταν μηδενικά. Η οθικική καταστολή θα επηρεάσει την έκβαση. Είναι αυτή η οποία θα μας πει ότι μπορούμε να αποφύγουμε ή όχι την χημειοθεραπεία. Φάνηκε λοιπόν ότι η επίδοση της εξέτασης, το να διαχωρίσει υψηλό και χαμηλό κίνδυνο, ήταν εξίσου καλή τόσο σε γυναίκες που είχαν πάρει οθικική καταστολή, όσο σε γυναίκες που δεν είχαν πάρει οθικική καταστολή. Και βλέπετε στην τελευταία καμπύλη πόσο μοιάζει ως πανομοιότυπη στην πραγματικότητα είναι η καμπύλη και η επίδοση στο διαχωρισμό υψηλού και χαμηλού κινδύνου στις προεμεινοπαυσικές γυναίκες, ακριβώς με τον ίδιο τρόπο που είναι και στις μετεομεινοπαυσικές γυναίκες. Και αυτό γιατί στον σχεδιασμό της εξέτασης δεν ελήφθη υπόψη η ηλικία. Ήταν ένας παράγοντας ο οποίος σχεδιάστηκε η εξέταση με τον ίδιο τρόπο για προ- και μετεομεινοπαυσιακές γυναίκες. Σε ό,τι αφορά τον διηθητικό λοβιακό καρκίνο, συζητάμε μεταξύ μας και λέμε ότι είναι ένας πιο ύπουλος καρκίνος, έχει πιο άτιμη συμπεριφορά. Βλέπουμε όμως ότι το EndoPredict και στον λοβιακό καρκίνο του μαστού και σε αυτή την κατηγορία μπορεί να μας διαχωρίσει τις γυναίκες υψηλού κινδύνου και να δώσουμε τη χημειοθεραπεία εκεί που χρειάζεται. Αναφέραμε ότι στον ορμονοεξαρτώμενο καρκίνο του μαστού οι υποτροπές δεν είναι κάτι το οποίο συμβαίνει μόνο στην πρώτη πενταετία. Συμβαίνει μάλλον πιο συχνά στην δεύτερη πενταετία και ίσως και πιο μετά. Δεν μηδενίζεται ποτέ ο κίνδυνος της υποτροπής Και στην πραγματικότητα το EndoPredict αυτό που μας βοηθάει είναι να διαχωρίσουμε ποιες είναι αυτές οι γυναίκες, να δούμε ποιες οι γυναίκες θα υποτροπιάσουν όχι μόνο νωρίς αλλά και αργά, και αυτό οφείλεται στο γεγονός ότι έχουμε τα γονίδια στην εξέταση που ελέγχουν την ορμονική εξάρτηση του όγκου, την εξάρτηση από τα ιστρογόνα, και αυτά είναι τα οποία φαίνεται να σχετίζονται με τις απομακρυσμένες χρονικά μεταστάσεις. Έτσι λοιπόν βλέπουμε ότι μπορεί να διαχωρίσει και υποτροπές οι οποίες έγιναν και αρκετά αργά, μετά την πενταετία, μέχρι και 15 χρόνια μετά την λήψη, μετά το χειρουργείο. Έχοντας πάρει, επαναλαμβάνω, 5 χρόνια ενδοκρινικής θεραπείας. Έτσι είναι οι μελέτες στις οποίες έγινε το validation, η επαλήθευση του EndoPredict. Ωραία. Έχουμε τη διάκριση των γυναικών που είναι χαμηλού κινδύνου, άρα δεν θα χρειαστεί βάση του κινδύνου να πάρουν χημειοθεραπεία. Μπορεί να μας πει όμως αντίστροφα και αυτές που θα ωφεληθούν από την χημειοθεραπεία. Το προβλεπτικό κομμάτι είναι νομίζω κοινός τόπος και κοινή παραδοχή, και αυτό έχει βασιστεί σε μεταναλύσεις μεγάλο αριθμό κλινικών μελετών, ότι το όφελος της χημειοθεραπείας είναι ανάλογο του κινδύνου υποτροπής. Και γι' αυτό λοιπόν τον λόγο έχει καθοριστεί και έχει συσταθεί ότι αν υπολογίζει το κίνδυνο υποτροπής γύρω στο 10% και πάνω, τότε αξίζει μάλλον τον κόπο μια γυναίκα να υποβληθεί σε χημειοθεραπεία, λαμβάνοντας από την άλλη πλευρά υπόψη το γεγονός ότι η ίδια χημειοθεραπεία έχει κινδύνους τοξικότητας, αλλά ακόμη και πιο σοβαρών συμβαμάτων. Έτσι λοιπόν, έχοντας έναν αυξημένο κίνδυνο, βλέπουμε πόσο μπορεί η χημειοθεραπεία να τον ελαττώσει, και διαχωρίζονται με το EndoPredict, με το score, οι γυναίκες υψηλού και χαμηλού κινδύνου. Το cut-off, αυτό που αντιστοιχεί στον κίνδυνο 10%, τον απόλυτο κίνδυνο υποτροπής, το δίνει το score το 3,3. Είναι το πόσο θα μειώσει τον κίνδυνο υποτροπής, έτσι ώστε να αξίζει τον κόπο να ληφθεί η χημειοθεραπεία. Γυναίκες που έχουν μεγαλύτερο σκορ πάνω από 3,3 θα πρέπει να πάρουν χημειοθεραπεία, κάτω από 3,3 δεν θα πάρουν χημειοθεραπεία. Έχουμε επίσης και την προσθήκη προοπτικών δεδομένων. Έχουμε τη μελέτη UNIRAD εδώ. Μελέτη η οποία είχε οι γυναίκες αποκλειστικά υψηλού κινδύνου. Από αυτές διακρίθηκαν οι γυναίκες που δεν μπήκαν στη μελέτη ως χαμηλού κινδύνου, δεν τυχιοποιήθηκαν. Βλέπουμε όμως και εδώ πόσο καλά είναι ο διαχωρισμός. Εδώ πρόκειται για γυναίκες οι οποίες είχαν πάρει όλες χημειοθεραπεία, ήταν υψηλού κινδύνου και θα έπαιρναν ή όχι ευερόλυμους συμπληρωματικά. Και σε αυτόν τον πληθυσμό η διάκριση του υψηλού κινδύνου αντίστροφα ήταν επιτυχής με το EndoPredict. Έχουμε και άλλα προοπτικά δεδομένα από την καθημέραν πράξη του EndoPredict και θα σας παρουσιάσω 2 μελέτες real world data από την Γερμανία, μια συλλογή γυναικών από το Πανεπιστήμιο του Μανάχου, 368 γυναίκες προεμεινοπαυσιακές και μετεμεινοπαυσιακές με θετικό και αρνητικό λεμφαδένα αναλύθηκαν και παρακολουθήθηκαν. Κατατάχθηκαν στο 65% χαμηλού κινδύνου και γλίτωσαν την μη αναγκαία χημειοθεραπεία, και αντίστροφα το 35% κατατάγησαν στους υψηλού κινδύνου με τη σύσταση να πάρουν χημειοθεραπεία. Βλέπουμε λοιπόν το follow-up, το σημαντικό ήταν στην πενταετία, δεν έχουν οριμάσει με τα δεδομένα για πολύ πιο μετά, όμως βλέπουμε ότι στην πενταετία ο διαχωρισμός του υψηλού και χαμηλού κινδύνου ήταν επιτυχής ακριβώς όπως και στις προηγούμενες σειρές που σας παρουσίασα. Τώρα, εδώ υπήρχαν κάποιες γυναίκες οι οποίες κατατάχθηκαν ως υψηλού κινδύνου από το EndoPredict. Κάποιες από αυτές πήραν χημειοθεραπεία, όμως κάποιες για δικούς τους λόγους επέλεξαν να μην κάνουν χημειοθεραπεία. Βλέπουμε λοιπόν εδώ ότι οι γυναίκες που ήταν υψηλού κινδύνου και πήραν χημειοθεραπεία, πώς ελαττώθηκε ο κίνδυνος με τη σκούρα μπλε γραμμή, ενώ οι γυναίκες που ήταν υψηλού κινδύνου και δεν πήραν χημειοθεραπεία διατήρησαν τον υψηλό κίνδυνο και υπέστησαν τις υποτροπές. Αυτό είναι ένα ξεκάθαρο τεκμήριο και της προβλεπτικής ικανότητας του EndoPredict, να πει ότι αυτές οι γυναίκες υψηλού κινδύνου πράγματι θα κερδίσουν να πάρουν χημειοθεραπεία. Δεν είναι μόνο το προγνωστικό κομμάτι. Ίδια αποτελέσματα στον προ- και τον μεταμηνοπαυσιακό υποπληθυσμό σε αυτή την κοόρτη ασθενών και γυναίκες με χαμηλό και 67 σε ένα ποσοστό ήταν υψηλού κινδύνου και πήραν χημειοθεραπεία και το αντίστοιχο όφελος. Αντίστροφα, υψηλό και 67 έπρεπε στο νου μας να πάρουν όλες χημειοθεραπεία, όμως και εκεί απομονώθηκε ένας πληθυσμός χαμηλού κινδύνου και πήρε τη σύσταση για αποφυγή χημειοθεραπείας με ασφάλεια. Η δεύτερη προοπτική καταγραφή προέρχεται από το Σαριτέ. Εκεί λοιπόν σε 842 γυναίκες είδαμε τα δεδομένα, γυναίκες και εκεί με διάμεση ηλικία 54 έτη, προ- και μεταμηνοπαυσιακές. Εδώ δεν έχουμε τόσο όρημα δεδομένα, όμως βλέπουμε ότι ο πληθυσμός που ήταν χαμηλού κινδύνου είχε ελάχιστες υποτροπές. Και εδώ αυτό πάλι είναι για άλλη μια φορά μια επιβεβαίωση της επίδοσης της μελέτης. Τώρα, το EndoPredict γίνεται όχι απαραίτητα κεντρικά, μπορεί να γίνει και τοπικά. Με μεγάλη ασφάλεια βλέπουμε πλήρη αναπαραγωγιμότητα της μελέτης και της εξέτασης και των δεδομένων της σε τοπικά εργαστήρια. Ό,τι θα γίνει στην Ελλάδα, ίδιο αποτέλεσμα θα δοθεί στη Γαλλία, στη Γερμανία ή όπου υπάρχει το αντίστοιχο εργαστήριο. Και μια πολύ σημαντική παράμετρος είναι ότι στις κατευθυντήριες οδηγίες της ΕΣΜΟ πλέον το EndoPredict έχει πάρει level of evidence υψηλό, το υψηλότερο που υπάρχει, και με το σχόλιο μάλιστα ότι στο Oncotype έχουμε έναν αποκλεισμό των δεδομένων της ενδιάμεσης κατηγορίας κινδύνου. Βλέπουμε λοιπόν ότι στις προεμηνοπαυσικές και τις μηνοπαυσιακές γυναίκες υπάρχουν οι αντίστοιχες κατευθυντήριες οδηγίες και εδώ αποδέχονται η ΕΣΜΟ για όλες τις μοριακές υπογραφές ότι χαμηλός κίνδυνος είναι πράγματι χαμηλός και ο υψηλός κίνδυνος είναι ένας κίνδυνος για τον οποίο χρειάζεται να δοθεί η χημειοθεραπεία και δημιουργεί μια εντύπωση ότι δεν υπάρχει αναφορά σε ό,τι αφορά το Oncotype στην ενδιάμεση κατηγορία κινδύνου, το 15 ως 26. Νομίζω ότι είναι μια έμεσα αλλά ξεκάθαρη αναγνώριση ότι υπάρχει μια γκρίζα ζώνη, κάτι το οποίο το βλέπουμε στις προεμηνοπαυσιακές γυναίκες στην απάντηση που παίρνουμε. Στο EndoPredict ο διαχωρισμός είναι καθαρός high και low. Οι κατευθυντήριες οδηγίες που έχουν ενσωματώσει το EndoPredict είναι της ESMO, της ASCO, του St. Gallen. Όλες οι διεθνείς κατευθυντήριες οδηγίες έχουν ενσωματώσει και αναγνωρίζουν και οι περισσότερες από αυτές την προβλεπτική αξία της εξέτασης, ενώ υπάρχει και σε αρκετές εθνικές κατευθυντήριες οδηγίες σε χώρες όπως η Γερμανία, η Ισπανία, η Ιταλία κτλ. Και μπαίνοντας στο τελευταίο μέρος της ομιλίας μου, θα δούμε συγκριτικά δεδομένα. Στην Ελλάδα έχουμε διαθέσιμες 3 μοριακές υπογραφές, το Oncotype, το EndoPredict και το MammaPrint. Να δούμε αν υπάρχουν συγκριτικά δεδομένα ανάμεσα σε αυτές. Στην πραγματικότητα, τα δεδομένα που έχουμε σε κοινό πληθυσμό αφορούν το Oncotype και το EndoPredict και αυτές προέρχονται από την μελέτη ATTAC. Ένας υποπληθυσμός εξ αυτών στον οποίο υπήρχαν διαθέσιμα τα δείγματα. 2 υποπληθυσμοί έχουν ελεγχθεί ευθέως Oncotype και EndoPredict, ενώ υπήρχαν και μελέτες στις οποίες συγκρίθηκαν περισσότερες από μία από αυτές τις υπογραφές. Σε μία λοιπόν ανάλυση του πληθυσμού στην TransAttack έχουν συγκριθεί οι υπογραφές πρώτης γενιάς και δεύτερης γενιάς. Βλέπουμε την υπεροχή των υπογραφών δεύτερης γενιάς στην αναγνώριση των γυναικών που είναι υψηλού και το διαχωρισμό με αυτές που είναι χαμηλού κινδύνου, κάτι το οποίο δεν έχει επιτύχει τόσο καλά το Oncotype. Τόσο στις υποτροπές συνολικά στην πρώτη δεκαετία, αλλά και πιο μεμονωμένα στα έτη 5 έως 10. Επίσης, στην μελέτη TransAttack βλέπουμε στο αριστερό διάγραμμα, βλέπουμε ότι το μοριακό σκορ μόνον, χωρίς την ενσωμάτωση των κλινικών παραμέτρων, υπερέχει του EndoPredict συνολικά για την πρώτη δεκαετία. Βλέπουμε πώς αυτή η επιρροχή αυξάνει με την ενσωμάτωση των κλινικών δεδομένων. Εάν πάμε στις υποτροπές που συμβαίνουν μέσα στην πρώτη πενταετία και συγκρίνουμε το μοριακό σκέλος του EndoPredict με το Recurrence Score, έχουν την ίδια επίδοση, όμως προσθέτοντας τα κλινικά δεδομένα υπερέχει ξεκάθαρα το EndoPredict. Ενώ αν πάμε στις υποτροπές που θα προκύψουν την δεύτερη πενταετία, ξεκάθαρη υπεροχή μόνο και μόνο του μοριακού score έναντι του Recurrence Score του Oncotype και ξεκάθαρη η διαφορά ακόμα μεγαλύτερη διαφορά με την προσθήκη των κλινικών παραμέτρων. Συγκρίνοντας την αποτελεσματικότητα στον διαχωρισμό υψηλού και χαμηλού κινδύνου μεταξύ των δύο υπογραφών σε γυναίκες με αρνητικό λεμφαδένα, βλέπουμε ότι είναι περίπου εξίσου αποτελεσματικές οι δύο εξετάσεις στο να διαχωρίζουν τους πληθυσμούς, αν και το EP-Clean, το EndoPredict, ανιχνεύει 10% περισσότερες γυναίκες χαμηλού κινδύνου στον ίδιο πληθυσμό σε σχέση με αυτόν του Oncotype. Αν πάμε όμως στις γυναίκες που έχουν θετικό λεμφαδένα, άρα εξορισμού μεγαλύτερο κίνδυνο, έχουμε πολύ καλή ανίχνευση των γυναικών με το EndoPredict που είναι χαμηλού κινδύνου. Τις γυναίκες που χαρακτηρίζουν υψηλού κινδύνου και οι δύο εξετάσεις είναι πράγματι υψηλού κινδύνου, όμως έχουμε ένα ανησυχητικό έβριμα σε σχέση με το Recurrence Score. 25% των γυναικών που ανιχνεύτηκαν ως χαμηλού κινδύνου με το Oncotype υποτροπίασαν, άρα δεν ήταν χαμηλού κινδύνου. Και αυτό αφορά την δεύτερη πενταετία αποτροπές, που είναι τη δεύτερη πενταετία, αρκετά σημαντική πληροφορία. Και να δούμε τι γίνεται όταν συμφωνούν και όταν διαφωνούν οι δύο υπογραφές. Αναλύθηκαν και σε όλους τους πληθυσμούς, σε όλα τα άτομα της σειράς και οι δύο εξετάσεις. Γυναίκες χαμηλού κινδύνου με το EndoPredict και το Oncotype πράγματι χαμηλού. Υψηλού κινδύνου με το Oncotype και το EndoPredict πράγματι υψηλού κινδύνου. Εκεί που έδιναν και οι δύο εξετάσεις, που έδινε μάλλον το EndoPredict ως χαμηλού κινδύνου, αλλά το Oncotype ως υψηλού κινδύνου, στην πραγματικότητα ως μη χαμηλού, γιατί ήταν το cut-off σε αυτή τη μελέτη το 18, όχι το 25 που είναι σήμερα. Μάλλον διαχώριζε καλύτερα το EndoPredict, τις γυναίκες που είναι χαμηλού κινδύνου. Το ανάποδο, εκεί που το Oncotype έδινε χαμηλού κινδύνου, το EndoPredict είχε τη δυνατότητα να τις ανιχνεύσει ως υψηλού κινδύνου. Και εδώ νομίζω ότι έχουμε ένα πολύ σημαντικό δεδομένο, το βασικό επιχείρημα που μάλλον μας κατευθύνει ότι το EndoPredict πιθανότατα έχει καλύτερη επίδοση και υπερέχει έναντι του Oncotype. Είπαμε λοιπόν την επαναληψιμότητα της εξέτασης, συν το γεγονός ότι έχοντας τα εργαστήρια σε τοπικό επίπεδο θα έχουμε την απάντηση σε 3 εργάσιμες ημέρες, κάτι που είναι πάρα πολύ θετικό για τις ασθενείς μας. Γνωρίζουμε πόσο αγωνιούν. Από όλη τη διαδικασία της διάγνωσης του καρκίνου, νομίζω πάρα πολλές γυναίκες το πιο τραυματικό ζητούμενο είναι η χορήγηση ή η αποφυγή της χημειοθεραπείας. Κλείνοντας, να επαναλάβουμε ότι το Oncotype είναι μια εξέταση γονιδιακής υπογραφής δεύτερης γενιάς, η οποία ανιχνεύει γυναίκες χαμηλού ή υψηλού κινδύνου για υποτροπή της νόσου και μας κατευθύνει στο να δώσουμε ή να αποφύγουμε την χημειοθεραπεία, και είναι ανεξάρτητο από το λεμφαδενικό στάτους, το μενοπαυσιακό στάτους. Φυσικά να τονίσω εδώ ότι ισχύει η σύσταση ότι προεμεινοπαυσικές γυναίκες με θετικό λεμφαδένα πρέπει να πάρουν χημειοθεραπεία, να μην έχουμε καμία παρανόηση σε σχέση με αυτό. Το KI 67 και το grade πάλι είναι κάτι τα οποία μπορούν να ξεπεραστούν ως πληροφορία με βάση την μοριακή υπογραφή, ιστολογικό υπότυπο. Προβλέπει το όφελος που θα υπάρχει και θα προκύψει από την χημειοθεραπεία, προβλέπει τις υποτροπές που θα γίνουν νωρίς ή και πιο απομακρυσμένα χρονικά και υπερέχει έναντι των υπογραφών πρώτης γενιάς στις γυναίκες που έχουν ορμονοεξαρτώμενη νόσο. Με αποτέλεσμα το οποίο θα είναι πολύ σύντομα διαθέσιμο στους θεράποντες και στις γυναίκες που έχουν κάνει την εξέταση. Ευχαριστώ για την προσοχή σας, στη διάθεσή σας για συζήτηση.
Συγχαρητήρια κύριε Λίπα, γιατί ήταν πολύ περιεκτική και εξαντλητική η ανάλυση του θέματος και μέσα στον προβλεπόμενο χρόνο. Επομένως, εάν θέλαμε να πάρουμε ένα μήνυμα για το σπίτι, το EndoPredict έχει predictive value ή μόνο prognostic value?
Είδαμε ξεκάθαρα ότι έχει και predictive value. Φυσικά η ισχύς του prognostic value είναι τόσο υψηλή που και να μην υπήρχε το predictive value που υπάρχει, όπως είδαμε ξεκάθαρα, νομίζω ότι είναι αρκετή για να μας πει ποιες γυναίκες δεν θα χρειαστούν χημειοθεραπεία.
Δεν σας ενοχλεί ότι το validation έχει γίνει σε μελέτες στις οποίες ήδη είχαν μπει με διαφορετικά inclusion criteria οι ασθενείς μας? Δηλαδή η ABC, η 6, η 8, η Trans Attack. Θέλω να πω, δεν είναι upfront η τυχεοποίηση.
Σε αυτό έχετε δίκιο και είναι ένα από τα δύνατα σημεία της μοριακής ανάλυσης. Όμως, έχοντας 6 διαφορετικούς πληθυσμούς, στους οποίους έχουμε ένα πανομοιότυπο αποτέλεσμα, έναν ίδιο διαχωρισμό, θεωρώ ότι η στατιστική ισχύς αυτού εν τέλει είναι ίδια, είναι εξίσου ισχυρή. Να το πάμε και από την ανάποδη πλευρά. Στην πραγματικότητα και σε άλλες 2 μοριακές υπογραφές πρώτης γενιάς, η τυχειοποίηση που έγινε δεν αφορούσε ολόκληρο τον πληθυσμό. Έγινε μια τυχειοποίηση η οποία στο προοπτικό της σκέλος αφορούσε, έχει διαχωρίσει τους πληθυσμούς του υψηλού.
Αναφέρεσαι στο MammaPrint.
Αναφέρομαι και στο MammaPrint και στο Oncotype.
Ωραία. Γιάννη, έχεις κάποιο σχόλιο?
Δεν έχω να συμπληρώσω κάτι. Είναι αποτελέσματα που θα δούμε προοπτικά και στον χρόνο και την επιβεβαίωση. Εγώ ήθελα να ρωτήσω, νομίζετε ότι υπερέχει το τεστ έναντι της πρώτης γενιάς?
Κοιτάξτε, τα δεδομένα που έχουμε από την Trans Attack που είναι στον ίδιο πληθυσμό δείχνουν σημεία υπεροχής, τα οποία είναι πιο εξεσημασμένα και πιο ξεκάθαρα στις γυναίκες που έχουν θετικό λεμφαδένα, σε πιο ευαίσθητο πληθυσμό. Είναι προφανές και αυτονόητο ότι αυτή την υπεροχή την αναμένουμε λογικά να ισχύει και στις άλλες γυναίκες χαμηλότερου ρίσκου.
Υπάρχει κάποια ερώτηση από το ακροατήριο? Ωραία. Τότε να σε ευχαριστήσουμε. Είσαστε πολύ σαφείς και να δώσουμε το Προεδρείο στο επόμενο τραπέζι. Ρωτάμε, είπαμε κάτι της. Ναι, αλλά χρειάζεται πολύ κουβέντα.
Ο κύριος Καρακατσάνης. Ο κύριος Καρακατσάνης.
Τι κάνεις? Λοιπόν, κάτσε που είμαστε εδώ τώρα. Θες να... Ποιο θες να... Ναι. Okay. Good morning. Καλημέρα. We're going to do this, το κάνουμε στα αγγλικά για όλους και για τους international speakers. So it's my pleasure to chair this session with Dr. Karakatsanis. I'm Terry Mamones, breast surgical oncologist working in the US in Orlando, Florida. So we have a debate this morning for a very important topic that we all struggle with, and this is the debate of axillary surgery after neoadjuvant chemotherapy. And the debate is whether clinically not positive patients who have converted to clinically negative after neoadjuvant chemotherapy, and then they have a positive sentinel node, either by sentinel lymph node biopsy, targeted axillary dissection, should they have an axillary lymph node dissection, a completion axillary lymph node dissection? And there will be a pro and con debate. So our first speaker, which will argue the yes approach, is Dr. Agarwal. He's a consultant oncoplastic breast surgeon in Cambridge. He's a member of the academic, look at it here, Academic and Research Council Research Committee, Associate of Breast Surgery in the UK, and founder and director of Cambridge Perforator Flap and Implant course. Dr. Agarwal will again argue the yes approach. Welcome.
Thank you. Thank you. It's a pleasure to be here. Many thanks to Hellenic Society of Breast Surgery for inviting me. I'm not going to be debating. I'm going to be discussing, actually, because it is such a conflicting topic, actually. So I do not have any conflict of interest, but the debate itself is conflicting, I guess. Now, if I may take a few steps back as to where we started with de-escalation trials in axilla. And we are all aware of a number of trials looking at ITCs, micrometastasis, and macrometastasis in non-neoadjuvant chemotherapy setting. So nobody does clearance for ITCs. Nobody does or should do for micrometastasis. For macro, of course, most likely more of us do nothing, but majority of these patients do get radiotherapy. And there are several cautions, if I must say, before I go on to the next step. All of these trials cater to 2 or less lymph nodes. Biology were not explicitly stated for intention to treat analysis because they were all-comers biology. Likely majority were ER positive, HER2 negative because they didn't receive neoadjuvant chemotherapy. So they were lower risk biology. Now, all these trials that have reported, probably Amaras and Z11 are the ones that have reported up to 10 years. Maybe they might be coming up to 15 years now. Now, we do know in ER-positive, HER2 negatives, we do see late recurrences. So have we seen long enough follow-up in non-neoadjuvant, lower volume, lower risk disease before we jump on to higher volume, higher risk disease, which do need neoadjuvant chemotherapy? And strictly by definition, if you talk to the purist in pathology, they would say complete response is only if there are no ITCs or micro or macrometastasis. So there are several issues that we need to discuss. I don't think we are going to get a conclusion today, maybe, but then can we discuss a few things before we vote? Now, about diagnostic imaging, are we happy enough with our current diagnostic imaging? Assessment or response in the breast is not perfect yet. Not to mention about axilla. This, the first one that you can see looking at the MRI, positive predictive value was highest in ER negative and HER2 positive in breast. They don't talk about much of the axilla. The second one, the PET scan, it showed higher sensitivity and specificity than MRI for assessing breast response. There's no nodal data. Now, there may be future predictive models. I think there's some study going on with some AI professor in Greece. It's kind of using predictive PET models to predict path response in the lymph nodes. And prelim data suggests that triple negative and HER2 positives are more likely to be responsive, which is kind of an obvious, than luminals. Now, but then we don't do preoperative PET, we don't do preoperative MRI, etc. to look in the axilla. We have preoperative ultrasound. So are you confident, are you happy with your your radiologist who's reporting, do they have inter-observer variability? Because when you are looking at clinically node negative or positive after chemotherapy, you have got to be certain which route to take. Then we are debating after. Sensitivity, if they look at one abnormal node, is 66, specificity of 77%. Preoperative MRI study, MSK, Monica Moro's, I think, group, they reported 35% false positive. So you have given chemotherapy, 35% patients would be called positive, clinically node positive, wherein you might do clearance. If they are called negative, you may not do. So there's that discrepancy over there. So we haven't quite got perfection in the axillary diagnostic imaging yet. There's lack of standardization in how they report. There's lack of accuracy in restaging. MRI, there's very early experience. PET, it's very early interest. Maybe in future, radiomics and AI might help. But the dilemma remains, how do you accurately differentiate, discriminate between node positive or node negative after chemotherapy for us to be able to decide whether to do sentinel node or targeted dissection? Then we get the question of positive or negative, and then we debate about clearance or not. Now, how about neoadjuvant chemotherapy indications and response? Chemotherapy initially, at least to a surgeon, was to downsize breast tumor size and downstage T of the TNM. But do we need to really give chemotherapy to many of these patients who used to receive chemotherapy in the past? In the era of oncoplastic, we don't need to. But then one could argue chemotherapy neoadjuvant is to downsize axilla, right? Downsize axilla. Now, if we are dealing with non-neoadjuvant chemo setting, node negative, no chemotherapy, if we get more than 2 positive lymph nodes, our tendency is still to do clearance, because none of those trials, as I mentioned about Amaras or whichever, they included more than 2 lymph nodes. And now we are talking in node positive setting, higher risk disease, where we're giving chemotherapy, and they remain positive, meaning chemo didn't quite work or didn't completely work, and then we are questioning clearance here. But of course, chemotherapy is not to downsize axilla, it's to downstage. How do you know you have downstage? If you don't even do clearance, you are still stuck at 1 or 2 or 3 lymph nodes, because strictly going by TNM classification, you've got to take a certain number of lymph nodes. If you don't do clearance, then you don't get that information. But then we can look away. We look away, we are all fine, from any problems in the world. And there's axillary intelligence, it seems, to auto downstage, because you don't look, it's already downstaged. What does happen in the undissected axilla? Now, there's a recent study, whilst prepping, actually, I came across this study, 1,900 patients, they found 26% additional positive nodes, 37% macroscopic, single center, single database, agreed. What was interesting, they say additional nodes were found in older age, T2 category, grade 1, ER positive, HER2 negative, lobular multifocality. Now, should these patients have received chemotherapy? So we're asking we're doing something not right, and then we're creating a problem, then we're asking what to do after chemotherapy. So that kind of proves the point in a way. And statistically speaking, I think it's called type 3 error. Now, meta-analysis of 2,200 patients, axillary path response rate was 37%. Another meta-analysis, 4,500 patients. They didn't quite talk about path complete response. They looked into different various methods of identifying with good identification rates. Now, could the response be burden related? As in, the more the tumor, the better the response, the less the tumor, the less the response. Well, this meta-analysis, again, identification rate of 91%, great, but they show that there was less complete response if the tumor burden was higher. So if you start off with C2 and 3, and this is, I'm playing with the topic I was given, because nobody told me C1. I was told clinically node positive. So if clinically node positive N2, N3, and if we were to give chemotherapy, should we even debate about this? We're talking about C1. Now, another residual nodal burden kind of prediction, looking at targeted dissection a step further, they found 27% patients had 4.1 additional lymph nodes. Now, in Cambridge, if a patient has 4 or more lymph nodes, we tend to stage them, because then they have got higher risk of metastatic disease. And that's where oncologists will jump in and give CDK, etc. But then we don't want to jump in. I'm going to Now, original study, Monica Moro's group, when they looked at 702 patients, 17% of ITCs and 64% of micrometastasis had additional nodes or lymph node dissection. Single center and this frozen section, so maybe there's a caveat over there. So maybe not doing clearance in ITCs may be okay, but perhaps not in micrometastasis. Is there any data on ITCs? Now, this is EU breast study, OPBC ICARO. They looked into population study of residual ITCs, clearance versus radiotherapy versus observations. 35% clearance were more likely if the surgeon was told it was N2, N3, LVI plus frozen plus disease. And when they did clearance, additional nodes were seen in up to 30%. So no clearance in ITCs, but probably it also means that it should be supporting clearance in micro and macro metastasis. Is there any data on micro? There is a study ongoing, the same group, 06 study, which is recruiting. In future, we'll have Alliance 11202 data and ADANET, which is a Spanish data. I'll go into a bit of detail a bit later. Other predictive nomograms, so we know better before we make the decision even for sentinel node or clearance, before we get to the point of sentinel node positivity. MD Anderson as Japanese cohort, again, very similar, grade 3 HER2 positive ER negatives, they do respond, they will respond in the breast, they will likely respond in the axilla. Now, oncologists would probably want you to operate, do clearance because they need information for CDK4/6 inhibitor. Perhaps not, there was some recent data, I haven't quite got into details, but if they ask you to do clearance, Jana de Boniface in Cenemet trial, she published very recently in Lancet Oncology, say that you have to do 104 clearances to gain one disease-free survival. So I'm actually talking against clearance here. But the point is, oncologists is asking you to do clearance to gain information about CDK4/6 inhibitors. But do the surgeons want to do clearance? American Society of Breast Surgeons, a survey done by Boy's group, 15% surgeons responded. So 85 didn't want to offend probably the PI, so they didn't answer. And what surgeons were doing was they were less likely to omit clearance if they found C1 disease rather than C0 disease. So if they start with node positive chemotherapy, node positive, they're kind of less keen on doing clearance. Michaelis Kontos from Greece, from Athens, he did a TAD survey, targeted dissection. 42% of targeted dissection found 1 to 3 nodes. Now, again, similar kind of profile, HER2 positives, triple negative surgeons would probably more likely to conserve axilla, but the rest wouldn't. So the oncologists wanted to do the clearance, but the surgeons are saying, no, we're not doing clearance because we are already convinced with the evidence. So how is why are the surgeons so unkeen? Perhaps it's to do with how the trainees are trained now. We do clip lymph nodes or mark the lymph nodes before chemotherapy with a number of methods, not going into the details, carbon tattoo, Maxid, etc., etc. Is there a difference between sentinel lymph node and targeted dissection? This is again population data, OMA study. What they found was targeted dissection, there were 3 lymph nodes, and sentinel node median was 4 lymph nodes. That's kind of, I thought it was interesting, probably something called Hawthorne effect, which means if you are watched, if there's a CCTV, you tend to behave better, don't we also? So maybe when the surgeons were doing targeted dissection, they were taking less lymph nodes, because in my mind, I thought targeted dissection, the word itself may mean more than 2 sentinel lymph nodes, because the average for sentinel node is 2, but in real world, it's 4. Now, Texas trial, which is run by Walter Weber, what it's looking into is, could there be something in between clearance and targeted dissection? So they're calling it TAS, targeted axillary surgery, which does include biopsied lymph node, clipped lymph nodes, sentinel lymph node, suspicious lymph node, and radiotherapy. So what's the problem with level 1 clearance? Because there's a lot being dissected over there, plus radiotherapy. But then this is a study that we'll look forward to, will have the data in future. False negative rate of TAS was 2.6%. Image-guided localization doesn't seem to improve outcomes. Oksana study, by my learned opposing counsel. We'll probably be talking later on, looking at different methods of axillary sampling, shall we say. So if we don't do clearance, what are the alternatives? Of course, the alternative is radiotherapy. Radiation oncologists, of course, can shrink everything, but then they don't like if you tell them positive margin is present, macroscopic disease is present, they don't generally tend to like it. Now, what I found it interesting, while we are fretting over lymphedema, all the complications, we are very kind of complication savvy. As surgeons, we look at the negative side of things, and we're trying to improve things, but how many trials have endpoints as side effect? Maybe the recent radiotherapy trials are having these endpoints, but then all these traditional, older trials, 10, 15 years old or longer, they don't report on side effect. EBCT-CG group presented more than 15 years survival, of course we know that. They say there's excess contralateral breast cancer due to radiotherapy, lung cancer, heart disease, etc. Having said that, the risk they quote is longer, 15 to 20 years later. We haven't even got trial results longer than 5 or maybe 10 years. We are giving radiotherapy to these patients. Do we need to wait, or do we need to change our practice right now? What I found interesting is in the middle row, the red one, 4.5% in N2, absolute reduction in 15 years breast cancer mortality. Of course, N2 is, if only you do clearance, then you know it's N2 or N1. When we do implant surgery, we talk to the patients about anaplastic large cell lymphoma. We have to talk to them. The maximum incidence is 0.3%. But do we tell the patients that you're not going to do clearance, you'll prevent lymphedema, but actually, this is the radiation therapy-induced sarcoma incidence, which is higher than ALCL. But do we talk to them? Do the oncologists, maybe they talk, I don't sit with them, but then do they talk? And it's poorer prognostic. And we are seeing them late angiosarcoma because patients are living longer. And Z11 itself, when they did a subgroup analysis, they say substantial minority received extended nodal radiation. So whilst you're reducing clearance, you are extending escalating radiotherapy fields. And they say further research is needed. Now, radiotherapy seems non-inferior in those who turn node negative, NSABP 51 trial. It did take larger tumors. I'm not going to go into details. Now, the specific trials that are ongoing in this setting, node positive on sentinel lymph node biopsy, Alliance 11202, what it's looking at, arm 2, I find it easier to understand, no clearance, along with breast or chest wall radiotherapy, plus nodal irradiation level 1, 2, 3, and SCF. So 1, 2, 3, 4. Versus clearance level 1 and 2, and the rest of the field irradiated. So it's an ongoing trial. They do exclude N2 and N3. So we need to be careful. If you are saying no to clearance, then you need to be careful who you are selecting, C1, C2, or N2 or N3. ADENA trial in Spain is another randomized trial, clearance versus radiotherapy. They include neoadjuvant endocrine therapy, and that I find it interesting. Maybe these are the patients in ER-positive, HER2 negatives who we may have some data in future. Now, so the conclusion from RT aspect is there's no robust evidence yet, perhaps in future. If for good prognostic ER-positive tumors, would the RT benefit sustain long enough to offset noted late recurrences that are happening 15 to 20 years later? And these are the patients who used to receive 5 weeks of radiotherapy in low-risk ER-positive tumors. What about the long-term side effects, fibrosis of the breast, if you are conserving the breast? That's again is long-term. If for good responsive tumors, triple negative and HER2, would the radiotherapy add on top of very good effective systemic therapy? Improving ALND, being a surgeon, can we improve on what we do so that we worry less about lymphedema? Axillary reverse mapping, this is something has come up where they map out lymphatics from the arm and lymphatics from the breast and try and see if they can avoid the arm lymphatics. It seems to have some success in non-neoadjuvant chemotherapy, but in chemotherapy setting, there's some limited success and probably untested because we are de-escalating a bit too fast, too soon. So we'll probably wait for the data, but whilst we are focusing on de-escalating, what we need to do is not to forget about the prevalent lymphedema. There are several ways you can prevent lymphedema before it really happens, rather than to de-escalate when there's no oncological evidence to de-escalate. There could be future stem cell mesenchymal cell transfer, which allows, and there's some lab data to say that it could lead to regeneration of lymphatic networks. So maybe we can do something else whilst not fretting about or compromising oncological safety. The final few slides to close the matter. Now, I did a clinical study looking at how the radiologists look at the lymph nodes versus what the features are on the breast. It's a retrospective single-center study. Interesting found was tumors that are closer to the skin, they tend to have more node positive, even if they are lower grade. And we see that in clinic. If we get ER positive, low grade, and node positive, whilst triple negative doesn't. So that could be one of the reasons. But second, lymph node is an immunological organ. We are de-escalating based on numbers, N1, N2, N3. We're not talking about the science behind it. And the lab data, collaborative data with Professor Mahata in Cambridge, there is some difference in immune profile of node positive versus node negative, wherein there's a shift about T regulatory cells. So there's more to the science before we jump into de-escalating. Now, pro-clearance, there's plenty of evidence, plenty of history. We are in Athens. We can't ignore history, so let's stick with it. Against clearance, we'll learn soon. So why do we need to do clearance? Number one, to prognosticate, as lymph node remains the single best variable when it comes to prognosis. Number two, we need to stage, because more than 4 nodes, we know whether the patient is high risk for mets or not, so that oncologists can escalate post NACT treatment. ER positive, HER2 negative, we need to wait longer for late recurrences before we can conclude, should we be giving them an neoadjuvant chemo? Does radiotherapy actually eradicate all the disease? If it eradicated all the disease in breast, we would never have local recurrences, but we do see local recurrences in ER positive and HER2 negatives. Could radiotherapy fields extended beyond N1 lead to extended risky exposure? We don't know. I'm not an oncologist. So we do need to know undissected axilla, because more than 25% are positive. There's more lymph nodes in T3, non-PET complete response, non-HER2, non-triple negative, will allow identification of neoadjuvant chemo-resistant tumor clones. If they haven't responded, something is bad. But if you don't dissect, you know you don't get that information. And if you don't need that information, then why are you escalating if you're with CDK, capecitabine, TDM, etc.? So with that, I'm going to rest the case in favor of clearance. Thank you. If you want to escalate, then you enjoy casual date. If you want to de-escalate, then fine, you can jump. Thank you.
Thank you so much, Amit, for that. Now we'll go for the opposite opinion, and I'm very happy to present Torsten Kuhn, professor from Ulm University in Germany and president of the EU Breast. Torsten needs no introductions. He will be talking to us about the no side of things. Torsten.
Yeah, ladies and gentlemen, dear Chairman, first of all, let me thank the organizers to invite me to this beautiful place. It's a real pleasure to come. And it's probably not so easy to convince the community of surgeons to omit axial lymph node dissection in patients who initially had a positive lymph node status, then converted to clinical node negativity and had still positive lymph nodes. But I will try to do so, since I'm convinced of that. These are my disclosures, and please note that I am a surgeon. So this is a paper I published almost 25 years ago, and we asked patients who at that time, all patients underwent full axial lymph node dissection, and we asked these patients for the most bothersome problem after breast cancer treatment. And by far, the most important problem was arm problems, and it was rated higher than fear for cancer recurrence, and also higher than any aesthetic problems, including mastectomy. So avoiding axial lymph node dissection wherever we can is an important issue. Now, we all know guidelines, and I think guidelines are the same all over the world, and these are German AGO guidelines, probably very similar to your guidelines. In patients who convert from node positivity to node negativity clinically, then undergo central lymph node or targeted lymph node biopsy and have a positive lymph node status. YPN1 micro or macrometastasis, we recommend axial lymph node dissection, awaiting randomized trials from the Alliance trial. So we have to recommend this because we do not have any data from randomized trial for omission of axial resection. And for patients with isolated tumor cell, we have a plus. So this is the plus, this is the recommendation, plus minus, meaning according to our guideline language, we do not know if we do more benefit than harm with the procedure. But was this done in clinical practice? And these are data from the Axana study, and I'm very happy and thankful that so many Greek sites participate. So we have, at the time of analysis, 4,300 patients from 26 countries and almost 300 study sites. And 2,100 of them had completed surgery and had undergone target axial resection or central lymph node biopsy or target lymph node biopsy. So we had an overall complete response rate of 56.5%, and 32.5% had YPN1 to 3 stage, 7% had micrometastasis in the central or target lymph node, and 2.3% had isolated tumor cells in the central or target lymph node. Now, what is done in real-world practice? You can see that for patients with macrometastasis, almost 25% of the surgeons omit axial resection today. They doubt if this procedure is of benefit for their patients, even in the absence of randomized trials. For patients with micrometastasis, more than 50% do not perform axial resection anymore. For patients with isolated tumor cells, almost 70% of surgeons do not go for axial resection anymore. Now, we all know data from the AMOROS trial. 10-year data is published in 2022, comparing in the upfront surgery setting, positive sentinel node axial resection to radiotherapy. There was no difference with regard to any oncologic outcome. Whoops. But there was a clear, significant difference in arm mobility, in arm edema. So, however, the elephant in the room is, can we translate data from primary surgery to the neoadjuvant setting? And there's some concern. First of all, these are data from Tracy Moore published in 2018 showing that after neoadjuvant chemotherapy, the rate of non-central lymph node involvement is much higher compared to the upfront surgery setting. In upfront surgery, we have, in patients with micrometastasis, we have in 18% additional lymph nodes. But if we have a micrometastasis in the central node after neoadjuvant chemotherapy, the rate is 64%. And so we do not know if omission, in upfront surgery, we omit axial surgery in these patients. But we are not sure if in these patients with a much higher tumor burden after chemotherapy, we should not go for axial resection. This was the conclusion of the authors of these papers. So we simply do not have data. The next hypothesis is that argue for axial resection is that chemo-resistant cells are resistant against radiotherapy. But why should they? Are chemo-resistant cells resistant against endocrine treatment? Are endocrine-resistant cells resistant against chemotherapy? So why should chemo-resistant cells should be resistant against radiotherapy? Well, with regards to axial resection, please know this is the meta-analysis of an early breast cancer collaborative group from 2005, showed that never, ever in history axillary dissection had any positive effect on oncologic outcome whenever radiotherapy was in some way part of the treatment concept. So axillary dissection has very limited or no therapeutic effect. Now, with regards to the hypothesis that chemoresistant cells might be resistant to radiotherapy. So this is a study addressing this issue, and as you can see, for patients who have a good response in the node, there is certainly effect of radiotherapy here to the chest wall. But for patients with residual disease in nodes, the effect of radiotherapy to the chest wall is at least similar, but if not higher, showing that radiotherapy is effective in chemo-resistant cells. And this is a retrospective study addressing exactly the topic that we are talking about. Should patients with a positive central lymph node or target lymph node after chemotherapy undergo axial lymph node dissection or central lymph node biopsy alone? It is retrospective, sure. 161 patients, 53 central lymph node biopsy alone, 108 central lymph node biopsy and Axillary section. And there was no difference in local control, regional recurrences, overall survival in any oncologic outcome, confirming the hypothesis that radiotherapy is not inferior in the neoadjuvant setting. And in this trial, as you can see, where did the recurrences occur? 5 recurrences in level 1 to 2, so 3 in the central lymph node biopsy group, 2 in the axial lymph node dissection group. 6 recurrences were observed in level 3 or supraclavicular, regions that we would probably not reach by axillary section, and 2 recurrences occurred in the internal nodes, another region that we would probably not address with axillary section. And the edema rate was between 25% for axillary section and 9.4% for omitting axillary section. And this is a very recently published paper from the US with very similar data as compared to the Axana study. And it was analyzed the evolution of axillary treatment within the years. As you can see here, for patients with YPN1 disease, the omission rate of axillary section between 2016 and 2019 was between 28 and 21%. So in Europe, we are probably even more conservative compared to the US. So in the Axana, we have 25% omission in this cohort, and in the US, it's going up to 41%. And for micrometastasis, there's an increase of omission of axillary section between 40 and 69%. So we have about 60% in our. So this is what is being done in clinical practice in real world. So surgeons increasingly doubt whether axillary dissection is of benefit for the patients with comparing to radiotherapy. And these are the outcome data, overall survival. And in this trial, which was certainly observational retrospective data, but it was from the National Cancer Base, with included 6,000 patients. And the overall survival was even better in the central lymph node biopsy alone group compared to the axillary dissection group. But when adjusted to potentially confounded factors, there was no difference. So at least there was no difference between axillary section radiotherapy, but morbidity is much lower. Oops. Where can I go on? What happens? Okay. So another issue. Okay, thank you. I found it. So another issue is, what exactly is axillary section? Is this a standardized procedure? Some may go for level 1, a bit level 2. Are there still surgeons going for level 3? Are there still surgeons who are able to resect level 3? So is it a standardized procedure? I would guess it is not. So we can probably address this lymph node in level 1 or 2 with axillary section. But what about supra-infraclavicular? What about internal? So why should we remove a potentially chemo-resistant node, but leave other chemoresistant nodes behind. So this does not make really sense. Another issue that is discussed by radiation oncologists is the problem of the forgotten node. This is a paper published recently by Orit Kaider-Persson. In a time where we increasingly decrease axillary surgery, radio-oncologists identify increasingly forgotten nodes because surgeons do less radical surgery. So is surgery really a standardized procedure? This is a paper we have already seen on isolated tumor cells. Is axillary resection of any benefit for patients who present with isolated tumor cells in the central lymph node? The ICAO study clearly showed that there was no benefit in this patient cohort. We could then argue that there might be a diagnostic benefit from completion axial lymph node dissection in order to upgrade the end stage and then modify systemic or local regional treatment. But for the YPN0I+ group, PCR is defined by response to the breast in most patients. There are very few patients who have a PCR in the breast and could then be upstaged by axillary dissection and then maybe receive post-neoadjuvant treatment. In PN0I+, is considered non-PSR for systemic treatment. In patients with YPN1 micro and PN1, the end stage is already classified and the patient is already categorized as non-PCR, and patients with triple negatives and HER2 positive patients will undergo post-neoadjuvant treatment with TDM1 or maybe with olaparib. There's no benefit anymore for detecting YPN2 in luminal tumors in the Natalie era. It was in the MONARCH-E era where we tried to identify it for nodes, but with the publication of the Natalie trial, all patients are candidate for CDK4/6 inhibitors. There's no need to identify more nodes. And only very few patients with luminal tumors and BRCA mutation and a CPS-EG score 2-3, who might be upgraded by axillary dissection, would benefit according to the Olympia trial. So there's very little diagnostic information from completion axillary resection that would modify systemic or local regional treatment. We will present our data on upgrade of micromets and isolated tumor cells at San Antonio in 2 weeks' time, and thanks to all GREC sites who supported the trial with many patients. So in conclusion, although axial lymph node dissection is the historic standard for YPN1, sentinel node target axillary patients, and we do not yet have randomized data from Alliance, but on the other hand, we have no evidence that axial lymph node dissection is superior to radiotherapy, but we have a high morbidity. So in conclusion, regional recurrences are rare whatever we do. There's no reason and no evidence that chemoresistant cells are radioresistant. There's no reason why a technique that depends on individual skills and covers only parts of the target area should be inferior to a homogeneous cytotoxic treatment that can be tailored to all regions of interest. There's little diagnostic information from completion axial lymph node dissection that affects further adjuvant treatment, and axillary resection is associated with high morbidity that affects quality of life. So please remember, lymph node surgery is diagnostic, not therapeutic. And focusing on lymph node treatment, and while focusing on lymph node treatment, we have to ask, do we miss the forest because of the tree? Thank you very much.
Thank you very much, Torsten. Now there is a vote. So you will see 3 questions on screen. You will have 20 seconds to vote on each question, and we will take the discussions afterwards. So please go to your QR code so that we can start dealing with that. Everybody done? No. Okay, while you're downloading it, I'm giving you a heads up. The first question is, should CN plus patients that have converted to YCN0 following neoadjuvant chemotherapy with ITC on SLNB, TAD, MLNB have a completion axillary lymph node clearance? Yes or no? Please vote. We'll give you some more time because it's more than 27 people in here. So we'll close that one. 75% of you would not offer completion axillary lymph node dissection, whereas 25% would. Let's move to the next question. And now it is the same question, but in the setting of a micro metastasis on sentinel lymph node biopsy, target axillary dissection, or marker lymph node biopsy. So would you offer completion sentinel lymph node, completion axillary lymph node clearance for these patients? Yes or no? You have to vote. More people would have to vote for that.
The timer did not register anything, so there we go.
Here you go, yeah.
About 50-50 maybe.
You still have 5 seconds to change these results. Okay. And now we're done. So the proportion is more or less the same. So in a total of 28, a little bit less than 1/4 would go for completion axillary clearance, whereas the rest would not. And now for the final question. I think that you can guess what the final question will be. So if you've got a macrometastasis during first surgery, would you go back to offer the patient a completion axillary lymph node dissection? Let's open it up and vote. Five seconds to go. Lovely. So the audience is afraid of the big bad wolf over 2 millimeters. Professor Mamounas, any comments on that?
Interesting results, and sort of expected to some extent. I think we all sort of agree that doing a dissection, at least for micrometastasis, is a standard, although we're waiting for trials. In our heart, we all know that probably it's not going to show any difference, and eventually we'll be able to avoid axillary dissection for these patients, but we're still waiting for the results of the randomized trials. But as was mentioned, in clinical practice, we often debate in our tumor boards, and sometimes we just don't do it, particularly if you have several nodes removed with only 1 positive or 2 positive, or you have done 6 or 7. We're afraid of the morbidity. We also in the US, we offer lymphovenous bypass more freely nowadays, and that at least helps us discuss with the patient an axillary dissection with a lymphovenous bypass at the same time. So it kind of sweetens the pill a little bit, and we hope reduces the risk of lymphedema. But I think the results are sort of what we expected. It's a tough topic for debate, but again, we're still waiting for more data. That's which hopefully will come not in the too distant future. We're still waiting for the Alliance 11-202 trial. Hopefully 25 or 26 will be when it will be reported.
Now, if I would have to put my money on something,
yeah.
So if I had to organize and fund a trial of this magnitude, I would make sure that it is a safe bet.
I think a lot of people, myself included, will believe that it's not going to be a positive trial because radiotherapy was used in both arms, of course, of the study. So.
Okay.
Questions?
Questions. I have a question for the audience, just a show of hands. So, for how many of you would the number of affected nodes make a difference in your decision to go for an axillary clearance, yes or no? So let's take the scenario of the 1 out of 4 nodes with a micrometastasis versus 3 of 4 nodes with a micrometastasis. How many of you would tip towards an axillary lymph node dissection if you had more nodes that were metastatic in that setting, albeit with a small burden? Don't be shy.
Yes.
Yeah. Okay. I had guessed as much. Okay. Any questions from the audience?
Yes, Professor Osman.
Thank you very much for this excellent discussion. Thank you very much for this excellent discussion. This topic is a very controversial and hot topic. And we know from NSAB-PB04 trial and also ACOSOC-Z11 and AMAROS trial show that there is no benefit of axillary lymph node dissection even if patients with positive sentinel lymph node. Our study also published in Cancer last month included 501 study and compared the patients with marked lymph node biopsy or targeted axillary dissection. And the result, 52 months of median follow-up results show that there is no difference between these two groups. It's a very low rate of local regional recurrence. We believe that axillary radiation therapy is enough to provide acceptable local regional recurrence rate. Thank you.
Thank you very much.
Yes. Yes.
I'm Dr. Natsiopoulos from Thessaloniki. Excellent debate, excellent discussion. We'll still be, I think it will be for some decades more, waiting for the results of trials. Okay, we'll have to face the master of questions, whether axillary cleaning, clearance, or is a therapeutic or an information, just an information. If we answer this question, we have the answer if the axillary clearance is a necessity after neoadjuvant chemo. We get the information just with one node. I think we don't need more information from other nodes planning the post-neoadjuvant treatment.
Thank you for this comment. I would just go and say, we'll talk about it during my second talk in the afternoon on that, but we are thinking, evidence suggests that we should be dealing with breast cancer in a much more multimodal manner. So I just think that the way that we will deal with it is that we will just need to realize that there are more than 2 or 3 tools in the box. Because right now we are thinking we had sentinel lymph node biopsy, we had axillary dissection, we put TAD or TAS or MLNB or however you want to call it. You can call it Easter Bunny for my part. But I think that the tools are not solely surgical and we need to go that way.
Thank you very much. Another question would be if not only the number of the affected lymph nodes after neoadjuvant would matter, or if the type and the number would matter, because it's another thing if you have a HER positive, if the type of the post-neoadjuvant therapy matters in your decision. How much benefit do you expect from the post-neoadjuvant therapy in this setting? And I don't know if there are any studies, which is another question, if the immunohistochemistry of the lymph nodes is another one than this of the tumor. This would be interesting to know, the immunohistochemistry of the affected lymph nodes.
This is an insightful comment. I would like a response from Torsten on that.
So I think this was a very good question. The question was if the tumor biology, the immunohistochemistry would affect.
Professor Karagatsani's question was if we would decide based on
Okay, I got it. Okay. Well, I think for the HER2 positives and for the triple negatives, the number of nodes does not matter because we decide on PCR or non-PCR to give TDM1, or in triple negatives, in BRCA negatives, we discuss capecitabine, and for BRCA positives, it's olaparib. But the decision is not made on the number of nodes, it's made on PCR or not PCR. And the majority of patients, PCR is determined by the response in the breast. So there are very few patients where it's decided on the nodes. And having a higher nodal burden, N2 or N3, would not modify the systemic treatment decision. And only for luminal tumors, we do not have a real post-neoadjuvant approach except for patients with high nodal burden and BRCA mutation. And in these patients, this is the only small cohort of patients who benefit from discovering a higher nodal burden, which is expressed in the Olympia study by the CPS-EG score, which must shift from 2 to 3. And this very small cohort of patients would benefit from additional olaparib. So this is why this is what I pointed out. We do not have diagnostic benefit from completion axillary resection for post-neoadjuvant decision making. Your second question I thought was really very, very good. If there was a difference in tumor biology between lymph node and primary tumor, and I think this indeed is a very interesting question. I think we do not have enough information on that, but I think it would really be worth going further into detail.
Yes, and given that we're a little bit late, we're going to close it. I'll very quickly that in the HER2 positive setting, when the residual disease is HER2 negative, we still see benefit from TDM1 in residual disease. It's very unlikely an ER negative patient will become ER positive. So I think it won't really change much of what we do, even if the biology was a little bit different. So with that, I think we'll close the table. Thank you very much for nice presentations and discussion. And θα κάνουμε ένα 10 λεπτό διάλειμμα και θα ξαναγυρίσουμε.
Νομίζω ότι πρέπει να ξεκινήσουμε και ελπίζω σιγά σιγά να έρθουν και οι υπόλοιποι μέσα στην αίθουσα για να παρακολουθήσουν μια πάρα πολύ ενδιαφέρουσα παρουσίαση. Δεν χρειάζεται να σας κάνω εισαγωγή για τον ομιλητή. Είμαι σίγουρος ότι όλοι το ξέρετε. Ο Λευτέρης ο Μάμουνας για ακόμη μια φορά μας τιμάει με την παρουσία του. Πολύ ενδιαφέρουσα ομιλία. Το τίτλος είναι Multi-Gene Assays, When and Which Ones.
Ευχαριστώ Βασίλη, ευχαριστώ για την πρόσκληση. Πάντα τιμή μου να βρίσκομαι εδώ. Μου επιτρέψτε να την κάνω στα αγγλικά την ομιλία για να γίνει σε ένα χρονικό διάστημα που μπορούμε να την τελειώσουμε. Let me change the settings real quick here. Okay. So we're going to talk about multi-gene assays and with the title When and Which Ones. And you already heard a little bit earlier about EndoPredict, so I'll skip some of that in the essence of time. These are my disclosures. So we all know that breast cancer treatment has evolved over the years with the introduction of important systemic therapies. We're going to talk in a minute, later on as well. And we know that from the overview analysis, data from Richard Pito, that the mortality and locoregional recurrence and distant recurrence rates have significantly decreased from the mid-80s, as you can see here from the UK and the US. But this evolution that has led to significant progress also is at the expense of significant overtreatment. As we cure more and more patients, a lot of the patients that get the therapy don't really need it. So we have to do better to identify the patients that need the treatment and those that do not. And of course, the introduction of molecular subtypes, the intrinsic subtypes by the group of Peru, Sorley in Peru, in 2000 or so, changed that because now we recognize that breast cancer is not one disease but has different subtypes that actually have different prognosis, as you see here, as well as different biology. So with that in mind, as we know, there have been several commercially available genomic classifiers, starting with the first MammaPrint, the 17-gene prognostic index, then the 21-gene recurrence score, and then the breast cancer index, and I will discuss this in a bit, as well as EndoPredict and Prosigna. So these are all commercial assays. Most of them, actually all of them now, can be done in fixed paraffin-embedded tissue. The initial MammaPrint required frozen tissue, but then eventually the assay now is doing in fixed paraffin-embedded tissue. So as we're faced with all these different classifiers, the question that we have to ask as we evaluate them is, first of all, what clinical question does the test answer? Is it the prognosis question? Is it the prediction question? And more importantly, will the test help improve treatment decision-making? I think that's the core of what we're trying to do. What type of information does the test provide? You heard about tests that provide dichotomous or trichotomous results or continuous variables. And perhaps the most important question is, what is the level of evidence behind the test? I think that's an important question. So when you make a prediction, or you make a prognostic prediction or predictive prediction, how confident are you that this prediction is correct? And of course, how practical is the test to use is not an issue anymore because all of these tests can be done now in fixed paraffin-embedded tissue. So all these genomic classifiers have clinical utility in doing a variety of things. Some do more, some do less. But essentially, all of them pretty much predict risk of distant recurrence. That's why they were developed. But of course, some also predict benefit from adjuvant chemotherapy, which is a very important part because that's a decision we need to make. Some predict risk of late recurrence and or benefit from extended endocrine therapy. And some prediction of risk of locoregional recurrence, which I will discuss as well. I won't discuss in this talk prediction of risk of late recurrence and benefit from extended endocrine therapy because we have a session in the afternoon at 5 where I'll discuss this topic, so I'll skip it for this one. So prediction of risk of distant recurrence, of course, as we know, the 70-gene prognostic index was the first one that came to the market based on the work by Laura Van Veer that's published here. 70 genes showing that early metastasis can be prognosticated by the test with a low risk and a high risk. It's a dichotomous test, or at least it was a dichotomous test. Now it's changing a little bit, and we'll talk about that. And of course, this test was put to a prospective trial, as you know, the MINDAC trial, that essentially evaluated this test for patients that have clinically high risk but genomic low risk, as you see on, let me see if I can see the point, as you see over here, those patients were treated with, if clinical and pathology were high, both were low risk, they actually did not receive therapy. If they were high risk, they received chemotherapy. And patients that have discordance between the clinical and the genomic risk were randomized to be treated according to the genomic risk or were treated by the clinical risk. And then the question here was, the main endpoint of the trial was for patients that have 70 gene low risk, but they were clinically high risk and did not receive chemotherapy, that they will do better than 92% 5-year distant metastasis-free survival. So the main purpose of the study and the main endpoint was actually prognostic, and then we'll talk a little bit about that later on in terms of prediction, because they compared the two approaches in terms of prediction. And what they showed actually when they presented the result was that the 5-year distant metastasis-free survival for this group here was 94.7%, even with a high confidence intervals, did not cross 92%. So this trial clearly showed that this is a prognostic test. We'll talk a little bit again later about prediction. And of course, then came the 21-gene recurrence score, as you know, which was validated in the B14 study for patients treated with tamoxifen, low, intermediate, and high risk. But this score statistically was found to be better fitted in a linear relationship, not a dichotomous relationship. So as the score went up, so did the risk of distant recurrence. And of course, this test also was put to a prognostic test. This was the TAILOR-X study that took patients with different recurrence scores under 11, 11 to 25, and over 25. Those that were over 25 got chemotherapy. Those that were under 11 got endocrine therapy alone, and then they followed, and we'll see the results from that. And those that were in the middle, the 11 to 25, were randomized to receive chemotherapy versus not. We'll talk about that later. But again, this study in 2015 showed that for those that had under 11 and had endocrine therapy alone, the test is very prognostic, 99.3 5-year distant relapse-free interval rate. So prognosis is clear for the low-risk patients, as we see here. And further data from this test were also obtained from the SEER data in the US in a large cohort of patients, 55,000 patients. And you can see here for patients with 0 to 10 and even 11 to 17 recurrence score with endocrine therapy alone, no chemotherapy given in these patients, 98.6, 98.1, very, very good prognosis in a large database. And also for those that had micrometastasis or those that had even N1 disease with, again, 0 to 17 scores, the prognosis was excellent. So clearly this test is also very prognostic as well. The breast cancer index, this is a test where it evolved over time. Essentially, it was the H/I ratio, the homeobox 13 interleukin 17B receptor ratio. And then they also introduced molecular grade index, was a 5-gene index, essentially related to proliferation and try to capitulate grade. And when you combine them together, then they got the BCI, which essentially categorized patients to low, intermediate, and high risk. And this is sort of a continuous score as well, but it was validated in additional data set that it is prognostic. And as we'll talk about that later on today, this is also a test that we use for prediction of late recurrence and benefits from extended endocrine therapy. But you can also use it up front if you like. And of course, I won't spend too much time because you already heard the detailed analysis about EndoPredict, the 12-gene assay, RNA-based, and again, combined with the EP, the clinical score, the EP clean. So there is EndoPredict and EndoPredict with clinical score. You heard all the data. This was validated in several of the Austrian ABC, SG, 6, and 8 trials, as well as the TransAttack trial in the low-risk group and the high-risk group. Again, prognostic, no question about it. And finally, the PAM50. Again, this is the risk of recurrence prognostic model, which also incorporates potentially clinical, like subtype model or subtype plus the T-score and subtype plus the T-score and grade, and optimizes the outcome. And even the subtype here, you can see that they're predictive. They can separate into the basal, the HER2 positives, the luminal A, luminal B. And essentially, mostly it's the luminal A patients that actually have low risk. Every other group has at least intermediate to high risk. And again, when you combine it with the clinical factors, there's a continuous score as well. So several of these tests are prognostic. I think there's a little argument about that. But what about the second question? Can we predict risk? Can we predict a benefit from adjuvant chemotherapy? Because that allows us to make a very clinical decision of whether we give chemotherapy or not. And the first evidence of that came from the NSABP B20 study with the recurrence score, as you know. The B20 study compared chemotherapy and tamoxifen to tamoxifen alone for non-negative patients. And when we went back and had the recurrence score and we looked at benefit from chemotherapy, overall the study has shown about a 5% benefit, which was significant, and a lot of patients were treated with chemotherapy because of this study. But when we applied the recurrence score, we saw no benefits in the low recurrence score category, pretty much no benefit in intermediate risk category, and about a quarter of the patients that were a high recurrence score appear to have pretty much all the benefit from chemotherapy, recurrence score of 31 or greater. So this was for non-negative patients, and then there was another retrospective study, the SOGATE 814, for postmenopausal patients with not positive disease that looked at the recurrence score and essentially showed the same results. No benefit from under 18, no benefit 18 to 30, and benefit in 31 or greater. And with that in mind, this was again put into the prospective trial validation. And this was the TAILOR-X that I showed you before, score of 11 to 25. And why 11 to 25 versus 18 to 30? We shift the cut points a little bit just to be more conservative. We shift them to 11, and then, of course, we shift the other one from 30 to 25 to make it, from 18 to 25 to make it more applicable. And so they were randomized to endocrine therapy alone or chemoendocrine therapy, and this is a large study. Almost 7,000 patients were randomized between the two groups. And as you know, the results showed absolutely no difference in the benefit from chemotherapy between the chemoendocrine therapy and endocrine therapy alone in this invasive disease-free survival as well as distant recurrence-free interval. These results now persist with 12 years of follow-up. I'll show you some data in a minute. But that was the original presentation. So when you then, at the time they presented that data, looked at different groups between 16 to 20 score, remember under 15 or 11 did not get any benefit, up to 15 did not have any benefit, but 16 to 20 and 21 to 25, what we see here, there was benefit for patients with 21 to 25, but it was only in premenopausal patients under 50 years of age with recurrence score against 60 to 20 or 21 to 25. So postmenopausal patients, absolutely no difference, but premenopausal patients had benefit if they had recurrence score of 21 to 25, irrespective of clinical risk, low or high clinical risk. And those 16 to 20 had benefit if they were high clinical risk, but not if they were low clinical risk. And these are the 9-year data, but this data, as you will see, also persists at 12 years. But when you look at according to age in the premenopausal patients, you see that potentially an emerging pattern is that maybe is related to indirect effect on ovarian function suppression. Because when you look at here, patients under the age of 40 that were premenopausal did not receive any benefit from chemotherapy. And then you see 41 to 45, 46 to 50, premenopausal received benefit from chemotherapy. But for 41 to 45, for 46 to 50, if they were premenopausal, there's benefit from chemotherapy, but if they're postmenopausal, there is no benefit from chemotherapy. So you can argue, why did these patients not get any benefit from chemotherapy if it was a direct effect? Because usually those patients will resume their menses even after you give them chemotherapy, so they're still premenopausal. But these patients are likely to become postmenopausal because of chemotherapy. And these patients that are young, but they're already menopausal, don't get any benefit. So that kind of makes sense that the effect may be more an indirect endocrine effect and not a chemotherapy effect. Again, these are the 12-year data from the TAILOR-X showing exactly the same thing. The difference is now a little bit higher. This is for patients with a 21 to 25 and high clinical risk, 11% difference. For 21 to 25 with low clinical risk, there's still about a 6% benefit from chemotherapy. But for those 16 to 20 with high clinical risk, the benefit is now about 3%. So it's a little bit less, and obviously no benefit for low clinical risk for 16 to 25. And again, this is based on a significant number of patients, so the estimates are pretty good. And of course, then after the TAILOR-X, once we did it in non-negative patients, then the other question is, what about no-positive patients? So the responder trial took patients with 1 to 3 positive nodes, ER positive, of course, HER2 negative, and if they had a recurrence score result of 0 to 25, they were randomized to endocrine therapy or chemoendocrine therapy. The majority of these patients received tamoxifen as their endocrine therapy, but about 13% had ovarian function suppression and either tamoxifen or an aromatase inhibitor. And the results of the trial essentially showed a little bit of benefit, very small benefit, but initially was statistically significant when they presented San Antonio. When they published it, actually wasn't even significant at p-value of 0.10, and about 1.2% absolute benefit in favor of chemotherapy. But then again, when they looked at it according to menopausal status, postmenopausal patients, their lines are practically superimposable, but premenopausal patients appear to get about a 5% benefit from the addition of chemotherapy. Again, is this a benefit for direct cytotoxic effect, or is this a benefit from indirect endocrine suppression of the ovaries? Again, similar to the TAILOR-X, about 13% of the patients in both studies only had ovarian function suppression. The majority did not. Going to the MINDAX study and looking at MammaPrint in terms of prediction of chemotherapy benefit, again, the discordant cases, the high clinical risk, low genomic, were randomized to be treated according to the clinical risk or the genomic risk, and essentially chemotherapy versus no chemotherapy. And none of the differences were statistically significant here, but for the high clinical and low genomic risk, there was a little bit of a trend in favor of chemotherapy. For the low genomic and high clinical, the low clinical and high genomic risk, you would have expected more chemotherapy benefit, but you don't see at all chemotherapy benefit here. But you do see a little bit of trend here. But this study as well, and I'm putting them now all together, the TAILOR-X, the MINDAX, and the responder, also showed that the benefit of chemotherapy appeared to be in the younger women under the age of 50. So when you look at all of the 3 studies, there was no benefit in postmenopausal, but a significant benefit in premenopausal patients who are under the age of 50. Now, when you look at these genomic classifiers, another indirect effect of chemotherapy benefit will be pathologic complete response after neoadjuvant chemotherapy. And of course, we've seen now several data sets, including with a recurrence score here, both pathologic response and clinical response in the Jenny Cheng trial, and some with the 17 gene index as well as the breast cancer index, showing that in the low end of the genomic classifier, low recurrence score here, low MammaPrint here, and low BCI here, pathologic complete responses are essentially not even there at all, or very, very low. And only in the high end of the recurrence score we see pathologic complete responses. Same thing with the MammaPrint. And of course, now MammaPrint has 2 categories of high risk, of MP1 and MP2. And MP2 is the one that has actually most of the pathologic complete responses, not so much for MP1. So essentially, even MammaPrint becoming more of a 4 different cut points here, 4 groups rather than 2 groups. So the question is, if those low genomic patients don't get pathologic complete responses, where is the effect in the premenopausal patients coming from? And again, we come back to the issue of potential for ovarian function suppression. So why the difference in chemo benefit between age menopause in patients with a low intermediate genomic risk? Again, the hypothesis is that perhaps this is not a cytotoxic effect, but an indirect endocrine effect of ovarian function suppression with chemotherapy. And to address this hypothesis, we actually now have designed and opened a study in the NRG, the so-called NRG BR009 or offset trial. And essentially, we base this trial for the findings from the responder and TAILOR-X. So the patients from responder and TAILOR-X that had benefit from chemotherapy, which are the premenopausal, for the PN0, 16 to 20 with high clinical risk, or 21 to 25 irrespective of clinical risk, or PN1, as in responder with a 0 to 25 recurrence score, they're stratified and randomized to ovarian function suppression plus an aromatase inhibitor, essentially maximizing the endocrine therapy, and then with or without chemotherapy. So this study, hopefully, if whenever it's done, which is going to take about 10 years, if it shows no benefit, I think we would have finally, get us to where we need to be, that we use the genomic classifier to predict lack of response to chemotherapy. I think that's an important point, despite of having higher clinical risk sometimes, even with up to 3 positive nodes. Now, an interesting observation that actually supports this notion of indirect endocrine effect is the data that were presented at the ASCO meeting from the Respondent trial looking at serum AMH, anti-Müllerian hormone, which is a marker for prediction of residual activity in the ovaries, right? And so, for example, if patients that have low AMH score at the final menstrual period, there was less than 10%, medium was 10 to 99%, and high was over 100%. And when you look at it according to age, what you find here is that for patients under 45, only 2.9% had low AMH. Essentially, they had ovarian reserve. But 45 to 49, about 14% had ovarian reserve, and 50 to 54, only 52% had ovarian reserve. More importantly, when they looked at the effect of chemotherapy according to AMH levels, for patients that have low AMH levels, there were no benefit from chemotherapy. These were essentially younger patients. They took under 55 and look at their AMH. And if the AMH was low, there's no benefit. But if the AMH was high, in other words, they still had ovarian reserve, the benefit was about a 7.8% absolute improvement. So even a better categorization, as in the Responder trial, based on the AMH. So I think this is something that we can potentially use now to actually predict if a patient is essentially, even if it's younger and may have some menstrual cycles or very close to the final menstrual cycle, if the AMH is low, there shouldn't be any benefit from chemotherapy. So what about the guidelines? What do the guidelines suggest against the US guidelines, the NCCN guidelines, looking at the postmenopausal and 0 or N1 patients with 1 to 3 hormone receptor positive, HER2 negative, essentially strongly consider the 21 gene assay for patients with tumors over 0.5 centimeters, so T1B and above. And of course, those patients, if they have a low recurrence score, adjuvant endocrine therapy alone. If they have recurrence score over 26 or greater, adjuvant chemotherapy. So this is for postmenopausal with N0 or N1. For premenopausal, though, things get a little bit different. For premenopausal N0, based on the Taylor-X, again, strongly recommend the recurrence score for tumors over 5 millimeters. And then again, the decision is based on what you see, under 15 endocrine therapy with or without ovarian suppression, 16 to 25 chemotherapy, or endocrine therapy, depending, again, and then over 26 chemotherapy because they benefit. And lastly, in the premenopausal with N1 disease, then here we can say we use any of these genomic assays that I mentioned to you for prognosis, but essentially not any of them predicts essentially benefit from chemotherapy, and usually we'll give chemotherapy followed by endocrine therapy, but also they talk about ovarian function suppression, they still as an option. The ASCO guidelines essentially very similar for postmenopausal over 50. Again, the Oncotype DX. The MammaPrint is indicated for patients with a high clinical risk, not for low clinical risk. And again, not for patients with a premenopausal under 50. And then EndoPredict and Prosigna, again, for postmenopausal patients over the age of 50, but not for the premenopausal patients. And so these are the guidelines, at least for the US. Now, the last topic I'd like to talk about is prediction of risk of locoregional recurrence. Because, of course, we have made significant progress in assessing risk of distant recurrence with genomic classifiers. But when it comes to locoregional recurrence, we still use traditional anatomical pathologic factors. For hormone receptor positive, HER2 negative, you can use genomic profiling. And I'll show you the data to support this, at least for assessment of risk of recurrence. Whether it makes a difference in treatment, that's a different question. And of course, for those that triple negative and HER2 positive, we take them to the path of neoadjuvant chemotherapy. And again, based on response to neoadjuvant chemotherapy, we can also predict the risk of locoregional recurrence. And we'll talk a little bit about that in subsequent talk. And some of the ER positive, HER2 negative patients that are high risk can also go through the neoadjuvant chemotherapy pathway as well. So the current available evidence with genomic profiling provides considerable insight to tumor biology, for sure, and this locoregional behavior. However, it's fair to say that at the present time, this has not yet resulted in meaningful changes in how we manage patients. Of course, the question you can ask is, can genomic profiling affect surgical management of the breast or the axilla? And the answer is it does not. We do the same surgery based on anatomic extent. We don't base it on on biologic factors. And of course, with neoadjuvant chemotherapy, we can reduce the extent of surgical resection based on response. But in traditional model of surgery first, the genomic profiling has very little effect or influence in the extent of surgical therapy. But on the other side, by individualizing at least or locoregional recurrence with genomic classifiers, can we actually tailor locoregional radiotherapy? Can we tailor breast radiotherapy after breast conserving surgery, or can we tailor post-mastectomy or regional nodal radiotherapy? So let's talk about that first, breast radiotherapy. Well, again, in a study from Dana-Farber a few years ago now, they looked at locoregional recurrence by subtype for patients that have breast conservation and radiotherapy, and they found essentially that patients that have triple-negative and HER2-positive disease had a lot more local recurrence in the breast compared to the luminal A and luminal B, and luminal A and luminal B patients had actually very similar rates. Now, that was before anti-HER therapy, and it was also before some of the more modern therapies for triple-negative breast cancer. So it's fair to say that these lines have come down now, but nevertheless, it isolated the luminal patients as those that potentially have low risk of in-breast recurrence after surgery first. And of course, we published data with the Oncotype since we had the data from the distant recurrence. We went back and looked at locoregional recurrence, and we did so for patients with tamoxifen or for patients with chemotherapy plus tamoxifen in the NSABP studies. Non-negative patients here, you can see that the recurrence score stratifies this of locoregional recurrence to low, intermediate, and high, even with tamoxifen alone or chemotherapy plus tamoxifen as well. And also in Europe with EndoPredict, the ABCG-A trial showed that the EndoPredict predicted risk of locoregional recurrence. The difference was small here, but again, locoregional free survival 98.6 for EndoPredict low versus 96 with EndoPredict high. And within that study also, they had a randomization between radiotherapy or not. It was like a 4-to-1 randomization. But what essentially this showed was that if you have low EndoPredict score, you still benefit from radiation. If you have high EndoPredict score, you still benefit from radiation, but you do better if you have the low score with radiation. So essentially showing that EndoPredict is prognostic of local recurrence, but not predictive of radiotherapy benefit, which is true also so far even for the Oncotype score. So as a result, there have been now several prospective trials that looked at the effect of omitting radiotherapy. Most of them that I will show you today with results, these three first, Lumina, IDEA, and Precision, were single-arm prospective trials where highly selected patients were not given breast radiotherapy. The EXPERT is a randomized trial. We have not seen results yet comparing radiotherapy versus observation. So this is the luminal study that they looked at Ki-67 less than 13.25% for clinical T1 and 0 patients with ER-positive, HER2-negative breast cancer treated with endocrine therapy. And their primary endpoint was in breast recurrence. And they said if we get anything less than 5% that without radiotherapy, that would be good. And they got a 2.3%, and even the confidence intervals did not reach the 5%. So that's very encouraging. Of course, we have followed for a longer time, but this was the first demonstration these patients can be treated without radiotherapy safely. The IDEA trial took patients 50 to 69, and with the oncotype of 18 or less, and did the same thing prospectively with endocrine therapy, no radiotherapy. And again, when you look at the in-breast event here, 3.3% or 3.6% depending on the age, but very similar. So very good outcomes, again, without radiotherapy in highly selected patients. And the Precision trial used the PAM50 ROR, and again, 50 to 65, a very low rate of in-breast recurrence without radiotherapy. In fact, it was a little bit lower than the contralateral breast cancer. So when you think about it, these patients are at risk of local recurrence, but also at risk of a new primary in the breast. So it's not fair to say our goal is not zero. Our goal is to get it to the same level as contralateral breast cancer. And so far, these studies support that, but again, they're not definitive. In the US also, we're running a large phase 3 trial, the DEBRA trial. Again, very similar oncotype under 18, and then randomization between observation, endocrine therapy, or breast radiation and endocrine therapy. Large study, 1,670 patients, we're about 1,200 in. So hopefully that study will be done soon. So again, when the results of these studies become available, I think we might be able to then de-escalate in-breast radiotherapy for patients that were selected by the genomic classifier. But the question here, all these are prognostic tests, and can we get a predictive test of radiotherapy benefit? And this is what this polar profile essentially trying to do, that was presented in San Antonio and eventually published now, JNCI. They looked at this profile as a potential predictor of radiotherapy benefit. So essentially, this is from the Swedish BCG91RT trial for non-negative patients who received whole breast radiotherapy or not. They developed this classifier, which essentially is a gene expression data in 764 patients. And eventually, they came up with a 16 mRNA-based signature that actually predicted outcomes in terms of, and also benefit from radiotherapy. So this is the results from the Swedish trial. You can see for the low polar signature, there was low risk and no benefit from radiotherapy. In the high signature, there was benefit, a higher risk but significant benefit. This was true for the Princess Margaret study as well as the Scottish Conservation trial. So 3 trials showing essentially the same thing. And then they did a meta-analysis of the 3 trials, again pointing to these results, no benefit and very low risk for the polar low, benefit from radiotherapy. And here, the interaction was statistically significant. So obviously, this needs further validation in prospective trials. We may be able to go back and do it in the DEBRA trial as well when the results become available. But that's very promising in terms of the predictive factor. So last thing, what about post-mastectomy regional node radiotherapy? Can we use genomic profiling for that? And again, we know that post-mastectomy patients with any number of positive nodes benefit from radiotherapy. These are the results of the overview analysis. One can argue these are older data, and the rates are pretty high without radiotherapy here. However, even more recent data, for example, from the MA20 study looking at the effect of regional node radiotherapy, do see benefit in disease-free survival, and distant disease-free survival, very borderline for overall survival sometimes. And also the EORTC trial, again, the effect of regional node radiotherapy after PMRT has shown benefit in distant disease-free survival and overall survival. So the question is, since this has become pretty much the standard for node-positive patients, can we find groups that perhaps don't need regional node radiotherapy? Again, going back to some of the Oncotype results from the B28, now this was a node-positive trial, patients treated with chemotherapy. Again, very similar results. You can see that it stratifies this of locoregional recurrence. And even according to number of positive nodes, this is interesting because even for a number of 4 or more positive nodes with a low Oncotype score, the risk is no different than patients with 1 to 3 positive nodes. So, and this was validated also in other signatures, like in other trials, the ECOG 2197 and the SWOG trial also saw the same things with the Oncotype DX. So now we have another prospective trial in the US and Canada. This is the Canadian Taylor RT trial that takes patients with 1 to 3 positive nodes and have a low Oncotype score of less than 25 and randomize them to regional radiotherapy or no regional radiotherapy. So this is the potential to de-escalate the also radiotherapy for patients with 1 to 3 positive nodes. But again, in this setting, can we develop predictive markers as well? Interestingly, when you go back to the Danish trials, the post-mastectomy trials, the benefit from these trials essentially in terms of locoregional recurrence reduction and survival came from the luminal patients, the ER positive, HER2 negative, or ER positive, HER2 positive. There was less effect of radiotherapy in triple negatives and less effect in HER2 positives. Now, again, that's before anti-HER therapy, so these results may not be applicable today. But nevertheless, we tried to de-escalate in luminal patients where the benefit here was robust, right? So you have to keep that in mind. So the same group actually, now are trying to develop a predictive marker for post-mastectomy radiotherapy benefit. And again, they came up with 7 genes whose transcripts interact with PMRT to modify the hazard of locoregional recurrence. And what they essentially found in this test and validation set is that low risk with this new classifier showed no benefit from radiotherapy and very low risk, but high risk for this classifier showed significant benefit from radiotherapy. So again, more validations may be needed for this, but that's the right direction. So, in summary, genomic profiling has been established and continues to evolve as a useful tool in the multidisciplinary management of early-stage breast cancer. There have been several commercially available genomic classifiers that independently predict risk of recurrence in non-negative and non-positive patients, and some classifiers also predict benefit from adjuvant chemotherapy, but again, to a varying level of evidence between the tests. Genomic profiling also has emerged as a useful tool for the prediction of risk of local regional recurrence, and now studies are currently evaluating the role of breast and regional nodal radiotherapy for patients with a low genomic score, but it hasn't really yet changed our practice. So with that, thank you very much for your attention. And happy to answer any questions.
Thanks a lot, Terry. Excellent talk. Any burning questions?
No.
Thank you very much.
Okay. Thank you.
Dr. Xapapadakis, would you like to join us?
Θα χρησιμοποιήσω αυτό. Ευχαριστούμε πάρα πολύ τον κύριο Μαμουνά που είναι εδώ και μας τιμά με την παρουσία του. Ευχαριστώ πάρα πολύ τον κύριο Βενιζέλο που με έχει καλέσει στο συνέδριό του για πολλοστή φορά. Και το επόμενο θέμα αναφέρεται σε όλη την ιστορία της χειρουργικής του μαστού. Από την ριζική μαστεκτομή στην αποφυγή ακόμα και της βιοψίας του λεμφαδέα φρουρού. Σας ακούμε. Ευχαριστούμε πάρα πολύ.
Thank you very much. And so we'll talk now about the evolution of axillary surgery, not overall surgery, because otherwise it would take a lot longer. But again, with the title of From Radical Mastectomy to Omission of Stent Lymph Node Biopsy. And of course, we all know how much progress we have made in the local regional management of early stage breast cancer. This is how we were treated when I was still a medical student. That was many, many years ago. Radical mastectomy, and of course then modified radical breast conservation, and of course the stent lymph node biopsy also revolutionized how we approach the axilla. Now we did that not in vacuum, but we did that in the face of significant escalation of adjuvant systemic therapy. And I think we all have to acknowledge that our success as surgeons and local regional therapists comes because of all the progress that our medical oncology colleagues have made in chemotherapy, as you can see here, CMF, anthracyclines, taxanes, dose density, anti-HER therapy, carboplatin for triple negative, and immunotherapy, and of course the whole endocrine therapy evolution with tamoxifen, aromatase inhibitors, ovarian function suppression, extended endocrine therapy, as well as CDK4/6 inhibitors. So these two trends working together allowed us to de-escalate surgical therapy, not only in the breast, but more importantly in the axilla. And so we know that axillary management has also undergone significant evolution. As you know, from the Halsted radical mastectomy, that was a standard till the late 80s, when the BO4 trial showed no significant survival advantage from elective axillary lymph node dissection, and other trials as well. And even after that trial was presented, still axillary dissection was how we managed the axilla. We did so because it provided us with very good local control. That was the only procedure we can do. Staging was important to understand what the stage of the patient was, and also to help with the decision of optimal systemic therapy. Back in those days, if you had positive nodes, you got chemotherapy. If you had negative nodes, you did not. And of course, then stent lymph node biopsy came to play, and of course, it can provide us with the same prognostic information or treatment decision information with a lot less morbidity, right? So with that in mind, there has been a roadmap, as you already have heard, and what I'm saying, most of what I'm going to say is been said before and will be said again, but essentially we eliminated axillary lymph node dissection for patients that have a negative sentinel lymph node biopsy. We substantially diminished axillary lymph node dissection for patients that have 1 to 3 positive sentinel lymph nodes. And of course, we diminish the use of axillary dissection for patients that present either with clinical or subclinical involvement of the axilla with neoadjuvant chemotherapy and then application of sentinel lymph node biopsy you heard already in the debate earlier today. So this is NSABP32 for historic purposes. We were discussing in the break, what is the purpose of these large randomized trials? I think the purpose is to give us now the certainty that we did not miss anything back then. By the time we finished and presented this trial with 5,600 patients, everybody was doing sentinel lymph node biopsy. And for negative sentinel nodes, nobody was doing axillary lymph node dissection. But certainly it's nice to see the curves, that there's no difference in disease-free and overall survival. Axillary recurrence was very, very low. And of course, significant morbidity, less morbidity with sentinel lymph node biopsy versus axillary dissection. And of course, then that led to the next step, which is what about patients with 1 to 2, or then eventually 1 to 3 positive nodes, ACOSOC Z11, you know that. That trial accrued less patients than originally thought, but nevertheless, with about 900 patients or so, 1 to 2 positive nodes. They had to have lumpectomy and breast radiotherapy, randomized to completion axillary dissection versus not. No difference. If anything, the sentinel lymph node biopsy line is on top of the axillary dissection. And about 27% of the patients are positive non-sentinel nodes in that trial. So leaving significant number of positive nodes behind did not seem to make a difference. Axillary recurrence was very low, 0.5% with axillary dissection, 1.5% with sentinel lymph node biopsy alone. And of course, in this table, I'm showing you all the studies since, otherwise it will take a long time. But again, what you see here in terms of with the ACOSOC as the sort of the reference, no patients had mastectomy here. 27% had positive no-sentinel nodes. You see the axillary recurrence, we talked about it. And then the next study was the IBCSG 2301. Some mastectomy patients, 9%. This was with micrometastasis in the sentinel node, more than one micrometastasis, one or more. And again, 13% of the patients have non-sentinel nodes, so less axillary burden. Again, same results, no difference in disease-free overall survival, very low local recurrence. The AMAROS trial comparing radiotherapy to completion axillary dissection, 1 to 3 positive nodes. 18% of patients have mastectomy, about a third had residual disease in non-sentinel nodes. Very similar results in favor of radiotherapy. Actually, the local recurrence was less with axillary dissection. However, no significant difference. Less lymphedema, though, with radiation versus completion axillary dissection. The Synodar trial with less follow-up, only 3 years. Again, you see about 44% of the patients positive non-sentinel nodes. More mastectomy patients. Progressively, we're getting more comfortable in including mastectomy patients. Very low rate of local recurrence in 3 years. And lastly, the Xenomac trial, the largest so far, 2,500 patients. About a third had mastectomy, 36%, and 44% had positive non-sentinel nodes. Very low rate of local recurrence at 5 years. So again, this established pretty much that even with patients 1 to 2, 1 to 3 positive nodes, sentinel lymph node biopsy alone is fine. Whether you want to give radiotherapy to regional nodes or not, thank you. That's a different question, but nevertheless appears to be good local control irrespective. Then going to the effect of neoadjuvant chemotherapy, which you heard before, I won't spend too much time. We know that neoadjuvant chemotherapy downstages the disease in the axilla. With the new regimens that we have nowadays, about 50 to 75% of the patients that have positive nodes will convert to negative. Tremendous opportunity to de-escalate axillary surgery with sentinel lymph node biopsy. And again, what we focus here is to, again, apply sentinel lymph node biopsy and not axillary lymph node dissection, but also there's possibility to de-escalate regional radiotherapy, or very briefly talk about the B51 trial. And again, to mention that this approach is primarily applicable to patients with clinical T1 to T3, clinical N0, N1 disease, because the feasibility and accuracy of sentinel lymph node biopsy for patients with locally advanced breast cancer, clinical T4, clinical N2, IBC, inflammatory breast cancer has not been shown, or in fact has been shown to probably not work very well. Now, whether this is different with the targeted dissection is a different question. So there was a lot of debate initially for patients with clinically negative axilla, so would do the sentinel node before neoadjuvant chemotherapy or after. The bottom line is it's better to do it after, because there are subclinically involved nodes that you can potentially sterilize. And now meta-analyses have shown no difference in the identification rate or false negative rate whether you do it before surgery or you do it after surgery. But for patients that present with documented disease in the axilla, clinically no positive, is it safe to avoid axillary dissection? Again, here there are 4 prospective trials, as you can see here. The 71, the Centeno, the Thorsten was involved. The Canadian trial, where they did also immunohistochemistry in the sentinel node, and the French trial. All this showed essentially a false negative rate that was a little bit higher than we anticipated. We wanted about 10%, but it was 14% here. And only the Canadian trial was under 10%, again, because they did immunohistochemistry in the sentinel node and identified disease that was very not apparent otherwise. And of course, consistently in these trials, we saw that if you remove more sentinel lymph nodes, the false negative rate goes down to almost single digit, but it's still high single digit. It's not low single digit. And again, so we said if you're going to apply that, do dual mapping, take at least 3 sentinel nodes. And then, of course, became the issue of the targeted dissection, which is in the 1071, the notice that when the clip of the biopsy node was in the sentinel lymph node biopsy specimen, the false negative rate was much lower, 6.8%, but was about 19% if the clip was in the axillary dissection specimen. In other words, they didn't take it out with the sentinel node. And of course, that led to this concept of targeted axillary dissection, the data from MD Anderson, when they took patients with positive nodes before, they became clinically non-negative, and then they either counted the sentinel nodes only, the clip node, or both. And what essentially they found was if they just counted the sentinel nodes only, about 10% false negative rate, which is what we expect. If they only counted the clip node, 4.2%, and when they counted both, 1.4%. The reason for that is in about 23% of the times, the clip node did not identify as a sentinel node because there was a bypass of the lymphatics, and it went to the non-sentinel nodes that became essentially the sentinel nodes. And of course, this was also prospectively validated in the RESAS trial. As you know, in Netherlands, they put a radioactive seed, and when they remove the radioactive seed, they call it the Mari procedure, just essentially the clip node. And with that, they had a false negative rate of about 7%. But in the RESAS trial, where they also added sentinel lymph node biopsy, lymphatic mapping, and sentinel lymph node biopsy, with the clip node removal, 3.47%. So again, this is a very accurate procedure, much more accurate, I think, by just doing sentinel lymph node biopsy, even if you remove 2 or 3 sentinel nodes. Of course, the argument against doing TAD and just taking 3 nodes is that the local recurrence rate is so low and is not necessarily any different between the 2 procedures. Here are older studies for patients that have clinical N0 and 1 and 2, and they were downstage. They had just sentinel lymph node biopsy, no axillary dissection, and it's with very variable follow-up, but you see very, very low single digits local recurrence. And more recent studies, as you can see here, some with TAD, some with sentinel lymph node biopsy as a single tracer, you can see very low rates, but again, the follow-up here is a little bit shorter. Now, the question that you want to be accurate is not so much in terms of local control, though, because radiotherapy typically will do that if radiotherapy is given, but it's also because of what happens after in terms of systemic therapy. Again, TAD versus sentinel lymph node biopsy in the retrospective study, again, not prospectively, but nevertheless, no difference in the local recurrence. Very, very good. But the reason you want to do it is because it affects what you do afterwards. So you have to be as accurate as possible, because nowadays, as I will show you, there's an issue about whether you need to give radiotherapy or not. So you need to get it right. And of course, adjuvant systemic therapy is very important. And all this has resulted in survival benefits. So you don't want to shortchange the patient and not give him the appropriate treatment because you didn't do the nodal assessment correct. So all these do that. In addition, nowadays in the US and worldwide, we're running several clinical trials that we escalate or de-escalate post-neoadjuvant therapy based on what we find in the axilla and also what you find in the breast, but the axilla also plays a role. So we have to make it right as well. We debated this, so I won't spend too much time on this. What do you do if the sentinel node is still positive after neoadjuvant chemotherapy? And then you can see that non-sentinel lymph node positivity is pretty high in some of the studies that I'm showing you here. And therefore, the standard at least is to do an axillary dissection. We're hoping that this study will be negative. We all think they're going to be negative. And when these reports, obviously, that would change the standard. But as you saw from the debate, depending on the number of nodes, the size of metastasis, and number of nodes removed, there is leeway in terms of what people do nowadays. Again, micromets, same thing. They still have a significant rate of non-sentinel lymph node positivity. ITCs, not so much. Again, in this study, it's about 37%. So I think it's fair to say that for ITCs, you probably skip it. For this, we're still going to debate. And as you voted today, some skip it, but some don't. And this is data, again, from ITCs, where they found that about a third of the patients with ITCs in post-neoadjuvant chemotherapy, when they do axillary dissection, you find more disease. But 18% of that was more ITCs, and only 12% were micromets. And of course, whether you had an axillary dissection or not, it didn't make a difference clinically, but again, this is not a randomized comparison. So now shift gear a little bit and let's talk about regional nodal radiation. Can we use neoadjuvant chemotherapy to actually de-escalate regional nodal radiation in the axilla? And again, we know that radiation works well for upfront surgery, but we don't know if it works so well or is needed for patients that have positive nodes but convert to negative. And that led us to the design and conduct of the NSABP-B51RTOG1304 that we've discussed previously. Even last year we were here discussing this. And this was presented in San Antonio. Happy to say that the paper has been submitted, and we'll see what happens. But again, this took patients with 1 to 3 N1 disease, positive nodes but documented by biopsy, neoadjuvant chemotherapy, they became clinically non-negative, axillary dissection, sentinel lymph node biopsy, or both. And then if there were negative nodes, pathologically, randomization to regional nodal radiotherapy or not. The primary endpoint was invasive breast cancer recurrence-free interval. And as you can see, with 5 years of follow-up, we see no significant difference between the two groups. Only 9 events separate the regional nodal radiotherapy versus the no-regional nodal radiotherapy. Most of them were local events in the axilla, in fact. And absolute difference, 0.9%. And again, when you look at all the secondary endpoints, isolated locoregional recurrence-free interval, distant, disease-free survival, overall survival, you see no difference so far. Now, the devil sometimes is in the details. We did subset analysis according to stratification factors, no difference in the effect of radiotherapy according to surgery, receptor status, HER2 status, PCR in the breast or adjuvant chemotherapy. But then we did an exploratory subgroup analysis according to the age of the patient, race, tumor subtype, and axillary surgery. And there was no significant difference in any of the factors except tumor subtype. And with the tumor subtype, there were some interesting findings, to say the least. Whether they were spurious or they mean something, we'll have to wait for more follow-up. But for triple-negative patients, radiotherapy appeared to do worse if you don't get radiotherapy. This favored no radiotherapy. In other words, twice as much recurrence if you didn't get radiotherapy as if you did. I don't know why. I don't have any possible explanation for this. On the opposite side, ER-positive HER2-negative patients appear to get some benefit with a hazard ratio of 0.41, so about a 60% reduction. So obviously those patients potentially can get more recurrences in the future. We'll have to follow them. These patients probably is unlikely that will change because most of the events in triple-negative breast cancers have already occurred, I think, in the trial. And HER2-positive subtype did not seem to make a big difference. They were about a 1. So we have to be a little bit more cautious for ER-positive HER2-negatives, but for triple-negatives, I think my advice to patients that we see now is just not to give regional radiotherapy. But more follow-up certainly is needed. So in conclusion, essentially, we showed that it's oncologically safe to avoid radiotherapy, at least at this point of follow-up, based on the results of this trial. And so we'll see what happens in the future. What are some relevant questions nowadays for axillary surgery? Well, the two opposing trends here. One is, can we even omit sentinel lymph node biopsy? What do we need it anyways if we're not going to affect our treatment? On the opposite side, do we need to escalate axillary surgery to make eligibility, patients eligible for these novel therapies that we have developed? So when it comes to the escalation of sentinel lymph node biopsy, avoid sentinel node biopsy, it's probably in the postmenopausal ER-positive HER2-negative patients that is sort of the low-hanging fruit. Because for those patients, we don't need to know the nodal status to give them therapy. We use genomic profiling. So can we avoid sentinel lymph node biopsy for these patients? Is local control or systemic control compromised? Again, the rationale is no therapeutic advantage for axillary dissection. We now have preoperative axillary ultrasound and core needle biopsy for suspicious nodes that have at least 80% sensitivity. And also, if you have a negative axillary ultrasound, it excludes N2 and 3 disease with negative predictive value 93 to 96%. In other words, if the axillary ultrasound is negative, you have almost 93 to 96% that you're not going to have 4 or more positive nodes. And again, for postmenopausal ER-positive HER2-negative patients, knowing the nodal status doesn't affect adjuvant systemic therapy decisions. However, having said that, nodal status and genomic classifiers can potentially dictate use of adjuvant CDK inhibitors, duration of endocrine therapy, and use of post-mastectomy and regional nodal radiotherapy, unless we found a way, as I showed you before, that you potentially can de-escalate local-regional therapy because of genomic classifiers. So this may go away for at least low-burden disease. So What evidence do we have so far for omission? One trial so far reported, the SOUND trial by Oresti Gentilini. T1 and 0 breast cancer under 2 centimeters, undergone breast conservation and breast radiotherapy, negative axillary ultrasound, randomization between having a sentinel biopsy with axillary dissection if there were a lot of nodes, but there weren't a lot, and then no axillary surgery. They have already shown that doing sentinel biopsy does have some postoperative disability. It's not an innocuous thing, but 24% in the sentinel biopsy arm versus 10% in the observation arm. And then these are the results, 1,463 women, median age 60 years, median tumor size 1.1 centimeters. It was T1, but again, low T1, as you can see here. Almost 88% of hormone receptor positive, HER2 negative. And again, in the sentinel lymph node biopsy group, 13% of the patients had positive sentinel nodes when they had surgery. Median follow-up was 5.7 years. And again, the results speak for themselves. These were presented in St. Gallen a couple of years ago and published in JAMA Oncology. And you can see no difference in 5-year distant disease-free survival, no difference in local recurrence, no difference in distant recurrence, and no difference in death rate. Of course, again, more follow-up is needed. Some of the overview analysis have shown that even 15 years later you may have events, so we definitely have to see more. There are other studies, and I hear that this INSEMA, which is a large trial from Germany, will be presented in San Antonio, I believe. So we're very interested to see the data from that trial. I don't know what part will be presented, but nevertheless, several other either randomized or prospective trials are examining the same question. The last topic, do we need to escalate surgery to allow patient eligibility for neoadjuvant therapies? That was debated a little bit earlier today. What therapies are we talking about? For example, chemotherapy in the Responder trial for patients with 1 to 3 positive nodes, Oncotype DX of 0 to 25. For premenopausal patients, there was chemotherapy benefit. Postmenopausal patients, there was not. But what if they had 4 positive nodes and they only had a sentinel lymph node biopsy? Would they benefit? The Monarchy with amebaciclib in patients with 4 or more positive nodes was the eligibility, or 1 to 3 with some other high-risk factors. Olympia, which evaluated olaparib in BRCA positive. Most of them were triple negative patients, but there were also hormone receptor positive, HER2 negative, and very few of them actually were in the adjuvant therapy group, so they had to have 4 or more positive nodes to get in. But if they were in the neoadjuvant group, as Thorsten already explained, it was a CPS-EG score of 3 or greater. So there was some notion that if you did an axillary dissection, you may make some patients candidate. And again, olaparib has improved survival. Monarchy, not so far yet, and the Responder, not as well. But the question is, what is the likelihood that patients with 1 to 3 positive nodes, they have clinically negative axilla, they get a sentinel lymph node biopsy? What is the likelihood they have 4 or more positive nodes on axillary dissection? There's several data sets that looked at that, including the ACOSOC Memorial, NCBD, and the Curie, Senomac, and all of those essentially showed about a 15% rate of 4 or more positive nodes if your sentinel lymph node is positive, right? So remember that number. And then, of course, there is a downside of doing axillary dissection. Lymphedema goes up. And here I'm showing you that this is what lymphedema is with sentinel lymph node biopsy alone, about 8%. With sentinel lymph node biopsy plus radiation, about 11%. And axillary dissection, 24.9%. And combination of axillary dissection and radiotherapy, close to 30%. So the reason I'm showing you this is to say that between sentinel lymph node biopsy and radiation, and axillary dissection radiation is about 20% more patients that will get lymphedema. So remember that. So pros and cons, whether you do it or not. Well, let's see. How many patients do you need to undergo axillary dissection to find one who benefits from chemotherapy in the Responder trial? So we get a premenopausal patient. The IDFS benefits about 5% in Responder. We know that about 15% of 1 to 3 positive nodes will be 4 or more, so 1 in 7. You multiply all those numbers. You need essentially, as Thorsten already showed from the Senomac paper, same analysis here, you need 133 axillary dissections to prevent 1 IDFS event in Responder, 230 to prevent 1 distant recurrence, and 500 axillary dissections to prevent 1 death. The math really doesn't add. And again, this is how much more lymphedema you cause to these patients. Same analysis for the Monarchy with amebaciclib. Again, the same rationale. IDFS benefit 7.6% so far, maybe get bigger in the future. And again, when you do the same math almost 100 dissections to find one that benefits from abemaciclib at this point. No survival as of yet, and again, so many patients get lymphedema. Of course, this may actually go away as far as the CDK inhibitors, because the NATALEE trial that was presented again in the ESMO and got approval now for ribociclib actually had patients either with non-negative disease or all the N1 patients were included. So, and the NATALEE trial has shown very similar patterns of risk reduction here. At 4 years, about a 4.9% benefit. This is about what it was in Monarchy. So you don't really need to know the nodes to make a decision anymore to give CDK inhibitors. At least for all N1 patients, you can do it. For N0 patients with high clinical risk, you can do it as well. And what they showed also is that whether you're N0 or N1 to 3, you still have the same benefit from the addition of ribociclib. So again, that problem may go away. So you can conclude from that, like in an editorial from Beth Minitor, although a minority of patients may be understaged by having axillary dissection, it doesn't mean they're undertreated. And although axillary dissection may be considered in individual patients, we should not routinely do an axillary dissection to make these patients eligible for additional systemic therapy. So in summary, there has been substantial de-escalation of the extent of axillary surgery in the past 25 years. Sentinel lymph node biopsy is now the standard of care for clinical N0 with negative sentinel nodes and for clinical N0 with 1 to 3 positive nodes, 1 to 2, 1 to 3, you can argue. And then axillary radiotherapy has similar control of the disease as axillary lymph node dissection for clinical N0 positive sentinel lymph node biopsy patients. Neoadjuvant chemotherapy has allowed de-escalation of axillary surgery and will likely de-escalate also regional nodal irradiation if you convert to negative. And in postmenopausal patients with hormone receptor positive HER2 negative breast cancer, avoiding sentinel lymph node biopsy is currently being evaluated in several phase 3 trials, with the early results from the SOUND trial being very favorable. Routine axillary dissection is not indicated to safely apply the results of Responder, Monarch, and Olympia, and results of the NATALEE may eliminate the need actually for axillary dissection to use CDK4 inhibitors. And again, I'll close with this. I mean, this has been, it takes a village to get all these trials, and this is some of the protagonists in all of these trials over the years, and we're all indebted to them for all their trials. Thank you very much.
Thanks a lot. Terry, thank you very much for these two very, very interesting talks. I'm sure that you have some questions. Fine, perfect. No questions. We can proceed with the next round table. Thanks a lot. Oh, sorry. Prof.
Yes.
I have one question, Terry. NCCN guidelines recommend sentinel biopsy in patients with positive, clinical, not negative, but positive loads at ultrasound, which are proven on biopsy.
Right.
So they are already proven, biopsy proven, so they're already staged. Could you shortly comment on this?
Yeah, I think that those patients, that, as you were discussing before, those are patients that technically sometimes they get punished if they get neoadjuvant chemotherapy because you have positive nodes before, which you had before the chemotherapy, because it doesn't work very well. And then you committed to do an axillary dissection for those patients. For those patients, increasingly in the US, we started to do essentially a targeted dissection. You know, if the nodes are positive, you do an axillary ultrasound, maybe there's a cortical thickening, you know, it's not like a 2-centimeter lymph node that's positive, and you biopsy this lymph node, then we do upfront surgery, we do targeted dissection, remove the clip node, and we do sentinel lymph node biopsy. And I think it's a reasonable approach to reduce risk of lymphedema, because these patients, even if you get neoadjuvant therapy, they probably have this node. If they sterilize, it's great, but if they don't, I don't think we need to punish them to do axillary dissection. We'll put them essentially through a Z11 with the idea that in Z11 axillary ultrasound was not applied, so some of these patients were there with subclinically positive nodes, they escaped the finger of the surgeon, so why should we punish them for more morbidity? And I think that's very reasonable. Yes.
Thanks a lot.
Well,
thank you.
Thank you.
We will proceed to the next round table 6, entitled Breast Surgery, Implant-Based Reconstruction. Dr. Mastoraktor and Professor Kuhn, please.
Welcome and thank you very much. My name is Dimitris Mastorakos and I have the pleasure to introduce the speakers for this roundtable together with Professor Kuhn. So we'll be starting with Dr. Zachariadakis from the UK. His topic will be breast cancer management in the augmented breast. Dr. Zachariadakis.
Thank you. I would first like to express my gratitude to the Hellenic Society of Breast Surgeons for the invitation, and there's no conflict of interest. So rates of breast cancer in women with coexisting bilateral breast augmentation are increasing due to the rising number of women having cosmetic breast augmentation. In 2021, an estimated 1.67 million bilateral breast augmentations were performed globally across a wide range of countries. Excluding the very rare phenomenon of breast implant-associated anaplastic large cell lymphoma, there is no proven increased risk of breast cancer after bilateral breast augmentation. However, as bilateral breast augmentation rates have grown since the 1960s, many older women with bilateral breast augmentation are now presenting with a concomitant diagnosis of breast cancer, and numbers are predicted to rise. The challenges of managing breast cancer in women with augmented breasts include screening, diagnosis, oncological and revisional surgery, along with surveillance. In addition, women with augmented breasts frequently have greater expectations of cosmetic outcomes. The surgical management of breast cancer in women with previous breast augmentation needs to be adapted to account for altered breast anatomy and the presence of the implant. A balance needs to be achieved between a good oncological management and acceptable cosmetic outcomes. Adequate counseling is necessary to ensure patients' understanding of the impact of breast conservation with radiotherapy on previous cosmetic breast augmentation. Women with breast implants often possess a smaller amount of native breast tissue. In one study, native breast tissue comprised less than 50% of the overall breast volume, and this can render breast-conserving surgery less feasible. A wide local excision can cause significant tissue deficit, leading to a noticeable deformity and insufficient tissue coverage for the implant, compromising the aesthetic outcome. As a result, women with breast implants are less likely to be suitable candidates for breast-conserving surgery compared to those without implants. One study described difficulties in achieving adequate margins in smaller breasts and found that 50% of augmented patients who were treated with breast-conserving surgery ultimately received completion mastectomy. Another study had similar results and attributed the high completion mastectomy rate to the fact that augmented women were 4 times more likely than controlled subjects to have positive surgical margins. Other implant problems include implant infection, intractable pain, poor cosmetic outcome, capsular contracture erosion, persistent seroma, and implant rupture. There are, however, some studies that report more favorable outcomes for augmented patients treated by breast-conserving surgery. Okay. Thanks. In a study by Krishna Clough et al., a cohort of 50 consecutive patients with breast augmentation that underwent breast-conserving surgery were reviewed retrospectively. The median histological tumor size was 12.5 millimeters, and 80% of women presented with T1 breast cancer, so really small cancers. Margins were involved in 14% of patients in this cohort, 4 of which underwent re-excision of margins successfully. Completion mastectomy rate in the cohort was 6%. There were no early complications, no cases of early implant loss. Long-term aesthetic results were evaluated using a 5-point scale. An excellent or good result was obtained in 68% of patients. Significant capsular contracture, Baker 3 or 4, developed in 34% of women in this cohort, 5 of whom underwent capsulotomy after fat grafting. The estimated 5-year local recurrence rate was 2.3%. Radiotherapy to breasts containing implants has not been shown to be less effective. Neither silicone nor saline interfere with radiation, and radiation dose distribution studies have shown that implants do not increase the risk of radiation damage to neighboring structures. Despite this, the presence of a permanent implant is considered by some surgeons and oncologists as a relative contraindication for radiotherapy because of recognized complications of capsular contracture with rates as high as 67%, infection, extrusion, and poor cosmetic outcome. Feasibility studies have shown that sentinel lymph node biopsy can be performed in patients with augmented breasts with high success rates and low false negative rates. Most patients in these studies had implants placed through either an inframammary or a periareolar incision. Now, the transaxillary approach can potentially interfere with sentinel lymph node mapping. Saline implants are less likely to disrupt lymphatic anatomy because the implant can be placed and unfolded only when housed in the pre-prepared pocket. In 2005, the American Society of Clinical Oncology released guidelines advocating sentinel lymph node biopsy if transaxillary implantation surgery occurred more than 6 months prior. Some patients request permanent removal of their implants to avoid implant-related complications and to achieve an optimal surveillance after treatment. However, this may only be suitable for patients who have maintained a large volume of native breast tissue. Excess skin may need to be addressed by mastopexy, which can sometimes be delayed to ensure that there is adequate blood supply to the nipple. The possible complications and disadvantages associated with breast-conserving surgery in augmented women has led some surgeons to recommend mastectomy as the primary surgical procedure after breast cancer diagnosis. The presence of implants should not interfere with mastectomy because the prosthesis scar capsule and capsule are removed with the mastectomy specimen. Reconstruction may be performed immediately or as a delayed procedure. Skin cover is rarely a problem after skin-sparing mastectomy, allowing a single-stage reconstruction, often using a fixed-volume implant facilitated by the presence of a pre-developed prosthetic pocket with excellent cosmetic outcomes. Whilst autologous tissue reconstruction is also an option, previously augmented women often are of low body mass index, which presents additional challenges when it comes to selecting donor sites. Most of these women have limited tissue available from the lower abdomen and have slim backs, making it necessary to resort to less satisfactory sites from the buttocks or thighs. Currently, there is no clear guidance on optimal management of breast cancer within an augmented breast. To address this issue, a questionnaire about current practice in breast cancer and bilateral breast augmentation was developed by the European Research Working Group, exploring several key issues including diagnostic pathways, surgical options, limitations on treatment options, current guidelines, radiotherapy issues, and symmetrization surgery. A total of 96 breast surgeons from 19 countries, including Greece, completed the survey. Now, if desired by the patient and technically possible, 84% of surgeons would preserve the implant and 93% would undertake breast-conserving surgery, if possible. There was good access to, but marked variability in the use of MRI. Of note, 82% of Italian surgeons would always request MRI, whereas UK breast surgeons would only use this for specific indications, reflecting national variations. The expected use of radiotherapy was not an absolute indication for removal of the implant. However, there was a wide range of concern expressed about the effect of radiotherapy on implant retention, with 60.5% of surgeons stating moderate or higher concern. Patient choice was a leading factor both in the decision to remove the index implant and in the contralateral explantation for symmetrization. Symmetrization surgery was offered by 93% of surgeons, although for the majority of these, it was offered as a delayed procedure because of uncertainty over adjuvant treatment requirements and the impact on aesthetic outcomes. The study yielded the following key findings. In an augmented breast with breast cancer, oncoplastic breast-conserving surgery is reasonable if oncologically safe and cosmetically appropriate. Breast implants can be preserved regardless of the need for radiotherapy, providing the patient is aware of the future risks of capsule formation and further surgery. Immediate symmetrization should be considered if required, and in most cases, MDT discussion included patient's choice in the personalized care plan. Now, to illustrate these challenges and treatment strategies in practice, I'd like to share 4 cases from our own experience. The first case is a 34-year-old patient that presented to our symptomatic service complaining of a left breast lump. She had bilateral breast augmentation 5 years ago. On examination, there was a 5mm P3 indeterminate nodule in the left breast, adjacent to the nipple areolar complex at the 7 o'clock position, measuring 9mm. On ultrasound, that was U3A1. We thought initially this was a fibroadenoma. US-guided NILCO biopsy revealed the presence of a grade 2 IDC, ER/PR positive, HER2 negative. Bilateral mammography was unremarkable, both breasts M2. So given the lesion's small size and the presence of sufficient native breast tissue, we elected to proceed with left maxillary-guided round block therapeutic mammoplasty with a sentinel lymph node biopsy, final histology, 9 millimeters grade 2 IDC, all margins were clear, sentinel lymph node biopsy was negative, 0 out of 3. Now, is there an alternative to skin-sparing mastectomy with reconstruction for patients where breast-conserving surgery is suboptimal while avoiding contralateral symmetrization? Now, we propose a less invasive approach, skin and nipple-sparing mastectomy with implant retention. This technique aims to minimize surgical morbidity by preserving the implant, thereby avoiding the need for immediate or delayed reconstruction or contralateral mastopexy. Now, the rationale for this technique is rooted in the understanding of breast volume composition in augmented patients. A significant portion of the breast volume in these patients is contributed by the implant. By removing the native breast tissue while retaining the implant, significant asymmetry can be avoided. This approach leverages the existing implant as a structural component to maintain breast volume and shape. Now, in this second case, we have a 42-year-old patient with an increased risk of developing breast cancer on account of her family history, but no identifiable mutation. She underwent a screening MRI that revealed the presence of a small 12-millimeter enhancing nodule in the left upper inner quadrant, MRI 4, M2, U5A1. Histology confirmed the presence of a grade 2 IDC, ER positive, HER2 negative. Mammogram was unremarkable. So the patient was informed of available surgical options, including breast-conserving surgery and bilateral mastectomy, left therapeutic, right prophylactic, in view of her high-risk status. The patient opted for a left skin and nipple-sparing mastectomy with sentinel lymph node biopsy while keeping the implant in situ. This would allow her to avoid adjuvant radiotherapy without compromising the cosmetic outcome. She did not want to proceed with synchronous contralateral risk-reducing mastectomy at this stage. So for patients with breast augmentation having a skin and nipple-sparing mastectomy, I use a hemi-batwing incision as it provides excellent exposure and access to all breast quadrants. The upper pole of the breast is dissected, and sentinel lymph node biopsy is usually performed through the same incision. Final histology, grade 2 IDC, 11 millimeters sentinel lymph node biopsy was negative, 0 out of 1. And she will proceed with contralateral risk-reducing mastectomy and fat grafting to improve the breast contour as a second-stage procedure. So the third case is a 39-year-old patient who presented to asymptomatic service with a diffuse area of textural change, P3, located medially to the nipple areolar complex of the right breast. Bilateral mammography demonstrated a diffuse area of increased density, measuring approximately 6 centimeters, right breast M4, left M1. On ultrasound, the area measured 42 millimeters. A single suspicious axillary node was identified. US-guided Nilco biopsy of the breast lesion and FNA of the node were performed, confirming the presence of a node-positive grade 2 IDC, ER, PR positive, HER2 3+. MRI revealed large volume non-mass enhancement involving all quadrants of the right breast, corresponding to the biopsy-proven malignancy. The patient was referred for neoadjuvant chemotherapy. She was also recruited in the ATNEC trial with a plan to proceed with TAD if she had a complete radiological response. A MAX, it was inserted in the biopsy-proven node. Post-chemotherapy MRI demonstrated complete resolution of the area of enhancement within the right breast. US of the axilla showed multiple lymph nodes with abnormal appearance. It seemed A5. So we decided to proceed with a skin and nipple-sparing mastectomy with axillary lymph node clearance, maintaining, again, the existing breast implant in situ. So post-neoadjuvant chemotherapy revealed the presence of a residual grade 2 IDC, 5 millimeters, node negative, only one node showed evidence to response to treatment. All the others were completely, did not show any evidence of response, they were negative. So finally, we have a 40-year-old patient who presented to asymptomatic service complaining of a left breast lump. On examination, P5, 1.5 centimeters. She had bilateral breast augmentation through an IMF incision 13 years ago using round PIP implants. So mammography revealed the presence of a low-density, irregular mass with microcalcs in the left axillary tail measuring 19 millimeters, 13 millimeters on ultrasound, with at least 2 suspicious lymph nodes visible in the left axilla. US-guided Nilco biopsy of the breast mass and the largest node were performed that revealed the presence of a node-positive grade 3 triple-negative cancer. The patient was referred for neoadjuvant, was enrolled in the ATNEC trial again with a plan to perform TAD. In this case, we placed 2 MAX seeds because there were 2 nodes, one proven positive, the other looked suspicious and was in a usual position. Baseline MRI revealed a diffuse area 28 by 30 millimeters of enhancement within the left upper outer quadrant. Lesion was closely opposed to the capsule of the left breast. That's, again, the MRI. The patient underwent neoadjuvant chemotherapy. Post-NAC MRI showed almost complete resolution of the left breast tumor. Ultrasound of the axilla showed benign appearing lymph nodes. So we proceeded again with a left skin and nipple sparing mastectomy along with target axillary dissection, including the 2 maxillary localized nodes, while keeping the implant in situ. Final histology showed a complete pathological response in the breast and in the axilla. So the patient was concerned about leaving the PIP implants in situ, so 6 months after completion of radiotherapy, we proceeded with bilateral capsulectomy and replacement of her round PIP implants with anatomical through an IMF incision. Thank you. Questions at the end? Questions at the end?
I suppose we can have a few questions now. Any questions for Dr. Zahariadakis?
Okay, then I think we will have further questions at the end, so thank you very much. And as next speaker, I welcome Professor Andreas Karakatsanis. I think he's a well-known speaker here. He's a professor of surgery in Uppsala University, Sweden, and expert in breast cancer surgery. Andreas.
Thank you so very much for the invitation. Now, I'm going to talk about the use of ADMs or meshes when we're discussing prepectoral breast reconstruction in the setting of mastectomy. And since I'm talking about the mesh-free, we're going to talk about what is the evidence for more or less each approach. These are my disclosures. Now, how did it start? Some 12 years ago, Mona Habidian wrote a very comprehensive idea of his perception on the use of meshes and what the reasons behind the use of meshes were, already in the day when we were discussing ADMs and meshes in the setting of retropectoral reconstruction. And it was very clear that we wanted to use prosthetic material in order to facilitate coverage techniques, to control the mastectomy plane and the prosthetic device so that it sits into place, to minimize any issues with periprosthetic fibrosis, and to optimize the performance of the outcome in the setting of post-mastectomy radiotherapy. And that was the case, as I said, for retropectoral direct-to-implant. But ever since the first systematic review to the most recent publication, actually, we did not manage to see any differences in clinical outcomes. The certainty of evidence was never increased between the low level of certainty. None of the studies could assist us by reporting standardized measures of input and output, and all resulted in the conclusion that more studies are needed, which is something that I usually say when I have done a study that does not put its finger on the problem. Now, interestingly enough, the technique of retropectoral reconstruction has become less and less relevant. So we need to discuss this one, prepectoral direct-to-implant. And in my head, as a clinician, I'm trying to kind of break down the big problem to smaller problems because it is easier for me to address them as I'm inherently lazy. So what are the stakes? What do we think, aspire, or hope, or believe that an ADM/mesh will do for us? Does it do what we hope, aspire, believe? And what do we do in a world without meshes? So let's go to the stakes again. We aspire to control the mastectomy space and the device, to reduce the skin flap pressure, and to reduce the wound tension. And whilst for the first one there is evidence, there are two big question marks for the other two. Now, what do we think about skin tension? This is what we think. We think that the native skin envelope will preserve the breast into place and will hold it over there, and thus, by balancing the tension, it can retain good sensation and good circulation, most of all. And this is the thing that we think this is going to do when we are dealing with the pressure. And in some sense, we believe that the pressure is linear and it holds the implant inside in place while keeping the skin envelope tension-free, right? Now, let's go a little bit closer. So this is a slice. I think that everybody is familiar to how that looks. We have all seen pathology slides. But if you look at another method that's called an image-based microstructural finite element model, it looks a little bit like that. And it shows you the lines of tension, and this is just 2 millimeters. And if you look at how the tension is divided without adding the fourth dimension, which is time, movement, breath, and so on, it looks like that. Now, how do you want to decode that? I had some easy practical tips about that. I think Kostas knows it. He's seen that before. So what you need to do is that you need to assess the deformation gradient and to find the infinitesimal line vectors from material to spatial configuration. And after that, you just adjust for the cofactor and the J determinant, and then you just find the second order identity tensor. There are 5 orders of identity tensors, by the way. And in the end, you put all these 3 invariants together. And it's easy. Everybody could do it, right? Now, what does that mean in English? That means in English that tension of the skin flap is a 3-dimensional and multi-directional phenomenon, and it happens over the unit of time on each and every point of the surface of the skin envelope, and it will range by a factor of 10 to 15 for every breath you take. And in the end, the flap circulation physiology is completely irrelevant to the mechanics. So there is one more level of complexity. Now, in terms of physiology, support means collagen, and the collagen stiffness that we would like is something that is approximately 170 megapascals. What you get from the scar tissue collagen is at best half of it. How much do you get from the ADM mesh? You will get double of what you get if you don't put an ADM at 3 years' time, but still 40% less than what you would need 2 days after surgery, when the outcomes are most critical. And this is how that looks. In terms of clinical outcomes, there have been series that have reported on the outcomes of non-mesh-based prepectoral reconstruction, and there is meta-analysis of these studies. And the interesting thing is that there have not been any significant differences in outcomes. More recently, the MSKCC, Peter Cordero's group, looked at that, imbalanced groups, but what they saw is that the presence or absence of supportive material did not make any difference in outcomes. So what does the ADM or the mesh do for prepectoral implant-based reconstruction? It will control the space of mastectomy and device. It will prevent the floating implant, but that's it. It will not do anything more. And what do you do in a world without ADMs? Well, I think that these are all things that any type of sound clinical judgment would suggest, that you would need to discuss how you select patients, how you would standardize your technique, and how you would avoid the most important factor, which is flap traction and injury during the mastectomy. And Cicero Urban from Brazil, they published their outcomes with no mesh at all on nipple-sparing mastectomies. And what they actually found was that known risk factors were usual suspects, with smoking as a predominant factor in these outcomes. Mind you, in this retrospective cohort study, cultural characteristics are very, very important, and it affected choice of incision. So Brazilian women want incisions that are covered from the Brazilian bikini, that mini triangle, meaning that our traditional goes to as a inframammary or lateral inframammary are not cases to be discussed because they are visible as scars. Now, these are the two questions that I'm asking myself. Am I going for an implant or a tissue expander, or do I need to revise the skin envelope at the time of mastectomy? And for that, the work from the group of Alberto Rancati gave us very good insights on how you would select a patient. So depending on the thickness of the skin mastectomy flaps, they go to classifications with 3 categories, suggesting that you could treat them differently. Now, what they said is that if you've got a poor coverage, you can go retropectoral. If you have a medium, 1 to 2 centimeters, you can go with a dual plane with or without an ADM. Or 3, you could go for a safe prepectoral DTI, so more than 2 centimeters thickness. Now, if you want to go prepectoral anyway, this is my way of understanding if I have a patient that will benefit from a safe expander to begin with. So if I have less than 1 centimeter, I will go for an expander, no questions asked, and I will deal with the thing afterwards. And actually, the capsule around the expander is going to be a very nice ADM for your implant afterwards. Now, why is that? Why is selection and how you place incisions very important? Because of this paper, again from Alberto Rancati, we know nowadays that the most favorable incision is that of the lateral part of the inframammary fold, as the only one that you will sacrifice, the only perforator to the nipple areola complex is the medial part of the LICAP, which is, by the way, the less robust, so it will not make any difference. Now, what do you do in this case? You try to keep things tight. So you need to have a good dissection plane. You don't need to stall. Optimally, I try to do this surgery without an assistant who's very enthusiastic and is pulling the retractors. And I will just raise the skin flaps as much as I need to put a Babcock or an Alice clamp and get a grip. I will perform the retropectoral dissection because there you can actually use a retractor because the mammary gland is like a protective pillow against the skin envelope, and then I will divide the lateral ligaments, the inframammary fold, and move my way towards that. For skin reductions, I routinely map all the cutaneous pedicles with Doppler so that I know where they are and to get an idea of the thickness of the skin flap while doing the mastectomy. And then I try to preserve as many as possible and to delay any potential point of no return. Do not remove the skin. You're going to need it. You're going to see why. And this is what I favor if I have to do a skin reduction, nipple-sparing mastectomy, and ETA. So it started with the Makisok, and some 5 years ago, I went to the tripedicle technique, and I'm going to show you a little bit of studies around that. So this is the idea that you more or less try to perform the mastectomy by deepithelializing the WISE pattern and maintaining at least the superior and the inferior pedicles. Now, this is easy. You just get used to it, and it allows for good mobilization. The studies do have very good results, and it gets even better. And this comes from Nicola Rocco. On a multi-center prospective study, what they actually did is that they did the mastectomy only from the black line that you see in the screen. Now, I think it's, yeah, that one. That way, what you manage to do is that you maintain all the pedicles. If you need to sacrifice something, you usually sacrifice the lateral one. And at closure, there is no part of the implant that is not covered by a dermal sling as well. So that is a very, very safe way to do things. And it goes like that. Now, how do we control for the ischemic complication risks? Clinical assessment. I am not that good a clinician. I don't know how to do it. ICG. ICG is very good and reliable, but if you are doing hydrodissection like I do, it will not work credibly if you have injected norepinephrine subcutaneously. It's going to be black, and you're going to get panicked. Doppler ultrasound is also another way, and there's another good thing. Do you remember the Rancati classification? So Marcia Salgarello's group from Rome went back and completed the classification approach by assessing the flap thickness ratio that they defined as the thickness ratio of the preoperative mammogram to the intraoperative ultrasound. So that provided an estimate between what the surgical intention was, that I have a 2 centimeter thick flap, and how much have I managed to retain when doing my mastectomy. And it is an intraoperative bailout maneuver because it can allow you to make decisions then and there. So what do? They complete with some more measurements, and that forms a cross for anybody who's into this. And what you actually do is that once you're done with your mastectomy, you just put the sizer in and close temporarily, and then you can look both at the skin and subcutaneous fat thickness and see how close it was to what you had assessed preoperatively, but you could also do a Doppler there and see the vascularization. And what they saw is that the closest to 1 this ratio was, the safest the outcomes were. Now, what is not there yet if we are discussing that in the absence of ADMs? we would optimally need, and would not have that yet, an ADM or mesh that will facilitate the reproduction of a more natural shape if some amount of reasonable ptosis is wished. We would like materials optimally with no immunological adversity, but we would accept less than what we have nowadays. And we would need both meshes but also implants that would fit one another and that would fit well on the chest wall that we want to reconstruct. So in conclusion, pre-PEC DTI without ADM and mesh is as evidence-based as its counterpart. The necessity, regardless of what you decide to do, is to perform a correct anatomical mastectomy, not in a very, very masculine and determined fashion. Standardizing patient selection and surgical technique will address when and why an ADM or mesh will be needed. Before closing my talk, I will just say that I have personally used one ADM in the last 10 years. And this is the patient that I had to reoperate. Thank you.
Thank you very much, Andreas. This was a really excellent talk. I have one question. If I understood correctly, you said there's a cutoff of 2 centimeters to go for pre-PEC without coverage. How many patients do we have with 2 centimeters? Because I think this is quite a lot.
Yes, we do not have that many, but actually if you see where they are taking the measurement, they are taking that measurement on the upper pole towards the end of the breast footprint. This is where they take all the measurements. And this is why Marcia Salgarello's group completed with that cross, because they felt that it was more comprehensive.
Okay.
In reality, the majority of your patients will be between 1 and 2 centimeters. We now know that it is completely safe to go that way as well, but you need the correct mastectomy. You cannot hack and slash. Or if you do it in a team design, you cannot provide your plastic surgeon with skin flaps that are transluminant and you can see their face behind them and tell them, oh, you can do it now.
If I may, the circulation of the skin comes from the subdermal plexus. So the thickness of the fat, even though Dr. Ancati helped us think about it, has nothing to do with the vascularization of the skin. What does matter is how much of the dermis is exposed. And Salibian, in his article, who does not use ADM, by the way, mentions that you shouldn't be having any areas of ADM exposure more than 16 centimeters squared. So this is what we're looking at. You can very easily damage the subdermal plexus with 3, 5, 10 centimeters of fat if you are not handling the tissues gently enough. Thank you.
Are there any more questions from the auditorium? So if not, we can continue.
We have the pleasure of hearing from Dr. Douvetzemis from Athens, Greece. His topic is going to be implant-based reconstruction and radiotherapy. Dr. Douvetzemis.
Hello, I would like to thank for the invitation. So, there is no conflict of interest. We know that breast reconstruction is increasing worldwide, and more than 80% of reconstruction is implant-based. There are certain risk factors. The first 2, smoking and previous radiotherapy, are in bold because they're the most important risk factors. Expected radiotherapy is another risk factor. We're going to talk about those things today. And of course, immunosuppression, high BMI, and fit patients. Radiotherapy has early and late effects. Effects start 2 to 3 weeks after radiotherapy with inflammation, erythema, moist, and then with delayed wound healing effects, it damages the skin to some extent. But the benefits of radiotherapy are well known, are recognized, and we cannot omit it in certain cases. So we need to choose the safest reconstructive technique in order not to delay adjuvant treatment and not to compromise the technical delivery of radiotherapy. Immediate implant-based reconstruction remains a widespread option for patients undergoing mastectomy. This can be a 2-stage procedure, as it used to be until recently, the most common technique. But now direct-to-implant is gaining popularity with very good outcomes, and of course we have autologous reconstruction. The International Multidisciplinary Expert Panel consensus on breast reconstruction and radiotherapy, of course they agree that radiotherapy increases morbidity in any type of breast reconstruction. They recommended, if a two-stage procedure is selected, not to inflate and deflate the expander during radiotherapy, not to deflate the expander before radiotherapy if possible, and they basically recommend a two-stage procedure. This meta-analysis, 15 studies, shown that post-mastectomy radiotherapy increased the rate of reconstruction failure, increased the overall complications, of course it increased capsular contracture, and it lowered patient satisfaction, as expected. Another meta-analysis again showed that post-mastectomy radiotherapy was associated with higher complication rates, skin flap necrosis, implant exposure, significant capsular contracture, Baker 3 and 4, revision surgery, and less patient satisfaction. So pretty much the same results. Now, is it better to radiate an expander or a permanent implant? Data from the MROC cohort study showed that there is no difference in clinical or cosmetic outcomes in women who receive radiotherapy, whether they radiated the expander or the permanent implant. A meta-analysis with 20 studies showed that post-mastectomy radiotherapy applied to the expander resulted in higher rates of reconstructive failure compared to when we radiate an implant. However, lower rates of capsular contracture. So if you radiate the expander, you have less capsular contracture, but more failures. This is an expert panel that, again, was asked to vote about mastectomy, reconstruction, and radiotherapy, so they were divided. They couldn't decide whether it's better to radiate an expander or a permanent implant. What about ADMs? As Andreas said, actually, I am in front of ADMs, in contrary to Andreas, but do they help? This study here, they took 30 cases. Half of them were irradiated, half of them were not. Subpectoral reconstruction with ADMs. So they removed the capsules, and they showed that patients that were irradiated and patients that were not irradiated had the same thickness of the capsule. So probably ADMs help having less capsular contracture. Another retrospective, a big retrospective study of 30 centers with 1,500 procedures, the IBAC study, they used a specific ADM for pre-pectoral reconstruction, and they identified the same risk factors as we usually know. Capsular contracture was associated with radiotherapy, as we expect. Complication, but it was low. In this case, all patients had pre-pectoral reconstruction, all patients had the same ADM. Capsular contracture was overall 2.1%, but more in irradiated patients. And 6.5% was the implant loss rate. In this series, we said about 1,500 patients, only 200 patients had radiotherapy, 42 of them had prior radiotherapy, 160 had post-op radiotherapy, and 3 of them had before and after. Radiotherapy appeared to be a significant risk factor for development of seroma, capsular contracture, rippling, and implant loss. For seroma, multivariate analysis eventually showed that it wasn't true. So seroma was not more in patients that had radiotherapy. Also, the radiotherapy in this series did not influence infection, skin necrosis, and wound dehiscence rates. Preoperative radiotherapy was associated with more implant loss and, of course, more capsular contracture. Radiotherapy given before surgery had even more implant loss, but the cases were few, so there wasn't any significant difference. But as you can see here, is there a marker? Yeah. Extrusion was much more in patients that had preoperative radiotherapy. Capsular contracture was much more for patients that had post-op radiotherapy. This retrospective review of pre-pectoral reconstruction and post-mastectomy radiotherapy showed that post-mastectomy radiotherapy didn't have any statistical association with adverse events despite the overall higher rate of complication in this series in pre-pectoral reconstruction. The capsular contracture rate, again, was higher in the post-mastectomy radiotherapy group. This study here compared pre-pectoral versus subpectoral in irradiated and non-irradiated patients, and despite the higher incidence of complication, there was no statistical evidence of influence between post-mastectomy radiotherapy, post-mastectomy radiotherapy and pre-pectoral breast reconstruction. So actually they say that there is no reason why we shouldn't do pre-pectoral since they didn't see any difference. And if a surgeon already knows that a patient is going to have radiotherapy, and if he's going to use an implant, shall it be pre-pec or sub-pec? From this study here, again, patients undergoing subpectoral breast reconstruction who received post-mastectomy radiotherapy had 3 times more capsular contracture and usually more significant capsular contracture. So again, here, it's probably better to go pre-pectoral. And from the IBAC study again, pre-pectoral, the capsular contracture rate was 2.1% overall and 6.3% for the irradiated patients, not that high, actually low. And what about autologous? Is it better to go to use an implant or to do autologous reconstruction? Of course, the risk associated with reconstruction and radiotherapy is much less when we use an implant. Again, implants versus autologous, higher complication rates in patients who had radiotherapy and implant reconstruction compared to autologous, 2 times more complications, 11 times more failure. So, and of course, complications were even higher, 51%, in patients who had delayed implant reconstruction post-radiotherapy because you have a flat skin and then you have to put an expander to put tension on that skin which has been irradiated and then put an implant there, which is usually a disaster. So, of course, here autologous again. Now, if we are going to do autologous reconstruction, is it better to do immediate or delayed? We know that if the flap is radiated, we will end up having some fat necrosis, some flap shrinkage. This is true. Some studies recommend delayed for that reason. Some other studies say that, you know, the complication rate is low, the aesthetic outcome is good, so why should we put patients in 2 operations if we don't need to? And MROC, again, cohort study said that there are no significant differences in complication rates after 1 year if we do immediate versus delayed autologous reconstruction. What about previously radiated breasts? As we said before, putting an implant there is usually very challenging. So here, autologous is the standard of care for delayed breast reconstruction. And everyone agrees that it should happen at least 6 months after radiotherapy. And some studies show that if this happens 1 year, at least after radiotherapy, the complication rate is even lower. What about fat grafting and radiotherapy? We know that it helps improve cosmetic outcomes. Some studies showed good outcomes in lipomodeling that is used in a 2-stage procedure before the 2nd stage to improve the skin envelope, and in delayed reconstruction, injecting fat in the flat chest wall in the skin before putting the expander there to prepare the skin. And what about polyurethane-coated implants? Do they help? We have small series, usually single surgeon, not very good data, but irradiated breasts develop, in some studies, capsular contracture more frequently than, of course, compared to non-irradiated breasts, but it was much less compared to textured implants. So we get capsular contracture if we irradiate the breast, but it is less. And a retrospective analysis showed that, again, we have early onset of capsular contracture when we use polyurethane implants, but again, much less compared to smooth or textured. So a couple of retrospective studies showed that, as we said, capsular contracture is less, not very good data though. What about polyurethane-coated implants versus ADMs? Here we see that polyurethane implants cause less capsular contracture if they get radiated, but they give us a worse cosmetic outcome. If we use an ADM, we get a better cosmetic outcome, more capsular contracture. Of course, again, small series, only 5% of cases were irradiated. We cannot usually rely on this data. So for capsular contracture, what options do we have? Just 2 words. Either capsulectomy, we usually don't need that. If the capsule is not very hard, we can just do capsulotomies. They can be either circumferential or radial. This is what I prefer, actually. And we can improve the cosmetic outcome. And again, the panel said that post-mastectomy radiotherapy is not an absolute contraindication for patients that are going to have reconstruction, so we can use, actually, that implant-based reconstruction is not contraindication for patients who are having radiotherapy, and that we should wait for at least 6 to 12 months after initial surgery if we are doing delayed surgery in order to avoid major complications. NCCN guidelines, again, recommendations state that they divide patients and whether they had previous radiotherapy, whether we expect them to get radiotherapy, or whether they will not have radiotherapy. For patients who had radiotherapy, they mainly advise autologous reconstruction as the preferred option. For all the other cases, they give all the options. And finally, of course, as you saw from the data, it's not possible to produce clear evidence-based recommendations. Expected post-mastectomy radiotherapy is not a contraindication for immediate reconstruction and is not a contraindication for implant-based reconstruction. It is very important to have a good surgical technique, as Andrea said a while before. We need to respect the skin envelope. It's not only radiotherapy, we need to take into consideration all other risk factors, like smoking, which is even more important for me. Previously radiated breast, by definition, needs autologous reconstruction. All other options are risky. Of course, we don't always have the option for autologous. If post-mastectomy radiotherapy is expected, autologous and implants are both valid options. If for implants, from the data that we have, possibly pre-pectoral is a better option. And I would, as the last words, we should avoid unnecessary mastectomies to avoid unnecessary reconstructions. And when we do mastectomy, we should usually preserve the skin envelope, because to sacrifice the skin envelope means that then you will have to make it again by, expanding the skin. Thank you very much.
Questions for Dr. Louvezemis? Please, Dr. Zaharidakis.
Congratulations, excellent talk. I wonder if you have any data on patients that had polyurethane implants that ended up, there's a lower risk of capsular contracture, but if they end up having it, how easy or how difficult is it to
remove the implant, you mean?
Yeah, do the capsulectomy afterwards.
I don't have any data. The data for polyurethane implants are not that many, so I don't have data on what you say, but from personal experience, I do reconstruction with either polyurethane-coated implants without ADM or with ADM. I don't do without anything. So because I'm using polyurethane implants, it happened one time, for example, to need to go back to remove the nipple. It was a nipple-sparing mastectomy, and I had to go back to remove the nipple. So it wasn't that difficult to detach it from the implant, and it was only a while after surgery. We know that they adhere very much there, and this is why they have less good cosmetic outcomes sometimes, because they make the implant margin visible. But I mean, if it is after 6 months, and from our experience at Guys as well, because we're using them with Professor Calabrese, you could remove them. It was okay. The problem is if you try to remove them very soon, like a month after. Then you can remove it, but it's a bit more difficult. But I don't think it causes any damage. I don't have data.
In order to do a capsulectomy,
Capsulotomy. I haven't. I have only done capsulotomy. I have not done capsulectomy with polyurethane implants. It wasn't necessary, and I don't have any data. I don't know if there are any data. I'm not sure.
If I may, usually when you take a polyurethane implant out, we have Dr. Antonopoulos who's an expert on that, but when you take it out, usually what you do is you delaminate the polyurethane and you take out the silicone. So if this has given time enough, you will end up removing the silicone pretty straightforward. Capsulotomy might not be so easy, and if you want to do capsulectomy, then you might find yourself removing significant part of the tissues around the implant. Thank you.
But as I said, capsulectomy is rarely necessary. I mean, if you have ALCL, okay. Otherwise, only if you have grade 4 capsular contracture. Yeah.
Okay. I'm a polyurethane man. So I have the experience of more than 7 years using polyurethane implants in prepectoral position. Through my experience, I found that it's very difficult, actually, to remove the polyurethane implant the first 3, maximum 6 months. After that,
it's okay.
Because it happened to me, so you can remove it very easily because all this polyurethane produce a very thin capsule. So what is the rest? It's just a silicone implant inside. So you put the finger, you take out. If you want to do capsulectomy of that capsule, because this capsule is very thin, what I do, I put some normal saline over that, and then it removes the capsule very easily. And if you want to do capsulotomies, you can do it very easily, but at least more than 6 months after the first
case,
okay?
first operation.
Thanks, Dr. Vivagemis.
Thank you.
Any other questions? And now we call Dr. Adonopoulos for his topic of implant-based reconstruction, choosing the right technique and the right implant for the right patient. Dr. Adonopoulos.
Good morning. Thank you very much for inviting me once again in this Congress. I'm very happy to show you my experience. So I say we go back to the earth. What's the reality? Okay, the data and all these papers are very nice, but the everyday reality is it's a little bit different. I have nothing to declare. So what the patient desire in breast reconstruction? Safety, fast recovery, comfortable, good natural result, less pain, less surgical steps. This is the ideal. Through that questions, we obliged to do a proper patient selection. So this is an ideal case for producing a very nice result after having done a nipple-sparing mastectomy. But in reality, we have to deal with patients like that. So different patients, that means we follow the same approach for every patient? No. Every patient needs to personalize all the data. I mean, starting from the oncological disease and then follow the breast reconstruction. But so we have to be very, very flexible, and sometimes we have to change our plan, the preoperative plan, during the mastectomy, because the breast surgeon found something. So somewhere he has to remove skin. Sometimes he has to remove the nipple. He has to leave a very thin skin flap. So how do we select the patients? This is an ideal selection. That means we select the implant, good mastectomy, minimal ptosis, the symmetry, IMF, the problem with the thorax, the size of the breast, small to medium. We stop here for having direct to implant, but sometimes we have to move further up, furthermore. The skin quality, post-radiotherapy, scars, previous scars from lobectomies, or I don't know. And then we have the envelope. Subcutaneous fat thickness. This is written here 2 centimeters, but for me, 1 centimeter would be okay to proceed to DTI in prepectoral position. But at the end of the day, because we are treating oncological cases, we're obliged to not to give false expectations. Let's tell the patients the truth. Let's say the truth to the patients according our experience, not the papers, not the data. What works good in our hands, with collaboration with plastic surgeon, with collaboration with breast surgeon. So let's put some questions. Which technique? Everything starts with mastectomy technique. This is the A to Z. All we know the types of the mastectomies, techniques, skin-sparing mastectomy, skin-reducing mastectomy, nipple-sparing mastectomy. What these techniques have in common? They need no cutaneous expansion because after the mastectomy, we have enough cutaneous envelope to do the direct-to-implant procedure. Nipple skin preserving and doing the mastectomy. This is an example. This is the ideal case, having bilateral mastectomy, nipple-sparing mastectomy, with an implant in prepectoral position before and after 1 year. Skin reduction technique with repositioning of the nipple areola complex. Another case here, big breast, okay, cancer here, we remove the cancer. We have this remaining tissue because of the quality of the skin and the underlying fat. We put an implant in prepectoral position and we lift the nipple areolar complex doing the double bud wing technique. And this is the result after 1 year post-op. Let's go to the skin reducing technique. Like in this case where the cancer is behind the nipple, so we have to remove the nipple and then to do a skin reduction and direct to implant in the same operation. So what we do is keep all this tissue depithelialized as to cover the lower part of the implant, and this is the immediate picture. And two years later, having a tattoo give us a very nice, and for the lady as well, nice result. Let's move now where to put the implant. Big discussion. In subpectoral position, cover the implant with a muscle. We don't use mesh or less amount of mesh in the lower pole. Cost effective, less complications. What is the problems? Extended operative time, possibility of animation deformity, less natural aesthetic appearance, presence of mild capillary contracture, and pain. But before that, we have some tools to estimate before the surgery where to put the implant if we see the mammogram, as Professor Rakati described and our colleagues said before. So you can see here a mammogram with a very good fat. But here, there is no fat. So according to my experience, I wouldn't do any direct-to-implant, in this case, in prepectoral position, using ADMs or using polyurethane implants, because I don't trust this very thin skin. I would go either in subpectoral position of if I do direct implant, or I would put an expander. And my question is, where are you going to put the expander when you have thin flap? Prepectoral or subpectoral? And we discuss it at the end. Another tool is the ICG camera in intraoperative. What I do is to use ICG camera, put the implant, the sizer implant in, and then estimate the vascularity in sitting position. If you do an ICG before that, and the patient is in a supine position, and then you do this, you put an implant in, a incisor in, and you lift up the patient, you will notice that the less vascularity using the ICG camera. What does it mean? Is the gravity and the pressure from the incisor. So we have to keep in mind that we must be very careful for our decision. Another easy thing, you can see the contrast. You put the light on the back. This is the flap. You see very nice fat, thick flap. So you go straight without any questions to do a direct implant in preparator position. But using the light retractor, you see this area here, close to the nipple, is a very risky place. And what would you do when you see this in theater? What is going to be our decision? And then the flap measurement intraoperatively, and we're happy to go straight for a prepectoral position. At the end, I say that no debate about prepectoral or subpectoral. This is the key. This is the surgeon decision-making in theater. But don't forget, this is our backup. When we say direct to implant, we don't promise actually that this patient is going to have one operation. I don't believe that in one operation we can resolve all the problems, because the majority of direct to implant cases, they need something in the future, fat grafting or revision or I don't know. So it's not really one stage operation. So we have to keep in mind, in difficult cases, to use, to go back to use the two stages, to put an expander. Let's go now to discuss about meshes. I'm not going to do all the details. Silicone implants, nanotexture or microtexture. Here there is a BALCL, breast implant illness. We have to inform the patients. We have to consider all the incidents using nanotexture or microtexture according to the possibility of having in the future, after 10 years, a case of BALCL. So is the mesh always we need to use the mesh? No. This is a case, prophylactic mastectomy in a young lady, small breast, nice skin. We can put just under the muscle, very nice anatomical implant 345, full covered by the muscle. But we have to do selective denervation of the pec major, what I do the last five years, to minimize the possibility of animation, because this is the main problem of putting the implants under the muscle, is the animation. This is the post-op picture. This is the case where we did right breast cancer mastectomy, skin sparing mastectomy, and the left skin risk-reducing mastectomy, having BRCA1. We used implants 485, 359 grams. This is the Belite implants, polyurethane Belites, where we have the benefit of using big implants, but in low weight. And this is 3 years post-op. The same lady, you can see that the breasts are natural, no capsular contracture. Natural motion of the breast is very important. So the meshes are biological, synthetical, many factors, many meshes, absorbable or mechanical, or but what the meshes does, it's just to correct the position of the implant, to give a stability of the implant to the chest. Does not substitute any thickness of the overlying subcutaneous layer. So the myth that was years ago that there is a tissue in growth into the ADM, so we gain thickness of the flap, this is not true. Let's move now to the micro-thin implants. I think something is wrong, it's stuck. Can everybody help me here?
Can we have the AV people, please? Θα μπορούσατε να βοηθήσετε λίγο? Ευχαριστώ.
Πώς θα πάω πίσω? Το πάτε εσείς πίσω? Δεν πάει.
Ωραία. Δεν έκανα τίποτα, το βελέκι πάτησε έτσι. I just pushed the arrow.
Αυτό το έκανα και εγώ στερεία.
To be continued next year. Τι έπαθε τώρα? So I'm using the last 7 years this micro-thin polyurethane implants, and last 5 years I'm using the Belite implants. As I said, is the Belite implant is a big implant. We can use 670 cc's, but the weight is 450. Another thing that we have to discuss is to, continue the next year, I'm sure. Another thing that we have to discuss is the cost of the operations and where we work. The cost is completely different for the patients having the surgery on the state hospitals than in private practice. Okay, those are the advantages of Belite implants in prepectoral position. This is my motto, simple, that means simultaneous immediate mastectomy polyurethane lightweight in epipectoral position. This is the Belite covered with polyurethane. Radiotherapy, it's a big question. The problem is that we don't see how the radiotherapist works. We don't see the machines. We don't see anything.
Αν μπορούμε να ολοκληρώνουμε, Δημήτρη.
I'm finishing. This is a case with having pre-op radiotherapy on the right breast, lumpectomy, and previous radiotherapy, direct to implant, and the result after 3 years. Is that what I'm saying, that we have to personalize our technique and adapt it in a certain case? 4 years post-op radiotherapy again, in prepectoral position. Good results, but I have bad results as well, disaster results after having radiotherapy. Same, using the polyurethane implants in prepectoral position. The risk-reducing mastectomy is a very, very difficult issue because all these ladies have very high expectations. So we have to think about, and we have to adapt our experience, like this lady here, young lady, in nipple-sparing mastectomy. I'm finishing. Okay, So let's finish with that. What's the problem here? It's a disaster, but it's a disaster because we choose a special ADM or synthetic mesh or something. Through my experience, I believe that the complications are not related so with the devices or anything we use, but with the surgeon decision making and planning. So there is no best technique, but there is always the best way. And don't forget, a good reconstruction begins with a good mastectomy. This is the A to Z, and this is my thank you.
Thank you, Dr. Antonopoulos. Questions? Sure.
Okay.
Can go ahead with a comment from Dr. Konstantinidis.
Thank you very much to all speakers. To start with, 4 very interesting talks from 4 very experienced people. I couldn't help noticing that the data is the data, but there are some things you all agree on, and some things that you all do very different things, right? So it seems to me that you all agree that a good mastectomy has to be done, right? So for the breast surgeons, that means, you know, they need to focus into doing a good mastectomy. And for us plastic surgeons, that we need to be very, you know, selective which breast surgeons we work with, probably, right? As far as the rest is concerned, the most interesting part for me was the difference in the concept by which prepectoral reconstruction is done. So we've got the mainstream opinion, I would think, is using silicone textured implants together with an ADM. Is that correct? And that's what Dr. Duvedzemis does? Is that? Where's their use? Yes? Okay. Is that correct? So the mainstream opinion is that you would use a textured silicone implant with an ADM to do a prepectoral reconstruction, right? Or you would jump into using a polyurethane, but in which scenarios would you do that?
So personally, and as you know, because we've worked together several times, if I do a reconstruction, I hardly ever use expanders. I usually use permanent implants. Textured implants with ADM is my first choice. If a patient cannot afford the ADM, because here it's not NHS, patients have to pay if they don't have private insurance, then I use a polyurethane coated implant without an ADM, prepectoral. The last time I did a subpectoral was 2016, I think.
Okay, so Dr. Duvedzemis moves to a polyurethane reconstruction based on cost considerations.
Yes, usually.
Yes, but Dr. Antonopoulos, yes, regularly uses polyurethane, and that's not only based on cost, is that right? Do you believe that the aesthetic result is equivalent between the two, using polyurethane and silicone with ADM? Or do you think
I think the polyurethane implant is difficult to manipulate it from the beginning. So you must have to get a lot of experience. So I don't agree with Asterios that in the long-term follow-up, the aesthetic result is less than of using ADM and silicone implants. But the cost is always something very, very, very important to us.
So if cost was not an issue, which of the two techniques would you use?
I would do the same, Belite implants.
Polyurethane. And then Dr. Karakatsanis, yes, is cost an issue for ADM in Sweden?
So that's a deeper question, because whatever you do in Sweden, first you would need to do a clinical trial, but even the things that you would audit outside a trial will be reviewed by an independent health economist. So it is never a matter of cost when you have tangible outcomes.
So you don't use ADM not because of cost, but because you feel there's a higher complication rate. Is that right? That's what I got from your talk. Or why would you not use an ADM?
Because I have not seen differences in clinical outcomes in prospective multi-center audits that we've done in the country.
So you feel you can stabilize an implant, and I suppose you use textured implants or polyurethane? Textured.
Dr. Sadinidi, we need to...
Okay,
This
sorry.
is comments, right?
Okay, sorry.
It's okay.
It's okay.
So, are you done?
Yes, yes.
Very well. So we have Dr. Nanidis. Sorry you're not here with us. We'll be happy to hear your comments.
Yes, thank you so much for inviting me, and congratulations to all the speakers. Fantastic talks. I'm not going to ask too many questions because I think some of the speakers have a lot more experience in DTI, breast reconstruction. But I've really moved away from using ADMs. I haven't really seen the benefit in my practice, and I've had to revise so many of them to autologous reconstruction, and they've never really been integrated. And I don't actually see the point of if you see all the implant manufacturers that spend millions to examine the interface and the interaction between an implant surface and the body, and that's completely removed within ADM, and the only thing that it does is stabilize the implant. So I've largely moved into a two-stage approach, as I think most DTIs are always end up being a two-stage approach anyway. In an internal audit we did at the Marsden, more than 90% of patients need their revision. So we now, with Chloe Constantino, who's in the audience, we do it as a two-stage approach. And that's my comment. We sort out all the problems. We don't have to worry too much about vascularity. There's no tension in the skin flaps, and it makes life a lot easier. So the second comment is that when radiotherapy is concerned, we kind of largely moved away from implants if possible, and I offer mainly an autologous option for those patients unless they're extremely thin. But even in very thin patients, I think I did present last year about lumbar flaps. There are autologous options. So those are the only two comments I will make, and excellent talks.
Thank you very much, and I guess my comments will be last. I have several things to say. For Dr. All talks were very good. For Dr. Chariudakis, I think the reason why sentinel nodes are not identified with the silicone is that from the axillary approach, this is probably because for a saline implant you need a smaller incision so you don't disrupt the lymphatics as much. As far as Andreas is concerned, I think that first of all, we know that there's no randomized or almost no randomized trials in plastic surgery, and that makes things very, very difficult to examine and draw results from. But we have to keep in mind the chances of bottoming out when you're using an ADM or any kind of mesh. For example, P4HB meshes are supposed to increase the strength, the tensile strength, about 4 times normal tissue. So this is something to keep in mind. Not very sure what's the purpose of using a textured implant, just like Dr. Nanidis said, when you do an ADM, unless you want to use an anatomical implant, but then you have to keep in mind that you have the chance of rotation. Joe Barnea's data, who did augmentations at the time of the lumpectomy and then radiated the augmentations, had about a 30% need of reoperation, which means that 70% of the patients that you radiated implants do well without capsular contracture that needs revision. So that means that most of the time, if the shape can be adequate, then probably augmented patients can be radiated and have a good result. Some of the pictures that Dr. Zachariudakis showed gave me the impression that there was a capsular contracture there. In that case, you're probably better off managing it at the same setting of the lumpectomy. What else? Dr. Dionysopoulos from Montreal is doing immediate reconstructions with no ADMs, with round, smooth implants, and has good results from McGill. So there are data if you can do it the way you can do it successfully. But there is meta-analysis saying that the ADM does reduce seroma formation. So if I would say what the ADM does, it's fix the inframammary fold in a better fashion, create a more anatomical slope, especially if you're using an ADM that covers back and forth, let's say like Braxton, and decreases seroma. So this is something to keep in mind. Of course, if I would do a two-stage approach, I don't feel necessarily the need to use an ADM, just like Dr. Nanidis said, in which case I tend to use an expander that you can secure on the chest wall. Thank you. Any other questions?
Okay, I think the time is over. So from my side, thanks to all speakers for these excellent presentations. Thank you all for your attention, and I wish you a nice break. Thank you.
Να ξεκινήσουμε ή να περιμένουμε λίγο ακόμα? Okay. Hello, everyone. We are moving to the next session, which has the title Advanced Oncoplastic and Reconstructive Surgery, Techniques and Considerations, Part 1. I'm happy to have with me Professor Osman from Istanbul University, who is also the Professor of Surgery and President of the Senologic International Society and also Editor-in-Chief for European Journal of Breast Health. Professor Osman.
Thank you very much for your coming. Have a good afternoon. It may be difficult to follow the session after the lunch, but we have to start with Dr. Exarchos. He is a consultant breast surgeon in Kingston Hospital, Royal Marsden Hospital in London, UK. Welcome.
So, when I was in my early surgical training 8 years ago, one of my senior consultants told me, George, what is your long-term plan? What is your subspecialty? What do you want to do? And I said with confidence, I want to be a breast surgeon. And he told me, oh, it's going to be a walk in the park. There are only 4 operations you need to know: a mastectomy, a wide local, a sentinel lymph node biopsy, and a clearance. Well, this is not the case anymore. So we have a variety of oncoplastic breast procedures, level 1, level 2. We have the autologous and implant reconstructions, and of course the chest core perforator flaps. So I'm really excited today to share my knowledge and experience in wise pattern mammoplasty. I have no conflict of interest. Before I move to my talk, I would like to express my gratitude to this man here, Mr. Peter Barry, who was my mentor during my fellowship at the Royal Marsden. We spent many hours chasing arteries and vessels, and he has been a great mentor to me and excellent teacher. So what is the wise pattern mammoplasty? So it is the most commonly utilized skin excision pattern. It provides an excellent option for large surgical excisions. However, it has a drawback of a large scar over the IMF and the meridian. And however, it enables wide exposure, so we can obtain very good and clear margins with a nipple elevation parenchymal distribution. So we're doing a wise pattern mammoplasty for various reasons. Usually we do it for reduction. We can do it for a therapeutic mammoplasty, and also we can do it for auto-augmentation, the so-called Ribeiro flap. Now, what are the indications for wise pattern? So there are 2 indications, mainly a big wise pattern breast and a big tumor. And the other indication that I always take in consideration is what we say the parenchymal ptosis. So what is a parenchymal ptosis? It is the distance from the IMF to the lower pole of the breast. So usually in a parenchymal ptosis of 1 to 2 centimeters, we would recommend a round block mammoplasty, 3 to 5 a vertical scar, and this is a typical wise pattern breast, more than 5 centimeters. So it is a very good case for a wise pattern. Now, how to do a wise pattern mammoplasty? First of all, you need to know your markings. Then you need to be have very good knowledge about the blood supply and the pedicles. You have also taken consideration where the cancer location is, and you need appropriate training and mentorship. Now, this is what I call the wise pattern breast. A few information about marking. So this is a 40-year-old lady that she presented with a multifocal, multicentric breast cancer, the upper central, upper outer breast, early this year in our unit. And we did a left therapeutic mammoplasty and target axillary dissection with a contralateral symmetrization. So what I do for the marking, I always do some dots on the midline, not a straight line because it can deviate. So midline, then IMF, and then the meridians. How do I mark the meridians? It is the half of the lower pole of the breast, and we extend towards the abdomen. Then I always mark the pita-G point, which is the anterior projection of the IMF to the breast, which is usually the new nipple position. And then I use the bicep back maneuver, so medial and lateral rotation of the breast, for the vertical limbs. So the vertical limbs usually are between 9 and 11 centimeters. And the last thing I always mark is the pedicle. So here the cancer was in the upper outer quadrant, so we did a superior medial pedicle. And this is the patient before and after the procedure with clear margins. Now, what are the pedicles? What type of pedicles do we have? So we have two types of pedicles. It's the NAC pedicle. NAC stands for the nipple areolar complex pedicle, which is a cutanoglandular pedicle, and it can be primary or extended. And then we have the parenchymal pedicle, which is a dermoglandular pedicle, that it is usually a secondary pedicle. And also today I will describe the septal perforator flap. Now, the NAC pedicles usually are these four. It is the lateral pedicle, which is a branch from the axillary artery. The superior pedicle, which is from the secondary costal space, internal mammary artery. The third costal space, the medial pedicle, and the combination, superomedial. So this one of my patients that she presented a few weeks ago, 3 weeks ago, with a multifocal right breast cancer. So this is a 3D MRI scan. You can see here, this is the breast cancer, this is the superior pedicle, this is the medial pedicle with two branches, so this is the superomedial. And this is the same right breast from the lateral view, so you can see here the lateral pedicle, this is the LTA, lateral thoracic artery, and this is the thoracodorsal pedicle. So before any mammoplasty, I always have a look on this 3D MRI scan. It helps me to do my planning. Now, as you know, a few years back, Wernicke, she identified the Wernicke septum, which actually it is the mesentery of the breast, and along that septum we have two usually perforators which provide blood supply to the nipple. Usually it's the fourth and the fifth intercostal perforators. Now, Rancati, 2 years ago, did a prospective cadaveric study which showed that along the Wernicke septum, it's not always the fourth and fifth, but usually the fourth, and the fifth goes along the medial pillar and the lower pole. Why this is an important slide? Because this will help us to understand the septal perforator flap, which is actually all this lower pole of the breast, that we can use it as a flap based on blood supply from the septal perforators, so fourth and fifth usually, and you can release the dermis and mobilize it in the upper inner or upper outer quadrant to fill in cancer sections defects. So this is how the septal perforator looks in the MRI scan. Usually when we do mastectomy, you can always find it. It comes from the pectoral chest wall. And this is how the fifth intercostal pedicle looks like in the MRI scan. Now, when we have to do a cancer resection, these are the primary pedicles. So in the cancer, in the upper central breast or in the upper inner quadrant, you have to do an inferior pedicle. If the cancer is in the lower pole or in the upper outer quadrant, you have to do a superomedial pedicle. Or if it's very high up, you can use an extended inferior pedicle. And the same, if it's high in the upper outer quadrant, an extended superomedial pedicle. And then we have the secondary pedicles. So we use the lower pole of the breast to fill defects in the upper outer quadrant or upper inner. The main principle here is to keep a broad base, so 3 times more than the height, which provides good blood supply. Now, what is the difference of the septum perforator flap? Is that it is actually a secondary pedicle, but I use the Doppler to find the septal perforators, and once I find them, then I release the dermis over the lower pole, and this increases the mobility of the flap. So I can mobilize high up in the upper outer quadrant. I will show you some videos in the next few minutes. So I always map the pedicles in the breast. So this is a bilateral case, left wise pattern mammoplasty and TAD, contralateral symmetrization. And these are the pedicles on the left breast, superior and medial, and this is the neck on the superior medial pedicle. Now, do we have the volume here? Can I use the volume to show you some? Oh.
Start. Okay,
So this is the left breast, lateral pedicle. You can easily excise it. This is the medial pedicle. Why it helps that? So you can release the dermis and increase the inset position, so there's no tension. It can go very, very close, as you can see here, and do it with confidence.
Okay, that's fine.
You can see that the pedicle is still alive, and with confidence you can do the inset rotation. Now, T-junction. So I always do a triangle over the T-junction because it helps take the pressure off and it decreases the morbidity of the wound adhesions of that area. This is a case that we did early in January this year. So 72-year-old lady with a large 4 centimeter cancer in the upper outer quadrant, diabetic. This is how she looks clinically. So it's a large tumor in the upper outer quadrant. And she's an ideal candidate for a wise pattern mammoplasty with a neck nipple areolar complex based on the superior medial pedicle. This is the mapping of the pedicles, superior and medial. And this is how she looked before and after the procedure. Clear margins. Now, this is the left breast of that lady. These are the feet. The head is here. This is medial. This is lateral. So these are the septal perforators, the fourth, usually the fifth. And once you identify them, then with confidence you can release the dermis and you can improve the mobilization of the flap. This is the pedicle from the skin. So you can excise skin from here and here once you find them. So it's the same pedicle from the outside of the breast. And then in the last slide, you can see the mobility of the flap. You can lift in the upper inner quadrant or in the upper outer quadrant. So this is the nipple on the superior medial pedicle. And you can see how much mobility it can give you if you release the dermis. So that's the septal perforated flap. Now, what do we use to find the pedicles? It's a personal preference. Some people use a Doppler, which I do. Some other more advanced use ultrasound. So what are the closing reflections? So I think patient selection is very important and discuss the expectations. Make sure that the smoker is diabetic. It's not a good option. Keep the pedicle shorter to provide better. It prevents you from complications or risks. Make sure also that there's no tension in the skin envelope because the nipple necrosis is not from the poor blood supply, but from the poor venous drainage. As I said, ptosis is your friend, so more than 5 centimeter ptosis, it's a good decision. Don't discard anything. So deep epithelialize the wise pattern, then raise the pedicle, then do the cancer resection, and then keep any skin available to fill the defect. And if you don't need any more, you can do the resection after. And what I found really useful is the practice pedicles during simple mastectomies. So when you do a mastectomy now, I hope from now on, you can always identify the fourth intercostal perforator, the fifth perforator, the lateral thoracic artery, the second intercostal perforator. So don't just go and do a mastectomy and close. It's a good practice to identify the pedicles, and during your next procedure, it will be easier to take into consideration when you're doing a mammoplasty. Thank you for your for listening.
Thank you very much for a nice presentation. Is there any question or comments from audience? Excuse me, do you use three-dimensional MRI in your old patients?
So all the MRI scans, they have this option.
It's a kind of angiography also.
Yes,
it's
the MPI and the 3D. So it's standard. Every MRI scan has it. It's not a special MRI scan I need to do. So I do a right-click, 3D or MPI, and your vessels are there. So it helps me with my mapping. So the plastic surgeons, quite often they use a standard superior pedicle. They say they don't have to do a Doppler, but sometimes the superior pedicle can be absent. So this is why I've seen it in quite a few times, not very often, but it can happen. So to me, the Doppler is like a light in the dark, so it helps me to navigate and also tailor the neck. So cut a very short pedicle and improve the neck inset to the new position.
Thank you.
I have a question as well. First of all, thank you for the excellent presentation. It made it quite obvious what we're trying to preserve in order to have a successful operation. I would like to ask, would you use that type of technique in a patient who had previous surgery? For example, if somebody had surgery for ptosis in the past or implants?
So ptosis is a friend. I will use this technique depends on the intraoperative findings. So if I would go for the standardized pattern, and if I identify the septal perforators, I will use it. So, but I wouldn't decide from the beginning. Quite often you have to make this decision intraoperatively. But it's more challenging in the previous operated breast. And you need to know what type of operation the patient had. Okay, was it an inferior pedicle? Was it superior pedicle? So if she had a reduction, for example, with sacrification of the superior pedicle, you cannot use that. So it's very important to look at the previous notes and see what type of pedicle she had before.
Right. So once again, we have to look for the vessels.
I always use it. So I always have a Doppler in my bag. I cannot work without it.
Thank you very much. Okay. Thank you, Mr. Exarchos. And now we move on to the next speaker, who we're happy to have with us Professor Alexandra Georgia Spiropoulou, who is a professor of plastic surgery at Aristotle University of Thessaloniki, and she's going to speak about free flaps in breast reconstruction.
Dear colleagues, dear President of the Congress, thank you very much for inviting me to give this talk. Ça commence mal. So I have no conflict of interest. First of all, we would like to discuss who is a good candidate for breast reconstruction with a free flap. Of course, apart from the wish of the patient, we have to take into consideration if there is excess tissue in an area distant to the mastectomy site that could be used for reconstruction in order to improve the whole body contouring of the patient. So, for example, if there is excess fat in the abdomen, and so if we perform the abdominoplasty that follows the DA procedure, we could say that the patient somehow benefits from in her mind, gains something out of the whole devastating procedure of the mastectomy. She has to be preferably a non-smoker and a patient that has or will be irradiated in the mastectomy area is a good candidate, as we know that there is a high potential of complications in an implant-based reconstruction. She must not have significant comorbidities, for example, thromboembolic disease, and of course, we take into consideration the patient's wish. So in this case, in this patient that we perform a DA flap, we can see that the body contouring has improved. If a patient is thin and toned and has no excess tissue, then she's not a good candidate, obviously, and we can have an implant-based reconstruction that will give her a very good result. So we should not try to do a free flap reconstruction in every case. When is it a good time to perform a free flap? The immediate autologous reconstruction enables us to preserve the breast footprint, which is the most difficult part of reconstruction. So this gives us a superior result. And the flap can be buried with a small skin paddle that we can use for the nipple areola reconstruction. And even if it's large at first, we can excise it and create a nipple areola at a later stage. This study that compared the immediate and late group of reconstruction demonstrates a higher scores for body image and self-esteem and patient satisfaction in the immediate group compared to the delayed group, where there are higher levels of overall distress and depression. And there is a less comfort with physical intimacy. Here we have to say, though, that the patients that undergo a delayed reconstruction are usually, let's say, more grateful towards the surgeon, if I can say, if this is not a very politically correct thing to say, but usually they are more grateful towards the surgeon because they spend the time mourning their mastectomy. In this case, we have an overweight patient. She wanted to undergo a DF flap reconstruction, and we can see that the effects of radiotherapy, even though we did an ICG and discarded zone 4, it can create an area of fat necrosis. That is why many surgeons advocate that we do a delayed reconstruction in order to avoid this mishaps. However, there are numerous studies that suggest that there is no decrease in the efficacy of radiation when a reconstruction is performed, and these studies, a prospective one and a systematic review and meta-analysis, suggest that there are equivalent rates of fat necrosis, flap loss, and thromboembolism. When then is a good time to perform a flap after radiotherapy? We should at least wait 6 months, but of course there is a clinical decision. So we have to evaluate clinically the quality of the breast skin, and if it's tight and inflamed, we should wait and for the inflammation to settle. The methods that we use for localizing the perforators are the handheld Doppler, which is the most classic method, that is the one that we use. But of course, there are other more sophisticated methods like the color duplex and CT angiography and MRI. The CT angiography is the mainstay for planning in most centers, and it is an indication when there have been previous abdominal surgeries, except, of course, the complete abdominoplasty, which is a complete contraindication to DF flap. However, well, we prefer to use the Doppler ultrasound. Just some thoughts. The 30 minutes extra operative time in an average cost clinic in Thessaloniki when I'm working costs 100 euros, while a CT angio costs 215 euros. However, every 30 minutes of prolongation of operating time increases complications by 14%, and these are all facts that we have to take into consideration. So when we try to form the flap to a breast, there are again sophisticated methods like 3D printing for preoperative planning or the Chrysalix camera. However, if you don't have access to this, you can just use your hand and your eyes to estimate the size. So my hand, I'm wearing 7 gloves, is approximately 150 ml. So it weighs, it can have the volume of a cup of a glass, a small glass of wine. So a good way to get used to this is try to estimate the size of the volume that you remove when you perform the mastectomy before it is weighed. So this gets you accustomed and you get used more and more to estimating correctly the size that you need and the size that you have removed. ICG, of course, helps us discard the areas that are non-well vascularized, and we discard the zone 4 intraoperatively because this undoubtedly will cause trouble. when we try to assess which flaps to perform, we assess the donor side and the breast size. And of course, the EP flap is the best donor side according to myself, but other people are very well of using other donor sides. The muscle-sparing tram enables you to have some more tissue because the muscle and a quicker dissection also, because this gives you a part of extra tissue. Like in this lady, this was one of the first cases that we did when I was in Thriasio, and she had a muscle-sparing tram. And this is one of the cases that we published when I was in UK. This is a double muscle-sparing tram and an implant reconstruction. So the DIEP flap, of course, as we said, is the main procedure that is used for free flaps. And it can be also neurotized if you use the 3 to 4 of lower 6, 4, 7 thoracic nerves. You can have a cap B in this patient, even though she's normal weight, and you see maybe you don't estimate that she has enough tissue, but you can get approximately the cap that she had. And even in overweight patients that, of course, have more complications when BMI is above 30, see, this one had BMI 39, you can still have a size that approximates the other side. As I said, I just use the Doppler, but of course you can have more sophisticated methods to use for reconstruction. And again, even though a patient may be thin, you can have enough tissue to have enough volume on the breast. The S-gap and I-gap have as disadvantages that even, especially in the I-gap, that there is a painful donor side to sit for 3 to 6 weeks, and if the sciatic nerve is not covered, may be painful. These are not mine cases, they are from a publication. According to myself, I don't consider this a nice donor side because I wouldn't ruin a buttock to create a breast, but this is the surgeon's and patient's preference. And the tuck flap, this may be a patient that has a good indication because she has a small cap and has excess tissue at the thighs, so she can probably have a thigh lift. She's still considering it. And the lumbar artery perforator flap again uses tissue from the lumbar area. There is also a possibility to perform a nerve anastomosis with the cluneal nerve, but the pedicle is short. Again, this is from a publication. And the Rubens flap uses the tissue superior to the iliac crest. The dissection is difficult because this is has a very tortuous course. And probably this is a patient that is a very unique patient to have this type of reconstruction due to her body contour. So where to perform the anastomosis in the internal mammary or thoracodorsal? There is no difference in the blood flow within the flap, either if you perform the anastomosis to the thoracodorsal or internal mammary. However, if you perform the anastomosis to the thoracodorsal, even though it might be open already when the breast surgeon does, for example, the axillary dissection or the sentinel node, you ruin the possibility to have at a later stage latissimus dorsi, so you burn your bridges with the latissimus dorsi. And finally, what if we do neurotized versus non-neurotized flap? There is a heterogeneity of the data in the literature, and that there is still not a strong evidence that there is a benefit in the comparison of these two procedures in the long-term results. Thank you very much.
Thank you very much, Professor Spiropoulou, for this wonderful talk. It's very clear that this type of surgery is a subject of only of plastic surgeons internationally. It's very complex surgery, and it requires training and continuous practice, so I get the impression that we don't have many. I can see a few very good plastic surgeons in this room, but I know that in Greece we don't have many plastic surgeons who practice free flaps. What do you think is the reason for that?
I think it's because it's very costly and needs specific training. So specific training you can have, but especially in the private practice, there are not many people that can pay for this type of procedure.
Okay. I think we have time for a few questions. Any questions, please?
Andrea? Make a comment? Make a comment?
We can do the comments at the end, if that's okay. At the end, yes. Is that okay? Yeah, okay, thank you.
Okay, thank you.
Okay, thank you very much. Okay, and now we will move on to the next speaker, who is an old friend and colleague from UK, Mr. Marcos Malachias. Marco is a very experienced plastic and reconstructive surgeon and works in one of the busiest, probably the busiest service in Europe at Queen Elizabeth University Hospital in Birmingham, UK. And we all had cases where we thought that may have been inoperable. Okay, so Marco, I think, is going to give us an idea of what else we can do to do with these cases. So the title is Chest Wall Reconstruction in Locally Advanced and Recurrent Breast Cancer.
Ladies and gentlemen, thank you for having me. Locally advanced breast cancers can present in a variety of ways. I've seen them as primary cancers originating in the breast, as recurrent breast cancers that arise after a patient has undergone previous breast surgery for cancer, radiation-induced sarcomas, which are a sequelae of the breast cancer treatment, and metastatic cancers from the breast to the chest wall skeleton. So the principles of management can be divided into the first part, which is the curative resection, the aim of curative resection, and the approach is in a multidisciplinary team where different subspecialists get together in order to discuss and plan appropriately. The plan is obviously teamwork. We all need to pull together, radiology, plastics, thoracics, and physiotherapists, of course. And the aim is to achieve a wide local excision with clear margins in order to rid the patient of the cancer. That is the aim of the curative resection. Now, with regards to the reconstructive part, we have to consider two parts. First part is the skeletal reconstruction, which may be rigid or non-rigid, and this is to restore the respiratory mechanical functional integrity of the thoracic area. And the second part is the soft tissue coverage. Nothing works unless you have adequate coverage with structural integrity in order to protect the reconstructed chest wall. Otherwise, infections become a problem, and you're pretty much back to square one, where you have to remove everything and put the patient on long-term antibiotics. And that is quite traumatic and quite challenging and problematic for a patient who's already limited in their resources, their physiological resources. So how do we reconstruct the chest wall, the metalwork, the bony bits, the hardware, if you like? We have flexible options like barriers such as synthetic meshes and biological meshes. The synthetic meshes like Marlex are quite cheap. They're easily available. The problem is that they are, technically speaking, a piece of plastic, and it will never get incorporated into the body and always poses an area for infection. The benefits of using a biologic mesh is that eventually this gets incorporated into the patient's own body, into the patient's own anatomy, and subsequently can fight infection and has the downside of creating more of a seroma during the first 6 to 8 weeks. Then we've got the rigid fixation osteosynthesis, which is titanium bars, cheap and cheerful, or something more sophisticated, which is a 3-dimensional titanium printed implants with hydroxyapatite. Our unit was the first in the world to successfully implant this in a patient who survived. It was printed for us in Australia after we forwarded the 3-dimensional reconstruction, CT reconstruction, to the company in Australia, and a few weeks later received the custom-made prosthetic, which fits like a glove would fit a hand. Then we've got a hybrid, which is basically a combination of the previously mentioned modalities, where you use Marlex and methyl methacrylate, or Marlex and titanium bars, or acellular dermal matrix and titanium bars, or a combination of Marlex, methyl methacrylate, and titanium bars. The benefit of methyl methacrylate is that we can also mix antibiotic powder into it, which makes it more resistant to any form of infection. So a few examples, and the very first one is the simplest version, and that is Marlex mesh. You can see here I usually use Ethibond size 0 or size 1 sutures in order to fix that in place. 3D titanium printed implant, this is actually the one that I mentioned earlier. ADM and titanium bars again, where the ADM is sutured into the chest wall in a similar fashion like the Marlex, but as I said, it has the merits of being incorporated into the patient's body. Methyl methacrylate and Marlex, we sandwich that. So basically, in order to do that, you would take one layer of Marlex and put the cement in the center, and put a second layer of Marlex on top, and this way you end up with a sandwich, and that allows you to have a rigid structure that is sutured into the chest wall, but has an element of flexibility as well, because the surrounding part, this bit here, allows some movement. So it's not as rigid, because patients sometimes complain that they feel that they're lying on something non-flexible when they're recumbent. And another one is the combination, where you have methyl methacrylate, cement sandwich with Marlex and titanium bars. That obviously depends on the size of the defect. Now, this brings us to the second part of the reconstruction, which is the soft tissue coverage. There are a few things to consider. I like to always consider my options regionally, for example, a pectoralis major flap or a latissimus dorsi flap from the back, or if everything else fails, an omental flap. But that, I'm not a very big fan of that, because you violate the abdominal cavity, you open that up as well in addition, so you have a problem in the thoracic area, and then you also open up the abdomen, and that can sort of weaken the patient a bit further. For a free tissue transfer, my preferred choice would be a deep inferior epigastric perforator flap, or sometimes an anterolateral thigh flap, or a tensor fascia lata flap, depending on size of defect and body habitus of the patient. The benefits of having a free tissue transfer, in my opinion, is that you can keep the operative sites clear. There's less chance of spilling and soiling, and it's definitely worth considering. Another thing worth considering, or one has to take into account, is whether or not there's an associated skin defect. Because if there's a skin defect, that adds the problem that we also need to consider, not just the coverage, but also getting robust skin. So if there's no associated skin defect, that makes things a little bit easier. Now, with regards to associated skin defect, we can use a myocutaneous or muscle cutaneous flap, which is either a free or a pedicle tram, as Professor mentioned earlier, or a latissimus dorsi. For a fasciocutaneous flap, we can use the anterolateral thigh flap from the thigh, or a muscle flap with a graft where we use latissimus dorsi, pectoralis major, or serratus and put a skin graft on. You may notice that I've put the omental flap under that, but I ran out of space on this slide, and that's why I've just included that. I've bundled that in with the muscle and graft flap. When there's no associated skin defect, things are fairly straightforward. You raise a latissimus dorsi or a pectoralis major muscle, and you rotate that into position and cover it up with the surrounding skin. So, a few cases. This is a patient with a locally advanced primary breast cancer and a free DIEP reconstruction. This lady was 29 years old, and if you look in the center of the scan, this part here, you'll see that there's a nasty growth. And that's the clinical presentation. It was treated by colleagues as a fungal infection for a few months, and that complicated matters in delaying presentation and things like that. So we proceeded and excised the tumor with rib down and pleura. You may notice the green background here. That is a little piece of plastic that we use in order to suture the vessels, and in her case we've highlighted that so that you can see the recipient vessel, which is the internal mammary artery. And here are the titanium bars in place with an underlying mesh that was sutured in place with the size 1 Ethibond suture, the green sutures. And this is the microvascular anastomosis done, covering the defect, and this is the final result. Now again, here you can see the scan with the tumor, as I highlighted it earlier here, up here. And the next scan will show you what the reconstructed area looks like. This is abdominal tissue that has been transplanted into the medial thoracic area. You can see a little bit of the scatter from the titanium bars. Another one is a recurrent breast cancer and a free tram. If you have a look here, there you can see our tumor, that area there. And this young lady presented with a swelling and a persistent wound, and this is unfortunately what we found. There you can see the excised specimen, and here's the undersurface of the excised specimen where we removed the breast, part of the lung, I think 4 ribs, and the pericardium as well. Sorry. This is the defect. The ruler is 20 centimeters in length, so we're looking at a defect of about 25 centimeters. And here we reconstructed the sternum by using a cheap and cheerful sandwich of Marlix and methyl methacrylate that was sutured in place. And this is the abdominal cavity of this lady. Here we are highlighting the perforators that come from the depth of the deep inferior epigastric artery that traverse the rectus abdominis and enter the lower abdominal fat, as mentioned in previous talks. And here is the flap that we resected. For speed, we took a little bit of muscle. It just sped the operation up by a good half hour. And when you deal with cases like that, time is of the essence because you do not want to be lingering and having them on the operating table for longer than you absolutely have to, because there are lots of factors to consider. This is the vein coupler. That's a plastic cage that brings the vein together. And as the cage closes, these two plastic bits unite and achieve a seal. The artery, which is 2 millimeters in diameter, usually sometimes a little bit bigger, is hand sewn. And there you have the microvascular anastomosis in place. Blue is obviously the vein, the other one, blue is the vein, the other one is the artery. And you may be able to distinguish that this one here has this plastic cage around it where the vein was connected, and this one here is the hand sewn anastomosis. And that is the end result of this lady. It's not with cosmesis. This is not a cosmetic intervention. This is a life-saving or life-preserving intervention, and unfortunately, sometimes we have to compromise looks. It is life over limb over looks, as we say in reconstruction. So the first thing is to survive. The second thing is to keep the limb if it's, for example, a cancer on the arm. And the third thing is to make it look pretty. Unfortunately, in this lady, we couldn't offer her much more than that. Next is a recurrent breast cancer with the latissimus dorsi muscle flap. This patient had the challenge of being very, very skinny, and therefore we were not able to harvest the latissimus dorsi muscle with the overlying skin, because that wouldn't have been closable on the back. I think you can appreciate that this patient is very thin with very little subcutaneous tissue. And here we excise the area again, 3 ribs down to lung, and the sandwich technique again. And the latissimus dorsi muscle flap was brought through from the back, through a separate incision on the back, and then tunneled along the lateral chest wall into the anterior aspect of the left chest. And unfortunately, again, it doesn't look great, but it has done the job to preserve this patient's life with the skin graft in place. And this is, I think, 8 weeks after surgery, 8 to 10 weeks after surgery. The next one, this is an interesting case because this was a radiation-induced angiosarcoma post-breast cancer treatment. And this is what the patient presented. You can see the darkly pigmented lesion in the mastectomy scar. This was the resection, again, down to lung. Latissimus dorsi muscle flap from myocutaneous muscle flap from the posterior aspect of the chest, the cement sandwich in place, and has covered the defect of 4 ribs quite successfully. And this is the end result. Recurrent breast cancer and free muscle-sparing tram flap, or the EP flap, is this a lady that had a combination of titanium bars, cement, and Marlex mesh, and this is her end result. And the last patient that I would like to present is actually a male patient that did not have breast cancer as such. He had a chondrosarcoma of the sternum, but because I didn't take any photographs of other patients with breast cancers and tensor fasciae lata flap reconstruction, I thought this would be a little pleasant addition, just so that you can see what a tensor fasciae lata flap can cover. Now, this is the gentleman. His wife had died a few years before. He was in a terrible state of self-neglect. He was an alcoholic, very well functioning member of society before that, but due to tragic events, he sort of spiraled out of control. This is the donor site. We've published this because this was the biggest tensor fasciae lata flap that I had ever seen, so that got published. And these are the resection down to pericardium, down to lung, where we removed 6 ribs on each side to the anterior axillary axillary line, including sternum. And there you have the ADM in situ with the titanium bars in place. Top view. And you can see the pectoralis major muscle left and right. We've preserved those because they were salvageable to some degree. This is the right lateral aspect of the thigh where we're raising the tensor fasciae lata flap. It's quite quick to raise because it's mostly uniplanar dissection, so the dissection is not very complex. And this is the end result for this gentleman. Side view, and more importantly, the donor site is quite acceptable, actually. Now, to take home the take-home message, multidisciplinary team is the way forward. Multidisciplinary team for surgery is also quite important, where we work very closely with the thoracic colleagues during the surgery, but also the immediate aftercare by nurses and specialist physiotherapists cannot be underestimated, because recovery starts immediately after surgery, where we sit the patient up. We start to get them to do breathing exercises in order to ventilate their lungs properly and hopefully help them recover. Unless there's a metastasis, most chest wall tumors are resectable, even if they look quite horrendous, like, for example, the last case that I presented. And it is imperative to have a wide resection in order to rid the patient and reduce the potential need for further surgeries. And obviously a robust skeletal reconstruction with soft tissue coverage to restore the ventilation mechanics is essential as well. Thank you very much. Sorry for overrunning.
Thank you very much. We are open discussion and comments from audience. Probably 20 or 30 years ago, we have seen this kind of patients more frequently. I remember, but today, new therapeutic agents and better surgery and radiation therapy prevented this kind of patients. I know that the morbidity and mortality rate is also very high in this kind of patients because stability of thoracic wall is disturbed, and there are many, many complications related with that. I would like to learn about the morbidity and mortalities of this kind of major surgical procedure. Thank you.
Well, usually we aim to give the patient a good quality of life for what is left. I remember a young patient, she was I think 31 or 32, she had a horrible chest wall cancer, and we knew she was going to die, and her biggest problem was that her daughter wouldn't go near her because she smelled.
Fantastic work, Marco.
Thank you, sir.
Thank you very much for being with us. Now, the commentators, do you have any comments from the commentators, please? Dr. Hamsas and Dr. Gravanis, and Hamsas, Dr. Gravanis and Dr. Kontoulis, yes?
We have 3 commentators.
Yes.
Okay.
Go on.
Very interesting talks of very experienced people. Regarding the first talk of Dr. Exarchos, I think that the take-home message is that the reconstructive surgeon should be familiar with all the possible pedicles in wise pattern, so to be flexible to use the pedicle that is necessary to reconstruct the defect. He said that he decides intraoperatively which pedicle to use. I think it's nice to have a pre-operative plan and have decided the pedicle before. Of course, you have to be flexible if the margins of the tumor.
I won't say that. So you know the pedicle from advance, and you use the setup perforator flap as a backup plan.
Ah, okay, okay.
So you know,
yeah, that's great. Yes. Sure.
And you use that as a plan B, so you know where you're going.
Okay, that's great.
You don't cut anything unless you're sure. So the setup perforator is a plan B.
Nice, thank you very much. Regarding Professor Spiropoulou, great talk with great results. I would like just to make a comment regarding the timing of the autologous reconstruction in relation with post-mastectomy radiation therapy. I think that there is a big meta-analysis in the US that it indicates and strongly recommends that the reconstruction should be delayed, because the autologous reconstruction is a very precious reconstruction, is a lifetime reconstruction, so there is no point to expose this valuable piece of tissue to radiation. And regarding the timing, I think that contrary to the implant-based reconstructions can be performed earlier as to implant-based reconstruction 6 months. I think there is a strong evidence, and also it's our experience that you can do it even in 2 months after the completion of the radiation therapy. And regarding the last talk of Dr. Malachias, very, very impressive cases. Thank you very much. Very important to have in mind that we have a skeletal reconstruction and soft tissue reconstruction. The skin is, of course, the key point for the successful reconstruction, especially if we are using foreign bodies. And I would like to comment that I think that in the reconstructive ladder, the free flap or a distant flap should be the first choice, because I don't think that it's very wise to use a local muscle flap such as pectoralis major or anterior, serratus anterior in already traumatized chest. And I would like also to highlight the great use of ALT flap, because you can use the vascularized fascia lata, so you don't have to use a foreign body, a foreign mesh, because you have the vascularized fascia lata that can be used as a mesh with very sealed suturing.
Yeah,
what is your opinion?
With regards to the second part of your comment, thank you very much. The fascia lata will not be strong enough. We find that in order to maintain adequate ventilation and the mechanics and the stresses of it and the repeat expansion, exhaling and inhaling, it wouldn't be sufficient. That will compromise your mechanical ventilation. Sorry, yes, of course. Thank you. I was basically just saying that using fascia lata as such would not necessarily give us the rigidity or the firmness that is necessary to maintain thoracic wall integrity. Please, with regards to the first part, yeah. Yeah, in all fairness, we use what we can, right? If we can get away with a smaller flap, I'll gladly take that. And the anesthetist is usually quite happy with us because you have to deflate the lung. It takes longer. We have to use whatever we can. And if we can successfully reconstruct with the smallest possible option, I will gladly do that. Because as Professor very accurately pointed out, every half hour on table is a 14% increase in postoperative complications. So speed is of the essence, because it's not just the resection, it's the deflation of the lung that is essential. It is the secondary donor site. There's so many different factors, and time runs away with you very, very quickly. All of a sudden you look up and it's 6 p.m. and you've been at it for 6, 7, 8, 9, 10, 20 hours. And if I can get out of a sticky situation swiftly, that would always be my first choice. But thank you for your comment.
It is important to follow the bibliography because, Andreas, you said you've seen a large meta-analysis, and I presented also a prospective study and a large meta-analysis that mentions quite the opposite. So that mentions that you can use, immediate reconstruction. Yes, and there is no difference, So one meta-analysis says the other one, the other thing.
A couple of months ago in PRS,
yes.
Radiation therapy breast reconstruction by Rory from MD Anderson. Okay.
Yeah.
Whatever
yeah.
My experience is also that whenever I have used the flap and then it was radiated, the aesthetic outcome was compromised. The flap was harder, even if I have used 2 perforators, better blood supply.
Yeah.
The flap was always.
Yeah, but we cannot rely on our experience. We cannot rely on our experience.
Dr. Hamsas, any comments, please? Quick.
Thank you all the speakers for the excellent presentations. We see that in the difficult situations, it's very important the combination of the collaboration of the different specialities in order to have the better results. And very important in Himalayas is that when we have a local advanced problem in the chest, it's very important to make a huge excisions of the problem in order to have better results and less recurrence. And this is important to collaborate with thoracic and plastic surgeon and other specialty in order to have the possibility to cover the defect. And thank you the other speakers for the...
Dr. Kontoulis.
Excellent talks and very comprehensive presentations. I don't have anything to add to our two fantastic plastic surgeons. I agree with Mr. Exarchos that we need to have preoperative marking and good knowledge of the circulation to the nipple. We should have a plan B. I assume that nowadays less and less you're doing an inferior pedicle wise pattern mammoplasty with the in the area of perforator flaps.
So my favorite pedicle is the superomedial. It has a better aesthetic outcome. There is good evidence that the inferior pedicle is bottoming out after many years. There is published literature. The only reason I would use the inferior is if the cancer is in the superior medial location in the upper central breast. If I don't have a superomedial, I use a lateral pedicle, which I Doppler it, I map it, and it has a very good outcome. So if superior medial is not possible, go for a lateral. So inferior, I've rarely used it, and I have many colleagues that agree with this approach.
Thank you very much.
Okay, we come to end of the panel session. I'd like to thank you for everybody for your listening to excellent speakers, guests. And I think we will have a break for 30 minutes, President. Okay, next session will be a satellite lecture. Okay, thank you.
Συγγνώμη, αλλά δεν έχουμε και πολύ χρόνο για να κάνουμε διάλειμμα. Έχει πολύ ενδιαφέρον η επόμενη ομιλία. Απλά επιτρέψτε μου να κάνω λίγο ιστορία. Και η ιστορία είναι ότι όλοι τώρα πλέον εδώ στην Ελλάδα χρησιμοποιούμε την προεγχειρητική χημειοθεραπεία και τη χημειοθεραπεία για τον καρκίνο του μαστού. Η Ελληνική Χειρουργική Εταιρεία Μαστού πριν από πολλά χρόνια ξεκίνησε αυτό το neoadjuvant chemotherapy, especially κυρίως με τους HER2 θετικούς νόσους, τότε που οι ΕΟΠΕ και οι παθολόγοι, ογκολόγοι πιέζανε τους χειρουργούς να μην χειρουργούν, αλλά να κάνουν προεγχειρητική χημειοθεραπεία. Νομίζω ότι αυτό είναι ένα μεγάλο βήμα που έκανε η ΕΧΕΜ τότε. Μάλιστα κάναμε και μια συνάντηση για να κάνουμε guidelines μεταξύ μας, μεταξύ της ΕΟΠΕ και της ΕΧΕΜ, και ήταν πάρα πολύ σοβαρό, ειδικά για τους HER2 θετικούς ασθενείς. Τότε που προσπαθούσαν οι παθολόγοι ογκολόγοι να πιέσουν τους χειρουργούς να κάνουμε προεγχειρητική χημειοθεραπεία. Και εμείς βέβαια προσπαθήσαμε να πιέσουμε τους εαυτούς μας καταρχήν και να πείσουμε ότι όντως έχει όφελος αυτό. Θεωρώ ότι η ΕΧΕΜ είναι πρωτοπόρος, δεν πρόκειται να το ξεχάσουμε αυτό, μην το ξεχνάτε, σαν χειρουργοί, γιατί κάπου αισθανόμαστε πολύ την πίεση των παθολόγων ογκολόγων, αλλά μην ξεχνάτε ότι παίζουμε καθοριστικό ρόλο στη θεραπεία του ασθενούς σε όλα τα επίπεδα. Και ένας από τους λόγους που πιέζουμε οι χειρουργοί μας του να έχουν άποψη είναι γιατί πρέπει να έχουν άποψη στο Ογκολογικό Συμβούλιο. Είναι πάρα πολύ ωραία αυτά που παρουσιάστηκαν σήμερα στο χειρουργικό κομμάτι και ναι, είναι απόλυτα αποδεκτά, αλλά θέλω να έχουμε άποψη και για τις μελέτες των ογκολογικών φαρμάκων για να έχουμε άποψη και στην προτινόμενη θεραπεία. Ξεπερνώντας λοιπόν αυτό, σήμερα πάλι εδώ, πάλι σε ένα συνέδριο της ΕΧΕΜ, θα προχωρήσουμε σε κάτι καινούριο. Σε κάτι νέο, το οποίο είναι η υποδόρια χορήγηση της θεραπείες για του hair. Η υποδόρια χορήγηση αυτή τη στιγμή δεν είναι gold standard. Είναι κάτι το οποίο το συζητάμε, αλλά υπάρχουν αρκετά προβλήματα. Νομίζω λοιπόν ότι καλό είναι που εδώ σε εμάς, πάλι σε ένα συνέδριο της ΕΚΕΜ, θα συζητήσουμε για ένα ογκολογικό θέμα. Είναι ιδιαίτερη χαρά λοιπόν να έχουμε κοντά μας την κυρία Σκόντρα, η οποία είναι παθολόγος ογκολόγος και η οποία θα μας μιλήσει για τα δεδομένα της μακροχρόνιας αποτελεσματικότητας και ασφάλειας στη διαχείριση του πρώιμου HER2 θετικού καρκίνου μαστού και η αξία της υποδόρειας χορήγησης.
Καλησπέρα σε όλους και από μένα. Ευχαριστώ πάρα πολύ για την πρόσκληση, την ΕΧΕΜ και τον κύριο Βενιζέλο. Είναι πολύ μεγάλη τιμή για μένα να συμμετέχω σε αυτό το συνέδριο. Επίσης, να ευχαριστήσω και την εταιρεία ΡΟΣ για την ευγενική χορηγία και πραγματικά ήθελα να πω ότι έχω πάρα πολύ καιρό να δω τόσο κόσμο σε συνέδριο. Όπως γνωρίζετε, ο καρκίνος του μαστού είναι η πιο συχνή κακοήθεια στο γυναικείο πληθυσμό. Παρ' όλα αυτά βλέπετε ότι τα ποσοστά θνητότητας που οφείλονται στον καρκίνο του μαστού αντιστοιχούν περίπου στο 7% του συνόλου των θανάτων που οφείλονται σε καρκίνο. Είναι χαμηλό το ποσοστό. Από το 1980 η επίπτωση του καρκίνου του μαστού κάθε χρόνο αυξάνεται κατά 1%. Ωστόσο, αυτά τα χρόνια η θνητότητα έχει μειωθεί κατά 40%. Αυτό σίγουρα οφείλεται στον προσυμπτωματικό έλεγχο κατά ένα μεγάλο ποσοστό. Η νόσος πλέον, όπως βλέπετε και στη διαφάνεια, στη συντριπτική πλειοψηφία ανιχνεύεται σε πρώιμο στάδιο όταν ακόμα είναι η άσημη. Ωστόσο, σε ένα ποσοστό 50% οφείλεται και στις θεραπευτικές εξελίξεις τόσο στην πρώιμη όσο και στη μεταστατική νόσο. Έχουμε τρεις βασικούς υπότυπους. Ο πιο συχνός είναι ο ορμονοευαίσθητος HER2 αρνητικός. Ο HER2 θετικός καρκίνος του μαστού, παρόλο που δεν είναι πολύ συχνός, είναι περίπου το 20% των περιπτώσεων, ωστόσο ο όγκος είναι η νόσος που έχουμε τις περισσότερες εξελίξεις. Και θεωρώ ότι η στόχευση του HER2 υποδοχέα ήταν μία από τα μεγαλύτερα επιτεύγματα που έχουμε στην ογκολογία. Όλα ξεκίνησαν το 1984 όταν ανακαλύφθηκε το HER2 ογκογονίδιο, ενώ 3 χρόνια αργότερα ο Ντένις Λέιμον συνδύασε την υπερέκφραση του HER2 υποδοχέα με μια πολύ επιθετική μορφή της νόσου. Μέχρι τότε οι ογκολόγοι δεν μπορούσαν να καταλάβουν γιατί έχουμε μία νόσο με θετικούς ορμονικούς υποδοχής και μπορεί να έχει τόσο χειρότερη πρόγνωση σε σχέση με άλλους ορμονοευαίσθητους όγκους. Είναι γιατί δεν είχε γίνει ακριβώς αυτή η συσχέτιση. Τα πράγματα άλλαξαν όταν ανακαλύφθηκε το τραστούζουμαμπ. Το τραστούζουμαμπ είναι ένα μονοκλονικό αντίσωμα το οποίο στοχεύει στο εξοκυτάριο τμήμα του HER2 υποδοχέα. Πρώτη φορά πήρε έγκριση το 2000 για τη μεταστατική νόσο, ενώ το 2006 εγκρίθηκε και στην πρώιμη νόσο. Και από τότε βλέπετε ότι έχουν εγκριθεί αρκετοί στοχευτικοί παράγοντες και τα τελευταία χρόνια επίσης έχουμε στη διάθεσή μας 2 καινούργια φάρμακα με πολύ αποτελεσματικά στο μεταστατικό setting. Και έτσι έχουμε φτάσει στο σήμερα, όπου λέμε ότι οι ασθενείς με HER2 θετικό καρκίνο του μαστού πάνε καλύτερα από κάθε άλλο ασθενή και μάλιστα έχουμε στη μεταστατική νόσο τις καλύτερες επιβιώσεις. Δηλαδή, αν οι ογκολόγοι μπορούσαν να επιλέξουν ποιες ασθενείς θέλουν να θεραπεύσουν, θεωρώ ότι θα επιλέγαν τις ασθενείς με HER2 θετικό καρκίνο του μαστού, γιατί έχουμε τα καλύτερα φάρμακα. Έχουμε εγκεκριμένους 8 παράγοντες στη μεταστατική νόσο, 8 στοχευμένες θεραπείες, εκ των οποίων οι 4 είναι εγκεκριμένες και στην πρώιμη νόσο. Έχουμε 2 μονοκλονικά αντισώματα, το τραστούζουμαμπ και το παρτούζουμαμπ, τα οποία στοχεύουν στο εξοκυτάριο τμήμα του υποδοχέα σε διαφορετικό επίτοπο. Έχουμε τον εράτινιμπ, που είναι ένας αναστολέας τυροσινικής κινάσης και στοχεύει στο ενδοκυτάριο τμήμα του υποδοχέα. Και έχουμε και το TDM1. Το TDM1 είναι ένα συζευμένο μόριο, έτσι ονομάζεται, το πρώτο που εγκρίθηκε στον καρκίνο του μαστού και στην ουσία αποτελείται από τραστούζουμαμπ, από μονοκλονικό αντίσωμα, φορτωμένο με χημειοθεραπεία. Έτσι, βρίσκει το στόχο, το μονοκλονικό αντίσωμα, το καρκινικό κύτταρο που υπερεκφράζει τον υποδοχέα, απελευθερώνει το κυταροτοξικός παράγοντας και σκοτώνει το καρκινικό κύτταρο. Όλα ξεκίνησαν το 2005 με τις μεγάλες μελέτες του τραστούζουμαμπ στην επικουρική θεραπεία, που έδωσαν όφελος όχι μόνο στην επιβίωση ελεύθερη υποτροπής, αλλά και στη συνολική επιβίωση. Βλέπετε εδώ μία μετανάλυση των μεγάλων αυτών μελετών, που φαίνεται ότι η προσθήκη του τραστούζουμαμπ στη χημειοθεραπεία μείωσε τον κίνδυνο υποτροπής κατά 40% και τον κίνδυνο θανάτου από την νόσο κατά 35%. Και το όφελος ήταν ανεξάρτητο από την κατάσταση των ορμονικών υποδοχέων. Ωστόσο, παρά την πρόοδο, υπήρχε ένα 25%, δηλαδή 1 στις 4 γυναίκες, που ακόμα μπορούσαν να υποτροπιάσουν. Οπότε υπήρχε χώρος για περαιτέρω βελτίωση. Γίνανε κάποιες προσπάθειες, κάποιες από αυτές ήταν αρνητικές, όπως το να δώσουμε για μεγαλύτερο χρονικό διάστημα τραστούζουμαμπ ή η προσθήκη του λαπάτιν ή του μπεβασίζουμαμπ. Είχαμε όμως και θετικές μελέτες, τις οποίες θα σας δείξω στη συνέχεια. Επίσης, γίνανε κάποιες προσπάθειες αποκλιμάκωσης της θεραπείας, να χορηγήσουν για μικρότερο χρονικό διάστημα το τραστούζουμαμπ, οι οποίες όλες ήταν αρνητικές, οπότε καθιερώθηκε στην πρώιμη νόσο η χορήγηση του φαρμάκου για 1 έτος. Θα ξεκινήσω με την επικουρική θεραπεία. Η επικουρική θεραπεία είναι μια τακτική που τα τελευταία χρόνια συνεχώς κερδίζει έδαφος. Χρησιμοποιείται όλο και περισσότερο. Και η αυξημένη αποτελεσματικότητά της θεωρώ πλέον ότι μας έχει πείσει όλους για τη χρησιμότητά της. Έχει κάποια σημαντικά πλεονεκτήματα, εκτός από το ότι κάνει downstaging του όγκου και της μασχάλης και μπορεί να οδηγήσει σε ένα πιο συντηρητικό χειρουργείο με μικρότερη χειρουργική νοσηρότητα. Έχει το πλεονέκτημα ότι γνωρίζετε ότι ο καρκίνος του μαστού είναι μια συστηματική νόσος και ειδικά όταν έχουμε επιθετικούς φαινοτύπους όπως είναι ο τριπλά αρνητικός και ο HER2 θετικός, χορηγώντας πρώτα τη χημειοθεραπεία μπορούμε να αντιμετωπίσουμε πρώιμα νωρίτερα τις ήδη υπάρχουσες μακρομεταστάσεις. Το πιο σημαντικό όμως πλεονέκτημα κατά την άποψή μου είναι ότι μας δίνει τη δυνατότητα να αξιολογήσουμε in vivo την ανταπόκριση του όγκου στην χημειοθεραπεία και έτσι ανάλογα με αυτό που έχουμε επιτύχει, δηλαδή αν έχουμε κάνει πλήρη ανταπόκριση ή μερική ανταπόκριση, αν υπάρχει υπολοιπόμενη νόσος, μπορούμε στη συνέχεια να κάνουμε αποκλιμάκωση ή αντίστοιχα κλιμάκωση της επικουρικής θεραπείας και να αυξήσουμε το όφελος για τις ασθενείς. Βλέπετε εδώ ότι τόσο στον τριπλά αρνητικό όσο και στον HER2 θετικό καρκίνο του μαστού τα πράγματα είναι εξαιρετικά όταν επιτυγχάνεται πλήρης ανταπόκριση, όταν όμως έχουμε υπολοιπόμενη νόσο και μάλιστα όταν έχουμε υψηλό φορτίο υπολοιπόμενης νόσου, το ποσοστό υποτροπής στον HER2 θετικό μπορεί να φτάσει στο 40%. Έτσι λοιπόν αυτή τη στιγμή στις κατευθυντήριες οδηγίες όσον αφορά το τριπλά αρνητικό και το HER2 θετικό, λέμε ότι είναι καλύτερο να χορηγήσουμε προεγχειρητική χημειοθεραπεία όταν ο όγκος είναι πάνω από 2 εκατοστά ή όταν έχουμε θετική μασχάλη ανεξάρτητα από το μέγεθος του όγκου. Μάλιστα, σε κάποιες περιπτώσεις, σε πολύ επιθετικούς φαινοτύπους, μπορούμε να χορηγήσουμε προεγχειρητική θεραπεία ακόμη και σε όγκους που είναι τα φ1C. Ακριβώς λοιπόν στα ίδια κατέληξε και η πολύ επιτυχημένη, όπως είπε ο κύριος Βενιζέλος προηγουμένως, συνεργασία της ΕΧΕ με την ΕΟΠΕ. Ακριβώς λοιπόν λόγω της αυξανόμενης χορήγησης νοεπικουρικής θεραπείας έχουμε τα τελευταία χρόνια χρησιμοποιούμε ένα βιοδείκτη, την πλήρη παθολογανατομική ανταπόκριση, που σημαίνει απουσία διαιτητικού στοιχείου στο μαστό ή στη μασχάλη. Έχει φανεί από μεγάλες μεταναλύσεις, όπως εδώ αυτή που βλέπετε στην οθόνη, 12.000 ασθενείς, ότι η πλήρης παθολογανατομική ανταπόκριση συνοδεύεται από μεγαλύτερη επιβίωση ελεύθερη υποτροπής, αλλά και καλύτερη συνολική επιβίωση. Στην πρώιμη HER2 θετική νόσο είχαμε το 2013 δύο πολύ σημαντικές μελέτες στην ΕΟΣΦΙΡ και την Τριφα-1, οι οποίες αξιολόγησαν, σύγκριναν στο εννοεπικουρικό setting την χημειοθεραπεία με τραστούζουμαμπ έναντι χημειοθεραπείας με τραστούζουμαμπ και περτούζουμαμπ, διπλή αντιχερτού στόχευση. Και οι δύο έδειξαν ότι με τη διπλή στόχευση επιτυγχάνουμε καλύτερα ποσοστά πλήρους ανταπόκρισης και αυτό αντικατοπτρίζει καλύτερα μακροπρόθεσμα αποτελέσματα. Έτσι λοιπόν αυτή τη στιγμή από όλες τις κατευθυντήριες οδηγίες παγκοσμίως συστήνεται όταν χορηγούμε νοεπικουρική θεραπεία στον HER2 θετικό να χορηγούμε χημειοθεραπεία σε συνδυασμό με διπλή στόχευση τραστούζουμαμπ και περτούζουμαμπ. Και πράγματι όταν η ασθενής μας κάνει πλήρη ύφεση, πλήρη παθολογανατομική ανταπόκριση, τα πράγματα είναι ενθαρρυντικά, είμαστε χαρούμενοι, τις ενημερώνουμε ότι η πιθανότητα υποτροφής είναι πάρα πολύ μικρή, όμως είχαμε πρόβλημα με τις ασθενείς που είχαν υπολοιπόμενη νόσο. Όλα άλλαξαν με τη μελέτη Catherine. Η μελέτη Catherine είναι μια πολύ σημαντική μελέτη φάσεως 3 που πήρε ακριβώς αυτόν τον πολύ δύσκολο πληθυσμό, τις ασθενείς δηλαδή με υπολοιπόμενη νόσο, και τη στοιχειοποίηση ήταν να συνεχίσουν με το standard of care εκείνης της εποχής που ήταν να λάβουν τραστούζουμα συνολικά για 1 χρόνο ή να λάβουν TDM1. Ένα φάρμακο το οποίο εκτός από μονοκλονικό αντίσωμα, όπως είπαμε, περιέχει και χημειοθεραπεία, να γίνει δηλαδή κλιμάκωση της επικουρικής θεραπείας. Θα σας δείξω τα τελικά αποτελέσματα της μελέτης που ανακοινώθηκαν στο περσινό Σαν Αντώνιο. Αυτά είναι τα αποτελέσματα της αρχικής ανάλυσης του 2018. Τότε είχε φανεί ότι η απόλυτη διαφορά μεταξύ των δύο σκελών ήταν 11,3% υπέρ του TDM1. Δηλαδή, το να δώσεις TDM1 σε αυτές τις ασθενείς μειώνει τον κίνδυνο υποτροπής κατά 50%. Στο περσινό Σαν Αντώνιο είχαμε αποτελέσματα 7ετίας, μετά από 8,5 χρόνια παρακολούθησης, που ήταν και τα τελικά αποτελέσματα της μελέτης, και φάνηκε ότι η διαφορά αυτή είναι ακόμη μεγαλύτερη, φτάνει το 14 περίπου της 100 και διατηρείται αυτό το εξαιρετικό hazard ratio του 0,5. Επίσης, είχαμε όφελος και στη συνολική επιβίωση, δεν είναι το τελικό αποτέλεσμα, φαίνεται όμως ότι στην 7ετία η απόλυτη διαφορά είναι της τάξης περίπου του 5%. Από τις ανεπιθύμητες ενέργειες δεν είδαν κάτι, υπήρχε λίγο μεγαλύτερη τοξικότητα με το TDM1, είναι όμως πραγματικά εύκολα διαχειρίσιμη από τους ογκολόγους. Έτσι λοιπόν η μελέτη αυτή άλλαξε το standard of care και σε ασθενείς οι οποίες μετά από νοεπικουρική θεραπεία, όταν έχουμε υπολοιπόμενη νόσο, δίνουμε TDM1 για 14 κύκλους. Τρέχει μελέτη σύγκρισης τώρα, TDM1, έναντι ενός νεότερης γενιάς συζευμένου μορίου, του τραστούζουμαμπ deruxtecan, ένα πολύ καλό φάρμακο που έχει πάρει ήδη έγκριση στη μεταστατική νόσο, μας έχει δώσει εξαιρετικά αποτελέσματα. Περιμένουμε τα αποτελέσματα, ωστόσο όπως είδατε τα standards έχουν ανέβει πολύ, ειδικά μετά την τελική ανάλυση της Catherine. Περνάμε τώρα στην επικουρική θεραπεία. Όπως ήταν λογικό, μετά από τα εξαιρετικά αποτελέσματα που είδαμε αρχικά στη μεταστατική νόσο με την διπλή στόχευση και στη συνέχεια στην επικουρική θεραπεία, ήταν επόμενο να μελετηθεί και στο επικουρικό setting. Εδώ έχουμε τη μελέτη Affinity, μια μελέτη φάσεως 3 επίσης, όπου συγκρίνεται το standard of care της εποχής χημειοθεραπεία με τραστούζουμαμπ έναντι χημειοθεραπεία τραστούζουμαμπ-περτούζουμαμπ. Όταν ανακοινώθηκαν τα αρχικά αποτελέσματα στην τριετία, η μελέτη ήταν θετική, υπήρχε στατιστικά σημαντικό όφελος, οπότε είχε δεχτεί όμως πολύ έντονη κριτική, γιατί το όφελος αυτό στην ουσία δεν ήταν κλινικά σημαντικό. Βλέπετε όμως, περνώντας τα χρόνια, το όφελος αυξάνεται. Στο συνολικό πληθυσμό στην 8ετία τελικά φτάσαμε σε μια απόλυτη διαφορά της τάξης του 2,6%. Το πιο σημαντικό είναι όμως, όταν έγιναν υποαναλύσεις, φάνηκε ότι οι ασθενείς που είχαν θετικούς μασχαλίους λεμφαδένες είχαν σημαντικό, όχι μόνο στατιστικά, αλλά και κλινικά σημαντικό όφελος από τη διπλή στόχευση. Η απόλυτη διαφορά έφτασε το 5%. Αντιθέτως, δεν είχαν κανένα όφελος οι ασθενείς με αρνητικούς μασχαλίους λεμφαδένες από την προσθήκη του περτούζουμαμπ στο τραστούζουμαμπ. Δεν έχουμε ακόμη δεδομένα συνολικής επιβίωσης, είχαμε όμως αριθμητικά λιγότερους θανάτους στο σκέλος που πήρε τραστούζουμαμπ-περτούζουμαμπ και επίσης δεν φάνηκε η διπλή στόχευση, όπως εξάλλου είχαμε δει και στις προηγούμενες μελέτες, να αυξάνει την τοξικότητα και κυρίως την καρδιοτοξικότητα που μας απασχολεί περισσότερο με αυτούς τους παράγοντες. Περνάμε τώρα στον εράτινη, που όπως σας είπα είναι ένας αναστολέας τυροσινικής κοινάσης. Στην μελέτη του την Extenet φάνηκε ότι όταν αυτό το φάρμακο χορηγήθηκε μετά την ολοκλήρωση του τραστούζουμαμπ σε ασθενείς υψηλού κινδύνου για 1 χρόνο, αύξησε την επιβίωση ελεύθερη υποτροπής. Και το όφελος αφορούσε κυρίως τις γυναίκες με τριπλά θετικό καρκίνο του μαστού, με θετικούς ορμονικούς υποδοχής. Βέβαια, ήταν ένα φάρμακο που είχε εξαιρετικά υψηλή τοξικότητα και κυρίως διάρρεια. Ένα περίπου 70% των ασθενών έκαναν διάρρεια και μάλιστα το 40% είχε διάρρεια grade 3. Και ενώ πέρασε στις κατευθυντήριες οδηγίες για γυναίκες με τριπλά θετικό καρκίνο του μαστού υψηλού κινδύνου για υποτροπή με προφυλακτική πάντα αντιδιαρροική αγωγή, στην κλινική πράξη στην ουσία δεν υιοθετήθηκε. Τώρα, τι γίνεται με τους μικρούς όγκους. Ξέρουμε ότι οι μικροί όγκοι και ειδικά οι όγκοι κάτω του 1 εκατοστού και με φυσικά αρνητική μασχάλη δεν συμπεριλαμβάνονταν στις μεγάλες μελέτες του τραστούζουμαμπ. Από την άλλη όμως είχαμε δει από αναδρομικά δεδομένα ότι ακόμη και αυτοί οι ασθενείς σταδίου 1 με χέρτο-θετικό καρκίνο του μαστού, είχαν ένα κίνδυνο υποτροπής από 10 έως και 23%. Επομένως, είχαμε την αίσθηση ότι κάτι πρέπει να κάνουμε για αυτούς τους ασθενείς. Σίγουρα όμως δεν πιστεύουμε ότι πρέπει να χορηγήσουμε αυτό το εντατικοποιημένο σχήμα που δίνουμε σε γυναίκες πιο προχωρημένου σταδίου. Το 2015 στο Σαν Αντώνιο ανακοινώθηκε η μελέτη APT που έχει μείνει στην ιστορία ως μελέτη Τολάνεϊ, μία μη τυχιοποιημένη πολυκεντρική μελέτη με 400 ασθενείς, όπου οι ασθενείς είχαν όγκους κάτω από 3 εκατοστά και αρνητική μασχάλη. Βέβαια, το 91% των ασθενών είχε όγκους κάτω από 2 εκατοστά. Αυτές λοιπόν οι γυναίκες πήραν κανονικά τραστούζουμαμπ για 1 χρόνο, αλλά σαν χημειοθεραπεία πήραν μόνο πακλιταξέλη εβδομαδιαία για 3 μήνες. Έγινε δηλαδή αποκλιμάκωση της χημειοθεραπείας. Τα αποτελέσματα της μελέτης ήταν εξαιρετικά. Βλέπετε στην 7ετία 93,3% των ασθενών ήταν ελεύθερη υποτροπής, είχαμε μόνο 4 υποτροπές συνολικά. Στη δεκαετία εξακολουθεί να είναι σημαντικότατο το όφελος, 91,3% των ασθενών χωρίς υποτροπή και το όφελος αυτό ήταν επίσης ανεξάρτητο από την κατάσταση των ορμονικών υποδοχέων, οπότε είναι ένα σχήμα που έχει καθιερωθεί και το χρησιμοποιούμε οι περισσότεροι ογκολόγοι για τις γυναίκες σταδίου 1 με χέρτο-θετικό καρκίνο του μαστού. Έτσι λοιπόν στις κατευθυντήριες οδηγίες λέμε ότι όταν έχουμε ένα πρώιμο χέρτο-θετικό καρκίνο, όταν το μέγεθος του όγκου είναι πάνω από 2 εκατοστά ή έχουμε διθυμένο λεμφαδένα, το καλύτερο είναι να ξεκινάμε με προεγχειρητική χημειοθεραπεία συν περτούζουμαμπ τραστούζουμαμπ. Όταν δεν επιτυγχάνεται πλήρης ανταπόκριση, όταν έχουμε υπολοιπόμενη νόσο, συνεχίζουμε με 14 κύκλους TDM1. Όταν έχουμε όμως πλήρη παθολογονατομική ανταπόκριση και οι ασθενείς μας αρχικά δεν είχε διηθυμένους λεμφαδένες, μπορούμε να συνεχίσουμε μόνο με τραστούζουμαμπ. Αν είχε διηθυμένους λεμφαδένες, έχει μεγαλύτερο όφελος αν λάβει τραστούζουμαμπ-περτούζουμαμπ. Τώρα, στους μικρούς όγκους, στο στάδιο 1, συστήνεται πρώτα το χειρουργείο και ο λόγος είναι αν όντως επιβεβαιωθεί το στάδιο αυτό στο χειρουργείο, μπορούμε να κάνουμε αποκλιμάκωση της χημειοθεραπείας και η ασθενής να λάβει ένα σαφέστατα λιγότερο τοξικό σχήμα. Και θα περάσω τώρα στην υποδόρια χορήγηση που ανέφερε πριν και ο κύριος Βενιζέλος. Είναι κάτι πολύ σημαντικό, διότι μπορεί να μην έχει αυξήσει το κλινικό όφελος για τις ασθενείς μας, σίγουρα όμως έχει βελτιώσει σημαντικότατα την ποιότητα ζωής. Ξέρετε ότι τα μονοκλονικά αυτά αντισώματα και στην πρώιμη νόσο χορηγούνται για 1 χρόνο, στη δε μεταστατική νόσο μπορεί να χορηγηθούν πραγματικά για πολλά χρόνια. Έχουμε ασθενείς που παίρνουν για 5, 6, 7 χρόνια τραστούζουμαμπ-περτούζουμαμπ και μάλιστα δεν έχουμε δεδομένα ακόμη για το πόσο πρέπει να τα χορηγούμε. Συνήθως τα χορηγούμε μέχρι υποτροπής και πολλές φορές οι ίδιες οι ασθενείς φοβούνται να τα διακόψουν. Οπότε καταλαβαίνετε ότι η ενδοφλέβεια χορήγηση είχε κάποιους περιορισμούς. Καταρχάς, ο χρόνος. Οι γυναίκες πρέπει να μένουν στο νοσοκομείο τουλάχιστον 1 ώρα, συν τον χρόνο που χρειάζεται μετά, που μένουν λίγο παραπάνω για να παρακολουθηθούν. Χρειάζεται χρόνος για τη διάλυση αυτών των φαρμάκων, δεν είναι έτοιμα. Οπότε απαιτείται χρόνος από το νοσηλευτικό προσωπικό. Αυξάνεται το κόστος γιατί χρησιμοποιούνται υλικά. Και η ενδοφλέβεια μέθοδος είναι επεμβατική. Και μην ξεχνάμε ότι συνήθως έχουμε γυναίκες που έχουν χειρουργηθεί, μπορούμε να χρησιμοποιήσουμε μόνο το ένα χέρι. Στο δημόσιο συνήθως οι γυναίκες δεν έχουν πόρτ και οι επανειλημμένες φλεβοκεντήσεις έχουν ως αποτέλεσμα πόνο, άγχος, δυσφορία και θλίψη για τις ασθενείς. Από την άλλη, έχουμε ήδη εδώ και αρκετά χρόνια στη διάθεσή μας το υποδόριο τραστούζουμαμπ. Το υποδόριο τραστούζουμαμπ στις μελέτες του, έχουμε κλινικά δεδομένα από κλινικές μελέτες που έχουν αποδείξει τη βιοισοδυναμία του με το ενδοφλέβιο τραστούζουμαμπ, την ασφάλεια και επίσης την προτίμηση των ασθενών. Βλέπετε ένα 86% των ασθενών στις μελέτες το προτίμησε έναντι της ενδοφλέβειας χορήγησης, αλλά και οι επαγγελματίες υγείας, το 81% ανέφερε ότι ήταν περισσότερο ικανοποιημένοι με το υποδόριο φάρμακο. Έτσι λοιπόν, παίρνοντας τα μειονεκτήματα της ενδοφλέβειας χορήγησης, συν τα πλεονεκτήματα της υποδόριας, που ήδη τα είχαμε δει από το τραστούζουμαμπ, δημιουργήθηκε ένα καινοτόμο φάρμακο, το οποίο περιλαμβάνει 2 μονοκλονικά αντισώματα μαζί σε μία fixed δόση, το οποίο μπορεί να χορηγηθεί υποδωρίως. Και αυτό είναι το φέσγο. Τη δυνατότητα να χορηγήσουμε ένα τέτοιο φάρμακο υποδωρίως μας τη δίνει η αλουρονιδάση. Η αλουρονιδάση είναι ένα ένζυμο το οποίο όταν εγχύεται στο σημείο της χορήγησης μπορεί και αποδομεί παροδικά το ηλιορονικό οξύ χωρίς να προκαλεί διαταραχές στη δομή των μακρομορίων, δηλαδή του κολαγόνου και της ελαστίνης, και αυτή η παροδική αποδόμηση του ηλιορονικού οξέως επιτρέπει το να χορηγήσουμε μεγάλη ποσότητα διαλύματος υποδωρίως, ποσότητα άνω του 1 ml. Στη συνέχεια, η αρχιτεκτονική του δέρματος αποκαθίσταται γρήγορα, γιατί έχουμε ταχεία κάθαρση της ιαλουρονιδάσης, χωρίς λοιπόν να δημιουργείται κανένα πρόβλημα στο υποδόριο ιστό. Και εδώ βλέπετε τι γίνεται αν χορηγήσουμε ένα διάλειμμα 10 ml χωρίς ιαλουρονιδάση, αμέσως δημιουργείται μια φούσκα, ενώ σε αντίθεση όταν υπάρχει ιαλουρονιδάση δεν δημιουργείται κανένα πρόβλημα. Αυτό λοιπόν το φάρμακο, η κλινική του ανάπτυξη στηρίχθηκε σε διαφορετικές μελέτες. Στην πρώτη μελέτη φάσεως 1B θέλανε να δούνε ποια είναι η δόση του Pertuzumab για το υποδόριο φάρμακο. Στη συνέχεια, οι βιοισοδύναμες δόσεις για το Pertuzumab και το Trastuzumab, βιοισοδύναμες σε σχέση με την ενδοφλέβεια χορήγηση. Και στις μελέτες Φεντερίκα και Φραντσέσκα αξιολογήθηκε η φαρμακοκινητική, η αποτελεσματικότητα, η ασφάλεια, αλλά και η προτίμηση των ασθενών. Όταν θέλουμε να αξιολογήσουμε την βιοισοδυναμία μεταξύ δύο διαφορετικών μορφών χορήγησης και συγκεκριμένα της υποδόριας και της ενδοφλέβειας, εξετάζουμε κάποιες συγκεκριμένους παραμέτρους. Αυτές είναι το concentration through, δηλαδή η κατώτερη συγκέντρωση του φαρμάκου στο πλάσμα ακριβώς πριν την επόμενη έγχυση, η οποία δεν πρέπει να πέφτει κάτω από συγκεκριμένα όρια, έτσι ώστε οι HER2 υποδοχής να παραμένουν συνεχώς σε αποκλεισμό. Και η άλλη παράμετρος είναι η area under the curve, δηλαδή το εμβαδό κάτω από την καμπύλη, που στην ουσία αντιστοιχεί στην ποσότητα του φαρμάκου που παραμένει στον οργανισμό. Βλέπετε λοιπόν, αυτό είναι από τη μελέτη Φεντερίκα, τη μελέτη της φαρμακοκινητικής. Βλέπετε ότι είτε χορηγήθηκε το φάρμακο ενδοφλεβίως, που είναι η πράσινη καμπύλη, είτε υποδωρίως, που είναι το πιο ανοιχτό χρώμα, η γαλάζια καμπύλη, το concentration through βρίσκεται και στις δύο περιπτώσεις κάτω από τη διακεκομένη γραμμή, που είναι το κατώτερο όριο, και μάλιστα με την υποδόρια χορήγηση αριθμητικά ήταν ανώτερη. Και το εμβαδό κάτω από την καμπύλη ήταν το ίδιο και στις δύο περιπτώσεις. Επομένως, φαινόταν ότι οι δύο τρόποι χορήγησης είναι βιοισοδύναμες. Στη μελέτη Φεντερίκα συγκρίνανε τους δύο τρόπους χορήγησης, την υποδόρια με την ενδοφλέβεια, και το κύριο καταληκτικό σημείο, ήταν μια μελέτη μη κατωτερότητας. Θέλανε να δούνε ότι το concentration through του Pertuzumab αμέσως μετά την 7η και πριν την 8η δόση δεν ήταν κατώτερο σε σχέση με το ενδοφλέβιο. Επιτεύχθηκε το πρωτέμου καταληκτικό σημείο. Βλέπετε 88,7 η συγκέντρωση με την υποδόρια μορφή, 72,4 με την ενδοφλέβη. Ο λόγος είναι 1,22 μέσα στα όρια και μάλιστα αρκετά επάνω από το non-inferiority όριο που ήταν το 0,8. Αυτό στην περσινή τελική ανάλυση της μελέτης που παρουσιάστηκε στο ESMO Breast επιβεβαιώθηκε και μετά από μεγαλύτερο χρόνο παρακολούθησης, δηλαδή μεταξύ 12ου και 13ου κύκλου. Και επίσης φάνηκε ότι η αποτελεσματικότητα, η άμεση αποτελεσματικότητα, που είναι τα ποσοστά πλήρους παθολογοανατομικής ανταπόκρισης, ήταν ακριβώς τα ίδια, ήταν 60%. Ένα ποσοστό που συμφωνεί και με τις προηγούμενες μελέτες του Trastuzumab-Pertuzumab. Τώρα, ένα ερώτημα που είχε απασχολήσει αρκετά τους ογκολόγους ακόμη και όταν είχε βγει το υποδόριο Trastuzumab είναι κατά πόσο είναι ασφαλής η fixed δόση σύμφωνα με το σωματικό βάρος. Στην μελέτη λοιπόν αυτή χωρίστηκαν οι ασθενείς ανάλογα με το BMI και φάνηκε ότι η αποτελεσματικότητα της υποδόρειας χορήγησης δεν επηρεάζεται από το σωματικό βάρος. Με μόνη εξαίρεση τις λιποβαρείς γυναίκες, που όπως βλέπετε όμως ο αριθμός ήταν πάρα πολύ μικρός, 3 στο ένα σκέλος, 7 στο άλλο, οπότε δεν θεωρώ ότι μπορούμε να βγάλουμε ασφαλή συμπεράσματα. Επίσης, στο περσινό ESMO Breast ανακοινώθηκαν στην τελική ανάλυση τα μακροπρόθεσμα αποτελέσματα αποτελεσματικότητας, η επιβίωση ελεύθερη διαιτητικής υποτροπής και ελεύθερης συμβάματος, βλέπετε ότι οι καμπύλες είναι ακριβώς ταυτόσιμες, δεν υπάρχει καμία διαφορά και επίσης φαίνεται ότι τα αποτελέσματα είναι εξαιρετικά όπως ήδη τα ξέραμε. Το ίδιο είδαμε και στη συνολική επιβίωση και μάλιστα όταν τελείωσε η μελέτη το 95% των ασθενών βρίσκονταν εν ζωή. Δεν είχαμε ιδιαίτερα προβλήματα όσον αφορά, δεν είχαμε επιπλέον ανεπιθύμητες ενέργειες με την υποδόρια χορήγηση και δεν είχαμε και επιπλέον καρδιοτοξικότητα. Και τέλος στη μελέτη Φραντσέσκα, που αξιολογήθηκε η προτίμηση των ασθενών, πήραν στην αρχή πρώτα 3 κύκλους ενδοφλέβιο και μετά υποδόριο και στο άλλο σκέλος πρώτα το υποδόριο και μετά το ενδοφλέβιο, τους δώσαν κάποια ερωτηματολόγια και τους είπανε ποιο προτιμούν. Φάνηκε λοιπόν ότι το 85% των ασθενών φυσικά προτίμησε την υποδόρια χορήγηση, έναντι μόνο 14% που είπαν ότι θέλουν να συνεχίσουν με το ενδοφλέβιο. Αυτά τα αποτελέσματα επιβεβαιώθηκαν και σε άλλες μελέτες. Στην Perforator ήταν 89% το ποσοστό και επίσης το 87% των ασθενών ανέφερε ότι θέλει να συνεχίσει με την υποδόρια μορφή. Επίσης φάνηκε στη συγκεκριμένη μελέτη ότι είναι ασφαλές το switching, το να περάσει από τη μια μορφή στην άλλη, είναι κάτι που μπορούμε να το κάνουμε. Με βάση λοιπόν αυτές τις μελέτες, από το 2020 έχουμε στη διάθεσή μας το FESGO, την υποδόρια μορφή, έχει πάρει έγκριση και από τον FDA και από τον αίμα. Και εδώ είναι μια τελευταία μελέτη που σας δείχνω. Αυτή η μελέτη ανακοινώθηκε στο ASCO το 2022 εν μέσω πανδημίας. Και θέλανε να δούνε αν είναι ασφαλές και αν οι ασθενείς επιθυμούν να συνεχίσουν την υποδόρια χορήγηση στο σπίτι. Πράγματι λοιπόν φάνηκε ότι οι περισσότεροι ασθενούς προτιμούν την υποδόρια χορήγηση, ότι προτιμούν να το συνεχίσουν στο σπίτι και φάνηκε ότι είναι ασφαλές. Δεν υπήρχαν ιδιαίτερα προβλήματα. Τώρα τρέχουν και άλλες μελέτες που προσπαθούν να επιβεβαιώσουν αυτό και ήδη στις Ηνωμένες Πολιτείες, στην Αγγλία και στη Σιγκαπούρη το φάρμακο χορηγείται κατοίκων από εξειδικευμένο προσωπικό και θέλω να πιστεύω ότι σύντομα θα γίνει και στην Ελλάδα. Έτσι λοιπόν μειώνει το χρόνο παραμονής των ασθενών, είναι πιο εύκολο σαν τρόπος χορήγησης, μειώνει το χρόνο που πρέπει να ασχοληθούν οι νοσηλευτές, μειώνει τον κίνδυνο να γίνει κάποιο λάθος στη δόση, μειώνει το κόστος και διευκολύνει σαφέστατα τη ζωή των ασθενών μας. Ήδη υπάρχει υποδόρια μορφή χορήγησης και ανοσοθεραπείας, το τεζολίζουμα, και πιστεύω ότι στο μέλλον αυτά τα μόρια θα μπορούν να χορηγηθούν υποδορίως και με ασφάλεια από εξειδικευμένο προσωπικό επιμένω στο σπίτι. Ευχαριστώ πολύ.
Ευχαριστούμε πάρα πολύ, κυρία Σκόντρα. Όντως είναι μια καινοτομία αυτή. Δεν ξέρω αν και το κατά πόσον αυτή τη στιγμή μπορεί να εφαρμοστεί. Γιατί βρίσκουμε δυσκολίες, δηλαδή χρειάζεται οπωσδήποτε να γίνει παραμονή στο νοσοκομείο για να γίνει ένεση.
Αυτή τη στιγμή στην Ελλάδα θεωρείται νοσοκομιακό φάρμακο. Είναι υποχρεωτικό να γίνεται στο νοσοκομείο. Απλά έρχονται 5 λεπτά είναι η χορήγησή του, θέλει εξειδικευμένο προσωπικό και εντός νοσοκομείου. Γίνονται προσπάθειες και περιμένουμε και αποτελέσματα. Η μία από αυτές τις μελέτες ήταν τεράστια, τρέχει σε 17 χώρες που προσπαθούν να αποδείξουν ότι είναι ασφαλές να το κάνουμε και στο σπίτι. Ακόμη στην Ελλάδα όμως δεν επιτρέπεται, μόνο με αυτό το πρόγραμμα, το οίκοθεν που υπάρχει σε κάποια δημόσια νοσοκομεία, που αφορά όμως διάφορα φάρμακα, όχι μόνο το υποδόριο.
Δηλαδή έρχεται στο νοσοκομείο, κάνει την ένεση σε 5 λεπτά.
Παίρνει οδηγίες και φεύγει.
Ευχαριστώ πάρα πολύ.
Και αυτό είναι πολύ σημαντικό, γιατί είναι πολλά τα χρόνια. Εγώ έχω ασθενείς πραγματικά που παίρνουν φέσγο πλέον πολλά χρόνια. Ασθενείς με μεταστατική νόσο.
Να ξέρετε, μια συζήτηση που μιλάμε συνέχεια για de-escalation, για όλα τα πράγματα προσπαθούμε να μειώσουμε. Μειώνουμε τη χειρουργική, μειώνουμε την ακτινοθεραπεία, μειώνουμε τα πάντα. Και δεν σκεφτόμαστε πώς θα μειώσουμε και την παραμονή των ασθενών στο νοσοκομείο. Δηλαδή αυτό είναι μια καινοτόμο μέθοδος η οποία βοηθάει πάρα πολύ, από ό,τι καταλαβαίνω, στο να μειωθεί η παραμονή του ασθενούς, τουλάχιστον κατά πάρα πολύ μεγάλο ποσοστό.
Και βελτιώνει και την ψυχολογία τους.
Εντάξει, λογικό είναι. Σας ευχαριστούμε πάρα πολύ.
Και εγώ.
I think we can proceed with the next round table. Dr. Kodoulis and Dr. Nasiopoulos, could you please come to chair this session? Thank you.
Okay. The next table is with experts. So I have the honor to come to the podium. Professor Kuhn is already known from previous presentations. Welcome again, Professor Kuhn.
Yes, thank you very much. Thank you again for the kind invitation and for discussing another urgent topic with you, the comparison of different X-ray staging procedures following neoadjuvant chemotherapy for an CN plus patient converting to CN0, comparing sentinel node biopsy, targeted X-ray resection, and marking lymph node biopsy. So these are my disclosures. So with neoadjuvant strategies, the conversion rate of lymph nodes in primarily node-positive patients is high, more than 50%, as we have seen in the Axana study. And this is up to 76% of the keynote study for triple-negative patients with the use of checkpoint inhibitors. So I think one thing is very clear, that treating these patients with axial resection would overtreat many patients. So we need less invasive procedures. There have been many studies ongoing during the last decades addressing the accuracy of sentinel lymph node biopsy after neoadjuvant chemotherapy, and I think this meta-analysis has already been shown. So for patients who have a negative lymph node status before chemotherapy, the accuracy is fine, so the false negative rate is 3.2%, but we have seen that the false negative rate for patients who present initially with a positive lymph node status is higher than the accepted cutoff of 10% with 14.8%. There were several measures proposed by retrospective analyzers to improve the false negative rate using immunohistochemistry in the Canadian trial that could reduce the false negative rate under 10%, the use of a dual tracer, or the removal of at least 2 lymph nodes. In 2015, a new procedure was introduced by Mila Donker from the Netherlands. Instead of looking the first draining node, the largest biopsy-proven node was marked with a seed, with a radioactive seed, a procedure that was called MARI. And with this procedure, the detector rate was high, 97%, false negative rate low, less than 10% by 7%. Now, in the meantime, since radioactive seeds are not available in many countries, many competing techniques to mark these lymph nodes have been introduced, like the use of charcoal suspension, the use of clips, coils in different sizes and shapes, with and without shells, that can then be localized with the use of ultrasound, or modern techniques with the use of magnetic, paramagnetic, radar-based or radioactive seeds that require probe-guided localization. Now, we have already seen this study from Terry, from Abigail Cordell, that was published in 2016, and this study, both procedures, a sentinel lymph node biopsy was combined with a target lymph node biopsy, and it was shown that for the sentinel node biopsy alone, as expected, the false negative rate was around 10%. For the target lymph node biopsy alone, it was 4.6%, and for the combination, it was very low, around 1.4%. And as already has been pointed out, 23% of the target lymph nodes were not sentinel lymph nodes, and 6 patients with a negative sentinel lymph node had a positive target lymph node, showing that the target lymph node detected positive lymphs that would not have been detected by the sentinel lymph node procedure alone. Again, this was a false one. Now, in 2021, we conducted a survey asking European surgeons, so what is your preferred procedure? And for patients with a CN1 status with 1 to 3 positive lymph nodes, targeted X-ray resection was the preferred method, followed by sentinel lymph node biopsy, although still many surgeons performed axial lymph node dissection. For patients with CN2, so more than 3 involved lymph nodes, axial lymph node dissection is still the standard for many surgeons, followed by target axillary resection or central lymph node biopsy. Now, what is the distribution within the Axana study, where we accept all procedures, and in the end, we will compare the procedures with regards to outcome, to life quality, and so on. So the majority of surgeons prefers target axillary resection. There are still many surgeons performing lymphadenectomy, but in some countries, central lymph node biopsy is still the standard of care, and in some countries, they require 2 or more central lymph nodes, in other countries not. In other countries, a simple central lymph node biopsy without dual tracer, without requirement of 2 or more lymph nodes is accepted. So countries where central lymph node biopsy is the standard is Turkey, Peru, Italy, Norway. I think in Greece it's 50-50 when I looked into our charts. And especially in Italy, surgeons do not rely on 2 or 3 lymph nodes. They just perform a simple central lymph node biopsy, single tracer, and 1 central node is enough. And we want to compare all these different procedures within the Axana trial. So if you want to compare of the technique, central lymph node biopsy, marked lymph node biopsy, or target axillary resection, we have to look at the accuracy, the feasibility, outcome, surgical extent with regards to number of resected nodes, the impact of life quality, and certainly costs. Now, regarding false negative, the 10% is an arbitrary cutoff, and we do not know how this translates, how a higher false negative rate translates into recurrences or outcome. There is no evidence if and how a higher false negative rate translates into word outcome, and should we really worry so much about a small increase of the false negative rate? Now, this is a comparison of false negative rates between primary surgery, NSABP B32, and the Sentinel and ACOSOX trial, where the false negative rates after neoadjuvant chemotherapy in node-positive patients was assessed. And you can see that in NSABP B32, the false negative rate was 9.8% for all patients, 14% in both trials in the neoadjuvant setting. But we do not know if this impacts recurrences or disease-free survival. And in NSABP 32, the false negative rate for 1 lymph node was 17.7%. And we never discussed removing more than 2 central lymph nodes. But we know that this does never translate into higher recurrences. So should we really worry so much about 14% false negatives? We don't know yet. But what does it mean, 14% false negative? And this is often misunderstood. So if we have a false negative rate of 10%, we have residual disease in 15%, we will overlook 5 patients among 100 patients, because the false negative rate always relates to the number of node positives in the group. In a group, when we have a false negative of 14%, we will overlook 7. So the difference is 2. And if the false negative rate, if the response rate is even higher, as in Keynote 522, there's only 1 patient that we would overlook with 14% false negative compared to 10%. So it's a little bit less than we often think. Now, what about detection? So this is the Sentinel trial, and in the Sentinel trial we had 4 groups. And at that time it was from 2009 that we started recruitment. We still looked at sentinel node biopsy before neoadjuvant treatment. And so we had 1 arm where sentinel node biopsy was performed before neoadjuvant treatment, and we had the group node positive after neoadjuvant. And among 100 sites that did the same techniques in every patient, the upfront central lymph node biopsy was associated with a detection rate of 99.9%, while after neoadjuvant chemotherapy in patients who converted from node positive to node negativity, the detection rate was only 80%. So there is something going on. And this may be one explanation. And these are pictures I took in the very early days of sentinel lymph node biopsy when we started with a blue dye. And you see a completely invaded lymph node. And you see the blue stained vessel, and it stops at the lymph node. Why? On the right picture, you see there's no lymphatic tissue. So this lymph node is simply not able to uptake any tracer. And this leads to detection failures, or there may be a bypass. And this is also the reason why very often we have false positive results with ultrasound after neoadjuvant, because we see the fibrosis after neoadjuvant chemotherapy that appears like a positive lymph node. So this is one explanation why we have a lower detection rate and a higher false negative rate in the group of in the sentinel node group. Now this is a meta-analysis confirming now with many studies that the detection rate a bit higher than we had in sentinel, around 89%. So it is a bit lower. But is targeted axillary resection now so perfect that it solves all problems? No, it does not, because we have failures to detect the target lymph node. With the carbon suspension, we have detection of 93 to 95%, which is quite high. Although the problem with the carbon suspension is that you have to open the axilla very widely, so it's a huge operation. For the clip, we have a detection of 77 to 99%, so this is very dependent on the radiologist to identify the central lymph node. And for the seeds, we have quite constant detection rates. Whatever we use, if we use radioactive seed or radar seed or magnetic seed, whatever, around 94 to 97%. And for the use of devices to mark the lymph nodes, we also have a problem with lost markers, with a 7% in the Axana study. Although I have to say, we have 7% of lost markers, but 5.8% are clips and coils which are not detected. So this is a problem associated with target axillary resection. Now, what about outcome? And we have several studies. Okay, most of them are retrospective. The observation time is quite low. But what we can see that whatever we do, axillary recurrence rate are low and less than 2%. So probably the technique of axillary staging does not translate into high recurrences, whatever we do. So this is the OMA study, and this is interesting to know what is the extension of surgery, and we all were quite astonished to see that with a sentinel lymph node biopsy, there were more sentinel lymph nodes resected compared to the target lymph node dissection, which is probably due to the fact that in this study only patients were included who had at least 3 sentinel lymph nodes. So sentinel lymph node biopsy after neoadjuvant chemotherapy is not a clearly defined technique, because some surgeons perform just the resection of 1 node, others at least 3 nodes. So this is not yet clearly defined. So does this impact morbidity? We don't know yet. We will analyze this in the Axana study. Now, what about costs? These are costs from Germany. So we know sentinel lymph node biopsy is associated with €250. Radioactive seed is cheap, but not allowed in Germany and many other countries. The charcoal is cheap, €35. Clip is quite cheap, 110, and the modern markers, magnetic or radar, 250 to €450 are certainly much more expensive. And when we compare sentinel lymph node biopsy alone to target axillary resection, certainly target axillary resection is much more expensive. So we need some reasons to do this, and this must be a matter of discussion. So in conclusion, there's probably no clear winner between sentinel lymph node biopsy alone, target lymph node biopsy, or target axillary resection. There are moderate differences with regards to false negative rate that probably do not translate into oncologic outcome. Detection is an issue for sentinel lymph node biopsy and the resection of a target lymph node. The impact on morbidity is unclear, but costs are also important. So we certainly need further data to examine this, and therefore we have the Axana study that recruited more than 6,000 patients now. We assess disease-free survival, life quality, also health economics. So thank you very much.
Thank you very much, Professor Kuhn. It's a debatable topic, and we hope that Oksana will put some light on this topic with the results. I don't know if someone of the commentators have some comment to do. Please, Professor Koratsanis.
Yeah, now it works. So there are two issues that I think that we should highlight and are clear from this talk for me. The first one is that until we know that we do not need to do better, as you and I have discussed a lot of times in the past, it's not a matter of false negative, but it is a matter of detection rate, given the fact that if you have a failed procedure, then you have to, per definition, condemn that patient to an axillary dissection, because we do not have the data to say that in the previously node positive, we can just refrain from any procedure if we don't find anything. The other thing has to do with costs. Now, that's a conflict of interest for me because I'm the Deputy Editor-in-Chief and the EJSO, and I got a very nice paper recently from Torsten's group that has to do with the sustainability of wireless localization methods in the breast, and the axilla is not very different. But what I would like to highlight is that the problem with radioactive seeds is not the cost of the device per se. In Sweden, for example, the cost of registration and deregistration, handling and disposition is about 6 times the cost of the device per se. So the most expensive in terms of incremental costs for a taxpayer state-funded system is actually the radioactive seed.
Okay. Thank you. Maybe a question from the audience? Okay, let me make a comment about the sentinel node after neoadjuvant chemo, as Dr. Karakatsanis mentioned, especially in patients with N2 or N3 diagnosed breast cancer before neoadjuvant, the sentinel node post-neoadjuvant simply doesn't work. So what about this population? There are many patients with N2 or N3 disease diagnosis that after neoadjuvant chemo, especially TNBC disease, triple negative breast cancer, or HER2 positive breast cancer, that convert in negative axilla. All these patients with sentinel node maybe finally have axillary dissection that is unfair. Please. Please, maybe an answer.
I agree entirely with you that we have too little data on the CN2 group. But personally, I think that when we also have to take into consideration the response of the breast. So if I have a complete response in the breast, I think I would not, personally, I would not go if I have a clinical response, and I would rely on target axillary resection in the axilla because this patient would probably undergo radiation therapy anyway. But it's still a matter of debate. We don't have data. And so far, according to German guidelines, it's not yet an indication for central lymph node biopsy or target axillary resection because we need no data. But I think with common sense, I would spare a patient an axillary resection if she had PCR in the breast. But this is a matter of debate.
With all respect, I'll disagree with the opinion that if we have PCR on the breast, we have probably PCR in the axilla. There are publications, even with HER2 positive or triple negative disease, that with PCR to the breast and up to 50% residual disease in axilla, especially in N2 or N3 disease. Maybe in N0 disease diagnosis, the possibility of residual disease in axilla and PCR in the breast is up to 0 to 2%. But in all other cases, N1, N2, or even N3, maybe it's residual disease in the axilla with PCR on the breast. Professor Karagatsanis?
Take the microphone, because they cannot hear you.
Just to highlight something that has to do with the source studies. CN1 refers to palpable mobile nodes. CN2 means matted nodes on the chest wall. So the reason that we are discussing 3 as a cutoff or more than 3 and so on is more or less an extrapolation from the Lucerne toolbox in order to facilitate de-escalation to begin with. But a patient with palpable lymphadenopathy, you should not count nodes on radiology. One palpable node corresponds to at least 4 metastases. We have known that since the middle of the 2000s. That's just an idea. Do not condemn patients from the number of nodes on an ultrasound. It is the clinical stage that matters.
We should crack on. Next speaker is Professor Mamounas from Orlando Health Cancer Institute.
Okay, so let me fix this for a second. So we're going to talk about optimizing risk assessment for late recurrence, as I already alluded to earlier in my previous talk. So we know that estrogen receptor positive breast cancer is a disease that continues to have recurrences for long periods of time. These are the data from the overview analysis showing that about half of the recurrences and about two-thirds of the deaths occur after year 5. And this is well demonstrated. In addition, risk of late recurrence in ER-positive disease has been shown again in a new update of the overview analysis that was published by Penn et al. In 2017. And as you can see here, clinical and pathologic factors at the initial diagnosis continue to be prognostic of risk of late recurrence all the way up to 20 years. These lines essentially don't have any sense of decreasing. The steepness of the curves is very much the same. But what's very interesting also is the original clinical pathologic factors have an impact even 20 years later in terms of how much the recurrence will be. So we know this is a disease that, again, continues to recur for long periods of time. We know that about 5 years of tamoxifen used to be the standard of care for many years, as you see, again, from the overview analysis, in terms of recurrence and breast cancer mortality. And 5 years of tamoxifen continue to have benefit all the way to about 15 years later. And when it comes to studies of extended endocrine therapy, these are the two old studies looking at 10 versus 5 years of tamoxifen. This is the Atlas trial and the Atom trial, the original sort of presentations. And as you can see, for both these trials, a late effect of delayed of tamoxifen appeared probably after 10 years. So the 10 years of tamoxifen versus 5, they're better both in the Atlas and the Atom trial in terms of recurrence. And also, in terms of mortality, the Atlas trial also has shown, it's pretty much the only trial that has shown a breast cancer mortality and overall mortality reduction with extended endocrine therapy, as you can see here. Now, of course, tamoxifen has been a drug that we still use occasionally anymore, but the aromatase inhibitors, as you know, have surpassed the tamoxifen, and they have been incorporated in multiple ways. As initial therapy, oops, sorry, let me go back. Oh, that's not easy. As initial therapy, we're superior to tamoxifen, 5 years of NAI versus 5 years of tamoxifen, in a sequential fashion after 2 to 3 years of tamoxifen. And in the extended setting, aromatase inhibitors after 5 years of tamoxifen versus placebo, I'll show you some of the trials, still superior. And nowadays, of course, with ovarian factor suppression, aromatase inhibitors are actually better than ovarian factor suppression and tamoxifen. So we combine them now with ovarian factor suppression. So in one slide, I want to summarize some of the extended aromatase inhibitor trials, because those are the ones that essentially, once we start using AIs, we wanted to see how long we should give the AIs for after the 5 years. And as you can see here, this is the MA17 trial. Initially, this was tamoxifen followed by 5 years of either letrozole or placebo. When this was established, there was a further randomization at 10 years to additional 5 years of letrozole or placebo. That trial showed about a 20% reduction, was borderline statistically significant with a p-value of 0.06. And then we had the B42 trial that included patients treated either with aromatase inhibitor or tamoxifen, followed by an aromatase inhibitor 5 years, and then randomization to 5 versus placebo for 5 years. This is letrozole here. And we saw about a 16% reduction with a significant p-value. The third trial for this group is the DATA trial that actually used only about 2 to 3 years of tamoxifen and then randomized to 3 years versus 6 years of the aromatase inhibitor and did show about a 21% reduction. So this trial sort of, I put it in one box, was shown benefit from the extended aromatase inhibitor trials. But again, here, 3 versus 6, it was significant, but it was only after 3 years of tamoxifen, remind you this. And then there are several trials, as you can see, the IDEAL, the ABCSG16, and the SOLEIL trial, that compared after the combination of tamoxifen, aromatase inhibitors, or the sequence, 5 years of all those, to 2 versus 5 or 2.5 versus 5, or here, the SOLEIL was interrupted aromatase inhibitor therapy versus continuous. And all these trials did not show a significant benefit from the aromatase inhibitors. So essentially arguing that after 5 years of combined therapy or sequential therapy, you don't have to necessarily extend it to 10 years, but you can probably stop at 7 years. But there was no direct comparison essentially of 0 versus 3 years extended endocrine therapy. So now, the overview analysis has looked at extended AI therapy, and what it showed so far is that depending on how you start, you may get a different benefit from extended aromatase inhibitor therapy. For example, tamoxifen followed by an aromatase inhibitor, there was about a 5% reduction in recurrence, 2.8% in distant recurrence, and 1.8% reduction in mortality, which all were significant. But where you have combination or sequence of tamoxifen AI followed by AI, then the differences were smaller, and the only significant difference was in recurrence. And then when you have aromatase inhibitor for 5 years followed by additional aromatase inhibitors, the benefits were even smaller. So I'm showing you this to tell you that essentially, although extended endocrine therapy was found to be of value, the benefits are actually small. So obviously, we need to do a better job to identify who are the patients that actually need extended endocrine therapy and also benefit more from extended adjuvant endocrine therapy. So how do we further optimize the selection of candidates for extended adjuvant endocrine therapy? Well, we can refine the risk of recurrence based on either clinical pathologic algorithms. We can assess circulating tumor cells and circulating DNA. This is something that we are having a lot of interest as of late. And of course, as we discussed earlier, we can evaluate genomic classifiers that predict also late recurrence as much as they predict early recurrence. And some classifiers also predict benefit from extended adjuvant endocrine therapy. So this is the CTS5 developed by Ms. Dowsett. Based on the ATTACK trial. It was validated in Big 198. And essentially is a score that includes it's essentially clinical treatment score post 5 years. And it includes age, number of positive nodes, and tumor size in millimeters, and grade. And essentially it's a very simple calculator that you can use at your office. Put the tumor size in millimeters, the age of the patient, the number of positive nodes, and grade, and then we'll give you essentially the risk of recurrence after 5 years for the remaining essentially 10 years of total follow-up. And as you can see, this was validated. It was developed in ATTACK, validated in Big 198, showing that you can separate patients to a low, intermediate, and high risk. That's a simple and easy way of doing it. What about circulating tumor cells? Well, this is a paper by Josh Parano from the ECO group that actually did a secondary analysis of a large study, the B5103, is the one evaluated bevacizumab at the time. And they had 547 patients with ER-positive, HER2-negative breast cancer. They obtained CTCs around 5 years after diagnosis. and they looked for risk of late recurrence. The CTCs were detected only in about 5.1% of the patients, and 6.5% of the patients had clinical recurrence. And having a positive CTC essentially led to a 13-fold increase in the risk of recurrence, as you can see here, much higher recurrence. And about a third of the patients with recurrence had a positive CTC assay result at a median of 2.8 years before clinical recurrence. So essentially, CTCs, and I'll show you next, ctDNA, appears to be a marker that essentially heralds the development of metastatic disease in the next year or two. So this paper from Lipsick Scharf, who now is at UCLA, it's interesting when you see an oncologist who sometimes you may have treated a relative 30 years prior to that. It's getting old. This is ctDNA for prediction of late recurrence, and again, it's 103 high-risk stage 2 to 3 hormone receptor positive patients diagnosed after 5 years and being NED. They did whole exome sequencing of the primary tumor, and then they took plasma at consent and every 6 to 12 months. And to make a long story short, 10% of the patients had positive minimal residual disease assay. 6 patients developed distant recurrence, and all of them were positive for MRD before. There was another patient that was positive that had a local recurrence, but they did not go on to develop distant recurrence. And you can see, of course, things that we've seen now in many, many other studies, that the minimal residual disease leads to a very poor prognosis. And again, when you compare to at initial diagnosis or at any time having a positive assay, the curves with the any time are always steeper, meaning that if at any time you were positive, you do very poorly, but if you remain negative, then you do better. But at one time, in other words, you're negative and you're okay, but you could be positive a year or two later, right? So you have to exclude these patients. What about genomic classifiers? And as I mentioned earlier today, I think it's fair to say that any of the genomic classifiers that predict risk of early recurrence also predict risk of late recurrence. Almost similar to what we see in the meta-analysis with grade or tumor size. It's a prognostic factor from the beginning, and it continues to be one. EndoPredict does that, breast cancer index does that, PAM50-ROR, and even the 21-gene recurrence score only for high ESR1 patients. The recurrence score doesn't work exactly the same for all patients, but only for the ESR1 high patients. But prognosis is one thing. The question is, can you identify who benefits from extended endocrine therapy? And so for that, actually, we have more data. The marker that has the most data is the BCI, the breast cancer index, and particularly the homeobox13 interleukin 17B receptor ratio, or H/I ratio of the BCI. So this was essentially shown in the MA17 trial to predict benefit from extended endocrine therapy. If you have a high H/I, there was a significant reduction with extended letrozole therapy. Low H/I, there was small benefit. It was not statistically significant. The absolute of recurrence was reduced by 16.5% for patients that have high H/I, and the interaction was statistically significant. They then validated this in the TransAtom trial, John Bartlett publication, looking again at longer tamoxifen versus shorter tamoxifen and finding essentially the same thing. For all patients, there was a difference. The BCI H/I high, it was a significant difference, but the BCI H/I low, it was not a significant difference. And as you can see here, in terms of absolute benefit, the overall was about 5%. It was 10% for the H/I high and almost 0% for the H/I low. And then in the ideal trial that I showed you a little bit earlier, these were patients with tamoxifen aromatase inhibitors of the sequence, randomized to shorter or longer letrozole therapy, 2.5 to 5 years. And then 88 of the patients received either an AI alone or the sequence of tamoxifen followed by an AI. And for those patients, the hazard ratio was 0.92. When they apply the breast cancer index, H/I ratio, again, this is the overall unselected population. There was no benefit for the low, but benefit for the H/I high. And again, remember, this was for shorter versus longer letrozole therapy. So you could make the argument, if we had the debate between 7 to 10 years, some of these biomarkers at least may tell us which one you should go to 10 years and how much you can stop earlier. And this is NSABP42, which we also evaluated the BCI. And I remember B42 had the same aromatase inhibitors or tamoxifen followed by aromatase inhibitors, and then letters of 5 years versus placebo. When we looked at the overall benefit, was about hazard ratio of 0.77% in the group of patients that were applied the BCI. This is about 2,100 patients from the B42 study. But when you look at BCI over high versus low, we did not see a significant interaction. You see hazard ratios with benefit both for BCI high, 0.83 and 0.69. Now, in the B42, there was a little bit of a different pattern of distant recurrence, what we noted in the parent trial. What we noticed was that there was no benefit from extended letrozole in the first 5 years of treatment, but after that is where the differences in distant recurrence emerged. So essentially, there was a significant non-proportionality of the hazards. As a result, we did a conditional analysis to look at the benefit according to essentially starting at 4 years. In other words, ignoring, so to speak, the first 4 years where there was no difference. And what we found then, it was the BCI high actually patients benefited from year 4 to year 10, but BCI low patients did not, if you did a conditional analysis. But again, this interaction was also not statistically significant, but clearly the benefit here was statistically significant. And then if you look at it according to non-negative patients versus non-positive patients, most of the benefit was seen for patients that have no positive disease, and it was seen for the BCI age over high for 4 to 10 years. Every other category did not have much benefit. And also, when you look at it according to HER2 status, essentially the HER2 new negative patients are the ones who benefited from the extended therapy from year 4 to year 10, and that interaction actually was statistically significant. So not exactly a pristine sort of demonstration of benefit, but nevertheless kind of the same thing. We also evaluated MammaPrint in B42, and essentially the hypothesis there was that MammaPrint high-risk patients would have more benefit from extended endocrine therapy, MammaPrint low would not. But essentially we found the opposite. We found that MammaPrint low patients appeared to have more benefit, which was significant. MammaPrint high patients did have some benefit, as you can see here, but the difference was not statistically significant. And also, this was RFI, distant recurrence here, but we have secondary endpoints, and these were disease-free survival and breast cancer-free interval, which includes contralateral breast cancer. And in these endpoints, actually, MammaPrint low patients had significant benefit from extended endocrine therapy versus MammaPrint high patients, and this was actually statistically significant for interaction. Arguing perhaps that the contralateral breast cancer adds to these events, and essentially saying that if you MammaPrint low, maybe you have more sensitive tumors, and then more likely to get a contralateral MammaPrint low tumor, and potentially you can benefit from extended endocrine therapy. Also, another analysis there was the MammaPrint ultra low versus the MammaPrint low but not ultra low, and essentially most of the benefit happened to the low but not ultra low because the ultra low were so good. Although, again, you can make much out of this because the numbers are very small, but they have very low risk. And then that was the first observation that MammaPrint may be important, but then we had also a report from the IDEAL trial. I remember I showed it to you with the BCI. So the IDEAL trial was also looked at MammaPrint for benefit from extended adjuvant endocrine therapy. And essentially what they found was what we found in B42, that MammaPrint high-risk patients don't benefit from extended endocrine therapy significantly, but MammaPrint low patients do. And this was for, again, distant recurrence as the endpoint. But also relapse-free interval, the same thing. You can see no benefit for the high risk, benefit in the low risk. When it comes to the low but not ultra low, most of the benefit, again, shown in that group of patients that are low risk but not ultra low, where they don't have much risk of recurrence anyways. And again, when you look at significant interactions, these were significant interactions for any of those endpoints. And the absolute differences for the MammaPrint low risk was 10, 11% for any of those endpoints. So this may be real. 2 studies now have shown that MammaPrint does predict the risk of a late recurrence. So based on that, what do the guidelines tell us to do? Essentially, for N0 NED after 5 years of endocrine therapy, there's insufficient evidence to use any of these biomarkers because essentially they are prognostic, but they don't help you much with the decision. If you're N0 or N1 with 1 to 3 positive nodes and NED after 5 years, may use BCI to guide decisions for extended endocrine therapy. If you have 4 or more positive nodes, then you should probably prolong the therapy, and there is insufficient evidence to use any of the biomarkers. And again, the premenopausal patients, there are very few, so there's not much treated information for that. In terms of NCCN guidelines, you can see hormone receptor positive T1, T2, PN0, the BCI, can be used to help with the benefit of extended endocrine therapy. And for hormone receptor positive T1 to T3, PN0, PN1, again, use the BCI, offers in terms of risk of late recurrence and benefit from extended adjuvant endocrine therapy based on the studies that I showed you before. Now, there's some remaining questions. After 5 years of an AI, is continued AI better, or maybe we should switch back to tamoxifen, do the reverse? Will some patients benefit from more than 10 years of adjuvant endocrine therapy? Can we go to 15? Will there be any more benefit? Would women who remain premenopausal at 5 years benefit from ovarian factor suppression versus extended endocrine therapy with 5 years of tamoxifen alone? In other words, can you extend the ovarian factor suppression? And will patients who are now receiving adjuvant CDK4 inhibitors, amebaciclib, ribociclib, will benefit from extended endocrine therapy? We haven't answered this question yet. And how will incorporate the new SERDs and extended endocrine therapy strategies into extended endocrine therapy strategies, because all these studies now are using SERDs to evaluate comparing to aromatase inhibitors in the adjuvant setting. So in summary, the extended endocrine therapy reduces the risk of recurrence and contralateral breast cancer in a selected population. It does not significantly prolong overall survival. I didn't show you the data, but essentially none of the studies except the Atlas has shown a survival benefit. Benefit from extended aromatase inhibitor therapy is larger after 5 years of tamoxifen and progressively decreases after 5 years of the sequence or 5 years of an aromatase inhibitor. And improved clinical pathologic algorithms, circulating tumor cells, and genomic classifiers can help refine the risk of late recurrence and to benefit from extended endocrine therapy. I think one of the remaining questions is, if you intervene at the time that the test turns positive by changing your treatment or extending therapy, would you make a difference? And I think that's a big question that is going to be answered in studies in the years to come. Thank you very much for your attention.
Thank you, Professor Mamounas. Any questions from the audience? Any comments? Any comments from our commentators? Thank you very much again.
The next presenter is Professor Vahid, President of Senologic International Society. Professor Vahid.
Good evening, dear my colleagues, dear presidents, chairman of this panel. First of all, I would like to thank the organizing committee for inviting me for this congress and for this beautiful city and country, our neighboring country. And my title is Surgical Management of Residual Disease After Neoadjuvant Chemotherapy. As you know, it's a classical thing to tell. Changing paradigms in breast cancer management changed the breast cancer treatment from radical mastectomy, according to Hush, that it was a local regional disease, and then this changed to systemic disease hypothesis by Bernard Fisher. He did many clinical and experimental studies show that it's also a systemic disease. And after that, we accept that breast cancer not only local regional, but also systemic disease. And after 2000, when we found that it has a different molecular subtypes and it's a heterogeneous disease, and we started to change our treatment target to personalized and tailored treatment for every patient. No treatment all size fits for one patient, but we know that we have to tailor treatment for individualized patients. And also surgery, the place of surgery in the treatment of breast cancer has escalated by the times gone by. And then surgery was alone almost more than 1 century, and then it was a radical mastectomy, and then changed to modified radical mastectomy preserving pectoralis major muscle in UK also, and then changed to simple mastectomy by NSABP-B04 trial and showed that there was no overall survival difference between the patients with radical mastectomy and mastectomy alone and mastectomy plus radiation therapy. The study also showed that axillary dissection didn't add any survival advantage to the patients with breast cancer. And then we started to perform personalized surgery after breast conserving surgery plus radiation therapy. There are some studies, ongoing studies, especially from MD Anderson Cancer Center by Dr. Kurer. He started a study to omit surgical procedure in patients with a complete clinical response in the breast after NAC, but false negative rates of vacuum biopsy in these patients was very high, and it's not accepted today. And we know that NAC changed the treatment in breast cancer patients from radical mastectomy to breast conserving surgery. It has been used for 50 years, and in last 2 decades, it has been used so extensively. And in a MD Anderson clinical trial published in 1990s by Dr. Eva Singletary, and it showed that the patients with locally advanced breast cancer, and actually they were undergoing the mastectomy, had a breast conserving surgery in 25% of patients due to the tumor size reduction and then possible breast conserving surgery. And in addition to taxane-based chemotherapy to adriamycin and cyclophosphamide therapy, the results of the combined NSABP-B18 and B27 trials published by Dr. Mamonas in 2012 in JCO show that PCR rates increased to 26% in patients taken additional taxane, and the breast conserving surgery rate increased to 42%. And how about the targeted therapy? Also immunotherapy added to the systemic chemotherapy NAC of breast cancer after 25, and we found that breast conserving surgery increased over 50% in this patients group. We know that neoadjuvant chemotherapy allows less extensive breast surgery and axillary surgery by downstaging the tumor and allows monitoring treatment response. PCR to NAC is strongly associated with improved long-term survival outcomes, but we don't know about locoregional recurrence after breast conserving surgery in patients after neoadjuvant chemotherapy. There was a multi-analysis and review show that breast recurrence rate is 6.5% over in patients with breast conserving surgery after NAC. And it also plays a crucial role in determining adjuvant therapy in the presence of residual tumor. And we know that from the Catherine trial and CRADE trials, additional adjuvant treatment increases survival in patients with triple negative and HER2 positive breast cancer. Pathologic complete response rate to NAC varies according to molecular subtypes of the tumor and NAC regimen given. As Professor Kuhn showed before, PCR rate is around 5 to 10% in ER-positive, HER2-negative patients. It's between 17 to 33% in patients with ER-positive, HER2-positive breast cancer. It's 36 to 50% in HER2-positive patients. It's around 35% in patients with triple-negative breast cancer. This similar rate is in lymph node conversion rates is around 15 to 20% in ER-positive liminal A patients. Is around 65%. In HER2-positive is 50% in triple-negative breast cancer patients. And now the place of surgery has been de-escalated in patients with poor molecular subtypes breast cancer. The one who has triple-negative breast cancer, today upfront surgery only recommended in patients with T1 and 0 breast cancer, tumor size less than 1 centimeter, and also T1B, T1C patients, NAC is recommended and after surgery, but upfront surgery may be considered in patients for selected T1 patients, and T2 patients, keynote study shows that almost 76-77% of PCR rate, and in this trial, pembrolizumab, carboplatin, paclitaxel, and AC are recommended as a neoadjuvant chemotherapy and after surgery, and additional adjuvants determined by residual disease. In also HER2-positive breast cancer patients, treatment algorithm change. If patient has a T1A and T1B0 tumor, upfront surgery is recommended. In patients with T1C and clinical A0 disease, there is a debate about the NAC or upfront surgery, but if the tumor size is more than T2 or greater, and any clinical tumor with clinical and positive disease should have an neoadjuvant chemotherapy. Surgical management of patients with residual disease. Patients should be evaluated before and after NAC for surgery. Clinical examination is most important step to me. Tumor breast ratio is important to protect, to save the surgery. Before and after, make a decision. And axillary status also important. Every patient should have axillary ultrasound and biopsy together with immunohistochemistry and marking on the breast tumor and positive lymph node recommended. PET MRI or PET CT in patients with positive lymph node, and brain MRI in patients with triple-negative breast cancer patients recommended. And genetic test is also performed in patients less than 50 years old and triple-negative breast cancer patients. But we can make a decision before surgery in some patients and after this NAC also. If the patient has a malignant diffuse microcalcifications and multicentricity and clinical T4 tumor, and if patient has an inflammatory breast cancer, and also if she has a pathogenic gene mutation carriers, especially for 6 genes, should be considered about the mastectomy. In our patient, you will see that there is a substantial decrease in microcalcification after neoadjuvant chemotherapy, but the patient has a small size of breast, and almost half of the breast had a microcalcification before neoadjuvant chemotherapy. We performed nipple-sparing mastectomy together with implants. If the patient has a single or multifocal tumors, and if she has a good response to NAC, and tumors and positive nodes should be marked before NAC, and negative margin, surgical margins after lumpectomy is necessary. But in a study, margin with less than 2 millimeter or close knowing on tumor versus margin more than 2 millimeter wasn't found associated with ipsilateral breast tumor recurrence after NAC for breast-conserving surgery. And good cosmetics result outcome is very important. We have to obtain good cosmetic results. And as you know, after new modern chemotherapeutic agents and radiation therapy, the life expectancy of the patients increased, and we also need to see a good cosmetic breast in our patients. Sometimes the partial latissimus dorsi flap reconstruction in our patients at diagnosis or after NAC, and I used partial latissimus dorsi flap and preserving its pedicle, vascular pedicle, and I use the same incision from axilla to remove the tumor, to check the surgical margin of the tumor and clip the margin if they are negative. I also do sentinel lymph node biopsy or axillary dissection from the same incision. I also take the partial latissimus dorsi flap from this incision and bring it into the tumor cavity to fill the cavity and fix it to the thoracic wall and pectoralis major muscles. It's cheaper than mastectomy plus implant and takes less time. Cosmetics results are good. And our paper published in 2020 with 317 patients with a good cosmetic results according to EORTC guidelines. And the Melody study in which we participated and published in last year was a prospective non-interventional multi-cohort study aimed to evaluate the 8 localization techniques of tumors at the time of diagnosis or after NAC, and the study revealed that the successful excision rates of all evaluated techniques were high, but each technique had its advantages and disadvantages. We usually place a marker in the tumor before NAC, use the wire-guided line technique after NAC because it's inexpensive and effective. And evaluation of surgical treatment was stated by Professor Mamunas in the morning. And axilla was considered the most important prognostic factor, but we have more important prognostic factors today. And also axilla was considered to increase the overall survival and decrease the local regional recurrence rate. But we know from NACBPB04 trials and Amoros trial and the Acozoxy 11 trial, axillary dissection doesn't add anything about the local regional recurrence or survival advantages, and provided that axillary radiation therapy is added. And then in 1990s, we started to perform sentinel lymph node biopsy, both blue dye and radioisotope. And then after 2000, Acozoxy 11 and Amoros trials showed that axillary dissection were unnecessary even if patients had 1 or 2 positive sentinel lymph nodes. And after 2010, and especially medical oncologists tried to use extensively NAC due to the more effective drugs for systemic chemotherapy and NAC, and we started to see downstaging in most patients with axillary lymph node positivity, And we started to perform marked lymph node biopsy and targeted axillary dissection in patients after NAC. And today we try to eliminate sentinel lymph node biopsy and maybe axillary dissection in marked lymph node positive or targeted axillary lymph node positive patients. In 1980s, professor from Italy did the first CMF trial, and he came to Istanbul. I listened to him. I tried to remember his name. Maybe Mamunos or Kyun name know the name. And he told us after successful CMF trial results, there will be no place for surgeons soon or in future because we will treat all the patients with systemic therapy. But we have place today, and we will have place in future as a breast surgeon. We accept to escalate the role of surgery, but we will have a place to the surgery in future. Today, axillary staging is, I remember Bonadonna. Bonadonna was the master of medical oncology in Italy. Yes, Bonadonna. Okay, today axillary staging is important for systemic treatment selection in patients with ER-positive, HER2-negative premenopausal women, patients with less than 2 centimeter in size tumor, clinical and 0 HER2-positive cancer, not receiving NAC, and triple-negative cancer less than 0.5 centimeter, and post-NAC patients. And nodal status is also currently a major determinant of the use of regional nodal irradiation and post-mastectomy radiation therapy. To stage the axilla, the slide was shown by Professor Kuhn. In patients with clinical and positive disease after NAC has been challenging due to anatomical and biological factors. And FNR false negative rate was 12.6% in ACOSOC Z11. It's 8.4% sentinel node biopsy following NAC trial, and it's 14.2% in Sentinel trial. And it was 13.7% in our prospective clinical trial published in European Journal of Surgery before these trials. And there are many attempts to reduce false negative rate after NAC, additional evaluation of sentinel node with immunohistochemistry using dual method, removing more than 2 sentinel nodes, marking positive lymph node with different markers and removing after NAC, and targeted axillary dissection, excision of marked lymph nodes, palpable lymph nodes, and non-sentinel nodes. In our prospective clinical trial published in also Surgical Oncology 2018, 98 patients with T14 and positive M0 breast cancer were included. Biopsy-proven positive lymph node was clipped before NAC, and dual method was used for sentinel lymph node biopsy, and identification rate was 87.8%, and false negative rate was 4.2%, an acceptable rate. And in a systematic review and pooled analysis for marked lymph nodes plus and targeted axillary dissection after NAC, 9 studies with marked lymph node, 13 studies with targeted axillary dissection were included. Post-negative rate was 6.28% for marked lymph node biopsy patients and 5.16% for targeted axillary dissection patients. These FNRs observed are below the accepted target of 10% for clinically proven node-negative breast cancer patients. Our paper published in Cancer last month with the title of Combined Analysis of MF1802, MF1803 neocentric studies. The pathologic node positive disease doesn't necessitate axillary lymph node dissection. in patients with breast cancer with a good response to NAC as long as radiation therapy is provided. And 501 patients who achieved complete clinical response to NAC underwent sentinel lymph node biopsy alone and or targeted axillary dissection alone. At a median follow-up of 42 months, axillary and locoregional recurrence rates were 0.4% and 0.8% in sentinel lymph node alone and targeted axillary dissection alone group respectively. And no significant difference was found in disease-free survival and disease-specific survival rates between patients undergoing TAT versus sentinel lymph node biopsy alone, those with breast pathologic response, sentinel lymph node methodology, number of metastatic lymph node, or type of metastasis, micro or macro metastasis. In conclusion of this study, the omission of axillary dissection can safely be omitted, can safely be considered for patients who achieve complete clinical response after NAC, even if residual disease is detected by pathologic examination, provided that adjuvant radiation therapy is administered. Neither the sentinel lymph node methods nor the number of excised lymph nodes affects oncological outcomes. I will shortly explain give about results of our own 209 patients after neoadjuvant chemotherapy. All radiologic studies performed before NAC were repeated before surgery. Tumors and positive lymph nodes were marked before NAC in all patients. Dual method was used for sentinel lymph node biopsy. Targeted axillary lymph node dissection was performed, and extensive lymph node positivity required axillary lymph node dissection. And Warguide localization was used, specimenography was obtained, and intraoperative evaluation was performed for tumor specimen and sentinel lymph nodes. The tumor cavity was marked and closed by volume replacement or displacement, additional partial smooth torsive flap. Mean age was 50 years old, and 63% of patients were premenopausal. Clinical stage was stage 1, 3%, stage 2, 63%, and stage 3, 34%. 11% of the patients had luminal A, 20% had triple negative, and 12% had a pure HER2 positive, and 57% of patients had luminal B plus minus HER2 positivity. And surgery for the breast and the axilla was mastectomy plus axillary dissection in 19 patients, lumpectomy plus sentinel lymph node biopsy in 34 patients, mastectomy sentinel lymph node biopsy in 24 patients, and lumpectomy plus axillary dissection in 23 patients. How about the surgery for the breast? In 26 patients, mastectomy plus implants was performed. Yes, only in 5% of patients had a simple mastectomy, 12% patients had a modified radical mastectomy, and 57% patients had lumpectomy. And the response to neoadjuvant chemotherapy, both breast and axilla, PCR rate was 24%. It was 34% in the axilla. It was 44% in the axilla. It was 34% in the breast PCR rates. And as you see, PCR is the lowest in patients with luminal A breast cancer. To my experience and knowledge, we don't do NAC for patients with pure luminal A patient disease. It was unnecessary given systemic chemotherapy for these patients. In patients with HER2 positive, ER positive, PCR rate 36%. It's 44% in patients with HER2 positive breast cancer and 32% in patients triple negative, and overall PCR rate was 24%. And if you look at this figure, you'll see that triple-negative breast cancer patients had a 65% survival in 5 years. It was highest in patients with HER2-positive. There were 6.2% local regional recurrence in 5 years. 6 patients had an axillary recurrence, 6 patients had breast, and 1 patient had both breast and axillary recurrence. And also, systemic recurrence rate was 16.8%. In multivariate analysis, we see that molecular subtype and axillary tumor burden was statistically significant factor for overall survival rate. And then, how about the disease-free survival? Only sentinel lymph node biopsy versus axillary burden is important for local regional recurrence rate. As a conclusion, greater use of NAC has led surgeons to have frequent encounters with women with upfront node positive disease and PCR, a better understanding of BC breast cancer biology and molecular biology and genetic structure, and new therapeutic agents have changed the role of surgery in breast cancer management from radical mastectomy to radical breast and axilla saving surgery. And node-positive patients achieving PCR after NAC can be risk-staged by marked sentinel lymph node biopsy or targeted axillary dissection if the appropriate techniques are used. And in patients receiving NAC, only sentinel lymph node biopsy may be sufficient, provided that radiotherapy is added. However, we have to wait for the results of ongoing trials, alliance trials, and taxis trials from EORTC to make a real decision about not doing axillary dissection in patients with positive sentinel lymph node after NAC. Thank you very much for your attention.
Thank you, Professor Usman. May someone of commentators have a comment or a question from the audience? Thank you, Professor.
We should proceed to the next speaker. Is Professor Karkatsanis, who works at the University Hospital of Uppsala. Andreas, the stage is yours.
Thank you so much. Thank you for the invitation. Now, this is a talk that I'm going to do wearing my editor's hat to discuss a little bit what seems to be a contradiction between what a trial shows, how do we deal with it, and how do we move forward. These are my disclosures, and since this is something for me which is a little bit of a philosophical talk, the first 3 slides have to do with fragments of works of one of my favorite authors, so that we'll just take a minute to sink into them. I'm not going to read them out loud, we'll just have the time to go through them. The next one I like more. And then the last one. So, to proceed to the talk. A trial question is and will always be driven by knowledge gaps that will hopefully inform practice. But more than one trials may examine the same question differently nuanced from different angles. And while trials will accrue patients and evidence to answer a question, the practice will independently proceed and evolve. That means that by the end of a trial, we do have more questions than the answers that we got from the trial. And this means that trial outcomes will always be needed to be interpreted within the trial context when that trial was thought of and with their clinical relevance nowadays. And the bed of Procrustes, since I'm talking to a predominantly Greek audience, should be left out of these types of discussions. So I just sampled a little bit of this and that as an excuse to discuss discrepancies. I got a lot of help, without knowing it, from the talk that Professor Mamounas had this morning. So you will see a repeating theme. We know how the axillary treatment landscape has evolved from the 80s until today. And we kind of understood that it is diagnostic but not therapeutic. And nowadays we are discussing biology instead of stage to inform practice. But especially in the setting of up to 2 macrometastases, we did trials, and there is one more pending, that all examine the same theme with different inclusion criteria, different policies on how to address avoidance of axillary lymph node dissection, and so on. But after these trials, do we have answers for everything? So, how many of you feel that there is adequate level 1 evidence to refrain axillary clearance in the presence of 5 micrometastases? You do not have level 1 data because the micrometastasis study, the IBSCG 2301, said 1 or more micrometastases, but they had no more than 3. They had 1 with 4 that was excluded. Does this mean that we do an axillary lymph node dissection? No, you actually extrapolate from the trial. How many of you feel that we have level 1 data that allows us to avoid completion axillary dissection in a patient with up to 2 macrometastases and a T3 tumor? The Xenomac had 6% only. So it is a subgroup. So formally it is an exploratory analysis, but would we consider doing axillary dissection in a patient like that? No, we just need to acknowledge that limitation. The same thing about extracapsular nodal invasion. It is the exact same thing. And especially about Xenomac, I can say anything I want because I'm not part of the author group. So when I say good things about the study, it is not because I'm part of the author group. Okay. So let's move forward. Omission of axillary surgery for CNO early breast cancer. So let's refine the role of sentinel lymph node dissection for the CT1 and O. Now, you will all think about the sound, but is it really a new thing? We'll come back to that later. And this is the sound. This is how the sound looked like. And this is what they intended to include and exclude. And this is what the primary outcome looked like. Now, the devil's advocate will ask you, is that a new thing? Already from the 90s, you had Roberto Agresti's trial that showed no benefit. And I would go on and argue that it is a very safe bet biologically to say that in a patient that has a unifocal tumor, most probably ER positive, HER2 negative, that has no signs of axillary disease on an ultrasound, giving the whole package of treatment will not probably change the disease, the distance disease free recurrence interval, depending on a sentinel node biopsy conducted or not. In Sweden, there was a prospective cohort study of patients that had been followed, and more interestingly, in this study, we actually knew what happened in the adjuvant setting. So you see that approximately 1/3 of patients got no therapy at all. They just got a lumpectomy, and still things were okay, nothing happened. So that tells us a little bit about the biology, and the Choosing Wisely campaign, you're all familiar with that, has already given us that type of data on an observational level. Now, is it prime time just because of the sound to go further? No, because other trials came and asked us about the axillary status in order to be able to inform systemic treatment decisions, as we discussed. And moreover, we now have more trials that will tell you that it is safely, you could safely omit radiotherapy, the CALGB and the prime, for example, or to discuss brachy or partial, if you know that they are node positive pathologically. And with regards to how the sound looks like, because the devil is indeed in the details, 1/3 of patients were actually candidates from the PRIME2 trial. So had you known that they are pathologically node negative, you could safely omit radiotherapy. The other third were patients with very small ER-positive HER2-negative tumors, where you would know that you could even discuss the omission of endocrine treatment in favorable characteristics. So the idea of balancing things is something which is quite relevant, because a 65-year-old patient standing in front of you that is eligible both for the SOUND trial and the PRIME2 trial would optimally, if you want to retain high evidence-based practice, they would have to choose either refraining a sentinel node biopsy but getting whole breast radiotherapy, or the other way around. So there is no clear-cut recommendation for this important cohort of patients. Now, we had this discussion about omitting what I like to call fast-track ALND, and Professor Mamounas alluded to that. There is a meta-analysis from Vivian Mann and Ava Kwong from Hong Kong a couple of years ago that showed that all these patients that had a single pathological node, if taken to fast-track axillary lymph node dissection, you could find that half of them were Z11 eligible. And whilst this is being discussed in the context of clinical trials, and Walter's Weber trial is one of those, Shelley Potter got approval for the Tadpole study in the UK now. We are discussing about primary targeted axillary dissection in the context of trials. However, the NCCN guidelines have included that since last year. And I do not believe that a guideline committee would put their money on a not safe bet. This is something that we discussed. You have seen all the numbers. Now, the monarchy misreading of the 4 nodes is a little bit another thing. The 3 types of analysis that you can do in a randomized controlled trial is the per intention to treat, the per protocol or efficacy, and the as treated, right? So the per intention to treat is what the regulatory bodies need to get approval. The efficacy analysis is what the medical oncologist needs to understand how things work and how safe and what do you expect from a drug. We as surgeons treat the as needed, as treated population. We are on the floor, we are working with these patients on a different basis. Now, if I were pharma and I wanted to show that a new drug has got superior outcomes because that new drug would increase costs, I would make sure that my money is on the safest basket. So I would choose the patients that have the highest possible risks to include them so as to make sure that I will show a difference. And this is what happens over here. But is it worth it? You saw the post-hoc analysis from Senomac. You also saw the population analysis from Gaillard from France as well. And that makes a very compelling argument as to whether this is a good idea. And I think it is not. And you could find an alternative, and there are nomograms. This is the most recent, another exploratory analysis from the Senomac, but it is performing completely comparably to previous works, the best of which I think is by Tuomo Meretoja because it was multinational, collaborative, and prospective. And now you've got another choice. And that means that this is not a question anymore. So we had this type of collision in our MDTs with our oncologists, but now, especially now that Ribo got a positive opinion and it's coming into practice, this is a non-issue anymore. And interestingly, for those that were not convinced by the first publication, the most recent publication gives a very clear outcome on how the curves look like. Now, we discussed about that. We know what the observational data looks like. We know what we are expecting, and we know how things are going to move forward. Neoadjuvant endocrine treatment. Do you really have any evidence that suggests that you should subject patients that are still node positive after neoadjuvant endocrine treatment to axillary dissection? In other words, does it behave the same way as the axilla, or does it mean the same things as a still positive axilla following neoadjuvant chemotherapy? I think that we actually know the answer for that. And the issues that we have with neoadjuvant endocrine therapy will probably lead us in dealing with metastatic lymph nodes that will guide decisions as per upfront surgery in these patients. And the most important thing, I think, is that this might be in the future a selection criteria for CDK4/6 in the adjuvant setting. I think that everybody in the room performs or flirts with the idea of oncoplastic breast conservation and immediate breast reconstruction. Do you have any randomized control trials that looked into survival outcomes with this question? No. Will we ever get any? No. And we shouldn't, because that would mean depriving patients of choice. And what I think is that we will move forward to a case where the axillary diagnostics will not need to be surgery, and there are different techniques, but I will not go into them. With regards to more surgical questions, in the last decade or so, there has been an explosion of research with regards to non-isotopic sentinel lymph node traces. And this is the primary outcome of a network meta-analysis that suggests that the paramagnetic tracer and ICG perform completely comparable, and you see that the confidence intervals are very, very narrow. So I can tell you that the trial sequential analysis of these trials says that the information size has been saturated. So no more trials will change the outcomes of this. Okay. Now, do you need a randomized control trial? If you go back to the ideal framework, you would need a randomized control trial if superiority claims are made. But if no superiority claims are made, you should not expect a randomized control trial. And given the detection rates that are higher than 98% for the isotope, but these tracers as well, if you wanted to perform a superiority trial, I just did it for the fun of it, you would need a sample size of 32,954 patients. So for everybody that is ambitious, good luck with that. I'm not doing it. And last but not least, breast surgery post-neoadjuvant chemotherapy, it is safe. And we have been debating the question of what we call response-adapted surgery. And we know how things look like, but this meta-analysis of these more historical trials suggested a higher loco-regional recurrence rate. So there were these concerns. I think there are no real concerns, because if one looks to more recent data, this is a meta-analysis on a patient level performed by Antonis Valachis from Sweden, and it shows what are the factors that have to do with loco-regional recurrence, but type of surgery is nowhere inside them. And if you don't like the Swedish data, this is data from Gustavo Berutsky and the German Breast Cancer Group that tells you the exact same thing, the risk of loco-regional recurrence. And if you're not very fond of the German data, this is the I-SPY 2 trial data that shows the exact same thing. So what that means is that your risk of recurrence may depend on many things, but type of surgery offered afterwards is not one of them, provided that you have clear margins. Now, this is a problem because complete pathologic response and BCT do not seem to correlate. And in a previous work that I did some years ago, what we saw in trials that included surgical intention at baseline and following neoadjuvant chemotherapy, there was no correlation between overall complete response, which is what you know before surgery, and shift to breast-conserving surgery. And when one was looking at that, you could see that primary systemic therapy doubled the eligibility. Only 70% of those actually got it, and that was not a significant effect in terms of conversion. But it is not reasonable, because what these two forest plots show you is that approximately 69% of patients that could undergo breast conservation and had an at least 50% reduction of the tumor size received mastectomy. And when you were looking at the patient's type of surgery and path CR, 6 patients that were eligible for breast conserving surgery and had path CR actually got a mastectomy. And, well, do we expect a randomized control trial on this outcome? We are blaming it on the fact that neoadjuvant trials do not include surgical oncologists. But this is a problem, because we are doing it, we know it works, and there will not be an RCT with these questions, because again, it is a matter of ethical regulation and approval. A tumor has disappeared, you cannot, or has, shrinked, you cannot possibly tell a woman that I would like to randomize you to a mastectomy or to breast conservation just because I'm curious about something. And that was me. Thank you very much.
Thank you very much, Andreas. Any questions or comments?
Thank you for the excellent talk. Actually, it was something I was not expecting to hear in a congress, but I think it was very interesting. My impression is that we know where we're heading, and we're designing studies to prove our practice most of the times. And I think there are many unanswered questions because the practice have already been established, and then you can't really make a study to prove that. And on the other hand, there are studies that when they were designed, they were not expecting that other data, for example, the sound trial was very unlucky because when the sound trial was designed, was not expecting that the monarchy was going to come up and other studies in between. So I think there are some studies that they are lucky and some other studies that they are unlucky. But at the end of the day, I think the practice is determined before we design the studies. What is your opinion about that?
I would agree. I would not call them lucky or unlucky. What I think is that we get a fuller piece of the big picture, but the pieces of the puzzle are not put on the picture on a linear fashion. You get separate bits and bytes here and there. We are discussing about omitting sentinel lymph node biopsy on these patients, for example. At the same time that the sound was recruiting, in Italy, they are performing 57% sentinel lymph node biopsy in patients that have in the end pure DCIS. So you see my point. We are discussing about where the spaceship will go, but we need to sort things on a completely different level when it has to do with informing clinical practice. The big challenge is how to adjust our interpretation of trial results today based on the understanding that this was a concept conceived 10 to 15 years ago. That's the big question. And where do you put a stop? Like, I have a question for the audience. How many of you know how many randomized controlled trials established the superiority of total mesorectal excision for rectal cancer? What is the evidence behind these? None. There are 2 monographs by R.J. Hild. 2 monographs. And that established practice. So we need to think on a pragmatic level when we are discussing these types of things. And we just need to prospectively audit, register, and understand what we think. The randomized control trial will always be the golden standard in terms of efficacy comparators if you want to produce an explanatory trial and provide inference. But the big question is, when do we actually need inference? If Axana had been a randomized control trial, they would have been able to put the power around one endpoint, right? Yeah.
Comments by Professor Kuhn?
And I have another question. So you are from Sweden, but not among the authors team of Xenomac. Is Xenomac confirmation of Z11 or confirmation of Amaros?
Amaros.
Yes, thank you. Now, question
because excuse me for interrupting, for the people that don't know the background, the initial intention for Xenomac was to omit radiotherapy. And whilst we were recruiting, there were national but also international objections from radiation oncologists, and this is why the New England Journal of Medicine did present the per protocol analysis. So what Xenomac tells you is that beyond doubt on terms of an adequate sample size, axillary radiation therapy can replace lymphadenectomy, regardless of type of surgery that you have performed.
Yeah. And this leads I think it's an important discussion. This leads to an important discussion in Germany. So with Z11, according to protocol, there were tangents. Then we learned from the analysis from JAXI that there were many patients with high tangents. So we introduced high tangents in our guidelines, whole breast irradiation and with the target volume until the lower border of the axillary vein. Now with Xenomac, 90% had whole regional irradiation level 1, 2, 3, 4. Now what happens in our country is that radiation oncologists say, okay, so far we irradiated high tangent, but now we have best evidence from Xenomac to go even further. Now with Xenomac we extend radiation therapy.
That's an interesting comment. Last week I was giving a keynote lecture to Denmark about the management of the axilla. So their concern was the Lancet Regional Health paper, Tuve's paper from Xenomac. And now they know how high a percent of patients will have more nodes because of the control arm. So the medical oncologists, what they say is that to be on the safe side, if you don't want to clear the axilla, we will give 2 more cures of chemotherapy, not dose dense, which I would understand, but they just prolong it. So they are buying 2 on the house. And that's also another thing that we need to account for, because cumulative knowledge will bring new questions and uncertainties in how to deal with these scenarios. And we need to be aware of that. And we need to just make our decisions in common sense. Eric Weiner has said one of the things that I think of more and more in my practice. Do you ever get the perfect trial that will give you the answer to all of your questions? No. You just need a reasonable subgroup in order to make safe extrapolations.
Any other comments or questions?
Oh.
Michailis Kondos.
Γεια σας, γεια σας. No. I recruited for the Xenomac.
But you still don't like it.
Oh.
Anyway, we can go
I have been defending Xenomac more than I defend my own trial, so...
Okay, we can talk about it later, but now I want to say something. I'm not sure whether we agree or disagree. Extrapolating conclusion from a big trial to a smaller group is part of is so attached, so closely connected to randomized controlled trials for as long as they exist. I mean, when you design a randomized controlled trial, you know that your population will be people with quite different tumors. And, but in the end, you have to come up to one conclusion. And if the trial is from there to there, this patient here is very different to that one, but still you come up to a conclusion for all of them.
I agree.
And what applies to this one may not apply to this one. And what is even more important is if you stick to the 2 trials you mentioned before, Z11 and Amaros trial, despite the fact that both of them were underpowered and they stopped before they reached power to prove what they wanted to prove, we took and despite the fact that the patients recruited in these trials are patients with very minimal axillary burden, we use the results for people who are much higher axillary burden in the axilla with time.
And this is how things will go. In the morning, Professor Mamounas showed the rate of more metastases on the control arm of these trials. And the newer the trial, the higher the percentage, which suggests that we dare to go more and more and more and more.
It will be impossible to have a randomized controlled trial for each one of the small
I agree.
Group.
I agree. But what I'm just saying is that in terms of methodological intactness, the main criticisms around Z11 were, subtypes, underpowered, not enough events, this, that. But the growing field of interest, if you apply the Z11 criteria in the patients of the trials that followed the Z11, you will see that the saturation level is at least 88%. That's my point. The point is that you will always apply data that are in subgroups that have been described, regardless of whether they have been adequately recruited for. And this is why I think that once you know the robustness of the results, and this is what, if we're talking Xenomac, this is what Xenomac did. Xenomac put the tombstone over the doubt for axillary lymph node dissection.
But it took it 10 years to do that.
Yes.
And these were the importance of registry trials or non-interventional trials come in. I think this is where the importance of Axana comes in.
Exactly.
Because it collects a large number of people very quickly, relatively quickly, and will have, I hope, will have enough power for each one small subgroup to draw safe conclusions. And furthermore, it is real-world data, not marathon runner,
I agree. I agree. I'll just say that to conclude. The LORD trial from the Netherlands was looking at the question of monitoring versus active surgical treatment for low-risk DCIS. That trial was running for 4 years as a randomized control trial, and they had included 72 patients. So they made it a patient preference study. And from the 4th to the 5th year, they went to 770 patients. And I do not think that the value of the results for clinical practice will be reduced because it is a non-randomized study now.
Any other questions? Okay, so a closing remark from Yannis.
Okay, I have to thank all the presenters for the excellent presentations. The most of them are here from the morning, so great thanks. Thank you very much.
Right. So would we moving towards the roundtable 9 now? We welcome you to all have a seat. Right, so we come to the conclusion of this very rich day, and we will have more insights on advanced oncoplastic reconstructive breast surgery. For our first speaker, we would like to welcome on stage Dr. Anastasios Tsekouras, a plastic surgeon from Athens. Dr. Tsekouras, the stage is yours. So Dr. Anastasios Tsekouras is the head of plastic surgery in Lito Obstetrics and Surgery Clinics. Dr. Tsekouras, thank you for joining us.
Thank you, Mr. President. I would like to thank Mr. Venizelos and the organizing committee for this invitation. My talk is regarding management of early and late complications in implant-based reconstruction. I declare that I have no conflict of interest regarding this presentation. Implant reconstruction is the most common form of breast reconstruction, and despite there are several techniques, all of them have showed appropriate safety data, which is, there are hundreds of papers in the literature. Having said that, however, complications are not uncommon, with an overall rate between 26 and 31%, and with a reoperation rate between 15 and 19%. We can say the complications to be related to surgery or related to the device we use, and they have a spectrum of severity that can range from mild aesthetic deformities to be managed with conservative treatments, but also to follow additional surgery, occasionally reconstructive failure, and rarely they can lead to systemic illnesses. We can classify them into early complications or short-term complications that occur within the first 30 days postoperatively, and they have the potential to threaten the reconstruction, such as hematoma, seroma, infection, and skin envelope necrosis of the mastectomy flaps, and late complications or long-term complications, which include the malposition of the implants, contour deformities and rippling, severe capsular contraction, animation deformity, implant rupture, anaplastic large cell lymphoma, and breast implant illness, which may not pose an acute threat of reconstructive failure, but can include undesirable aesthetic results. They can lead to more significant reconstructive concerns, and rarely to systemic illnesses, and each one of them to require distinct management strategies. A hematoma presents about 1 to 3% in the literature, and commonly presents within the first postoperative week with symptoms of breast swelling, ecchymosis, and tenderness. What is important with hematomas is that they can compromise the mastectomy skin flaps to necrose them. They can lead to capsular contraction, to poor aesthetic outcomes, and sometimes to need for transfusion. As preventing strategies is a careful pocket dissection and meticulous hemostasis. Preoperatively, you have to make sure that we have discontinued anticoagulant drugs, that we address coagulopathies, possible coagulopathies. Now, drains, they don't seem to prevent hematomas, but it seems that they are important to detect a hematoma if present, and also to relieve a mastectomy flap from the pressure that will apply after a hematoma. The management is a prompt return to the operating room for evacuation and hemostasis. Now, aspiration or compression, they have limited evidence of success. As adjunctive measures, we can use the tranexamic acid that I'm using it, or intravenously or topically, which I prefer to perhaps avoid systemic effects. Infection is another dreadful complication of implant breast reconstruction, which can lead to implant loss, to delay adjuvant oncological treatment, and to lead again to poor aesthetic outcomes. Since there are high rates of infection when we compare with cosmetic breast augmentations, the rates can raise up to 30%, with a presentation ranging from mild periincisional cellulitis to whole breast erythema, and sometimes even to poor drainage. There are risk factors related to the patients, as like a high BMI, smoking, and the history of preoperative radiation or chemotherapy, but also they can be due to non-infection complications, to be implicated with non-infection complications, as like skin necrosis, hematoma, and seroma. The management, of course, it includes meticulous sterile technique during surgery and intraoperative antibiotic prophylaxis. It seems there is evidence that it's important to use some postoperative antibiotic prophylaxis as well, but these days they don't believe in a long-term postoperative antibiotic prophylaxis. If you review the literature, for mild cases, oral antibiotics for 10 to 14 days is enough, but if you have severe cases, then you have to convert to intravenous antibiotics and hospitalization, and we can escalate sometimes to wash out and implant removal if it proves to be necessary. Reviewing the literature, you can find that implant salvage rates can be as high as 64%, not only with antibiotics, but also if we have to remove implants as well. The seroma reports are high as 20% in the literature. They can cause patient distress and discomfort again. They can delay progression to adjuvant therapy, and they can escalate to infection and the loss of the prosthesis. The etiology is multifactorial, with etiology related to the technique of the mastectomy, with a post-mastectomy inflammation perhaps, with dead space formation, due to the dead space formation, due to lymphatic disruption, or to electrocautery damage during hemostasis, or can be related to the implants, to the devices, via foreign body response or contamination and presence of the biofilm. There are risk factors related to the patient, again an elevated BMI, and risk factors related to the use of surgical risk factors, as like the use of ADM and the preoperative radiation. Prevention strategies, again, is the use of vacuum drains, closed suction drains, but on the other hand, it's important to remove early these drains because it seems that improves the overall outcome. Of course, surgically, it's important to eliminate the dead space during surgery with quilting sutures if necessary, tailoring the skin flaps, and with tissue expansion if that's again important. Again, the topical use of tranexamic acid, in many papers, they prove its efficacy during this complication. Also, these days, if we use ADMs, it's important to be fenestrated, which the most new devices are. A sterile technique, of course, is very important to reduce the bacterial load and the biofilm risk. And also postoperatively, it's important to advise our patients for a limited shoulder and arm movement in the initial postoperative period. Now, if we have seroma, the most effective treatment is to aspirate it under ultrasound guidance to avoid any damage of the possible damage of the implant. In cases which are more complicated or refractory seromas, then you have perhaps to be more aggressive and to drain them surgically and to eliminate the dead space if exists one. the skin envelope necrosis on the mastectomy flaps can lead to incisional dehiscence or to partial or full thickness skin or nipple loss. The incidence in the literature, it can be between 4.5% up to 41%, which is very interesting, depending on the criteria used. It seems like there is a lack of standardized classification system, and in the literature, what is defined as necrosis is any degree requiring deviation from the normal postoperative care protocol. Again, related to the patient risk factors is smoking, a high BMI, comorbidities, diabetes, previous radiation therapy to reconstruction, and of course the techniques of our mastectomies, usually with the nipple sparing mastectomies due to the large perfusion areas, with periareolar incisions, and with cases of macromastia that increases even more the rate of necrosis. The prevention, of course, is simple to adhere to the proper anatomic planes. Reviewing the literature, I found that when the mastectomy flap thickness is below the 70% of preoperative subcutaneous tissue, that can be correlated with ischemic complications. Of course, the use of cyanine green angiography can visualize in real time the superficial blood flow, and this can be important because if we suspect poor flap quality, we can decrease expander volumes if we expand the reconstructive breast, or we can resect poorly reperfused tissue, or we can convert on the operating table the reconstructive type from immediate implant reconstruction to tissue expander to two-stage reconstruction, or we can convert from a prepectoral to total submuscular reconstruction, or sometimes in more severe cases to delay reconstruction for a later stage. The management, if it is some small partial wound thickness dehiscence or necrosis, we can treat it with local wound care, with clinic debridement, and with VAC therapy perhaps. But if you have a total loss of the skin and the exposure of the implant, then you have to move into more radical surgical approaches using perhaps regional flaps, mucocutaneous flaps to put between the implant and the skin surface to try to salvage the reconstruction. Moving to the late complications, capsular contraction is a well-known entity that is related to the implants, and despite its physiologic process of non-porous foreign body response, with implants, in some cases, can be dysregulated. The incidence, we thought at the beginning that was limited to the first years of reconstruction after surgery, but it seems that it continues up to sometimes to 24% of incidence over the 10 years. New implants, of course, they seem to drop even more the capsular contraction rate recently. The etiology has not been confirmed, and there are theories that they relate the capsular contraction to the subclinical implant infection with biofilm development or to an autoimmune predisposition that is causing chronic inflammation. We know that post-operative hematomas, they can increase the rate of capsular contraction risk, and the same with radiation therapy. Now, in the literature, it says that when we wash out the pockets with betadine, that can be beneficial towards capsular contraction, which doesn't seem that the same applies when we rinse the pocket with antibiotics only. This is a case of mine where this patient presented with capsular contraction after radiation, and finally we salvaged the whole operation, removing the implant, replacing the implant, removing the capsule, and doing a better dissection. That's a post-operative result with expander at that point, waiting for the final implant to be inserted. Now, as a management, we can have non-operative solutions Well, usually with some adjuvants, medications that we usually use in the management of asthma, but there are barriers, and to speak frankly, the management of capsular contraction is surgical with a capsulectomy, usually total capsulectomy, and the replacement, exchange and replacement of the implant. Because that is what can eliminate the root cause of the symptoms. We can use a neo-pocket, perhaps, removing from pre-pectoral to sub-pectoral to submuscular or dual plane conversion, or even sometimes if we were in the subpectoral plane, we can create a neo-pocket, and as you can see there in these pictures, and we can always create a new plane to insert the new implants. The ADM use, it seems to reduce, again, the rate of capsular contraction, and that's very good news. It is being used very often in the last years. What is important, though, is to understand that with recurrence, with revision surgeries, we can still have high recurrence rates of capsular contraction, and that's important to educate our patients, to discuss it with our patients, to set the proper expectations for them. And someone can say that every surgery can differ based on implant type, prior complications, and the patient history. Malposition is the displacement of the implant in any direction, or a rotational malposition if we are using anatomical implants. It can relate it to the chest of the patient's anatomy, chest anatomy of the patient, but also in surgical technique when you have an over dissection. I don't go through more into this, but managing the malposition, we have to revise the existing implant pocket with capsulotomies or capsulorrhaphies, or using an ADM again to reinforce a thick or weak capsule in recurrent cases. Also, again, to do a new pocket from pre-pectoral now to subpectoral, or a neo-subpectoral pocket as well, as like with capsular contraction management. And sometimes you have to change the implant if the previous implant was too big for the pocket. Contour deformities at rippling. The most common one is the stop-off contour deformity in the upper pole, usually after the use of round implants in the prepectoral space in patients with a low BMI. It is important preoperatively, again, to have discussed with our patients in detail that this possibility may happen. And the most popular surgical technique is autologous fat grafting, which is effective and well tolerated for our patients. Of course, you have to make sure to avoid implant damage and overfilling. And also, we have again to inform our patients that multiple rounds may be necessary to reach the final result. We can also change the plane from prepectoral to dual plane, but this is not so common for these days. The autologous fat grafting seems that it can help us in the most of our cases. The rippling of the implants, again, is you can see it in low BMI patients with thin subcutaneous tissue post-mastectomy. And again here, the autologous fat grafting can camouflage the rippling. Also, we can take into account to use in this type of patients form-stable implants, more highly cohesive, and also to decide what kind of pocket we have to use and what kind of reconstruction we have to use for the reconstruction of this particular patient. If this happens, you have to shift to another pocket, usually to subpectoral pocket from prepectoral pocket, and again, ADM can help us very much in preventing or correcting this complication. Animation deformity, it can be high as up to 76% and occurs with implants in the subpectoral plane, which not only they not produce cosmetic dissatisfaction, but also can cause musculoskeletal discomfort to the patients. Again, you have to proper design of our reconstructive technique is important. You have to consider the patient lifestyle, if there's an athlete or a weight training patient. And in this case, the conversion from subpectoral to prepectoral plane, it helps us to treat this complication. There have been tried non-surgical techniques as like botulinum toxin or other techniques like fat grafting or nerve ablation, but with they haven't proved to be so successful. The rupture of the implant is again a very serious complication. If there are saline implants, it's very obvious. The one breast is deflated suddenly, and also the answer how to manage it is very obvious. We have to replace it the soonest, the better, so to maintain the implant pocket size. But these days, most of the implants are silicone implants, so we have silent, undetectable on physical examination ruptures. That makes things more difficult. MRI, as all of us know, the ultrasound scan are the examinations, radiological investigation that can suspect or confirm a ruptured implant. The management is the removal of the implant with a total capsulectomy. As total as we can make it, it will be more important so we don't contaminate the pocket with the implant. These days, implants, the gel of the implant are more cohesive, so things are perhaps slightly better. Here you see a case like this, and what you see here is the many holes. And this is indication that this rupture happened following a fat grafting procedure, unfortunately. Now, the anaplastic large cell lymphoma is a well-known entity these days. Hopefully, fortunately, it has a very low occurrence. Develops usually 7 to 10 years after implant placement, and the aspiration of a late-onset seroma and cytological examination is perhaps it's the protocol that we have to follow in order to diagnose it. It is related solely to texture implants, and there is an FDA warning towards all texture implants. We all know that the BioCell, the Allergan implant, has been withdrawn from the market. Here, I'd like to show a case of mine. You saw that seroma previously. This patient had two-stage breast reconstruction 15 years ago. I lost her in the follow-up, presented again after 12 years in the office with this problem. We followed all the protocol, finally didn't prove to be an ALCL. I thought that would have been my first case. But we decided to, of course, to remove the implant, to replace the implant, to do a total capsulectomy, and this is the result after this operation. And the interesting thing here is that here I used an anatomical implant. Actually, it was a McGunn in those days, Allergan implant, and here a round implant. It shows similar aesthetic results, something that is very much supported from the literature. So the management of the associated anaplastic of the ALCL is an unblocked capsulectomy with resection of any residual mass. This can be done through a very brave incision following the whole inframammary fold of the reconstructive area, and shows that if we achieve it, we have 91% survival rates at 5 years. Now, if we have more advanced disease, then the treatment is not it's not surgical but oncological, similar to de novo systemic anaplastic lymphoma. Finally, the breast implant illness is an entity that with symptoms that range from vague symptoms from fatigue to symptoms similar to autoimmune diseases with no characteristic findings in imaging modalities, and with lack of standardized diagnostic criteria. There is a sort of etiology, and the management is poorly related, entirely related to the patient if she wants to have them removed. Capsulectomy hasn't been found in the literature to be of benefit to the patients, but finally what we do is a total capsulectomy, removal of implants, and replacing of the volume with fat graft or autologous reconstruction. Closing my presentation, I have to say that the importance of the perioperative patient counseling to understand the risks, the potential risks of the implant-based reconstruction, the complications that may occur, and the way you have to move forward. And also, just to let you know that there are risk calculators to provide individualized risk assessments if required. Therefore, successful implant-based breast reconstruction requires a proactive approach to address both early and late complications based on all the key parameters that we discussed in the previous slides. Thank you very much for your attention.
Thank you very much, Mr. Tsakouras. We will leave time for questions, comments at the end of the presentations. We will move forward with the next presentation. Mr. Kontoulis, podium is yours.
Ladies and gentlemen, thank you for your presence till this hour. In the next few minutes, I will try to give an overview of the chest wall perforator flaps. What are we trying to avoid here in these pictures? There was an indication for volume replacement. Volume replacement is a technique of small breast by large or medium-sized breast with a larger tumor. There is no need for symmetrization. For the past 20-25 years, Mini LD was the workhorse. Mini LD was introduced by Rainsbury in 1994. It's a reliable flap, but there is donor side morbidity, and if mastectomy is needed, we have used up one of the patient's options for reconstruction. On the other side, chest wall perforator flaps consist of skin and adipose tissue. They are perfused from an isolated artery and vein, perforating the deep tissues, muscle or fascia, and they are named after a source vessel. As they are muscle-sparing flaps, they reduce donor side morbidity to the minimum, and they seem to be the missing jigsaw puzzle, allowing the extension of breast conservation. The first that described a chest wall perforator flap, in particular a lateral intercostal artery perforator flap, LICAP, it was Mustafa Hamdi in 2004. Perforator flaps are not random or axial flaps, which are more familiar with. Random flaps are raised without regard to any known blood supply other than to maintain the presence of the subdermal vascular plexus, so they have minimal blood supply and fixed ratios, length to width ratios, to ensure viability. On the other hand, perforator flaps are robust and well perfused. They're more mobilized and relatively large. Relatively large are also axial flaps, which are oriented along the axis of the vascular supply. What happens with perforator flaps? There is a vessel that comes up like a tree, and then it branches, and the flap that we raise depends on its branches. How this thing works? We have a single perforator, and can we depend on its branches to ensure viability of this large flap? Well, perforator flaps are based on axiality. Axiality is the degree of certainty that blood vessels will travel in a certain direction. How this thing works? Well, each perforator has its own unique vascular region, which is called a perforosome. Perforosome consists of perforators and linking vessels that connect vascular regions, perforasomes, with each other. We have direct linking vessels, which are larger within the supraphyseal and adipose layer, and indirect linking vessels in the subdermal plexus. The flow from our main selected perforator to other perforators occurs by means of these linking vessels. So vascular axis follows the axiality of the linking vessels. High perfusion pressures through our main perforator open linking vessels, allowing the perfusion of many other perforations. So in this way, large flaps can be harvested based on a single perforator. Around the breast, there is a range of rich rays of vasculature which could be used in certain situations. The most frequently used perforator flap is the LICAP, and then ICAP and LTAP. Perforator flaps are ideal for small non-ptotic breasts or medium-sized breasts with minimal ptosis, but there is a subset of patients, up to 18%, that are not keen on having contralateral procedures, and they want to keep their current size and volume, and they want to have and they having a perforator flap. Now, contraindication. Contraindication is the lack of suitable perforators at the donor site because of previous surgery. It's the lack of adequate tissue at donor site, lateral or anterior to the breast. Perforator flaps are suitable for most tumor locations. The landmarks, how to find perforators. First of all, we have the anterior border of the LD muscle. According to HAMD, 2 to 3 centimeters anterior to this border, we can find the perforators. I find more useful the triangle demarcated by the anterior axillary line, the tangent line to IMF, and the lateral breast fold. The workhorse of intercostal perforators are found in this triangle. The perforators for a LICAP are found between the 5th and 7th intercostal space usually, very close to the lateral breast fold, are about 1 centimeter back from the lateral breast fold. And we recognize them with a handheld Doppler as a suddenly enhanced signal. We can hear the tree trunk before giving the branches, and it's a signal that disappears in all directions. If we hear a signal that doesn't disappear and it's linear and we can follow it, usually it's LTA, lateral thoracic artery, next to lateral breast fold, which gives off perforator branches from the 3rd to 5th intercostal space, 8 to 12 centimeters from the axillary fold. When there is a lot of bleeding during sentinel node biopsy, usually is LTA. It's very close to the lymph nodes. It gives 2 branches, one going to the breast, which is not important for our perforators, and the descending branch, which is present at 90% of the cases and gives off perforators 1 to 2 centimeters back from the lateral breast fold. The ACAP has a consistent perforator just below the inframammary fold at the meridian of the breast at 6 o'clock position. The descending branch of the thoracodorsal artery is important for our perforators in case of a TDAP flap. It runs parallel to the muscle fibers of the LD muscle, 1 to 4 centimeters from the anterior border. It gives a consistent perforator, which can be found 8 centimeters inferior to the axillary fold and 2 centimeters back from the anterior border of the LD. Now, regarding our planning, we want to have the best access for our tumor resection, but we also want to have our perforators are close as possible because this will be used as a pivot point for the turnover of our flap to cover the defect. We start by doing the wide local excision and axillary surgery, and then we raise the flap from lateral to medial, and the dissection is carried out in the supraphacial plane until the recognition of our selected perforators. How to determine how long our flap is going to be? Well, as I said earlier, our selected main perforator will be the pivot point, and we measure the distance from our pivot point to the defect that we want to cover, and this is the length of our flap. Now, sometimes, especially in our first cases, when we're doing the dissection from lateral to medial, we find some other perforators too, and we're desperate to keeping these also. If we don't stick to our initial plan and measurements and maintain also these other perforators, we change our pivot point into a more lateral position, and the whole flap becomes lateralized. The pinch test is, with the pinch test, we check the laxity of the donor side, determining the width of our flap, which is important for the closure of our donor side without tension. Like-up flaps are used for defects in the upper and lower outer quadrants. They're easy to locate. Here we can see the flap designs by Hamdi, and the modification by Maybody has a more vertical flap with an easier access to the axilla. L-tap flaps are used in also in larger breasts, again for lateral defects, alone or in combination with a like-up. The dissection of the pedicle allows greater flap mobility, so it can be used also in more centrally located tumors as an alternative to mini-LD or a TDAP flap. We should keep in mind that lateral thoracic artery may get injured during axillary surgery, so first we're doing our axillary surgery, and if everything is okay, then we raise our flap. A-cup flaps are crescent-shaped for defects from 5 to 7 o'clock position, and sometimes also up to upper inner quadrant in small breasts. We need to recreate inframammary folds, and the new IMF is lowered to include our perforator. TDAP flap has a large skin paddle with a long pedicle, so it's suitable for all locations in the breast. It needs careful dissection of the pedicle, which is technically challenging and needs microsurgical skills. We should keep in mind also that when we're doing a TDAP flap, we cannot have an LD as a backup. It can be used also in revision surgery, in reconstruction after a mastectomy in small breasts. Although perforator flaps were described many years ago, their use in oncoplastic surgery has increased only over the last few years. There are small case series with low volume experience. I will mention from the literature 3 studies on clinical outcome from perforator flaps. First is this systematic review showing low complication rate. The studies that were included had variable follow-ups and non-concordant data sets. This is Part-Bricon study. It's a large multi-center cohort study showing again low complication rate, low margin re-excision rates. It was a retrospective study with no PROM data and inadequate data on radiotherapy. This is another large cohort study confirming the same result. It was prospective. It did not have any PROM data. And at last, it's Part-Bricon Pro study, which is still open. It's a multi-center prospective trial, including PROMs. It studies the impact of perforator flaps and radiotherapy on clinical outcome. We're awaiting the results. PI of this trial is Mr. Agrawal, who's our next speaker, and I think he will blow you away with his expertise. Thank you very much.
Dr. Kontoulis, thank you so much. As we said earlier, we reserve questions for the end. So we would like to welcome on stage Dr. Amit Agrawal. He is a very well-known surgeon from Cambridge and world-renowned expert in the field of local flaps. Thank you for joining us.
Thank you. With my name and surname, normally I'm first in the queue for talks, but I'm giving the last talk of the day. So that's very rarity in my career, but thank you for inviting me. There's still people listening. So conflict of interest, I think it's kind of relevant to this talk. So there's this book I've edited, and there's a course that I run. The next one is 8th and 9th of May, and the Part B con, thank you for mentioning it. Now, we surgeons, we do get excited about everything, de-escalation, and yet we escalate some surgery at the same time. So in the course, I tend to throw caution that, look, breast surgery, oncoplastic breast surgery conservation, when you're starting off, don't argue with your oncologist. Find cases that they are probably not interested or want your help. So if the tumor is upper inner quadrant and if it's got DCIS, then that may be one target population you have, because oncologists won't be giving any neoadjuvant chemotherapy. And if they are invasive lobular or luminal A subtype and luminal B non-HER2 type, that again is your target for oncoplastic breast conserving surgery, because unless you believe in neoadjuvant endocrine therapy and your MDT allows. But patients who do have neoadjuvant chemotherapy for relevant indications, if they don't have the concentric response that we see, you may still be left with the footprint that you need to take, the so-called Swiss cheese pattern response. And then again, you raise your hand, right, I can still save the breast, I'll do something fancy. And of course, the fancy options, there's plenty. As we know, for large ptotic breast, you could do myoplasty, volume displacement options. Somewhere in the middle, you could do a bit of both. You could do a bit of a displacement option, you could do replacement option, or many times you could simply lift the so-called therapeutic mastopexy as opposed to mammoplasty. Now, for the last one, on the right column, if there is smaller breast, non-ptotic, maybe A or B cup, you don't have much room to maneuver. So what do? The way I explain to the patients that, look, you've got a slice, 10-inch pizza. I have two options. If you had bigger breast, I could, move and make you smaller, give you 8-inch pizza, or I could just replace two slices, fit in, and suddenly, yeah, I get it. So that's kind of easy way to explain to the patient. So replacement option, and there's plenty. But before selecting a complex oncoplastic options, I do tell my fellows of the essential principles. It was more of a mnemonic that I put it for myself, because once I booked a myoplasty, I forgot to ask about smoking. Another time I booked a large perforator flap, forgot to ask about diabetes. So I kind of got a tick box in my computer wherein if I see higher complexity, that they have had radiotherapy, they are due malignant surgery, if you're doing it for cancer surgery, they've got comorbidities, all these alarm bells, if they're ringing, traffic light system I've got in my head, keep it simple. Because the priority has to be oncological. As much as you can do fancy something, keep your priorities right. Number one, oncological, keep it simple, avoid anything symmetrizing. Even if we are doing therapeutic myoplasty, avoid implant a free flap. You can always do a delayed recon. And if you can't correct anything, you can always come back and correct. So that's kind of keeps me in control. Now, to focus on the topic in hand, as we have just seen, excellent talk of anatomy. So these are the flaps that are available to us: MICUP, medial intercostal, anterior intercostal, lateral intercostal, as well as lateral thoracic artery perforator flap and TDAF flaps. So it's almost like a progression in complexity. Now, the topic that I was strictly speaking was to correct breast conserving surgery, but as an oncoplastic surgeon, you shouldn't be producing any defects. So I'm going to be talking about other chest wall perforator flap uses. So how do you prevent deformity rather than correct deformity? So this is the patient who had screen detected 33 millimeter high grade DCIS. She had B cup and no ptosis. As you can see, radiologists were having a field day. They were having some kind of target practice, trying to, it's like when the patient came to theater, I had to, one of the very few times I kind of telling off, what were you doing? We're trying to bracket DCIs for you. And we missed the first one, we put in a third one. And poor patient, she's always happy with me because she had so much of poor experience before even coming to theater. But because it was DCIS, very close to nipple areolar complex, I did the surgery in 2 stages. So I did first stage, did the wide local excision. It turned out to be 45 millimeter high-grade DCIS, weight of 39 grams. As you can see, it's a very flat breast and upper outer quadrant. So I went through the periareolar with the intention that if the margins were extensively involved, then I haven't burnt any bridges. I can go through periareolar incision and do a skin-sparing mastectomy or implant or whichever reconstruction. And the second stage, because margin was closed, less than 1 millimeter one margin, combined with inferior excision, and did the flap. And this is the patient on the upper or wherever, on the left side, it's before surgery, and on the right side, it's after surgery. So it's pretty preserved anatomy, so it's kind of preventing the deformity that otherwise you would have had to do a mastectomy. And does it limit arm movement? You can't see her arms really in the picture. So full range of movement, no problem with arm mobility. Can you see the vessel? Because she was one of the first few, so trying to prove myself in a very competitive place in Cambridge. So I got the radiologist to look at the blood vessel. That's the blood vessel that I've mobilized for you. Now, another example, this was indeed the first case I did as a consultant, actually. It was pretty bold at the time. Lower inner quadrant, 2 tumors, 6 millimeter, grade 3, I think it is a type of 6 millimeter grade 1 and 8 millimeter grade 2. Both were ER positive, HER2 negative. Now, she had a previous right wide local excision. I don't know whether you can appreciate just the right periareolar incision at the top. Now, that was 10 years earlier. MDT said, well, it's multifocal tumor. You need to do mastectomy. Fine. I was new. I was following the instruction and sat with the patient, and, typical Cambridge patient said, well, it doesn't make sense to me, Amit. Right side, 10 years ago, for grade 3, 20 millimeter, you guys conserved my breast. And now you're saying for 8 millimeter, 6 millimeter, grade 1, grade 2, you're telling me I need to have mastectomy. Why can't you do something? Can you fill in with something? I said, oh, yeah, I can fill in with something. Let me go back to the MDT. MDT said, well, they'll have a defect and all. I said, well, I kind of half promise I won't give defect. But are you happy oncologically for me to do this surgery? They still were kind of unsure, so I did in 2 stages just to keep everybody happy initially. So I did a wide local excision through the IMF incision. As you can see, friendly radiologist this time really marked with the wire, so he was trying to help me out. And when the margins were clear, well, of course they were clear because there was a tiny little foci. Went back, as you can see, on the left upper corner, there's a glistening capsule. So what we tend to do is put in water in the cavity, wait for the margins to be clear, and then come back and fill in the gap. So you see that glistening capsule that you see around implant. And then I harvested an L-tap vessel. You could see with the right upper hand corner, there's an artery forceps pointing at the L-tap vessel. I tunneled the flap through the lateral into the medial corner. And that's the flap, and that's the result preoperatively on the left and right side. That's the postoperative result. You could still see the blue dye on the areola. Now, I wasn't quite happy because there's a bit of, kind of unevenness, which kind of persisted for some time. But she told me off, I said, Amit, you have been finicky. You have saved me a breast. You have given me a scar, which I can't see. Left side doesn't remind me of cancer. Right side still does. So I'm happy, leave me alone. So you're fine. And what about the radiologists? Because they were seeing this first time. Were they happy with the surveillance? So you could see the wire preoperatively, and you could see the flap. I don't know whether this pointer works. Let me try. Can you see? So I looked at the mammogram with the radiologist, and I said, well, there's my flap. And so she couldn't see the flap. And that's the dermis, because it's deepithelialized skin, and that's the dermis. So you could see it's nicely gels in. and it gives that nice texture and those 2 clip sites for radiotherapy. Now, what about central excision? This is a little video of use. I personally am not a big fan of Grissotti because it does shift the whole footprint of the breast. I would rather do a flap now. Yeah, we're ready? So this is central excision, and that's a TDAP flap. You can just about see the thoracodorsal artery vessel with the skin island, and I simply replace the skin into an aerial island, like you do for LD flap. And that's central excision done. Now, when do you have when you want only way out? Now, this is a very good example of another patient, screen-detected high-grade DCIS, who had ileostomy. As you see, she was C-cup, as you can see. That's a C-cup on the right side upper outer quadrant. Now, again, MDT recommended mastectomy because that was the default at the time. And she said, why I want implant? I said, no, I won't do implant because you've got a stoma. I said, can I have DIEP? I said, well, you can't have DIEP because you've got stoma. Can I have muscle? I said, well, now I'm not donating my muscle to you because I can't see much muscle on you. And then she said, can you not do this perforator flap? I said, how are you coming with these options? Oh, my son is a medical student. He's been reading about it. So I said, okay, fine. But maybe you should still have mastectomy. No, I'm not having mastectomy. If you can conserve the breast, I give you permission. So patient-driven, literally. I wasn't thinking, I have to say. And again, 2 wires to bracket, and that's the result. Left side preoperative and right side postoperative. So that saved her day. She got her choice. She managed to save her breast, and 10 years on, she's still okay, thankfully. And no problem with shoulder movement at all. Now, oncologists, because I work with Charlotte Coles, so there was initial concerns, so would there be radiotherapy boost issues? Patients, young patients, grade 3, triple negative, if they need radiotherapy boost, will it fry the flap? I'll come to the actual real-world data. But the concern also was regarding planning. So there's this systematic review which we looked at. There is a problem that oncologists do feel exists with planning. And a good example, as you could see, they are probably planning radiotherapy because there's a clip. But as a surgeon, I'm seeing this flap because that's where the tumor is. And probably because I'm able to do flap, I'm not going into the margin debate. I'm probably tempted to take more. So my margins are actually finishing there, but the oncologists are seeing that. So they are worried that we are giving too much of radiotherapy boost volume. So, and in fact, I haven't got a paper here. I got this fellow to sit down with a radiation oncology fellow and map out what he was seeing, what she was seeing, and the two were not matching, suggesting that there are some concerns, which means I took a cake to the radiotherapy oncology meeting, sat down with them few meetings, and started cutting the cake, to try and explain to them as to what we were doing. Now, this was a retrospective study, earlier mentioned, that we published last year. The intention was to look at surgical complications as well as what's going on with radiotherapy side of things. Of course, we didn't find any radiotherapy data. We didn't find any PROMS data. And hence, this PART-BRECON prospective study that we are doing, it's almost 400 plus patients have entered the database. Looking at 3 points, surgical complications, oncological radiotherapy kind of side of things. So I've got oncologists on board as well. And third, centers who are giving breast Q like PROMS to see what we see as good result. Are the patients actually feeling the good result? Because some of these scars can cause paresthesia. Now, extended use from perforator flap, cover for locally advanced breast cancer, grade 2, ER positive, HER2 negative, had neoadjuvant endocrine therapy. She was compliant for some time, but then ultimately had to be operated. Now, yeah, you could pull in upper abdominal advancement. You can pull in with all the tension. But the advantage, what I took, I kind of looked at the ICAP vessel, identified. So rather than random pattern pulling that, bringing them together, identify the ICAP so that I know it's going to survive. And it did. I think I'm trying to point the perforator, but it's can't see. Now, when the patients get local recurrence, some of them, like this perfect example, 72 years old, had neoadjuvant chemotherapy, triple negative, but had extensive chest wall recurrence. I haven't got the recurrence picture, but then had to replace the whole. Essentially, the recurrence was literally upper outer breast, or pretty much whole of the breast. So this is a good example of non-muscle based chest wall cover. Basically, she was referred to the plastics. They referred back to me. They said, well, why have you referred? She hasn't got much of muscle. So this is a TDAP flap cover to save the day for the timing. Having said that, she developed recurrence within 6 months and passed away a few months later. Could the flap be used for total breast reconstruction when you get patients who do not want implant, when they are into physical activities that they don't want muscle to be used? What can you do? Perhaps you could use some CT angio to try and prevent problems. A systematic review, not a huge deal of data, as you can imagine out there, to identify, and still you can do some full flap. Can you do delayed reconstruction? Yes, that's an example of a delayed reconstruction, previous mastectomy. Of course, it doesn't look great at the time. You could lipofill, create a nipple, lift the other side. She should be happy. Total breast reconstruction, plus minus implant. Again, a fellow kind of did a collaborative study with Egypt University because he was doing a PhD degree. TDAP could be used as a cover. So you saw example of flap necrosis, skin sparing or nipple sparing. Could you use LICAP or ICAP or TDAP, one of these app flaps, to save the skin or cover the implant? Or if you don't want to use the ADM, you haven't got access to ADM, can you use one of these flaps as a hammock? One of the last few slides. Could full TDAP itself, chest wall perforator flap itself, give you a breast? Of course, in A and B cup, if they've got enough plumpy tissue around the chest, perhaps you could do a full flap reconstruction. Just an example of patient who again came in wanting to have TDAP recon, and she handed me a couple of my papers, probably 4 or 5 of Mustafa Hamdi. One I didn't have, so I borrowed it from her because that was a full copy. And she said, I want TDAP reconstruction, no muscle. And that's her, I think almost 2 years or maybe a year later. So it kind of saves the day in certain situations when you don't have any other option. You can't have implant, you don't have ADM, patient can't pay for it in private sector. Then chest wall perforator flap can have all these multiple uses that you have just seen. And I'm going to thank you for listening. I'm just about in time. Thank you.
Thank you very much. Any questions from the audience or comments from the commentators, please? Mr. Karkatsanis?
Or Professor Kuhn? Any comments? Andreas, you're the expert, another expert in the field in the room, so we'll probably value your view on that.
My 5 cents is that I think that Amit will corroborate that, is that once you start doing, once you start seeing the possibilities, you usually don't go back. Now, we have prompts in that study. We have another intention for the comparison of prompts. But it's a little bit like stealing candy from a baby, because it is a very reasonable assumption to realize that had these patients been mastectomy and reconstruction cases, the financial toxicity, the morbidity, the need for revision would be multiple in this sense. What I think we need to realize is that this is not the scary technique that had been alluded to in the past. I think that the first pictures I saw of these, especially with publications coming from Amit's neighbors, they were scary. What I would like to tell people, and I don't know if Amit agrees to that, is that, Amit, how often do you need to really dissect the perforator to do a perforator flap?
That's a very pertinent question. Essentially, once you have done quite a few, you're bored anyway. So do you really want to spend time in theater skeletonizing the blood vessel? It's literally, nowadays, you put in a Doppler. I don't use Doppler if I'm operating alone, but if there's a trainee, it's good for demonstration purposes. You know where the perforators are. You're not even thinking. You put in Doppler, and you know the vessels are there. As long as the flap turns over, or whichever position, it's lying without tension, you stop. Just like LD pedicle and LD flaps, you go as long as it allows movement, that's it.
Exactly. And how often do you actually need to do a single perforator-based reconstruction?
Well, majority of the times you find more than one. Majority of mine are combination of LICAP and LTAP, because we are still doing sentinel lymph node biopsy, and next time you're doing sentinel lymph node biopsy and you get a bleeding, then you can safely say that was, in past tense, LTAP. Okay, so next time you get a bleed, to save it. So because they kind of come together. The only problem is when you've got two LICAPs and you're trying to mobilize maybe a bit of a twist, then it's almost like fixing the testis. Then you don't want to clip one. So I tend to, then you have to clip one of them. So very occasionally, based on one perforator, thankfully it does survive.
It does. What I do when I have this dilemma, so I call this monkey business. You never leave one branch until you get another, right? But if you're stuck with two, and that limits your mobility, there are different ways to deal about that. Like I know that Peter Barry uses microclamps, for example. I do not use microclamps. I will just double pass a vessel loop. I will strangulate that. I will cut the tip and see if it bleeds. If it continues bleeding after 5 minutes with one vessel strangulated, then you just clip it off. You've seen that in a couple of, So my point is that without saying that you should just go back at work on Monday and start doing it if you have never done it before, it is much more anatomy-based and rationalized surgery than what I think we were led to believe when we were younger.
Correct.
So we kind of had to demystify and to demonize something that we had been told is very, very difficult. It is not something that you do without any consideration, but I think it is a much more sensible way of doing things and approaching that.
I can't agree more with you, Andres. Oncoplastic and identifying these perforators and all, even during mastectomy, I kind of almost, you can tell there's going to be a bleeder soon, and it's carry on. And then suddenly hits the face, and I said, I told you there's a bleeder. Because you know it's going to be there. Next time you put in a drain anteriorly or from the side, and you've got that bleeding in the drain hole, that was LICAP or that was ICAP. So these things, we were doing it all the time. We didn't know, but now we know the anatomy. So I tell the trainee, in fact, I was doing the flap a couple of days ago, just a day before coming here, was that, look, there's more to breast anatomy, because this is your first breast posting. You've come from colorectal. Don't believe them. Don't trust them. I can do anterior resection. They can't do perforator flap.
Well, I have another question, because I think that this is something we have in the past discussed about it, and we're doing it slightly differently. Do you have particular patients in which you would preoperatively decide on two-stage?
One is pure DCIS. We do use lots of MRI, actually. It's somehow, one of these like trials we were talking about with no evidence. Suddenly, because there are MRI trials, MRI radiologists were keen on having patients into the MRI trial. And we got a series of MRI in DCI. So we published 2 literature. One is original data from Cambridge, and another is a review of use of MRI to help with oncoplastic planning in DCIs. As we all know, it kind of helps, but then it doesn't seem to decrease the re-excision rate or the mastectomy rate. So in those cases where radiologists don't tell me exactly where it's starting or finishing, I'd probably bite the bullet, not bite the bullet actually, and go for 2 stages. Okay. If it's palpable, certainly I'll go for it. And the other scenario is invasive lobula. That again catches us out many times. With the caveat that it's not a default pure DCIs ILC. It's a consideration, like, I agree. As an option.
Yeah, because this is something that we have not included in the paper because of word restrictions. But in those cases that we have in there, the single case that was done as a 2-step was an unintended. It was I think it was one of Peter's patients, where he got concerns about, mobilizing adequately enough, and does this make it, does it not make it, where he just decided to redrape it, staple it, and went back a couple of days later and just completed the procedure. Yeah. And this is what I think these are very nice fields to work on and understand how we will be treating that optimally. I usually become greedy in the sense that, you said it yourself, you can be very generous with your excision, so we just try to reascertain that margins will be fine. Yeah. And what I usually do if I have a positive margin is that I will go through a periareolar incision so as to avoid opening everything. Correct. You just go through a periareolar and just shave what you need to shave.
I mean, looking at my data, if I did, because we've got a very good pathologist, much of your margin positivity depends on your pathologist as well, as to how they do the blocks and how careful they are in looking. When I look at my simple wide local excision, it's about 1 in 6.5 or 7. I code the patient. I tell them if I did wide local, if I did mammoplasty or perforator flap, because these both are options, it's about 1 in 13. Nobody is going to give you 0% margin positivity.
No, it's just that it is important for the audience to kind of make the argument that when you expect re-excision numbers, you should not be comparing that to those of a therapeutic mammoplasty, because there you have a very big breast to work with, right? Whereas here, you're working with a kappa A or a kappa B breast predominantly, correct, at least this is my population, and that makes things a little bit more challenging in the sense that you are offering that because your counterpoint would have been a mastectomy anyway.
Correct. Correct. Yeah. Thank you.
Thank you very much.
Thank you.
Thank you all. Any other questions from the audience? So that probably concludes the second day of the Congress. Thank you all for being here. See you tomorrow.